राइट वाली लाइंस हैं ये आप बोल देना, ठीक है।
ओके।
और फिर ये सेशन मैंने ऑल्टरनेट कर दिए थे।
स्टार्ट एंड बीच में मैं बोल दूँगी,
हाँ,
ठीक है ना, राइट, ठीक है, डन है।
तो मैंने थोड़ा सा वो कोशिश की थी कि जहाँ पे ज़्यादा मेडिकल टर्मिनोलॉजी है वो सेशन मैंने अपने पास ले
ऑब्वियसली
लिए।
या
और ये जो है ये वाला जैसे ऑल्टरनेट कर लेंगे।
अच्छा, ये आपने लिखा है, राइट राइट,
ठीक है, तो बहुत ही सिंपल सा है। और ये
मुझे हार्ड
और
कॉपी चाहिए
सुन
होगी।
सुन और ये जो है ना ये चेयरपर्सन्स के नाम, जो चेयरपर्सन्स के नाम है, इनके साथ ये बोलने की ज़रूरत नहीं है हॉस्पिटल,
ओके
ठीक है।
ओके।
ज़्यादा से ज़्यादा अगर बोलना भी है तो सिर्फ वो बोल दो बस, हॉस्पिटल का नाम, नहीं इनकी डेजिग्नेशन बोलने की कोई ज़रूरत नहीं है।
पूरा नाम तो आज पता चला।
डॉक्टर मृगांक शेख हज़ार फ्रॉम मैक्स साकेत,
मृगांक,
ठीक है।
डिफिकल्ट है।
बल्कि ये है कि इन बिटवीन हम वो भी बोलना छोड़ देंगे, सिर्फ स्पीकर्स के बोलेंगे, दैट्स इट।
ठीक है।
और कल तो मैं सोच रहा हूँ वो भी नहीं बोलेंगे।
हाँ ठीक है, आज इंट्रोडक्शन हो ही जाएगा सबका।
आप ही रख लो। आपको छोटी सी बात जो
ना
डिस्कस
ना,
करेंगे
ठीक है
वहाँ पे।
ठीक है ठीक है, मैंने बोला ना, मैं बोलूँगी आप यहाँ से शुरू करोगे, गुड मॉर्निंग, हाय,
हाँ
एंड देन मैं बोलूँगी आई जसप्रीत कौर आलम।
ठीक है, बाकी तो ये मैं बोल दूँगा, फिर ये वाला बोल देना, मैं बोल दूँगा आप बोल देना, कोई बात नहीं, मैं बोल दूँगा। देख लेंगे डिस्कशन, लिखा होगा 8 मिनट्स प्लस 2 मिनट्स डिस्कशन, 8 मिनट्स 2 मिनट्स डिस्कशन, ठीक है। पहले मैं सोच रहा था कि ये वाला जो फॉर्म है ना ये इंडिपेंडेंस डे वाला ये वाला जो है ये मैं एप्लीकेशन के बारे में नहीं बोलूँ, तो मुझे लगा कि उस टाइम बहुत सारे लोग होंगे तो मुझे टाइम मिलेगा, तो मैं ये सोच रहा था।
कंटिन्यूशन के साथ ही इनॉग्रेशन है कि देयर इज अ
नहीं गैप तो नहीं, साथ के साथ ही।
मंडे, मतलब साथ में जाता है,
हाँ
मुझे
सब कुछ,
लगा
नहीं नहीं
ब्रेक है
एंड में,
शायद,
एंड में था।
एंड में है 7:30 मतलब दिस विल रिमेन गो ऑन टिल 7।
टिल, हाँ टिल 6, आई थिंक 6:30 के enlargement by Max Super Specialty Hospital, Saket, here at New Delhi. We meet here today just a day after our nation celebrated its Independence Day, a reminder of the courage, sacrifice, and vision that gave us the freedom to dream and to build. As doctors and healthcare workers, our own profession carries forward that spirit to serve.
And today is special for another reason. It is Janmashtami, the birth anniversary of Lord Krishna, the divine strategist, healer, and philosopher. So, as we embark on the Max Prostate Conclave 2025, this unique blend of patriotism and wisdom and science will surely make the next 2 days both enlightening and inspiring.
Over these 2 days, we unite some of the country's finest minds in urology to share, learn, and collaborate on the theme of the benign prostatic enlargement management and the evolution of new minimally invasive surgical therapies.
So, our scientific program is rich in lectures, debates, and panel discussion. Throughout the day, we will have live operative demonstrations.
We are honored to host this event and to guide you through the proceedings. So let's begin with the first set of lectures chaired by Dr. Mrigank Shekhar Jha. So please come on the stage and take your seat. Dr. Vikas Singh, Dr. Sumit Bansal, Dr. Nitin Srivastav, Dr. Manish Chaudhary, Dr. Pragnesh Desai. I request all the chairpersons to please be on the stage. We'll begin with the first talk of the day by Dr. Ritesh Goyal, who is going to speak on terminologies in male LUTs. Over to you, sir.
Thank you.
Good morning. Thank you, organizing committee, for giving me this opportunity. I'll speak on a very important topic, terminology in male LUTs, and I'll try to keep it as simple as possible. To start with, in the past, we started with the term prostatism, and we used to label everything as prostatism, and we assumed that all it is because of BPH and only can occur in males. So this was the early view. Then came some intelligence, and we evoluted, and then the LUTs had replaced the term prostatism for all age groups, irrespective of the age or gender of the patient. Initially divided as irritative and obstructive symptoms, but with advent of urodynamics, and we found that not every obstructive symptoms is due to bladder outlet obstruction, and not every irritative symptoms is due to problems in filling phase. So because of that, this was early understanding that prostate, this was second understanding that not all prostate enlargement will have symptoms, but also not every symptoms is because of obstruction. So there is an overlap. This is commonly known as Hall rings. So now we know that LUTs is not only because of benign prostatic obstruction. There can be multiple other factors that can cause similar kind of symptoms, and we should always spend more time in history taking and evaluation to identify the right cause and treat it accurately. So current classification focuses on 3 different verticals. One is filling or storage symptoms, predominantly commonly said as fun symptoms, frequency, urgency, nocturia, and voiding symptoms or problems in emptying are hesitancy, poor stream, intermittency, straining to void, dysuria, terminal dribble. Also, we must always ask post-voidal symptoms like post-micturition dribble, feeling of incomplete emptying, and post-micturition incontinence. I'll come on each and everything, all these things. So the acronym minefield. This is something which is very important, and invariably most of us have been using this interchangeably. And so I like to just brief out all these things. BPH is just the term described as a typical histological pattern that defines this condition. Enlargement is something that you see on ultrasound, which is the prostate is beyond a particular size range for a person, specifically when that enlargement is due to the benign cause. When benign prostatic obstruction, now it means that this enlargement is causing obstruction, and usually defined as a urodynamic diagnosis, but also you can even tell it on a uroflow when it is due to the prostate enlargement. Now, bladder outlet obstruction does not mean benign prostatic enlargement only. It is the term used for any cause of subvesical obstruction and defined always by urodynamic study. So whenever we call a bladder outlet obstruction, it is a urodynamic diagnosis. So this is the focus has been changed from initial Hall rings to a very basic understanding to now the causes of male loads that includes polyuria, bladder dysfunction and outflow tract pathology. So these are the three different reasons for male loads. And they can occur simultaneously, all three can occur in the same patient, two of them can occur in the same patient, and they can occur as a solitary finding. So storage symptoms, the diagnosis, ICS in their last meeting in 17, 18 and 19 in different time frame, they refined the diagnosis and made it more simple for understanding. Rather than giving a very specific thing, they gave it a broader sense. So increased daytime frequency simply means that complaint of a patient who feels that he or she should void more often during a day than previously they used to. And commonly accepted for us is more than 8 micturations per daytime, but this is not something that has been described, that more than 8 times. If a person says that मैं 6 बार जाता हूँ, and still I feel it is more than usual, still it is a symptom. Nocturia, it is simply that patient wakes to pass urine in the main sleep period. Does not mean the patient is up in the night and he gets the urge to void. He should, the nocturia, first nocturia episode must precede by a deep sleep. And again, there is no exact numbers now given, but the commonly accepted is 2 per night, more than 2 per night. Now there's something that we need to differentiate nocturia versus nocturnal polyuria. Nocturnal polyuria means excessive share of a 24-hour total urine produced at night. In younger males, ICS gives as a cutoff of 20% of total 24 hours output. In adults, it is more than 33%. It is determined by frequency volume chart or bladder diary as we call it commonly. Urgency means a compelling need to urinate which is difficult to differ either because of pain, pressure or discomfort. When you associate it with a pain, it comes into the category of interstitial cystitis. Special mention to overactive bladder. Now overactive bladder is not part of the storage symptoms. It simply means a condition of urgency, usually with associated with frequency and nocturia, can occur with or without urge incontinence, and in absence of any infection or any obvious pathology. So it is something that occurs de novo in the bladder. Coming to incontinence, urinary incontinence simply means leakage of urine, involuntary leakage of urine. But we must also understand various factors like type, frequency, severity, precipitating factors, social impact, effect on hygiene, quality of life, and measures used to contain that leakage. People drink less waters and they avoid social visits. Stress incontinence means that the complaint of any involuntary loss of urine on effort of physical exertion, either by sporting activity, coughing, sneezing, or laughing too hard. Urgency means it is either leakage is either accompanied or preceded by an urgency. Mixed simply means stress incontinence occurring with the background of urgency. Enuresis. Enuresis means again involuntary loss of urine. Nocturnal enuresis means a loss of urine occurring in the night time during sleep, and it may suggest a history of overflow incontinence. Now bladder sensation is also something that we must be very aware. A normal bladder sensation is that patient is aware of bladder filling and gets an increased sensation when there is whenever there is an urge to void. It is said increased when patient feels that an early filling of sensation when he used to before, and then is a persistent urge to void and occasionally associated with pain also. Reduce is that patient complains that initially I had in every 3 to 4 hours, now I don't feel in at least twice in a day. So that is something that his overall bladder sensation is reduced. Absent is that the patient reports there is no absence, there is no sensation of bladder filling or any urge to void. May suggest a condition of chronic retention. Now voiding symptoms, slow stream or a weak stream, it is a patient reported data. They simply say my stream has become poor compared to the previous performance. Splitting is that urinary stream may be splitted or diverging. Intermittency, it is a start-stop kind of a flow with one or more occasion. Hesitancy is patient requires a lot of effort or lot of time to initiate micturition, often resulting in delay or an onset of voiding. Straining simply means increased muscular effort required to initiate, maintain or improve the urinary system. Terminal dribble is again an important thing that patient describes a prolonged final part of the micturition where after performing the voiding, patient has a slow urine and he trickle or dribble. A sense of incomplete voiding again is a patient reported symptoms, especially said experienced by some individuals. Post-micturition dribble is that involuntary loss of urine that happens once patient has completed urine and often soils his clothing. Common pitfalls, that is calling bladder outlet obstruction from flow curve alone. It needs a pressure flow study. Qmax is neither specific nor sensitive part of the bladder outlet obstruction. Second pitfall is equating LUTS with prostate. A non-prostatic cause bladder neck dysfunction, stricture, meatus remain common. Use BOO very precisely. Nocturia versus nocturnal polyuria we have already discussed. Nocturia is a symptom, nocturnal polyuria is a diary defined condition. Urge incontinence versus urgency incontinence. Now ICS favors urgency incontinence. In last workshop they have done away with the urge incontinence as part of their term. Diaries, this will be discussed in coming sessions. These are common diaries and prior instruments which we must use for evaluation. A small brief 5 seconds on Euroflow and PVR. Euroflow has lot of strengths, simple, quick, non-invasive, good baseline, treatment comparison, detects abnormal flow, and guides surgical versus conservative treatment. But the limitation is it is an effort dependent modality. Also requires strong desire. Low volumes will not give you good results. Cannot differentiate bladder outlet obstruction from detrusor underactivity. So by just having a Euroflow, we must not label somebody a bladder outlet obstruction, because such patient when will undergo a surgery and will not have a desired outcome may come to you with a bad experience. Not suitable if a patient cannot void on demand. Also PVR, main important thing is in patients, especially females, who have a pelvic mass or cervical mass, it may be overestimated in cases of pelvic mass or ascites. So that is something we must, there's a limitation of Euroflow and PVR. Small conclusion, use ICS term whenever possible. Not every term is interchangeable. Symptom domains are most predominantly storage, voiding, post-micturition. Mechanism markers are important, document precisely and avoid casual terms unless proven. Thank you.
Any questions from the audience? Okay.
Yes, sir. Yes, sir. Yes. Sir, that is where ICIQ, I wanted to put that, but we have already lectured, that is covering up. That includes bother in addition to your this IPSS. Thank you, sir.
I invite our next speaker, Dr. Sudhir K. Dewana, Associate Professor, Department of Urology, PGI Chandigarh. Thank you.
A very good morning to everyone. At the outset, I want to thank Dr. Anand Kumar and Dr. Rohit for having me to be a part of this conference. I think after the brief terminology, now the most important part of any patient who is presenting to us with lower urinary tract symptoms is his basic evaluation. And I believe that this part is a very important for every urologist to understand how to proceed in a given patient, because this is the time after evaluating you come to a differential diagnosis in that given patient, and then accordingly you treat it. And many a times patients do come being managed by with a wrong diagnosis, and again they are persistently having those symptoms and they don't get improved. So that's why if you evaluate a patient very well and you come to a proper diagnosis, that even builds up a good rapport and good confidence in the patient with the doctor. So that's why this is a very important part of any evaluation. I think you have seen the same slide which is being projected by my previous speaker, that there are a plethora of causes which lead to lower urinary tract symptoms. More so, the difference between the differential diagnosis in a young patient with an elderly patient is altogether different. So that's why it's very important to dissect out the history as to what are the possible differential diagnoses in a given patient and then proceed. So let us go to the basic evaluation. So evaluation can be briefly described into basic and a specialized evaluation in any given patient with LUTS. So the basic evaluation includes the lower urinary tract symptom history and also the amount of bother, as being mentioned previously, that is the most important for any given patient. What is the bothersome symptom? That you have to identify and then treat accordingly. Then the subsequent examination and then urine analysis, even PSA to rule out CA prostate, because these patients, many a times CA prostate patient presents to us with lower urinary tract symptoms. And then you go to the subsequent specialized investigations and go on and so on. Coming to the history, all these symptoms have been, just now we have already seen them. The most important always the bothersome symptom which you have to go. The acute urinary retention is a significantly bothersome symptom for any given patient, and then the most important thing is the urgency and incontinence. So these are the symptoms which bother the patient a lot. So you have to focus on them while treating these patients as well. Then the next important is the nocturia. It's the most difficult part of any patient with LUTS to treat is nocturia. It's so easy. It doesn't mean that any patient, whosoever patient, elderly patient comes to you, the moment you ask them whether you have nocturia, they will say, I get up 2 to 3 times. But evaluating in depth into that area as to what is the reason for that nocturia is very important. Now, specifically, I want to focus that storage predominant LUTS are the most important thing which we have to focus. Because why it is important is the other etiologies also overlap with BPH in this part of symptomatology. Like it can be a case of overactive bladder, it can be a case of interstitial cystitis or a chronic prostatitis. Patient can be a case of GUTB. I know, of course, elderly patients, GUTB is not so common, but we have seen patients developing small capacity of bladder due to either GUTB or some inflammatory pathology of the bladder leading to the same presentation at that age group. Then rarely malignancy. I put out this ultrasound picture of one of my patients who came to, his main symptom was frequency and nocturia. He never had hematuria or anything. But subsequently ultrasound was showing bladder tumor which is completely occupying the bladder leading to his LUTS. So once in a while, rarely malignancy can be a cause for the storage LUTS, more so when you have irritative and increased frequency. Now coming to another case scenario, just to point out few case scenarios, I thought that these are the practical cases which I have come across, like a 60-year-old male with LUTS presenting with, specifically he complains that pain is increasing on holding the urine, and that radiates to the penis while he passes. So these symptomatology of pain associated with LUTS is also very important, where your diagnosis, you have to think more of other possibilities. Like you see the frequency around 20 to 25 times, and night time it is more. And this patient on scopy subsequently he was diagnosed to a case of IC, and the age you see, it is 60-year-old. It's not that all patients in elderly coming with the only, it is not the BPH is the most common etiology. So when you have severe storage LUTS, think of other etiologies as well. Another patient, severe storage predominant LUTS, he has dysuria, nocturia, he went to a hospital where he was diagnosed to be having grade 2 prostate, he even underwent HOLEP. And the patient after surgery, 1 month down the line, he started saying that my symptoms have worsened. He became incontinent now. So now the same patient, when he came to us, we evaluated, we found that his actually bladder capacity is very low. So that's why be careful whenever you have storage symptoms, dissect out and then keep a diagnosis, because rushing to a surgical management in such cases should not be there. And of course, this patient subsequently underwent cystectomy. You can see the amount of small capacity bladder which he had. Now, next important thing is nocturia. Nocturia per se is the one which causes more of bother and sleep disturbance to any given patient. Like in this bladder diary being written by one of my patients, you see that from 11:30 to 7 o'clock, he has to pass around 1.5 liter in the night. So those patients where nocturia is predominant, bladder diary helps. And you always tend to diagnose whether there is nocturnal polyuria. Like in this given case, around more than 4 liter of urine output production was there, but predominantly if you see in the night from 9 to morning 6 o'clock, majority of the voids, half of the voids are there at night. So that nocturnal polyuria, then you have to manage them subsequently accordingly. And the same patient, after giving advice, don't drink much of fluids beyond 5 o'clock in the evening, he started having decreasing frequencies at nights. So fluid management also obviously in such patients will help. Now coming to validated symptom scores, EIU guideline says that you have to validate with IPSS scoring or any other validator score so that you can categorize them into mild, moderate, severe, and mild symptoms doesn't need treatment, that I think every one of us know. So categorizing them with some sort of scoring also definitely helps for as a baseline, and even as for understanding the natural history of to what is happening to that given patient, and also response to the therapy also can be understood with that. Additional symptoms other than LUTS, hematuria, very important. Whenever you have hematuria, you should keep possibility of other diagnosis as well other than BPH. Chronic pain symptoms, all those symptoms which are mentioned there, then there is a component of IC oblique chronic prostatitis in the given patient. Like this patient who has LUTs for many years, most of the times chronic history of symptoms of storage LUTs with pain, obviously they can have a possibility of chronic prostatitis. Like this patient, when he was treated with Septran for 4 to 6 weeks, he had 100% resolution of symptoms. So don't rush to the possibility that only the BPH is the thing. Acute urinary retention, of course, we have to look for is it a chronic retention or a precipitated acute on chronic. So those categorizations should be done in a given patient. Coming to medical history, definitely diabetes, CAD, because nowadays lot of treatments are there, MIST are available, where patients with comorbidities can be given minimally invasive therapies. And drugs, specifically anticoagulants, you go for laser therapies. Otherwise, drug interactions, because a lot of anticholinergics and drugs are there, where even the alpha blockers, you have to look into the comorbidities. Neurological history, specifically Parkinson's, particularly in elderly patients, is very important, because the post-op symptoms, if you offer directly TURP without documentation of bladder arterial obstruction, can lead to worsening of symptoms. Surgical history, I think there is no need to inform this, because patients with post-TURP or HOLEP, obviously you have to look for other possible diagnosis. Examination and this thing, particularly like this patient, he was planned for TURP, he had a surgery in childhood. See, for meningomyelocele, which nobody has inquired it. So obviously when once this patient presented to us, he has a very lax sphincter, and subsequently we had to change the plan of TURP, because in this patient, neurological evaluation, urodynamics evaluation is very important. Lifestyle habits, fluid intake, smoking, they have to be avoided. So these history you have to take. Let me rush to other cases, like sexual function assessment at the baseline of any patient with LUTs is very important, because the drug combinations now with PDE5 inhibitors are all available, so you have to take specifically into this into account. Bowel function, associated bowel function should be corrected, always include bowel history, bowel disturbances in your history of LUTs. Examination, bladder distension, focal neurological examination, these are also very important to know whether there are any associated neurological symptoms. Just a few points related to urine analysis. Sometimes sterile pyuria can be there in patients presenting with LUTs, where the diagnosis of tuberculosis or any other etiology would be there. So it is a strong recommendation according to EIU guidelines that all patients with LUTs should undergo urine analysis. PSA, I think my next speaker, Dr. Tushar, will be covering that. I don't want to do that. And bladder diary is a very important part of evaluation, particularly storage LUTs and nocturia. Always do bladder diary, which is a strong indication or recommendation by the EIU guidelines. And another 2 points related to uroflowmetry. Uroflowmetry, as been mentioned by the previous speaker, that it's a very individual variability in the same patient would be there, and it depends on the amount of voided volume as well. So that's why whenever you are planning a medical or invasive therapy, always do a uroflowmetry at the baseline to see the response anyway. Then post-void residual similarly is very important part of any patient patient presenting with LUTs, because the high PVR is associated with the risk of symptom progression, and you have to go for more invasive therapies. Imaging, not recommended in every patient, but in patients with hematuria and renal efficiency, you have to look for upper tract changes where the upper tract imaging is needed. Cystoscopy, similarly, when you have other odd symptoms like hematuria or suspected bladder cancer, and when you have a median lobe, sometimes patients now with the minimally invasive therapies, where the presence of median lobe decides which treatment you have to offer. So there, scopy will help. So summarizing, this is a final slide of mine, where the first and most important is the medical history, assessment of LUTs, symptom severity and bother assessment, then physical examination, urine analysis, PSA to rule out CA prostate, and a frequency volume chart. These are the basic things which every patient should undergo. And then based on this, when you have complicated LUTs, like with an abnormal DRE, hematuria or abnormal PSA, and in those patients with neurological disease, where you have to go for a specialized evaluation in the form of urodynamic, cystoscopy or other investigations. Thank you.
Thank you, sir. So, if the audience has any questions, otherwise we can move on to the next speaker, and I would request all speakers to kindly adhere to the time given.
I request Dr. Aditya Prakash Sharma and Dr. Pankaj Gaud to please join our panel of chairpersons. Next speaker we have is Dr. Nikhil Khattar from New Delhi PSRI, discussing the role of UDS in male lower urinary tract symptoms.
Good morning, everyone, and thank you, organizing team, for giving me this opportunity. So I'll be discussing on the role of urodynamics in male lower urinary tract symptoms. So this is the latest EAU guidelines, where for almost everything in male LUTs, the urodynamic study has got only a weak recommendation. And this has come after this, has changed after this trial that is called the upstream trial, where all men above 18 years who were not on catheter and non-neurogenic were randomized either to an arm pathway where urodynamics was part of workup, and other pathway where it was not part of workup, and it was found that both ways the results were same, whether they underwent urodynamics or not. But lower urinary tract symptoms in men generally, as Dr. Ritesh had pointed out, that either it is the younger male or the other age group is benign prostatic enlargement age group, that is men with an older age group, and the differential diagnosis is different in both of these age groups. Whereas here it is mostly primary bladder neck obstruction, detrusor overactivity, dysfunctional voiding or underactive bladder. In elder men it is benign prostatic obstruction, detrusor overactivity, it can be detrusor DHIC and hypercontractility with inhibited contractility, and underactive bladder. So we have to somehow reach to these diagnoses when we are evaluating, and then the urodynamic comes into picture, and we'll go in a little details about urodynamics, that when we evaluate the graph we must see that both the cuff and the cuff is reflecting equally in PVES and PDET, and then just before voiding there is a cuff, then so that we can interpret the voiding phase as well, and there should be a command to pass urine, and then there should be one cuff afterwards to make sure that that it is all the tubes were in place even after voiding. Then if there has been any dip here in the P abdominal chart, then the PDET, maximum PDET achieved, should also be adjusted according to that, to make sure. These are some changes that have to be done over and above what machine calculates. So going forward from here, let us see what kind of diagnosis, how we can get to the diagnosis in younger men. So this is a young male who presented with poor flow and pain while passing urine. His RGU was normal, and we can see on urodynamics that he has typical bladder outlet obstruction, and this alone does not make the diagnosis. Here in a younger male, the diagnosis gets complete after a micturating film, which shows that there is poor funneling at the bladder neck. So this is a primary bladder neck obstruction in a young male. Again, here we can see bladder outlet obstruction, and then we can see poor funneling at the bladder neck, and this is also a bladder neck obstruction. Whereas here, if we see in this male with bladder outlet obstruction, we can see on the MCU film that there is dilatation of the proximal urethra, and this is a dysfunctional voiding. One thing I will like your attention to be that the micturition command here in this urodynamic trace has come after he has achieved the PDET. So probably it was a detrusor overactivity, that it was a terminal detrusor overactivity, and then a command was given during that overactivity. So ideally, in such cases, one should wait for the detrusor overactivity to subside, or if the command has to happen, then it has to happen before or maybe at the beginning of the flow, then that is valid. Again, this male again during his terminal, there is terminal detrusor overactivity, and then the voiding command has been given, and this is also a dysfunctional voider. Then young males can also have bladder benign prostatic obstruction. This is bladder outlet obstruction in a 44-year-old male, and on the MCU we can see that the dilatation is only till the prostatic level, not at the external sphincter level. So this he got relieved after TURP. There can also be bladder underactivity in young men. Then patients with benign prostatic enlargement age group, if they are in refractory retention and cannot void, generally there is, since they will not be able to void, so either a diagnosis of bladder outlet obstruction, urodynamic obstruction, or bladder contractility one won't be able to give. So the value is less, but still if you get a urodynamics and see a detrusor pattern like this as compared to this, then definitely you know which patient will is expected to void better after relief of obstruction. In patients with chronic retention, again you will be happier operating on a man with a curve like this rather than the previous one. Then if there are both storage and voiding LUTs, then see here there are detrusor contractions, but I waited for the contraction to subside before command for voiding, and then this voiding graph goes over and above the previous contractions, and he is able to pass urine here. And compare this graph with this graph. He is these all of them are older men. This one is a 70-year-old man, where with 400 ml of residual urine on his ultrasound, he had chronic retention, and you see here that there is strong detrusor overactivity, and the voiding graph, whenever the command to void has been given at the beginning of detrusor overactivity, but the voiding graph is just similar in amplitude as it was here in the detrusor overactivity part. So so whether this is actual volitional voiding contraction or it is just an overactivity, that is left to imagination only, and so one has to be careful about labeling these as bladder outlet obstructions. Then detrusor hyperactivity with inhibited contractility can also be there, which is present in approximately 20% of men above 70 years. So now although urodynamic, whether it is there in the pathway or not, if it is available, it can help you more informed decision making. That is what is the consensus, but it has to be used very carefully, and not for every man with voiding LUTs, especially in the BPE age group, whereas in younger men, that is video urodynamics is mandatory for reaching to a diagnosis. That is all. Thank you so much.
Thank you, Dr. Nikhil. Yeah, please. There's a question from the audience.
Yes, it's true that urodynamics is not a must, but I think in modern scenario, one, that patients' expectations have increased too much out of your procedure, what you do. Secondly, treatment has become very expensive. So patient expects that once I undergo surgery, I must get the best of the results, which many times may not be possible. So I think sometime now what I see in my practice, maybe I'm inclined more towards doing urodynamics, more to give or counsel the patient before surgery what to expect out of surgery. Also, as we become senior, we keep on getting patients operated by others, and they are so unsatisfied because their expectations are very huge from the surgical intervention. but many of them have component of underactive detrusor. So just to have an opinion from the house that considering these factors, should we be more inclined or safe by having urodynamics to really counsel the patient or to understand what to expect out of the procedure which you are doing?
I think you are very right. Sometimes, especially in elderly patient with chronic retention, this becomes a very important fact. Sometimes disease is the diagnosis is very clear. He has got significant symptoms. He has a obstructed uroflow. He has a PVR, and he could generate good uroflow. So you know that this guy is voiding. He has got symptoms. He is having problem. But sometimes those who are not voiding, that is the problem. And one thing is urodynamics is usually left to the technician. That is not. There should be a clinician who should interpret the symptoms as he pointed out, and then do the diagnosis, especially those patients who could not void. Now that probably he could not void even if his bladder contraction is not bad. That is one thing. Sometimes urethral catheter alone can cause problem. This patient might need repeat test with the insertion of epidural catheter or something into the bladder to keep the urethra open without any tube to see whether he is voiding or not. Voiding command has to be in a good environment where there is not much disturbance, like somebody is coming, going, and patients are disturbed. So there are many things is to be done. And sometimes like video urodynamics is a very important test. If you are doing simultaneously, you can also observe what is happening. And EMG should also be incorporated when you are not sure what is happening, whether it is diffuser sphincter dyssynergy or not. Only looking at the image that sphinctering region is not relaxing gives you a hint. But if simultaneously you had EMG also, then you have very definite diagnosis that what exactly is happening. The urodynamics helps us in understanding the patient in which you are not sure what is happening. And many patients who are coming with chronic retention, especially if they are diabetic, elderly patient, that this is an important investigation. At least you can prognosticate, you can tell them, or even if suppose you see that pressure is up to 40, you can tell them that after decreasing your outlet resistance, you may be able to pass urine with such a pressure. And these things are important rather than number of times TURP is run and patient is still in the same condition, his uroflow is bad, he is still holding PVR, and then you are not happy, patient is not happy. So if you suspect that, it is better to have full information before you go ahead. And pressure flow studies is very important to detect what will be the outcome.
Yes, sir, definitely. In fact, it was disheartening to see that everywhere it is a weak recommendation. And in fact, for younger men, it is the diagnosis that is diagnostic test of choice. In fact, a video urodynamic is, and otherwise also it helps prognosticating. Although maybe you end up doing deobstructing both of the scenarios, but then it helps prognosticating. Yes, Dr. Umesh.
Can
yes,
I ask a question?
Last question.
Yeah. So, sir, is there a role of cystoscopy and size of prostate in deciding whether a urodynamic study should be done, particularly in young patient? Because many a times we see that a young patient of prostate, a big prostate with a median lobe with increased PVR. So in this scenario, we sometimes prefer to do a cystoscopy and relieve the symptoms by doing TURP and then decide whether he will be relieved
I
of
think
symptoms
that
or
comes
not.
later somewhere when you have already decided. If you go at the path flow of diagnostic algorithm, if you find that it is main of voiding LUTs are there and uroflow is poor, then in a younger male you will get a RGU, and if RGU is normal, then MCU at the same time, and if then you will move ahead with urodynamics. And then only if everything is in place and you feel that there is some bladder neck obstruction or early prostate, then only you will go ahead with a cystoscopy. I don't think cystoscopy to decide whether a urodynamic or not, that is it does not work.
Cystoscopy has now recently emerged as a investigation to be done, especially if you are choosing these minimally invasive procedures, want to see whether there is a median lobe or not. And and sometimes also when you are labeling the patient bladder neck obstruction, which I labeled it as a functional bladder neck obstruction. There is no obstruction in the bladder neck which is not relaxing. And when you have a look also that is a high bladder neck and it's not relaxing. So sometimes cystoscopy do helps, but yes, cystoscopy should not be done to decide whether urodynamics to be done or not. Cystoscopy should be done to have more information about these situations so that you can plan the procedure, especially suppose you are planning for urolift in this resume or I-tint, then probably cystoscopy is important investigation, see that whether is appropriate for that particular type of patient or not.
Yes, sir. But then you must have decided beforehand that this person requires deobstruction.
Yeah.
How that can be decided by cystoscopy?
Yeah, same way like if you see the previous recommendation was that ultrasound should not be done for prostate patient. But ultrasound is an important investigation for two things. Size of the gland is not, and we know that size of the gland has no correlation with degree of obstruction. But size of the gland helps us in deciding type of the therapy, whether you want to add dutasteride, whether you want to, which mode of surgery you want to do it. The size also helps us in deciding it. So size has got different, and ultrasound also gives us information about post-void residue and median lobe. And see the median lobe is also very important information. Size of the median lobe projecting into the bladder, if it is more than 1.5 centimeter, most of the time medical therapy will not help. So that's why probably these things are still hidden in guidelines and not clear-cut things are there. But you need your decision to make sure that what is happening and what is there and what is not there, and help you in choosing the proper procedure. And big median lobe, there is no need to put the patient on medical therapy. Most of them will not respond unless patient wants to try for that.
And high bladder neck, sir, on flexible cystoscopy these days, high bladder neck cannot be ascertained.
High bladder neck is one of the thing will give you suggestion that this is a functional bladder neck obstruction. But to prove that point, the best investigation is pressure flow studies, including with video aerodynamics,
yes,
which I published in 2000 in Journal of Urology. And we have seen similar thing happening in female also, which we have also published. That you will see that bladder neck either is not opening or intermittently opening, and you don't see proper funneling. If you don't see proper funneling, if you see intermittent opening, you see only streaks of things are coming bladder neck, and simultaneously you see that your P diffuser is very high and uroflow is leaky. Then its diagnosis is confirmed that this guy is not relaxing bladder neck.
Thank you, Dr. Nikhil. I think
thank you so much.
We move to the next talk by Dr. Tushar Aditya Narayan on current status of PSA screening. I again request the speaker to restrict to time, and the discussion can be restricted to 2 minutes.
Sure. So, very good morning to all of you, and a big thank you to Anand sir, Dr. Rohit and Dr. Pragnesh for this opportunity. My topic is quite simple. It's on PSA, unlike the other three topics. So, and I'm sure all urologists know everything about PSA. I will not be telling you anything new. But I'll take you to some of the studies, landmark studies that were done to establish whether PSA should be a screening tool or not. So just before I start, I want you to just answer these two questions in your head. Two scenarios. One, a patient of 60 years of age comes to you, IPSS of about 20 by 35, he is bothered. He's had medical therapy, combination therapy for about 2 years and is now wants a surgical therapy. So before going in for a surgery, would you advise a PSA test to him? So that's the first scenario. Second, should PSA be included in a mass screening program by Government of India or the private labs that do a health checkup? Should PSA be mandatory there? Should all males, irregardless of the age, get a PSA blood test done? So these are the two scenarios which I would discuss again in the end. So my outlook for the talk, history of PSA, benefits versus harms, the major trials which I'll focus on, the global guidelines, what are the new strategies that we're adopting, and the key takeaways. So I'll skip this because we all know what PSA is. It's a glycoprotein produced by epithelial cells, and it came in first in 1986. It was FDA approved. And the main thing is, the key point, that PSA is not exclusive to cancer, which all of us know. If we follow the timeline of PSA and the recommendations that came with PSA screening, it basically mimics the rise and fall of the detection of prostate cancer. Initially, when PSA was introduced, there was a boom in prostate cancer cases. There was a stage migration from metastatic to locally advanced diseases. But in the early 2000s, there were recommendations against PSA screening. So there was a decrease in the in the detection of PSA prostate cancer detection rates, and the increase in the mortality rates. So why is there a debate whether we should do a prostate cancer screening or not? Obviously, we know early detection saves lives, and some of the trials have shown that there is a decrease in the mortality with prostate cancer. But then there is also a risk of overdiagnosis and overtreatment. Many screen-detected cancers would be indolent. They would be Gleason 3+3. They would never harm the patient or do anything to the patient, and we are diagnosing those patients. Not just the disease, the detection of the disease, the biopsy, the treatment of the disease, all of this would harm the patient rather than benefit the patient. And obviously, there are a lot of false positives also. Elevated PSA can lead to anxiety, repeated testing like MRIs, repeated biopsies, and invasive biopsies for benign conditions. So the benefits, what's the evidence and the outcomes? So obviously, there have been studies, and especially the ERSPC, the European randomized study of screening for prostate cancer, which demonstrated a significant reduction in mortality. There was about 20% reduction in the mortality. There was decrease in metastatic disease. This is logical. If we do a PSA testing, obviously we would detect more patients in the localized disease stage, and there's obviously a stage shift from the metastatic to the localized disease. But what are the harms? Overdiagnosis, overtreatment, and obviously psychological distress, as all of this outlined here. Now coming to the first major trial that I want to talk about, the European randomized study for prostate cancer. This was in 2019. This is a brief of what the trial had. There were about 162,000 participants, and they published their outcomes at different variable intervals, and the latest data was at 16 years of follow-up, and they showed that there was a 20% reduction in the prostate cancer mortality. That's a good number, but then they said that the NNS stands for number needed to screen. To save one death, they had to screen about 740 patients. This number went on decreasing as the follow-up increased. So at 16 years, the number was 570. So they had to screen 570 patients to prevent one prostate cancer death. And the number, NND is number needed to diagnose, was between 18 to 26. So they needed to diagnose 18 to 26 patients to prevent one prostate cancer death. So this was the European trial. Next, coming to the PLCO trial, this was a mirror trial, but it was from the US. The prostate, lung, colorectal, and ovarian trial, the screening trial. There were about 76,000 men, and the intervention was annual PSA screening plus a rectal exam versus usual care. And they did not find any difference in the overall mortality. The European trial showed there is improvement in mortality. The American trial showed that there was no difference in mortality. But this trial had a lot of criticism because the control arm, there was a lot of contamination. A lot of patients went on and had a PSA testing in the control arm also. So a lot of authors have said that this was probably the reason why they could not show a difference in the overall mortality. The third major trial, this is a UK-based trial, the CAP trial. There were about 4 lakh men that were in this trial. This was a single time, one-time PSA testing. Obviously, there was low uptake. It was easy to do in the NHS because NHS beyond 50, all of them are sent a letter by the GP that you come and get the PSA testing done. So they sent a letter and get a PSA testing one time done, and that is where they were enrolled. And they also showed that they were, at 10 years, there was no benefit. You keep doing a PSA testing for the general population, there is no benefit. At 15 years follow-up, they showed a small, statistically significant improvement in the overall mortality. So the summary of the key trials again, ERSPC, they showed there is improvement in the overall mortality. PLCO, the USA one showed no improvement, and the UK one showed there is a small improvement. So this slide takes data from all of this. This is basically, this one is from Perplexity AI, and I put all the 3 papers there, and they came up with this data that if you, for example, if you take 1,000 men, if you screen 1,000 men, you will save 1 to 2 lives, you will prevent 3 metastases, but there will be 50 patients who will have erectile dysfunction, 15 patients who will have incontinence. There, in those 1,000, there will be 220 biopsies and 2 hospitalizations for various reasons. So the key recommendations of all these, the guidelines, the next are the guidelines. The UPSTF is the US one. All of these, there are 4 major guidelines, AUA, EAU, NICE, and obviously US Task Force. All of them say the same thing. You do PSA testing after informed decision, shared decision making, and the European one goes a little beyond and says use nomograms and MRI before the biopsy to decide if you need the biopsy. So basically it's just a play of words. All of them say don't screen the masses, pick out individuals, discuss the benefits and harms of PSA screening, and the European one says add an MRI before going on to do the biopsy after the PSA. So this is in detail about all the guidelines, so I'll skip that. I'll come to the EAU. EAU says initiate PSA screening about at 50 years of age, bring it down to 45 if there is a high risk African family history, BRCA1, BRCA2 positive. Do a baseline PSA and then decide. If at the age of 50 it's less than 1 and at the age of 60 it's less than 2, then increase the interval to almost 8 years. If it's more than 1 and more than 2 at this age, do once in 2 years, the PSA screening. And yes, they add that MRI should be done before a biopsy. This is the NICE guideline, again, says the same thing. Do informed decision making, talk to the patient. The main thing in talking to the patient is obviously about overdiagnosis, but to telling them also that if you have a Gleason 3+3 and even some Gleason 3+4 disease, you should go in for an active surveillance. And I've experienced that patients who were diagnosed with Gleason 3+3, 3+4, it was like they were not even given an option of surgery. They were just put onto active surveillance. They were not even asked if you want to do a surgery or radiation therapy. They were told this is your treatment option, active surveillance. Obviously, MRI, so this is the newer advancements are the inclusion of the MRI. The PROMISE and the Precision trial have shown that MRI has some place before doing the biopsy. And obviously incorporation of novel biomarkers, that's PHI, 4K score, PCA3 in the urine. All of this, if incorporated, the MRI, the biomarkers, would decrease the need of doing a biopsy, would decrease the diagnosis of low-risk prostate cancer and increase the yield of clinically significant prostate cancer, because that is what we want to find out. So the future of prostate cancer management, obviously MRI first, genomics and polygenic risk assessment, they should be, we are not still using them, but they should be incorporated in our decision making as to whether this patient should have a biopsy to detect clinically significant prostate cancer. Biomarkers, as I said, 4K score, PHI, PCA3 in the urine, and AI integration. Deep machine learning models are being developed, who will be fed the PSA data, family history, age of the patient, MRI findings if available, and they'll give you a score. If you do a biopsy, this is the risk of you having a significant prostate cancer. So the key takeaways from my talk, we should balance the harm and the benefit. Benefit, obviously, we detect prostate cancer at an earlier stage, we reduce the overall mortality. But what's the harm? Overdiagnosis, overtreatment, harm of biopsy, harm of doing a surgery for a Gleason 3+3 prostate cancer. Precision is paramount. Adopt targeted, informed, and risk-based screening strategies. Move away from blanket screening. Don't screen everyone. If you're beyond 50, okay, one PSA blood test, probably you can get to know your baseline, but you have to have a shared decision making. Embrace modern tools, that is MRI, integration of MRI and novel biomarkers before you decide which patient to do a PSA screening and biopsy, and prioritize active surveillance. Active surveillance probably in our country is a little underused. Gleason 3+3 and 3+4 can, some Gleason 3+4, not all, can be very good candidates for active screening. Thank you. I'll be happy to take any questions.
Thank you, Dr. Tushar. I think we can move to the OT because the OTs are ready and
Sir, please. Yes, sir.
Yeah, I have two questions.
Sir.
One is that the patient who is coming to OPD
Sir.
with low nucleic symptoms. So
that was my first question that I posed.
And
yes.
that parectal examination is normal.
Normal.
So do you do PSA or not?
If he has low impact symptoms, yes, I will do a PSA. That's what all the guidelines say, shared decision making. जिस दिन OPD में आ गया सर आप उससे बात करो PSA करने से ये हो सकता है, diagnose हो सकता है.
But he has symptoms. You
yes,
never know whether symptoms are related
I forgot to
that.
come back to my question, sir.
That
was
the one
thing.
thing.
Yes.
Second thing was I feel with development of the multiparametric MRI and more precision with new scorings.
Sir.
What is the role of biomarkers? Because MRI tells us there is a suspicious tumor or not. Then over there doing biomarker, will it help? Because biomarker are just
It adds, I agree with you, sir. MRIs are very sensitive, and if they're showing a pyrus.
and we also don't have these biomarkers.
Yes, we do.
with
That's
us.
the reason we don't have,
So-
because they don't add a lot of value.
So that's why I think the MRI is the final thing
Standard
which you will
one,
decide
yes.
about it rather than.
But it does add, because studies in the US have shown that it does improve the sensitivity of MRI when they are clubbed with MRI, but it doesn't help a lot and they are expensive. That's the reason why probably in India we don't have these biomarkers, sir.
Sir, the biomarkers are being developed to attain a biopsy-free pathway. That's what the research is going towards, to have a MP-MRI imaging along with the biomarker and omit the biopsy and go to a treatment.
Yeah, as sir has suggested, like most of the times we encounter, like let us say you are seeing a patient for LUTs and with BPH as background in your background. So in those patients, while prescribing an alpha blocker or some sort of surgical therapy, performing PSA is mandatory for every patient.
Yes. No,
But there, does it come that shared decision discussion is basically for those who are you're doing as a part of screening, who doesn't have LUTs.
Yes.
But the patient who comes to you with LUTs, where you're managing
You
as
should-
a case
you
of
should do-
BPH,
you should do
where
a
in
PSA screening, yes.
in those patients, I think we should do,
do.
because even the PSA value itself, even if you see the previous published data on outcome of failure of medical therapy, PSA also has a role. Like patients who had higher PSA levels,
Would
combination
respond.
therapy is preferred.
Yes.
Like in those things, in that way.
And another point that you made, before starting dutasteride, I think you should have a baseline
Yes,
PSA
yes, definitely.
before you start dutasteride therapy.
The whole discussion started.
Sir,
Just
can
one
we
point.
move to the OT now, because all the cases are ready and we need to start.
Last one question. Just last one. Sanjay, I was first. The whole discussion started with screening. And ultimately, inside your last slide, you said that MRI screening should be added. Now, the concept of screening was to add a test which was freely available, reproducible, and also cheap. So, where has MRI started to become a cheap screening test? I mean, in Jaipur, an MP-MRI costs 20,000. So, how would you screen your patients with an MP-MRI and then, say that it is a good screening test? No, PSA was the screening test which was started because it was pretty cheap. It did not require any inter-observer, as far as I remember. I mean, you had a PSA, that was it.
Yes.
But I think that
So
putting
MRI
this thing that an
No,
MP-MRI
MRI
would
is
be used
not
as
a screening
screening
tool.
is
No, no,
going
MRI
against
is-
the gambit of a screening
No,
test.
no, MRI is not a screening tool at all. It just adds to the sensitivity of PSA, whether which patient should be followed up further, and adds to the value of the
And
PSA.
also adding to that point, so the MRI screening protocol, what you are talking, is not the conventional multiparametric MRI. Because this idea came up
Yes.
particularly in UK,
UK, yeah, they're
where
doing
they
it.
do specifically a different protocol for MRI, which is very fast. It doesn't take much time, and specifically also to reduce the number of biopsies being
Biopsies.
performed.
So they are doing it
in that
routinely.
way, it will help.
I totally agree. This is a wonderful discussion which is going on. But however, even if you curtail your MP-MRI by doing a say whatever it is, a curtailed MRI, I mean, you cannot bring down the cost of the MRI to a screen test which will be applicable to a country like ours. I mean, you can bring down the cost from 18,000 to 10,000, 8,000, but still 8,000 is a large amount of money.
Yeah, so that's not screening for the masses. You do a PSA. That's what the UK people are doing.
But
Yes.
in the last slide, it was that your own last slide said that an MP-MRI may be incorporated as a screening test. I mean, if you go back to your own slide.
Before you go on to the biopsy, you did a PSA screening, and to decide which patients from that screening cohort should have a biopsy, you do a MRI. So that is the thing. It is cutting down. US, a large study, large cohort study is going on, and they're doing it for all patients. UK.
A patient with CKD or patient with liver dysfunction, in that case, in that group, will you advise for a screening or not? If advised, then what will be the cutoff value?
So it depends on his age, depends on the family history, depends if he has any symptoms. And if he is beyond 50 and he is interested in knowing his prostate cancer risk, yes, I would advise.
Then in that group, what will be your
So
cutoff
I'll
value?
corroborate with the MRI or the ultrasound findings, the PSA size, prostate size of the gland, the PSA density, and cutoffs. 4 is a higher cutoff for general population also. The UK, US, we are using 2 and 3 cutoff for these patients.
No. I think total PSA is metabolized by liver and free PSA by kidney. So both will be affected. Then that range will.
I'll do an MRI in this case to find out if there's something significant.
Sir, CKD, CLD have different cutoff values. I think that let's end it
Right,
here.
I'll end
Let's
it
move to the
here,
OR for the next session. I think we can have a different set of chairperson. Thank you so much. One talk is left in this, I guess.
Sir, I request all of you to be on the stage. So we'll connect with the operating
Prostator. We have Dr. Anil Kumar Vashne, who is demonstrating Moses with us. So is it audible to you?
Dr. Anil, can you hear us?
Audible and visible?
Very well, sir. We can see you, sir. Are we audible to you?
Yes, yes, yes.
Good morning, sir. This is Dr. Aditya Sharma from PGI. We can see you very well, sir.
Okay, Aditya, very good morning, and I must thank the organizers, especially Dr. Anand Kumar, Dr. Samit, Dr. Rohit, for having this wonderful event. And now, before we start, our case is to be presented. So, kindly present the case.
Good morning, respected faculty and delegates. Today, I am presenting a case capsule as part of the live operative demonstration. This case is being operated by Dr. Anil Vashne, Senior Director, Department of Urology, Max Hospital, Shalimar Bagh. So we have a 75-year-old gentleman. His chief complaints were that he presented with benign prostatic hyperplasia and refractory urinary retention. He is on indwelling catheters, which is being changed regularly since April 2024. He underwent right inguinal hernioplasty in the year 2000, which was likely to be a tissue repair. He also underwent TURP in 2009 after he developed an episode of acute urinary retention. His histopathology report was not available, but reported as benign by the patient. In December 2024, he had an episode of hematuria with clots, and it required clot evacuation. There was no evidence of bladder growth. He was planned for repeat TURP, but his PSA was 26, for which he underwent truss-guided prostate biopsy in June 2025, and which was suggestive of BPH. And there are no significant medical comorbidities. Examination-wise, his abdomen was soft, and he had a 16 French Foley's catheter in situ. He had right inguinal scar from prior hernioplasty. He had a reducible left direct inguinal hernia. His bilateral testes and cords examination were normal. On DRE, he had a grade 3 prostate gland, which was smooth, non-nodular, and non-tender. He was evaluated. His MRI prostate showed 130 grams prostate with median lobe, and he had a pyrite 3 lesion, and which was biopsied to be benign. He had a positive urine culture in view of catheter, for which he took adequate duration of levofloxacin. Right now, his PSA is 16, and his HbA1c is in euglycemic range. So the final diagnosis is benign prostatic enlargement with refractory urinary retention on indwelling catheter. The plan is that patient will undergo Moses laser enucleation for this large prostate, considering prior intervention and current refractory retention. I now invite Dr. Anil Vashne to begin the procedure and share his expert insights. Thank you.
So, good morning, friends. Once again, greetings from Max Saket, New Delhi. And can you see the endo view?
Yes, sir, we can see it, sir.
Yes, sir, we can see that. Yeah.
Okay, endo view is visible. Then I think we have done the cystoscopy. Is post TURP done in 2009. But if you see the kind of TURP is still intact median lobe, large lateral lobes, quite vascular gland, and these are the two lateral lobes. And if we come out, it's huge big prostate, and this is another overlapping tissues. And if you see here, then this is the viru. So this is a very extended viru, long this thing, and this apical tissue is coming distal to viru, and here we have the sphincter. So if you look at this prostate, then we have tried to look at the ureteric orifices. Actually, the median lobe is overhanging, so none of the ureteric orifices is visible. So the message for the learners is that if you are not able to see the ureteric orifices, don't try to push, because it will induce bleeding. Now, how to prevent any injury to ureteric orifice is the task here. And if you see the median lobe which is overhanging into the bladder, in such a case it is better to put one incision at, say, somewhere, this is 7 o'clock. So my plan will be that I'll make an incision right up to the Viru at 7 o'clock just to see and safeguard the orifices. So the only thing is that if you have any questions regarding anatomy, you can ask me. Otherwise, should we start?
Good morning, sir. I'm Dr. Manish from Max. Just one question. How do you decide the apical limit of your incision in this case, where the prostate is overhanging beyond the Viru?
That I'll show you. Just now. We just start from this point. Is it ready? Okay.
Good morning, sir. For the sake of audience, we would like to see the settings and the machine also. What are the settings?
Okay.
Yeah.
So if you see, this is a Moses 2.0 machine, and currently being a vascular prostate, we have set the settings. Show this settings. Settings here. These settings is I have kept it 2 joules 30 hertz for the enucleation and 1 joule 20 hertz for the coagulation. And if you see this equipment is same as classical for TURP resectoscope, 26 French continuous irrigation resectoscope. And this fiber is a Moses fiber, this one. So let us see whether it, have you seen the this thing, settings,
No,
laser
sir.
settings?
The machinery was not visible, sir.
Just show the laser settings.
Now it's there in PIP. Okay, sir.
Can you see the laser setting? This one.
Yeah, it can be zoomed a little bit, but we can get a hang of it, yeah.
Yes. So this is the equipment. It is very simple. You just have a key which it starts, and then you have a fiber which can be plugged in. You have to be very careful that fiber has to be absolutely clean so that it doesn't causes damage to the blast shield. And once it is on, all fibers must be inspected before starting the machine. And then this machine is has 2 pedals. Can you show these pedals? One is cutter and one is coagulation. So these pedals can be shown. Yes. So this one is on the left side and one is on the right side. So this is just like your accelerator and this thing, brake. So we can always start going. So can we start now?
Yes, sir. Please go ahead, sir.
Yes, sir. Start.
Okay.
Good morning, Varshney, sir.
Very good morning.
I want to know, is there any advantage of Moses over 100 watt luminous holmium laser? Once you are starting the procedure with 60 watt only, and as you rightly said, in a highly vascular gland, sometimes we start with 45 watt only. So does it give any advantage over a 100 watt laser machine, this Moses machine?
No, there is a basically advantage in technology. Technology means Moses creates a bubble which is different from the luminous 100 watt. If you look at the this thing, stone, there is no retropulsion. Similarly, when you use Moses, the energy is such that it causes dissection with coagulation. So that is why the publications and RCTs are in its favor, that it causes more efficient enucleation and hemostasis. So basically it is a technological difference. It is not a matter of energy. It could be 60, 80, 100, 150, but the technology is slightly improvised and improved. That is the only thing.
Okay, sir.
So with this we start, and this is the point at 7 o'clock where I am trying to start the groove, creation of a groove. And if you see that once we create this groove, our purpose is to reach to the bladder neck. And we are at bladder neck, but the question is that as I told you, that we have to understand that there is no injury to the ureteric orifice at this particular point. We have not seen the ureteric orifice. So how to prevent injury to the ureteric orifice is something which is important at this particular point. And if we appreciate there is some stone, phosphate stones, because 1 year this patient was on catheter. And when I removed this catheter, there was lot of pus flakes inside. Now, if you appreciate that, what I am going to do is that at the level of bladder neck, I am just going to widen it. So once you widen it, you have marked a proximal limit. So that is our goal that we mark. So our goal at this particular point is just try to reach to the capsular fibers. And once you have reached to the capsular fibers, to improve the irrigation dynamics, you have to widen this. So you can widen it on the right side. Similarly, you can widen it on the left side. Now this widening is something which is going to, because the biggest complication is undermining of trigone and injury to the ureteric orifices. So the first thing is that you have marked the proximal limit that will give you prevention from injury to the orifices as well as undermining. Now how you prevent undermining, that is another thing. For this we will just keep on coming like this in this groove right up to the viru. So this is the second step. Having made a proximal mark, now we are coming here. In this patient, because TURP was done, there are lot of synechial formations and lot of adhesions. So we will just not work towards the adhesion. Now the question is, the second question, you see the kind of synechial formation and the adhesions here, because whosoever has done the TURP, he has just removed few chips and that has created adhesion formation. So therefore our goal is just to create this groove and complete this groove right up to the bladder neck. So having done this groove, we can do N block also, but this is a large gland and I am not doing N block.
Dr. Varshney, sorry to interrupt you. Dr. Jha here from Axakit.
Yes, yes, Dr. Jha.
Sir, we are, the other OTs are ready as well, so we continue watching you and we'll get back to you soon and we can just switch over to the OT2 to get an idea of the case there.
I just want to show, Dr. Jha.
Yes, sir, please.
There was one question raised that how will you decide on the distal, proximal this thing, distal limit. So I just want to tell that this is the viru. So if this is the viru, see how prolonged is the viru.
Yes, sir.
And this is what the TURP has been done. And question is that this limit is also equally important. The first part was the bladder neck and second part is the apex. Now I just want to show you that apex is equally important, and what is important is scooping out here. Because the question somebody who asked was that how you decide that how much distal you have to come distal to the viru. So the point which has to be understood that it is adenoma, and if this is adenoma, you just have to respect the adenoma. If you respect the adenoma, wherever is the adenoma, you are focused on to the adenoma only. Now I'll just want to show you, this is known as scooping out. So when we are at the adenoma, we are least bothered about how distal it is going. What we are bothered about, that we are scooping it out of the capsule. So this is the gentle movement which the laser is doing, and the adenoma is being scooped out. Now similarly, this same procedure, now you will appreciate that this is the adenoma being scooped out here. Same way, this is the viru here, and same way here again, these are the synechiae, and we will scoop out the adenoma on this side. So this answers the question that how distal you have to go. So if some vessels are there, they will get coagulated, and this is again now you see on the right side. And another thing is there is a big vessel, but I am not bothered about this vessel just because it is on the side of the adenoma. So whatever is on the side of capsule, I will be bothered. Otherwise, I will just See, this is again the movement, scooping it out. See how the adenoma is being scooped out. Can you appreciate?
Yes, sir, very nicely demonstrated. We all can appreciate it. Just one small question. Do you
Yes.
make the 12 o'clock incision first or you do it later on during the procedure?
No, my
the
first
12
step is develop the floor.
Okay, sir.
So that is, we will now simply develop the floor. We have scooped out at the apex. You can appreciate the adenoma on top. And now you will be, we will not go to the 12 o'clock till we have developed the floor to satisfaction. And what do you mean by developing the floor? I will develop the floor from 3 o'clock to 9 o'clock.
Okay.
So having developed the floor from 3 to 9, then I will switch on to develop the roof from 9 to 3.
Okay.
So that will make my job very simple. So this is the capsular plane, and I am working on the adenoma. Adenoma is getting lifted up, and this is how we will just work our way, and we'll continue. You can go to the other OT now.
Thank you, sir, for a wonderful presentation. Now we'll switch on to OT 10, where Dr. Arup Nath is waiting, and he's ready with his surgery. So we'll first present the case in short, and then we'll hand over the mic to him.
Gentlemen, good morning again. I would want to present this case under the leadership of Professor Dr. Arup Kumar Nath, Chairman and Head of Urology Affairs at Institute of Urology and Kidney Diseases, Guwahati. So our patient is a 65-year-old gentleman with a history of obstructive lower urinary tract symptoms for last 5 years with no other complaints. He has been on tablet Urimax D for past 4 years without any significant improvement. Examination-wise, his abdomen, external genitalia and digital rectal examination were grossly normal. His blood and urine workup were normal. His PSA was 6.2. So an MRI was done, which suggested a 60 cc gland without any suspicious areas. His uroflow was, his Qmax.
Dr. Umar, we have lost you here.
Hello? The diagnosis was, the diagnosis is benign prostatic hyperplasia with failed medical management. After adequate evaluation, the decision was made to proceed with transurethral thulium fiber laser enucleation of prostate. The surgery is being performed by Dr. Arup Kumar Nath, and the goal is the complete removal of adenoma. Now handing over to Dr. Arup Kumar.
Dr. Umar,
Thank you.
we just missed the size of the gland. Can you please say it again? The size of this?
It was a 60 grams gland, sir, on MRI.
Okay, sure. Thank you.
Can we
Thank you,
switch
sir.
the screen to OR10?
Can we have the audio from OR10?
Hello.
Yes, sir, we can hear you. Dr. Jha here from Max Saket, yeah.
Sir. And has a 68 gram prostate and not responding to conservative treatment. So we have taken up for thulium fiber laser enucleation of prostate. In the meantime, we did the cystoscopy and seen some back pressure changes inside the bladder. Both the ureteric orifices are easily visible, And if you see, the urethra was capacious, and as you can see, there little enlargement of the median lobe and lateral lobar enlargement, and this is the verumontanum. The gland, you can see the margin here. So we'll do en bloc enucleation with thulium fiber laser, en bloc enucleation with that is anatomical endoscopic enucleation with early apical release, and we are using IPG 60 watt machine from IPG Life Sciences. It's a very dependable machine I'm using for last 5 years or so. And the lower track instrument from Custors, the endovision set from, I think, Stryker, and the morcellator, black morcellator from IPG again. So back to Piranha morcellator from IPG. And we'll first try to develop the plane at the peri-veru area. Because that is the area where the capsule is shallower and much thicker and easier to develop the plane between the adenoma and the surgical capsule. So we'll start doing developing the plane at the peri-veru area on the left side.
Sir, can you please tell the settings for the benefit of the audience? We had a brief view of the machine. Just settings once again of the laser machine.
Yes, for enucleation, I'm using free joule energy and 20 hertz frequency that makes the maximum power of that machine. At my place, I sometimes use up to 4 joule energy, and for coagulation, we are again using 30 watt, that is 0.1 joule and 300 hertz.
Okay, right, sir.
So if you use high power in thulium fiber laser, you can see that charring is very, very less, and you can better identify the capsule as you see in holmium laser.
I think audience should note this is an important point, as he mentioned that the capsule is thinnest at this point. Professor Andreas Gross called it the Hermann's pillars, and he punctures this bluntly initially so that you are into the capsule, vis-a-vis Dr. Anil Vashni, who started at the bladder neck first as compared to what Dr. Arup is showing. We have lost vision from OT10.
I have a question.
Yes, sir. Sudhi, sir.
Like, let us say for a novice surgeon who is actually starting doing this enucleation of prostates, as being done by Anil sir, where you can see he is using only the laser to make that plane and go. But for a beginner, you know, many a times when they start cutting like this, they enter into a deeper plane or a superficial plane. So, do you recommend that, like, whenever you start, use that passive force, like Andreas Gross actually he does most of the times
bluntly.
He does dissect that plane, which automatically opens up, and then wherever there are bleeders, they ablate it and then go. So what is the advice?
Dr. T. Manohar want to answer that question.
Yeah, I mean, I think it should not be done. The manual should not be done because it is easier to get into the plane, but then that plane takes you into the sphincteric pillars and it gets loosened up. So that is the most common cause of stress incontinence.
But suppose, let us say, if we give that mucosal incision to begin with, like the early apical release, you just give the incision all around, and then if you do that,
the same thing. What I do is the inverted V incision in front of the vero. You make incision, and actually, I mean, the concept has changed. We need to save these sphincteric pillars. To save the sphincteric pillars, you have to leave behind some kind of prostate tissue around the sphincteric pillars. Because if you go completely enucleation, you are bearing the sphincteric pillars, and stress continence is to the tune of 90%. Better to preserve some kind of tissue at the level of the sphincter. That can be done only on incision. In fact, to start with, the concept has changed from manual enucleation to incision. Actually, enucleation is not a complete enucleation. It's only about 30% enucleation. Rest are all resection and incisions. If you ask me that, because the whole sphincteric pillar has to be inside and has to be resected so that it is released earlier.
But sir, leaving that tissue at the apex, will it, like in some patients, affect voiding? Like, I mean, maybe that itself is actually causing some amount of
No,
obstruction
it
leading
is
to
very,
that
very
happen.
uncommon. It's very uncommon.
So it's actually a balance that you try to
Yeah.
leave that area.
So in fact, you have to have a enucleation. The enucleation zone occurs when the prostate is around 60-70 gram. If you choose for a 40-50 gram prostate, you will end up in problem initially itself. In fact, enucleating zone happens bigger the prostate. So if you want to start the case, 60 gram, 65 gram is better. More than 50 gram is better, so that you have complete vision of what you are doing it, and then slowly you can increase the size of the prostate.
Actually, you should not apply passive force. Once you give the incision, it's the water flow, as you just see the attaching fibers. Simple thing, just the attaching fibers, keep cutting attaching fiber, it will keep lifting it. If you put your passive force, then it will tear it. And especially if you are doing from 9 to 12 passive force, it will pull the sphincter in, and that's how the problem will occur. So you have to give incision, it's the water flow and all attaching fibers. You will see the white fibers attaching, just cut, it will keep moving, keep moving, keep moving.
Can we switch over to the third OT now?
That's a different way of doing it.
We can continue watching these.
I think a lot of papers which has come for bipolar TRP, they have completely stopped. I think if you see any papers coming bipolar enucleation, it's completely stopped. Even in Indian, a lot of people who are doing it, it's been stopped because a lot of stress incontinence. No, he also stopped. He said that it cannot be replicated. I asked him. No, last week I was asking him, why did you stop it? He said that no, it cannot be replicated by others. That's it.
Actually, sir, the problem with, I can understand what he's trying to ask, because he's using thulium YAG laser, which has a little more charring effect as compared to the thulium fiber and holmium YAG laser. So in that case, I think a lot of time we tend to do a blunt dissection and then cut those fibers, because that charring masks the capsule area. So what is your take on that use of thulium YAG, a 200 watt laser?
I mean, I've used only the thulium. Initially, I used it, but then again, the tissue plane entry is more. See, what is this Moses or holmium is causing is, basically they produces the pulse. Pulse is the one which separates the tissue immediately. It doesn't cut. It doesn't enter into the tissue plane. That's what the Moses is actually, the tissue separation. Once you enter into it, you will get into the plane of dissection very quickly into the capsule. So where you are not entering into the tissue. That is the advantage of holmium. The separation of the tissue, holmium against thulium, YAG is, holmium YAG has got a enucleation effect and tissue effect, which takes about a minute to enter into the capsule. Vice versa, in holmium, you enter into the capsule because the tissue separation is faster. That's why you don't require to do any enucleation manual there.
Just a point of thought in a mechanical enucleation. This is how things evolve. Previously, number of techniques have come which showed a mechanical force applied, but incontinence was much more. And the dreaded thing in all these lasers was in the initial phases, you see, all of those who have tried had much more. Now they have evolved. All of them become wise. In sphincteric area, better to leave some tissue rather than doing incontinence. So you don't have to apply any mechanical force because it is going to damage. So this is a wisdom. You keep on evolving the things, and things comes and goes, and once effervescence settle, then consensus comes. So now consensus is there. You don't have to apply mechanical force. Whether it is any technique, you have to just cut it sharply.
So can we please move to the third OT now? Dr. Vivek seems to be ready with the case.
Good morning, gentlemen. Am I audible?
Yes, you are.
Can you please put on the slides? Are the slides visible, sir?
No, we are seeing the two ORs. And in one OR, we don't have an endo view.
Dr. Rohit, we can see Dr. Vivek, the slides are not visible, and The audio is not there from this OT. Yeah.
ये डाटा पे है ना?
Are the slides visible now?
Yes, it is visible now.
Now I'm presenting the third case capsule. It is to be done under the care of Dr. Ashish Saini, consultant, Excel Urology Center, New Delhi, and ex-assistant professor, AIMS, New Delhi. So we have a 79-year-old gentleman with history of benign prostatic hyperplasia with refractory retention despite medical medications. He is on indwelling catheter since April 2025. So he has a significant past medical history of hypertension, coronary artery disease, status post PTCA in 2018. He is on ecosprin right now. So his key findings are that his prostate is 63 grams with median lobe enlargement. His PSA is 12.7 and his prostate MRI shows a pyrite 3 lesion in right anterior transitional zone apex, which measures about 13 into 10 millimeter. There's a bladder wall thickening with diverticulum suggestive of changes of bladder outlet obstruction, and his uroflow pattern is poor. So here's the flow pattern that you can see. So his plan is a transrectal fusion prostate biopsy for evaluation of raised PSA and suspicious lesion, and followed by Thuflep for definitive management of bladder outlet obstruction. Thank you, sir.
Hello. Am I audible? Hello?
Yes, yes, Dr. Vivek, we can hear you. Yeah.
Good morning, all of you. I am Dr. Vivek Vasudev from Max Saket. Thank you for the opportunity. This case, we have raised serum PSA. So before doing the enucleation procedure, we are doing a fusion biopsy of prostate, transrectal with the BK5000 machine. So I'll just explain regarding the basics. First is the position. This procedure we can do it under local anesthesia. So the patient is in left lateral position, right side up. The pelvis should be straight because slight tilt in the pelvis, and you can have to move the ultrasound transducer too much. The second is the ultrasound probe. It is the regular biplanar probe. If you can see it, it has two transducers, one on the end, one on the side. So we'll be doing the prostate biopsy with the end fire because the MRI lesion is in the anterior transitional zone. So it is a better idea to do an end fire transrectal prostate biopsy because with the side fire, the hit is very shallow. So chances of missing the anterior lesion is very high. So we'll be using the end fire probe. Then we have the next is this tracker. This is a device which reads the movement of the probe, because if we are doing a MRI fusion biopsy, we need to first superimpose the images of the ultrasound and the MRI. Then we have to read the movement of the probe. So whether the probe is moving towards the base, towards the apex, so that is picked up by this transducer, and it sends some electromagnetic waves, and there is a sensor which is over the ultrasound probe connected with a wire, and it goes to the machine. So movement of this probe is picked up by this tracker. The tracker has this Eiffel Tower kind of sign. So this Eiffel Tower should face the this sensor. So, and this is the machine. This is the BK5000 machine, little advanced one. But it is mostly same as the previous versions of the BK. The good thing is that we have the fusion facility both for transrectal and transperineal. The difference with the transperineal fusion is that with the transperineal we have a stabilized thing, and with transrectal the probe is in hand. The MRI I already told that it is a 58 cc gland with right anterior transitional zone lesion of around 10 mm, that is around 9-10 mm. So now we start with the procedure. First I will demonstrate the local anesthesia, and then I'll start the fusion biopsy, and then I'll do the systematic biopsy.
Dr. Vivek, why are you planning both the procedures simultaneously and not waiting for the biopsy report to come?
So one is that the patient is quite old. Anyways, he will not be fit for any radical procedure later on, and he is on indwelling catheter since long. So we want to get him rid of the catheter. If after the biopsy, if it comes positive, then we can plan him on some kind of hormone therapy as per his age. And that is why we are planning both the procedures in the same sitting.
But
So these-
I have a comment on this.
Yep.
One thing is the lesion on MRI is a Pyrites 3 lesion. And
Right.
That lesion is specifically there in the transitional zone. So most of the times the indication for biopsy in a Pyrites 3 lesion is equivocal. More so, if the lesion is in the transitional zone, it's more likely benign. So there is definitely a debate in this of whether to do a biopsy or not for a lesion Pyrites 3 in a transitional zone. The other question regarding as Dr. Aditya has rightly pointed, if you have planned a biopsy, then why the surgical procedure? Because let us say this patient biopsy comes out to be positive. Obviously, the management of CA prostate, even though if he is in retention, sometimes patients do respond to hormonal therapy coming out of the retention part with medical therapy also. So I would definitely go against going for a definitive surgical procedure in this case if you are planning for biopsy. I mean, the rest of the opinion, maybe the house can give comments on this.
Right, that is the thing. But I think with such a large median lobe, the chances of getting him off catheter just with a ADT is very less likely. And many people in our practice, in the audiences, must be doing the channeling procedure upfront.
But even we have seen patients with obstructive uropathy, I am saying, patient present with raised creatinine with CA prostate, after hormonal therapy, they come out of even the PCNs which were there, the gland shrink significantly.
May I intervene you, Dr. Sudhir?
Yeah.
If disease is localized, not metastatic, what is the role of putting him on any hormonal treatment? You just do TRP and send the patient and wait and watch for metastasis to appear.
Yes, sir.
Only then you start your hormonal
Yes, sir.
treatment.
Then you don't resort to biopsy in that case. That's my point.
Yes, that's what the point is.
There are 2 points. Is that the 75-year-old, we discussed it, what you are saying it. We discussed it before posting this patient here. So there was 2 things. He is on catheter for long. He has a lot of comorbidity. He is not a candidate for any curative intent therapy if it comes out. And his lifespan is also not much. But he wants to get rid of this catheter. So, and he has a Pyrites 3 lesion. So the question is, we'll have a biopsy and we'll take care of his retention. And biopsy will help us in future. We are not going to start hormone treatment now. As and when required, we'll have information about if he has a cancer. And required, then we will institute hormonal therapy as and when required. And we will avoid, and because he's so much of comorbidity, so we're taking this. And that next question, what you said, there is a very nice paper published long back that those patients who are in retention, if you just do bilateral archectomy or hormone treatment, only 50% will have relieving of retention in minimum of 30 days of catheterization. Like it will take 30 days for hormone to shrink the prostate in a sufficient size to have, and 50% will not void. So looking his all the condition, everything, we thought probably we'll take the opportunity to do the biopsy and then follow up and see the things.
The problem with the biopsy is infection. That is our main concern when you
So in the hello? Right. In the meanwhile, we'll switch to OT10. Dr. Arup wants to make some point.
You are doing a transrectal biopsy and
please.
then going ahead with a definitive procedure. Are you not worried about the infection? And if infection happens, it can be a disastrous consequence.
This patient had a culture you have seen, and he has been started antibiotic 3 days before, appropriate antibiotic. So in appropriate antibiotic cover, this is the dictum that you give 3 days antibiotic and then do the operation, continue same antibiotic till the catheter is out. So that way you can pull through, and this happens in the patient who has in prolonged catheter. They 100% they are infection. So the only way is start the appropriate antibiotic for 72 hours, take care of the problem and give antibiotic till the catheter is out.
If we go theoretically, then there is thing that transrectal could have been avoided and transperineal could have been done.
One simple question in this regard. Can a patient with a pyrite 3 lesion who have likelihood of having NCA cannot have a significant prostatic problem with such a large median lobe? Cannot both things coexist? When there is a significant BPH, especially large median lobe, there have been studies, those who have large median lobe are unlikely to respond to medical treatment. So when there is a median lobe, big median lobe, he wants relief. It is a patient relief. And he is a morbid patient, unlikely to have any significant radical procedure. So why not to do TURP, which will, or whatever procedure is done, so that at least he gets relief of it. He has a life expectancy of such a morbid patient, 5 to 10 years. Whatever pathology may later on come out.
Sir, my point here is that the prostate biopsy itself would hamper the planes and make enucleation difficult. And in this patient, the possibility of having significant disease is nearly negligible. I would skip biopsy and do only enucleation, that I would accept. But to do biopsy and enucleation at the same time probably is not justified, sir. Second, we know that median lobe itself raises PSA. So patients with median lobe, even without malignancy, are likely to have a higher PSA than those without a median lobe. So in this patient, probably, sir, either we do biopsy and stage the enucleation or skip biopsy and do only enucleation.
Sir, I have one more point to that. Since there is a doubt of malignancy in this case, do you suggest rather than enucleation, is TURP better? Because why I am telling is because you know the number of percentage of tumor which is involving the gland, you will get that idea. And with that also, many a times your treatment, whether it is a low risk or high risk also, that decisions also will come up based on the biopsy of the TURP resection. So is it that in such doubtful cases, that we should not go for a enucleation rather than go for a TURP?
No.
Any comment on that?
I do not see any reason why it should be different. You see, rather we would get a higher tissue with enucleation.
I
Morcellation doesn't hamper the histopathology. That has been proven without doubt.
Correct.
Yeah, I totally agree with Dr. Pankaj that amount of tissue available for in HOLAP is enormous, and we have seen 8 to 10% of the benign gland showing up malignancy in the histopathology report in HOLAPs as compared to TURP. In this case, we are talking about logical thinking. It is a logical procedure which has been done. In fact, the PRR score is in the transitional zone. In either way, transitional zone will be taken out. It's not in the peripheral zone. I don't think biopsy is not at all required in this case. So since it is a peripheral zone, transitional zone, just a TURP or enucleation will give everything in this.
So TULAP was never in question, the biopsy was in question.
Yeah, that's what. I also would avoid
Exactly,
biopsy because infection rate is definitely the bothersome thing.
Dr. Arup, are you connected?
So we'll now connect to Dr. Arup's OT.
Yeah, please.
He wants to make some point, and then we'll move on to Dr. Vivek.
Yes.
Thank you.
Hello. Hello.
Yeah, hello. We can hear you, Dr. Arup. Yeah.
Sir, as you could see that we did complete apical dissection, and on the right side at 11 and to 12 o'clock position, you can see that this sphincter fiber I am separating, and you can see that we have already enucleated earlier up to 9 o'clock position. Now we made an incision at 12 o'clock and then entered into the space between the capsule and the adenoma. Now you can see that I will just join this, and whole gland will be separated from the capsular fiber. Then we will continue enucleating in this plane. As you can see that I am using the laser fiber to just divide the fine attachment between the capsule and the adenoma. So we need to apply minimum force, not a mechanical force, minimum force to make the thing stretched out, so that we can see the exact plane where, as you can see, that I am using the laser fiber just to divide the fine attachment between the capsule and the adenoma.
So now we'll move on to OT 11, where Dr. Vivek is waiting. Please switch to OT 11.
Hello?
Yeah, Dr. Vivek, we can hear you. Can you just
Yes, sir.
briefly tell, and then we'll move on with the presentations over here.
Right, and I'll just quickly finish it up. I'll just show the local anesthesia. So we just go inside till the base of the prostate. We visualize the seminal vesicles and go on the one side. We see the tip of the vesicles. Yeah, and then we go on with our needle. And there we, just below the seminal, tip of the seminal vesicles, we inflate around 2.5, 3 ml of local anesthesia. Then we go on the other side, again over the tips. Yeah, you can see the bleb rising there, just below the seminal vesicles. And the third point is below at the level of apex, maybe around the dentate line, and here also we put some local. Now I am switching to the fusion. So the MRI information is already loaded in the machine. The first step is we just lock the fusion alignment. So this is the predicted or the information which we have marked from the MRI. We just overlap it. Yeah, so this is the mid-sagittal view. We just drag this MRI outline over the ultrasound image and we just lock fusion alignment. So after locking, with the movement of the probe, the MRI information or MRI image is synced and the machine is telling the same. We can check on the other planes whether the marking is right or not, and then proceed. So since the lesion is in anterior transition zone, I want to take this in the end fire. The lesion is on the right anterior transition zone near the apex. So here comes the lesion marked in the pink and the prostate is marked with blue. So I'm just starting with the fusion part first. Fusion. So we can mark it in the machine. Yeah. So that we can later on generate the report. This is the first code. Yeah. One more core and we'll be done. फोन देख लेना एक और ले लो okay one more code, this will be the last. That's it. Now I will proceed with the systematic biopsy, the regular biplanar one.
Dr.
And-
Vivek, we can continue watching you, the systematic biopsies. I'm sure most of us would be aware how to proceed with it. And we will
Right,
carry
right.
on with the presentations over here and we'll continue watching you on screen. Yeah.
Okay, sure, sure. Thank you, sir.
Coming back to the last lecture of the first session, Dr. Amit Agrawal. So please come on.
Good morning, everyone. I'll be speaking on topic bladder diary, time-consuming task or must. I thank Max Prostate Conclave team for giving me this opportunity. I'll be keeping my talk short and related to clinically aspects of the bladder
Dr.
diary.
Amit, can we just hold on for a minute? Dr. Varshney wants to talk. He is about to show something here. Can we switch to Dr. Varshney's OT, please?
Me? Hello?
Yes, sir, we can hear you. Yeah.
Okay, so just I wanted to show you that the point which is important is that as I told you that first step is you develop the floor and right up to 9 o'clock. So if we have to see, we have developed the floor, it's a large gland, but then the floor has been developed right up to 9 o'clock here. And if you look at what we have done, this is all the capsular fibers and we have worked beneath the adenoma. And this is where the capsular fibers are seen right up to bladder neck. Now same thing has been done on this side. This is the median lobe and we have worked our way right up to 3 o'clock and this is our 3 o'clock and going there. Now after this, I was asked this question that when will you go to the anterior, 12 o'clock. So now this is the time that we move to 12 o'clock. From here, we have defined our limits, and this is the adenoma, and this is how the extended adenoma is. And now we will develop the roof. To develop the roof, we reach to the this thing, 12 o'clock, and at 12 o'clock, the early apical release is the principle. So in this principle, what we have to do is that we have to come back to the sphincter. So if you look, this is the sphincter. So can you appreciate the sphincter now?
Yes, sir, very well. Yeah.
So if we appreciate the sphincter, we go 5 millimeter proximal anteriorly, and then we develop the this incision. We have a point that we develop an artificial viru at this particular point. So what is this? I always say that this is how we develop the wings of a butterfly. So on both the sides, we'll work our way right up to the capsular plane, leaving a small artificial viru in the center. So that will create a, that is how we call it early apical release anteriorly. And can you appreciate that we have reached up to the capsular fibers anteriorly? So same way, if you are developing this plane, what I wanted to show was this kind of a artificial viru is being created. Can you appreciate this?
Yes, sir, very nicely. It's a nice point
And
of
now we will work our way onto the anterior part of the adenoma. So this is how we are going to work here. And same way we will work on the other side and we will create this capsular plane. Now this capsular plane is going to meet at 3 o'clock. And that will finish our job in the sense that this is just a adenomatous plane. So reaching to the correct plane is vital and leaving this tissue is important anteriorly so that as Manohar was telling that the philosophy has changed and early apical release is important. Capsular reach is very, very important. And now this is all what we are aiming at. Leaving this. This is the mucosal strip. So this is the point I wanted to make, that how you prevent any kind of stretch onto the capsule anteriorly by making this cut. So with this you can move to the lecture and then we'll show you how what we are done. This is development of the roof.
Yes, sir. Thank you so much, Dr. Varshney. It was very nicely demonstrated. We'll move on with Dr. Amit now. Yeah.
Thank you.
So I'll start my talk. Different types of bladder diary maturation time chart in which we just record the time of voids, patient voids in the night or daytime. Frequency volume chart records the time and volume of each maturation, and the standard bladder diary which records the type of fluid, volume of fluid, time and volume of each void, and episodes of incontinence, urgency, etc. So it's a non-invasive tool, as Sudhir sir has already told. All the guidelines have a strong recommendation to include bladder diary in the evaluation of lower urinary tract symptoms. So I'll just skip it. I conducted a Google poll for all the clinicians to answer this question: in how many patients with lower urinary tract symptoms do you feel a bladder diary is clinically indicated? So less than 60% says that less than 25% of their patients need a bladder diary. I would like to comment from chairpersons if they agree with this poll. Aditya sir.
I think that reflects quite correctly. Less than 25% of LUTS patients will require that.
So yes, we agree with this poll that less than 25% of our patients require a bladder diary. And in those patients, do you actually advise bladder diaries? 40% it has reduced. So only 40% patient says that they actually advise a bladder diary. So I think it also depends on the clinical scenario and the health setup where clinician is practicing. In corporate sector, sometimes patients want treatment on a quick basis, and so clinicians also skip the bladder diary. So general points to record: time and frequency of urination, volume of urine produced, urgency level, number and severity of incontinence episodes, fluid intake, type, volume, and time of fluids. And more important is associated symptoms or triggers such as pain, leakage, discomfort, or activities that provoke symptoms. These are the various parameters which we can derive from voiding diaries. Most important is the nocturnal polyuria and the maximum voided volume, which was initially the functional bladder capacity. So these bladder diary can help us in identification of patterns, make a diagnosis, treatment planning, and more important as a baseline for monitoring progress. Some of the frequent findings of bladder diary: when patient comes with bladder diary after 3 days, we find that there were normal frequency and voided volumes. Patient was bothersome without any reason. And another is increased frequency and normal volumes. So this indicates that patient is having high fluid intake or having comorbidities like diabetes mellitus, diabetes insipidus. And one scenario is reduced volumes with minimum variation in the volume voided, which can be present in cases like bladder pain syndrome, interstitial cystitis. Reduced volumes with variation in the volume voided. This is the important one. This might indicate that patient is having detrusor overactivity, as this variation in the volume voided. And then increased nocturnal production of urine, that is nocturnal polyuria, may have some medical comorbidities like cardiac failure, hormonal and fluid imbalance, or maybe idiopathic in origin rather than having any urological connection. So how do we guide a patient to note bladder diary? So this is the guideline recommended ICIQ bladder diary. They recommend a 3-day bladder diary. We'll just discuss about it. So we need to tell the patient in a non-technical language, not voiding, maturation. We just need to explain the patient in a layman term and to reflect the important circumstances, whether he need to record that in workplace or home environment, the container to be used for measuring the volume, and especially in the females, we need to specify the type of container, the big mouth container, and the privacy also. So this is the main crux of this talk, that what challenges do we face in real time while making a bladder diary for the patients as well as the clinicians. So I would require feedback from the expert panelists, from the expert chairpersons and audience for this. First, if we encounter a patient with low literacy or cognition level, how should we ask them to get a bladder diary done? And even from the chairpersons, how, if they have encountered a patient who is illiterate, and how they advise that patient to make a bladder diary?
So we had a lot of experience with the bladder diary which was needed at our institute at SGPGI in the kids. So kids are usually not of that literacy and cognition level that they can themselves do. So we have to advise one attendant who is educated. We can do that similar thing with the adults also. If somebody is not understanding, then we can just make a good chart, make the times, the ready-made available diaries can also be given, and to the attendant we can tell that he should, if it is possible to accompany the patient, if he is in the home all the time, then he can do that for the
So if
that patient.
that patient is having nocturia and he's waking up 4 to 5 times in the night, so that attendant will note it in the night, or the patient will tell?
No, if the
next day
patient
to
is
the
not
attendant?
self-able to not or not to spill the urine, then the attendant has to be there. That is the cumbersome part of the
Aditya
bladder
sir,
diary.
if you want to make any point.
I think there was a very nice paper from Safdarjung group, Dr. Pawan
Yeah.
Vasudeva group. They have advised using pebbles.
Yeah, we are coming
and
to
then
that,
I think that was a very nice way to tell illiterate people, a lot of patients who come to our setup. Second thing, I always find that the quality of bladder diary will be proportion to what time you spend on the patient telling him how to make a diary. So he can have a small chat with patient coming telling that I went for frequency this many times versus a bladder diary as Dr. Sudhir has shown in his figure. So amount of time you spend and exactly tell them what exactly needs to be done is to be told, especially patients if they are on PC and all those things. So you need to spend time with the patient, and for the lower literacy, I think I found that paper very, very interesting and
Yeah,
useful.
we are coming to that paper only. So as sir was talking about the paper from Safdarjung Hospital, so they used 2 containers and the pebbles of different color, and similar paper was written from my alma mater AIMS Jodhpur. Dr. Nikita Srivastava is very fond of bladder diary, so both papers are kind of similar thing. They have used containers and different color pebbles, but in Safdarjung Hospital they admitted the patient for bladder diary for 2 days. So I don't think whether it is feasible in corporate sector for admitting the patient, because even in the corporate sector sometimes you can have an illiterate or low cognition level patient. So if anyone can tell how to manage that patient, Jha sir.
The type of patients that we encounter, if we tell them properly what to do, and it's very easy to get a jar with a marking and just to measure, get a marking glass or something, and just to keep a account of how much they are drinking in a day and how much urine and when they are passing. So it's easy, someone in the family can do it very well. So we don't encounter such illiterate people who won't follow this kind of an advice. Yes.
Okay, sir. So the clinical scenarios, guidelines recommend bladder diary for 3 days. Do we agree with that 3 days bladder diary is actually required? If I may ask Sudhir sir, he is very fond of bladder diary. 1 or 2 days bladder diary suffice. What information we get from 3 days, can we get it from 1 day or 2 days? Not 1 day, even for 2 days?
I agree to that point. You know, many a times doing for 3 days is cumbersome for the patient also. You know, you need to, if they are working profession, I mean, it's very hardly difficult for them to even document entire day for so many days. But yes, fairly 2 days is a good idea. You know, you will get that good idea as to what is happening to him. So I think rather than 3 days, 2 days is enough practically if you ask me.
So in your practice, you are advising for 2 days?
I advise 3 days commonly, but if he is unable to do, I generally say 2 days. I
Okay.
mean, most
So
of the
from
patients, you
3
know,
days we have
elderly
reduced
patients,
it to
I
2
advise them
days.
to for 2 to 3 days.
Okay, sir.
So 2 days is a good enough period. You can get a fair idea actually what is happening.
Nachiket, sir.
No, I think that the guidelines said for 7 days, and in OPD, especially for patients who are coming from rural setting and coming for 7, it was difficult. So that's why then from 7 they reduced to 3 days. Presently, there is no guideline that you can make it lesser than 3 days. This is because, remember, when patients are traveling, then it's very consequential and the circumstances become difficult. They change. I mean, they're traveling, they're not at home, they're not having the same thing. So I don't think that you can get below 3 days. Is because from 7 it was abbreviated to 3 days. And I think that 3 days
sir,
minimum is the
these
diary.
3 days should be continuous or intermittent?
Yeah, just about.
Sorry, sir, please.
Just about illiterate patient, there is always one smart patient along with the patient. He may be illiterate, but he is smart enough. So one thing is acquiring a measuring flask, which is not available commonly. So you should tell him a shop where to buy a measuring flask, then he should bring it, and then you should explain him each procedure in detail. Otherwise, your one nurse should be dedicated for that. Otherwise, he will do hayward. he will do whatever, he will come with a diarrhea and you will not get enough information. One is exact measurement कि और उसको कैसे सफाई रखना है ये भी आपको उसको बताना पड़ेगा.
Yes, sir. For these containers issue, we used to use 3-liter bottles which we use in TURP and the IV plastic bottles at AIIMS Jodhpur to give them handover to the patient for the collection purposes.
That can be done. That can be done, and sampling measuring flask have very good hygiene because you can wash it and throw it away. And what we have done, we have told him a shop, you can procure it from there, it is very cheap, and then can measure and throw away, then wait. And there is always, you have to, this is a clinician has to identify who is a smart person who is bringing an illiterate patient. Illiterate patient does not come himself. There is always one person you have to identify, and that is also sometimes a bread owner who also pays for that. So these two identification actually helps in making the good diary. And maybe 2-3 days, if they make it for 3 days, there are some patients, they may be sounding illiterate, but they make such a meticulous diary for a long time, you get a lot of information from that.
Dr. Amit, 2 OTs are waiting just to show some point of technique, so if you can just wrap it up fast and
Okay, sir.
move to
Just
the OTs. Yeah.
questions to these questions, should these 3 days be continuous or intermittent? So what advantage we are getting from being continuous rather than, so we want IT person to stay at home for 3 days, or he can go to office and collect the information for bladder diary? And these are clinical practices which we have to guide to our patients. How will he carry the container in his office to?
See, one of the practical issues that you face is for the patient to make a 3 days continuous diary. It's almost next to impossible.
Yeah,
you tell them to bring a bladder diary. Yes, it is more informative, but they will bring it after 6 months. What I follow in my practice is that either on a long weekend you can tell them to do that. Otherwise, it is more convenient to have 3 random days.
So we are reaching to a conclusion that these 3 days cannot be continuous.
It's almost, it's very difficult.
Okay.
Like it's like only 10% of patients will bring you a 3-day continuous diary.
So I would request Anand sir to please put light whether 3 days should be continuous or intermittent, weekdays or weekend.
And till the Monday morning if you are working, or otherwise the weekend. So most of the time they come with the 2 days only, and that we get important information.
No, sir. No, clinical evidence says that a minimum 3 days diary should be there, but we are talking on clinical aspects. So when patient is coming to our clinic, how should we counsel them?
Dr. Amit, we are running out of time.
Okay,
Your
sir,
time is over long back.
I think we have discussed the main points. I'll skip here.
Anyways, IT professionals, they are working from home, you were asking.
Yeah, thank you.
Just I want to add two additional comments regarding bladder diary. One thing is many a times we have to tell to our patients that this bladder diary documentation should be his natural problem which is happening day in day out. Many a times what happens, the moment you say bladder diary, they start drinking more water and just keep on recording things. So that's why we should educate them that it is not that you are, since I told you that you are writing like this, you have to just do whatever is happening daily void, you just mention it in a paper, that's it. That is one point. The other point is regarding in which patients we have to advise this. In that I would specifically say that not all patients need bladder diary. Specifically storage predominant lower urinary tract symptoms where there is significantly higher frequency and nocturia. In those patients where you have to dissect out as to what are the possibilities, because there lot of etiologies overlap there. Like it could be a case of interstitial cystitis, it could be a case of overactive bladder.
Sir, we can continue these discussions in the lunch time now.
Okay.
The OTs, there are 2 OTs are waiting. Okay, thank you. So can we move to the OT, please?
So we conclude our first session. So thank you, sir. We'll move to our next lecture session simultaneously. I would invite the next
switch to the OT
panel.
first because they're waiting to show. Sir.
Yes, I would call the next panel of chairpersons for the time being.
Hello? Hello?
So,
hello, am I audible?
Pankaj sir.
Hello? Hello.
Pankaj God, sir. Photograph. Please connect to the OT simultaneously.
Hello.
Yes, sir, we are listening you.
Okay. As we have already discussed the apical dissection, and in the meantime, I did the mid fossa. Now you can see that this is bladder neck, and we are at 12 o'clock position. You can see the bladder neck fibers, which Dr. Sansa described as the rain under the bridge. So just by puncturing this, we will enter the bladder. And in the meantime, you can see that this is the area verumontanum, where I have enucleated on both the side. You can see on the left side, and this is on the right side. We have completely dissected it, and then finally at 12 o'clock position, as we regularly enter the bladder at 12 o'clock position, and then control the dissection around the bladder neck from up downwards, from top to bottom, and that makes life easier to maintain the bladder neck contour. At the same time, there is no sense of going subtrigonal or something like that, because we will be coming from lateral side at floor to the medial side. And you can see that by just dividing these fibers, we will enter into the bladder. We are already inside the bladder. Now, the weight of the adenoma will help me to do the bladder neck dissection, because the adenoma will now, on its own weight, it will fall down, and we can control the bladder neck dissection like this, because we have almost completed the dissection. And you can see that I can just put some pressure there and control the dissection at the bladder neck, and we'll go up to 6 o'clock from this side, and then we'll come to 6 o'clock from other side. Here you can see that we can see the trigon and ureteric orifices here. While doing the enucleation from side to medial side, from lateral side to medial, we can even have a look of the trigon and the ureteric orifices, you can see. So this is the way we will complete the dissection. And as you know, the thulium fiber laser is the best hemostatic laser available. So you can see a beautiful capsule. At the same time, there is not much of bleeding. So I will continue dissecting. As you can see that with little force, we can see the attachment between the fiber and the adenoma, and we will control with controlled dissection near the bladder neck. We will go up to 6 o'clock from this side, because we have already, you can see that we have dissected till mid fossa. We just need to connect it and dissect it at the bladder neck. This is the median lobe. We'll dissect it like this. You can see that I'll do like a sleeve dissection. So I'll not put my laser fiber here and activate it. I'll activate and go like this from lateral to medial side. So it will not make it deeper to go subtrigonal. Here you can see that I'll put little pressure with my endoscope assembly to put the traction and stress out the attachment, and I'll take it down.
So sorry to interrupt you in between. I have to call the next set of chairpersons on the stage. Dr. Rishi Nair. So I request you to please come on the stage for the next session. Dr. H.S. Bhadiyal. Dr. Umesh Sharma. Dr. Saurabh Joshi. Dr. Subhash Yadav. Dr. Sanjay Kumar. Dr. Bhuvan Chauhan. So please join the panel.
Point and then finish it up. Dr. Vivek, you're on live.
Yes, so I just finished the procedure. Am I audible?
Yes, you are audible.
Yeah. So this is the final report which this template generates. You can see how beautiful the report is. First is that it gives 3 sections, one at the base, then at the mid gland, and then at the apex. You can see at the apex our lesion was there, marked in pink. Then it gives you the whole prostate contour as well as the lesion. And since I have only marked the target lesion, I cannot see my systematic course. So I have only marked the target lesion just to not create confusion. So we were doing in this plane. So patient is in left lateral. So you can see this is the base, this is the apex, and this is the apical lesion which we have taken. So regular prostate biopsies, we could have just targeted this much area. But you see, with the help of fusion and obviously with the probe, and we can take the area where we could wanted the lesion. And this is the real-time pictures. Thank you so much for the opportunity. Now, the same case will be taken over by Dr. Ashish Saini for TUFLEP procedure. Thank you so much.
Can we move to the lecture session, sir?
Yeah, I think we should start the lecture session. So simultaneously the video will go on in the backstage.
I would invite Dr. Gaurav Garg to please come on the stage to, he's having a talk on role of alpha blockers and 5-alpha reductase inhibitors.
Good morning, everyone. Thank you, Anand sir, for giving me this opportunity. So now for next few minutes, we change our focus of attention on prostate, on the medical management. We are already seeing the surgical management. So I'll be starting with the most basic medicines that are used in the management of BPH all over in India. And most urologists, they are using it. So my topic is role of alpha blockers and 5-alpha reductase inhibitors in male LUTs. So we have a lot of paradigm of male LUTs. So the old view was that prostatism and one size fits all approach. But the new reality is that the LUTs is a multifactorial syndrome and not just a plumbing problem. It involves prostatic enlargement, a static component, a smooth muscle tone, dynamic component, and bladder dysfunction. So we all urologists face a challenge that how do we effectively address all these components, especially in patients with a high risk of disease progression. So as a quick refresher, we have the monotherapies which were earlier used, like alpha blockers were used. They have a mechanism of action. They rapidly relax the smooth muscle in the prostate and the bladder neck. So the effect is a quick symptom relief within days to weeks and improved urinary flow. But the limitation is that they do not alter the natural history of the disease or reduce the prostate size. Similarly, the 5-alpha reductase inhibitors are there, which have a mechanism to block the conversion of testosterone into active dihydrotestosterone, shrinking the prostate gland. So the effective is a long-term reduction in the prostate volume and decrease in the risk of BPH-related surgery or acute urinary retention. So, but they have a strong limitation that the onset of action is slow onset. They require minimum 3 to 6 months for showing a marked symptomatic improvement, especially if they are used as a monotherapy. And they have potential for sexual side effects. So this thing potentially limits their use in especially young sexually active males. So we, in a nutshell, we come to a conclusion that monotherapy, especially in high-risk patient, it's kind of inadequate therapy. Like alpha blockers, they provide symptomatic rapid symptom relief, whereas 5-alpha reductase inhibitors, they provide long-term risk reduction. So if we do an overlap of these two medications, a combined approach can help these patients. And a key message is that for many patients, especially for those with larger prostates, monotherapy falls short. So now we come to a conclusion that why combine? What is the rationale for combining these two medications? So combining them gives us a dual mechanism of action. It simultaneously targets both the dynamic and static components of bladder outer obstruction. It has a synergistic effect. It provides superior efficacy compared to either drug alone. The 5-alpha reductase component modifies the underlying pathology, the basic pathology of BPH, preventing disease progression. And also the patient benefits from early symptom immediate relief with the 5-alpha reductase inhibitor effect taking longer time for the action. So the combination therapy kind of gives improvement in all the parameters, reduces the chances of progression, reduces the chances of retention, UTIs. So there have been 2 landmark studies for which have shown results in favor of the combination therapy. So I will quickly go through these studies and their results. So we have the AMTOPS and the COMBAT study. So AMTOP study was a large multicentric double-blind trial that compared doxazosin finasteride combination therapy and placebo. And the key finding was that the combination therapy was superior to monotherapy in preventing BPH progression. So this study used different parameters for like deciding on BPH progression, like reduction in the symptom score, chances of having a UTI, chances of retention episodes, chances of kidney dysfunction. So the data showed that the combination therapy has a cumulative incidence of progression that is less as compared to monotherapy or placebo. So this is a very good landmark study. Another study was a combat study. So this also showed similar results, and this also showed that significantly combination therapy was more effective than monotherapy in improving LUTs and reducing the risk of BPH progression. So very large scale studies. Now we come to who is the ideal candidate for combination therapy. So the ideal candidate is a patient with a high risk of disease progression. So what is a high risk of disease? What is a high risk patient? So different guidelines, different studies have like tried to describe who is the ideal patient. So the key predictive factors are prostate volume. If the volume is more than 30 to 40 cc, the larger the prostate size, the more likely the benefit from 5-alpha reductase inhibitors. If the PSA value is more than 1.5, especially like we need to rule out cancer before like deciding on that. And patients who are having moderate to severe LUTs, IPSS more than 8, and as we discussed in the morning also, the older patients who are more likely to have significant prostate enlargement, so they are more likely to benefit from a combination therapy which reduces the disease progression. So now we have some like problems with the combination therapy, like we need to address these issues whenever we are deciding these patients for like deciding on the combination therapy. So one major issue is the PSA issue. So we all know that 5-alpha reductase inhibitors, they reduce PSA levels by approximately 50% after 6 to 12 months of therapy. So this reduction is a key consideration for prostate cancer screening. We discussed in the morning. So the best practice is to establish a baseline PSA, double the on-treatment PSA value for accurate interpretation, and any on-treatment PSA increase or PSA value more than 4 should prompt further investigation, like measuring the PSA velocity or like going for MRI or biopsy, like depending on case-to-case basis. So the AU and the EUA guidelines, they now have refined patient selection. They are more explicit on the use of prostate volume and PSA to identify appropriate candidates for combination therapy. They emphasize on shared decision making. They increasingly stress the importance of discussing all the options, including combination therapy with the patient and considering their preferences and priorities, including sexual function. And there is long-term data on the efficacy and safety of combination regimes that is there in the studies. So now we come to different aspects of these combination therapies. So like in market, different like combinations are available. Fixed dose combinations are available. Separate pills are also available. So there is like a lot of pros and cons. So if we talk about the pros of fixed dose combination, there is improved patient compliance, simpler dosing regimen, but the cons is less flexibility in dose adjustments and may be more expensive. Whereas separate pills, they allow for dose titration of each agent, potentially lower cost. Like many patients, they are having side effect with like psilocybin full dose. So if we are using the separate pills, you can modify the dose of alpha blocker and give 5-alpha inhibitor in the full dose. So, but the cons is higher pill burden may lead to decreased compliance, patient not continuing the medication for the long term. So we have to tailor the choice to the individual patient needs, cost considerations and preference. So now a very important burning question which every patient I think must be asking in the OPD, like they are having improvement with the medications. Now for how long they have to continue these medication? Do they have to continue for indefinite use? Are there any long-term side effects? So recent studies, they suggest that in some well-selected patients, the alpha blocker component may be withdrawn after 6 to 12 months once the 5-alpha inhibitor has achieved its maximum prostate shrinking effect. So this can reduce side effects associated with alpha blocker and potentially lower long-term cost. So, but this approach is not for all patients and require careful monitoring of symptoms. We have seen like many patients in long term, they may require surgical options also. So this has to be tailored according to the patient needs. So now recent studies, they are coming up that like chronic bladder outer obstruction leads to detrusor muscle hypertrophy and dysfunction. So 5-alpha reductase inhibitor, by reducing prostate volume and urethral resistance, they may help reverse some of these secondary bladder changes, improving bladder function and reducing the risk of decompensation. So new data is emerging that it can like prove as a bladder sparing strategy in the long term if we are using the combination therapy. So now if we have to, alpha blockers primarily address voiding symptoms. So new data is emerging that storage symptoms are better managed with antimuscarinics or beta-3 agonist. But some studies, they have shown that 5-alpha reductase inhibitor and combination therapy also significantly improves storage symptoms, likely through a reduction in bladder outer obstruction. So we should give some time before adding or some antimuscarinic to the combination therapy, and we should assess the response after some time to the combination therapy before adding any third agent.
Dr. Gaurav,
Yes,
please
sir.
wind
Yes,
up.
sir. I'm just wrapping up, sir. So a balanced view should be taken, and a frank and open discussion about potential side effect is crucial, especially regarding the sexual side effects. And there are concerns that the combination therapy may worsen ED. So we have to screen for ED at baseline, consider adding phosphodiesterase inhibitor as a co-therapy, and combination of alpha blocker and PDE5 inhibitors is also a guideline recommended option. And like this will come in the subsequent talks, triple therapy, role of PDE5 inhibitors. And as it can be a cost-effective long-term therapy for BPH patients with high risk. So I'll quickly summarize my talks. Like combination therapy is the gold standard for men with LUTs and an enlarged prostate, especially more than 40 gram or PSA more than 1.5. It provides superior efficacy in both symptomatic relief and disease modification. The landmark studies provide the robust evidence basis. Patient selection is crucial. Don't overtreat patients with small prostates. Male LUTs is a progressive disease. We have the tools to not only manage symptoms but to alter the course of the disease. Combination therapy with alpha blocker and 5-alpha inhibitor is the most powerful and evidence-based tool in our armamentarium for the high-risk patient. Thank you.
Thank you, Dr. Gaurav. In view of the time, we'll take the questions at the end of the session only. So may I invite the next speaker, Dr. Aditya Sharma, to talk on the anticholinergics and the beta agonists, their role in the management of LUTs. Thank you so much, Rishi sir. At the outset, I would congratulate and thank the team of Max Prostate Conclave, especially Anand sir and Rohit Kaushal sir for giving me this opportunity. In next 8 minutes, I will try to decipher anticholinergics and beta-3 agonists, especially in context with BPH and storage LUTs, are newer ones better. So while dissecting this query, you need to understand what is a better. If you are categorizing a class of drug or a drug as better, it can have a better safety profile with equivalent or better efficacy, or it can have a better efficacy with a similar safety profile. And second query is, what are these newer anticholinergics? So if you look at the evaluation of anticholinergics and beta-3 agonists, in 1970s we had oxybutynin, still most commonly used drug in pediatric population, especially in our center. In 1990s came tolterodine, followed by just 2 decades ago we had trospium, solifenacin, derifenacin, fesoterodine, and in 2010 we had mirabegron. Keeping it in perspective is BPH patients, we had till 1990s, we had surgeries, open or endoscopy had started. Alpha blockers came in 1990s, and in 2014, just a decade ago, anticholinergics were approved by EAU for use in BPH patients with storage LUTs. So to understand, the newer ones are selective, they are M3 selective, they cross the blood-brain barrier less, have lesser cognitive disturbances. So drugs which are newer anticholinergics can be categorized as solifenacin, derifenacin, trospium, which is a quaternary ammonium compound, fesoterodine, which is a prodrug, and mirabegron and mirabegron, which is very well available in our part. The query comes because a lot of companies has come up with n number of combinations, and they are pushing you through with various MRs coming to you that please use this combination, this drug for your BPH patient. Various combination has come up. To illustrate an example, this is one of our case presented to our OPD, seen by my resident, had neurogenic, had some neurological component on antiplatelets, hypertensive, well controlled on drugs. Initially started on silodosin, got an ultrasound and a voiding diary. The voiding diary reflected urge incontinence and urgency as a predominant symptom, started on silodosin and mirabegron combination. Reviewed after 3 months, his son came, he lives in Himachal, far away. The symptoms had altogether disappeared and he's doing well, so the drug was repeated. So this is an example how a BPH patient with storage LUTs can be managed on these drugs. If you look at the pharmacological consideration, what is driving these newer antimuscarinic is basically the M3 selectivity, which makes it bladder selective or a uroselective drug, and lesser CNS penetration as compared to other older congeners. While we look at the beta-3 activation, it has a different pathway altogether and different set of side effects. So if you look at solifenacin and derifenacin, they have very high M3 selectivity. They cross the blood-brain barrier lesser as compared to oxybutanin and tolterodine, and therefore the dry mouth and constipation are still there, but lesser as compared to the older ones. If you talk about trospium and fesoterodine, one being a prodrug, has similar side effect profile as solifenacin and derifenacin, and trospium does not cross the blood-brain barrier, and mirabegron, of course, has increase in blood pressure as compared to the anticholinergics per se. What do the guidelines say? Guidelines are important, especially for the prescription patterns in Western population, in certain Asian population also, because until unless a drug is approved by a guideline, that cannot be prescribed as compared to in India, where you can get these drugs over the counter. So guidelines AU and EAU says clearly that offer antimuscarinic or alpha blocker for storage predominant lusts. Don't use them in patients who have PVR of more than 150 ml. So as in the morning there was a discussion on ultrasound, PVR becomes an important connotation when you are prescribing antimuscarinics in these patients. Beta-3 agonists again are all acceptable alternatives. If you look at more detail, you have a strong recommendation for anticholinergics while weak recommendation for a mirabegron. And if you look at AUA guidelines, you have grade C recommendations for both antimuscarinics as well as the beta-3 antagonist, again with the safety caveat that avoid anticholinergics in patients with PVR of more than 150 ml. It is very important that you reassess the patient after 4 to 6 weeks, maybe 12 weeks if you have a busy practice, but it needs to be revisited in terms of PVR, IPSS, quality of life, and any cognitive disturbances arising thereof. When you try to decipher or dissect such questions, you resort to systematic reviews, and what better to then go for a Cochrane library. This was a meta-analysis published in 2021, which showed that combination therapy with anticholinergics and alpha blocker are associated with little or uncertain effects on urological symptom score compared to placebo, alpha blockers, or anticholinergic monotherapy. So this refuted the use of anticholinergics. However, you can see the grade of recommendation, it was very low for all these database. Moving on to 2024, we had a systematic review and meta-analysis which compared head-to-head alpha blocker mirabegron with alpha blocker antimuscarinic, and it concluded that both these combinations have similar safety and efficacy profiles in male patients with storage LUTs and BPH. To dissect it further detail, let's look at the forest plots of this meta-analysis. If you look at the post-void residue volumes, beta-3 agonists fared better. Anticholinergics have higher chances of increasing your PVR, although not reaching a statistical significance. Regarding Qmax, beta-3 agonists again fared better as compared to anticholinergics in terms of not decreasing the Qmax. If you look at symptoms questionnaire, micturations per day or incontinence episodes per day, anticholinergics have better efficacy than beta-3 agonists. Again, you can see the forest plot chart crossing the midline, not reaching a statistical significance. But if you look at urgency episode and you look at the above chart, you can see as compared to alpha blocker alone, mirabegron and antimuscarinics have much better profile in reducing the urgency episode as compared to alpha blocker alone. And if you look at this lower chart, you can see that both mirabegron and antimuscarinics are very much comparable head to head. When we come to adverse events, the treatment emergent adverse events were better with beta-3 agonists, especially in terms of urinary retention also. The trend is towards prescription of mirabegron. Now let's come to the real world data. This is in setting of randomized control trial. So what is happening in the real world? This is a review from Japan in which they have found that almost 96% are monotherapy prescriptions with alpha blockers alone, and only 15 and 12% are addition of antimuscarinic and beta-3 agonists. And if you look at the treatment adherence, only an alpha blocker with 5 ARI are ones which persist in 19% over a period of 2 years, while only 7% of these prescriptions using beta-3 agonists or antimuscarinic persist. What is the trend in India? If you look at this chart, this is published in 2022. Mirabegron has rise like a rocket kind of thing from 2016 with 0 prescription to 2022, 44 prescriptions for OAB, not particularly for BPH LUTS, being 44% of these patients are prescribed mirabegron as compared to solifenacin, which is slightly going down, and rest of the drugs are going down, so much so that trospium is almost 0 prescription which were screened. This is our dosing and monitoring, just a quick guide. We all know the dosing and tolerability. So Just to conclude, by this algorithm from EAU, if you have a patient who has a male urinary tract symptoms with bothersome symptoms, and you find that they have storage predominant symptom, you have done your voiding diary in whatever fashion you have done, you have to prescribe them education, lifestyle advices, fluid restrictions, delaying voiding, and along with you can prescribe the muscarinic and anti-muscarinics or beta-3 agonist. You can start with combination therapy of alpha blocker along with these drugs, or you can have a combination of these with a caveat that you have to screen for cognitive disturbance and side effects 4 to 6 weeks later. So key take-home points are the newer anti-muscarinics fares better in terms of tolerability with lower cognitive risk, lower side effects. However, beta-3 agonists fare better in terms of safety profile as compared to anticholinergics. Personalize these management by using PVR, cognition, blood pressure, and other polypharmacy, especially CYP inhibitors, which are like antiarrhythmics being used in the management. Avoid combination if the PVR is more than 150 ml, and watch out the shift for these treatment trends a decade down the line, because now you are having mist, which is coming up. It's going to change the trend of this management. Thank you so much for your patient hearing.
Thank you, Dr. Aditya. There would be several questions on this, but as said, we will take the questions at the end of the session in view of the time. Meanwhile, can we have a comment from the OT? Hello?
We are speaking from the OT, sir. Yeah. We are listening to you, sir.
Yes, yes. Dr. Ashish? Hello? Dr. Ashish, can you hear us?
Dr. Ashish, is it audible?
ये ना ये सारे तुम्हारे जहाँ पे तुमने वो किए हुए हैं ना ये आ रहे हैं इसमें अब.
Hello, are we connected to the theatre?
ये ना ये जो छेद हुआ है ना ये basically biopsy के हैं ये.
Or else we can just continue.
Yeah, so thank you for giving me an opportunity to present and to demonstrate this thulium fiber enucleation of the prostate. I'd like to thank Professor Nandkumar, Rohit, Pragnesh, and the whole team. They have put up a good program. So this is a 60-gram prostate where a truss fusion biopsy has been done. And one can see, as I was, my plan is to do a two-lobe technique. This is a trilobar prostate. And as one can see, this is the medial lobe. So this is the medial lobe. And we will be following one of the planes which has been there. So I'll be following this plane when we are doing it in two lobe. So as been discussed, we are using a thulium fiber laser by Intercardia. It's a 60-watt laser. And the settings are the pulse energy is 2 joules and the frequency is 17.5. I may increase the frequency to 20, so we'll be using 35 watts, and then we will increase it to 40 watts. That is what is required. Hemostasis is at around 6 watts. And this is a striker system, which is basically, it's a new one. It's a 1788 striker system. And they say that the flicker of the laser is less with it has a laser shield. Looking at the anatomical enucleation of the prostate or AEP, I started at the apex. So this is the area, this is the veru. This is the area where we can define the capsule. You can see these are the holes of the prostatic biopsy which has been done. So I'm hoping that they do not create any problem during the enucleation. And so we first of all create a plane where we make the floor of the incision, and the floor of the incision is from 5 o'clock till 7 o'clock at the apex. This is the area where the capsule is very well defined, and once you are able to make out the capsule, the things are easy in an enucleation. The other thing is that as people are talking about the mechanical pulling, I usually say that you should forbid from that. Just use a laser, and I'm using so my laser is I'm just carrying a laser carrier. So it's an Indian made bridge from Calcutta, and so basically by Gopinath. And you can, just by my thumb movement, I can have the laser to and fro so that I have the control of the laser in my hand rather than with the laser working element. So this is how we will be proceeding, and if there are any questions, I'll be glad to answer them as we look forward. Okay? Thank you.
Can you please show the laser carrier? What kind of it is?
This is the laser carrier. Can you put the camera here?
Over the laser carrier.
So this is a simple laser carrier where this is a store's TURP set. You have to just buy this laser carrier, which is I think 15,000 rupees, and the same outer sheath can be used with a store's morcelloscope. So if you have a morcelloscope of the same company, you do not need to change it, and then by using this, it makes your job easy.
You are not able to see the carrier. Where is the?
Actually, they are fixing up the camera.
Okay,
Just hold on for a minute. Yeah, this one. We want to see this. So this is the. Can you see it now?
No, not visible.
No.
It's still.
Yeah, this wale ka you have to switch.
We are only seeing the endoscopic view. We need to see the external view of your hands.
Okay. So the cameraman, they want the external view of my hands when I am operating. So what you can do is this screen can be shifted to this one. Yeah.
Yes. With this camera, you can show. Yes. We can now see. Just point it out to us.
So basically, this is the laser carrier, and this is how we'll be doing it. Okay.
Is this the same as the Patankar sheath? The Indian
No,
made
sir.
Patankar sheath used for?
No. So it's not the Patankar sheath. So basically, what this laser carrier is that it has a channel. So it has a channel which is around 100 French. So with this, there is no movement of the laser fiber. So it dampens the movement, and the other thing is that it gives me a control on my laser. Whenever I want to go deep, I can just pull it, and I do not need to do it with the way we do a resectoscope or the way we do a TURP.
So this sheath extends along the entire length of this cystoscope?
Yes, sir. So it's a channel which extends, and as you can see at 6 o'clock, you are seeing there is a protrusion. So what happens is that it also saves your telescope. So you can see the laser fiber, which is blue, and then you can see a gray marking. So it has a tip which is around 2 millimeter extended, so that you have that leeway where you may misfire, and then your telescope may go in a normal laser bridge. So this is not happening in this case.
Okay, so we will continue to see you, and meanwhile we complete our session here.
Okay.
May I call Dr.
Next
So
next
Dr. Raman
speaker
Tanwar.
is Dr. Raman, and he's going to speak
going
on
to
the current role of PD5 in male LUTs. Dr. Raman, please.
Thank you, respected chairpersons. And a special thanks to the entire organizing committee of the Max Prostate Conclave for having an andrologist on stage when we're talking about the prostate. Now, this not only reflects the fact that something that I, as a philosophy, own, that urology and andrology are not very different. Actually, andrology is truly an offshoot of urology because everything in andrology is quite fiercely linked to what happens in the urological domain. And that's, again, this talk is again an example, a fierce example of the same philosophy, that the andrological aspects and urological aspects are deeply engraved in each other. So we really cannot have separate andrologists. We always need to have a urologist who evolves into an andrologist so that they can understand the nuances that an andrology patient and andrological diseases face. So my talk is going to basically cover just 5 important questions. around PDE5 inhibitors in BPH. So how does PDE5 inhibitor have a role to play in BPH? What are the indications where I would want to use PDE5 inhibitor in my practice? And can you give a monotherapy, which means that I just give tadalafil to my patient for BPH? Is that possible? Is it efficacious? What is the level of evidence around it? And who is the ideal patient to give the phosphodiesterase 5 inhibitors? So this is what my talk is going to feature on. But before that, I'd like to know from the audience, how many of you here have used tadalafil as monotherapy for prostate enlargement? By raise of hands, please, so that I can understand what is the level of understanding here regarding monotherapy and tadalafil. Okay, we have some people from the chair side also. Very good. So basically, this is a 15-year-old research that we are discussing today, wherein we started thinking about tadalafil causing improvement in lower urinary tract symptoms. This was in 2007 when this first paper kind of came, which gave insight to urologists to talk about it, to discuss, do more research around it. But this is still an enigma, because as I could see that we didn't have everyone raising their hands on using PDE5 as a monotherapy. They've never even thought about it, most likely. So how does PDE5 inhibitor act? So you'll be surprised to know that it's a beautiful drug. Maybe we haven't explored it enough, but it causes relief in more ways than one when you compare it with a alpha blocker or when you compare it with a 5 alpha reductase inhibitors, because it's not only causing a nitric oxide mediated muscle relaxation, it is actually causing changes in the blood, in the bladder muscle. So I hope you remember something from the pharmacy where we used to think that, beta blockers can change how the kidneys work, how the heart remodels. So phosphodiesterase 5 inhibitors have that potential to remodel things. And especially I've seen that in my erectile dysfunction patients, where the chronic use of these drugs can remodel the penis, rehabilitate the penis, especially around radical prostatectomies and all those kind of invasive procedures. So it causes bladder compliance changes. It causes improvement in the bladder wall perfusion. So that is something that we talk about when we talk about regenerative therapy as such. It has anti-proliferative effects and also CNS mediated effects. It's not just that locally it's acting, it's also letting the nerves act in such a way that it gets synced to the muscle tone. And then there are many unknown mechanisms, but a unique pathway that I wanted everyone to have a look at is the role in reducing the prostatic inflammation, wherein the phosphodiesterase 5 inhibitors become a very good drug of choice for patients with prostate inflammations and male accessory gland infections, because it's not just acting by relaxing or blocking something which is causing a tone to increase like alpha blockers do. It's actually acting on ROCK, it's actually acting on CGMP and also the stability of the autonomic nervous system. So here are certain salient points that you need to understand when you are using a phosphodiesterase 5 inhibitors. One is that for storage symptoms, it's not really good, because as I discussed, it's something that is doing something around the passage and the bladder wall perfusion. It works good for storage symptoms, but not as good as the alpha blockers. And second thing is that you need to understand that avoiding symptoms, it really works very well. So we have to integrate somehow our IPSS scores with our IIEF scores here. So again, I wanted to understand from the audience, how many of us are actually using IPSS scores in their OPDs? Do we have that time where we actually do it? Second, when we are asking for an IPSS, how many of us are understanding the patient as a human person and not just a prostate that has come to us, and also talking about their sexuality? So how many of us are also using IIEF scores along with IPSS scores? Because these are the things that our next generation should adopt somehow, considering that there's so much happening here. Anyways, so you need to also understand that phosphodiesterase 5 inhibitors does not work in certain situations. For that, you have to understand that phosphodiesterase 5 is not expressed in the epithelial or stromal components of the normal prostates, which means that if I have a young patient, because my tendency to give a phosphodiesterase 5 inhibitor is to that patient who is a young patient, like a 40-year-old patient with a primary bladder neck obstruction, and some sort of a prostate infection. That is the ideal patient for me to do the thing. But here the phosphodiesterase 5 inhibitor is not going to act, because you have to understand that the receptors for phosphodiesterase 5 inhibitors are actually highly expressed in the stromal component of a BPH, which means that the gland has to be enlarged for it to be able to cause those kind of effects that we're talking about in this talk today. So a small prostate, say a 20-gram prostate with basically a PBNO being the cause of the obstruction, is not my ideal candidate to give a phosphodiesterase 5 inhibitor. So where do I use phosphodiesterase 5 inhibitor? Where I have seen by studies that it causes an improvement score in the IPSS of at least greater than 3. So I would either use it for very mild or moderate LUTS, because as the research has suggested, that it doesn't work on all components of the IPSS score. It will work mainly on supposedly the voiding component. So only mild to moderate LUTS can be managed with phosphodiesterase 5 monotherapy, or it can be given to patients where we have some sort of a prostatic component with erectile dysfunction, because there it becomes a drug of choice for us to take care of. Then we have those who have side effects with the alpha blockers or with 5-alpha reductase inhibitors, because there again, this is something which has less side effects, and you can just time those side effects. I'll talk about them briefly. And then those wherein we have severe LUTS, there we can use a combo therapy, which is a well-established thing now, so I don't really need to advocate phosphodiesterase 5 inhibitors for that. And specifically now, a new thing which I want to highlight in this talk is inflammations, where I have personally used it for treating erectile dysfunction, because we also, in my experience, have come to know that erectile dysfunction is not an andrological problem, it's an androurological problem, wherein a lot of male accessory gland infections are actually inducing changes in the nerves and causing the erectile dysfunction. So here again, it's a beautiful drug to help us with both the things. So this is just a brief slide. You have to understand the side effects are mainly around muscle aches. Now muscle aches are typically happening briefly. So you can ask either the patient to discontinue the PD5 inhibitors for 3 to 4 days and restart, and most of these patients would not have those muscle aches. And dizziness and dyspepsia are something which is very well tolerated, but dyspepsia is a real problem, and many patients would come to you with gastritis, so you might want to add a proton pump inhibitor in those cases. So the advantage point of PD5 inhibitors are they are more modifiable combination. They also target the erectile dysfunction while only causing a slight increase in the adverse events. So daily doses of phosphodiesterase 5 inhibitors does fit in, and it is very useful when you're switching back to monotherapy. So it has been said that if you're using combination therapy, after 6 months, if you can switch back to one therapy, phosphodiesterase 5 inhibitors have the ability to maintain the scores or the comfort of the patient. So you don't have to continue the monotherapy at all. So thank you for your time and attention. I just wanted to be brief and finish well in time. Thank you, sir.
Thank you, Raman. Can you connect us to Dr. Varshina Oti? Hello? Are we connected to the OT?
Acha.
Yeah, Dr.
Okay, so I have done the enucleation part, so I just wanted to show you what we have done. If you see, there is definitely a vascular gland, and what we have been able to do it, I'll just show you from the Viru. क्या दिखाई दे रहा है? Now, just see this. These are the bladder neck fibers. We have inspected both the orifices, and there is some kind of a oozing which is going on at the level of bladder neck. We'll just fulgurate all this, and these are the two lobes which are inside the bladder. And let me check where is the bleeding. But if you see anteriorly, this is what we have done. This is the anterior limit, and this is the lateral side. This is all enucleated. This is the left lobe. So the left lobe is all done. And then I'll come back and show you the artificial Viru. This is the artificial Viru which we had created, and this is the right side. So this whole thing is the capsule which is on the right side. So I'll have to look for the bleeders, and then we will do the morcellation.
Can we see the original Viru, sir? You have shown us the artificial
I'll
Viru.
just show you the Viru. कुछ कलेक्ट है नहीं ये देखा.
So you have created one Viru at 12 o'clock, sir?
We created an artificial Viru at 12 o'clock, and I'll just show you that what is the status of Viru here. Now if you see this side, so we are on on one side of the Viru, and here on the other side of the Viru. So this is a very coming distal. So the whole Viru, this whole thing is Viru.
Yes, sir.
And
yes,
it
sir.
is coming like this.
We can see it, sir. I think you control your bleeding, sir, because...
Let me achieve hemostasis
yeah,
and
achieve,
then,
and we will
then
come,
I'll
we
show
will,
you.
we'll come back to you, sir.
Yeah, let us achieve hemostasis.
Yes, sir.
Varshney sir.
पानी
Sir,
नहीं जा रहा।
Sir, what is the advantage of
पानी बंद किया
creating
हुआ है यार तुमने।
artificial value?
आ ही नहीं रहा। कुछ problem है।
You can
दिख
call
नहीं रहा
the
ना
next
वो।
speaker.
ऐसा तो नहीं होता। पानी तो अच्छे
Next
से आता
speaker,
है।
next paper. Yeah.
कहाँ से आ रहा है? दोनों खोल देना।
Dr. Pankaj Gaur.
Dr. Pankaj Gaur.
नहीं है, पानी का pressure ही नहीं है।
So we are switching to the lecture, next lecture.
I extend my sincere gratitude to the organizing team for inviting me to give this talk. So I have been given the topic of role of vasopressin analogs in the LUTS management. So before going to the vasopressin analogs and its use, we must understand the nocturia and its effects on the quality of life in our day-to-day OPD practice. So you can see this gentleman, he is quite sleepy and not able to concentrate on his work. That can be an effect of the nocturia, and he has come to the OPD to us to relieve this symptom also. The nocturia is the most prevalent LUT. So this epidemiological epi-LUT study has shown that the nocturia is almost 70 to 80% prevalent in the overactive bladder female patients and as well as the BPH patients. And nocturia can be because of the small capacity bladder, because of the overactive bladder, and also because of the nocturnal polyuria. So this is the key thing which we have to understand, that nocturnal polyuria is present in a large proportion of the patients with the nocturia, and it is almost 83% in our Asian countries. So the example of potential simple algorithm is this. We can divide broadly into the daytime LUTs, mixed LUTs, and nighttime LUTs. And nighttime LUTs, we have to identify the patients who are having nocturnal polyuria. So what is nocturia? It is a brief definition. It is defined by ICS like the complaint that the individual has to wake at night one or more times to void. And waking has to be preceded and followed by intention to sleep. He may not be able to sleep, but he still has an intention to go back to the sleep. And nocturnal polyuria is defined as the urine output of more than 20% of the daily output in youngs and more than 33% in elderly, which is taken as more than 65 years. So it should be recognized as a condition in its own right and potentially profound consequences on the quality of life of our patients. So it is a bothersome LUT and it highly prevalent. The frequency of nocturia is defined as extent, problem, disruption, and resulting into the bother. So if it is more than 2 times, it can affect up to 90% of our patients. Nocturia causes sleep fragmentation. This study has clearly shown that. And it is bothersome symptom in both the sexes, not only in males, but also females. So prevalence of nocturia, we have already covered it. Almost 80% of the BPH patients are suffering from the nocturia. So what are the consequences? Consequences is sleep fragmentation and daytime somnolence, which can affect their productivity. It can increase in falls and fractures. And it can be indicative of poor health status also, because sometimes it can indicate towards the uncontrolled diabetes and chronic heart failure. The impact of nocturia, this graph is showing that the daytime productivity of the patient is decreased. What are the causes? We will just look into the causes of nocturia. The most common is nocturnal polyuria, then benign prostatic hypertension, detrusor overactivity, reduced bladder capacity, then uncompensated heart disease, psychological or sleep problems, and anxious patients may be going to the loo again and again. Then there can be estrogen deficiency, primary polydipsia, and untreated diabetes mellitus. We will concentrate on the men. We have mainly 2 things, that is prostatitis and prostatic cancer, exclusive to men. Others are shared by both. So what is the mechanism causing the nocturnal polyuria? It is can be water diuresis or solute diuresis or combination of both the diuresis. The water diuresis is caused by reduction of arginine vasopressin overnight. So there is a circadian rhythm in which the AVP is secreted more in the night and it causes less urine production in the night. But as the age advances, this circadian rhythm is disturbed and it can lead to the nocturnal polyuria, as well as there is impaired response to the vasopressin with age due to aging nephrons and number of nephrons decreasing. And there can be hypertension and negative feedback on the pituitary gland. Then solute diuresis as in the heart failure, sleep apnea, diabetes. And I have already explained you about age. The third space, fluid sequestration in the daytime due to the gravity effect, can also cause to the increased urine production in the night. How to diagnose nocturia? So my dear friends earlier have already covered this topic by bladder diary and frequency volume charts. So nocturnal polyuria is a major underlying factor, is caused by impairment of, so we have covered this. Then the assessment of a patient, we have to take a detailed history of urinary symptoms, then we have to identifying the underlying cause just by going into a deep discussion regarding his day and night schedules. Relevant investigations as already have been discussed. Then urinary diary. So it is the milestone, the main milestone investigation to diagnose nocturia and nocturnal polyuria. So what treatment options do we have? So real life practice analysis helps in understanding the patient, and he may feel the symptoms and quality of life is getting poorer and poorer day by day. Then the potential benefit lifestyle modification we should do, that is minimizing the fluid intake at least 2 hours before going to the bed, restrict total fluid consumption to less than 2 liters. Then dietary modifications has to be there. While sleeping, patient can be advised to elevate legs above the level of heart when we are finding that there are cardiac element also. Then take diuretic mid-afternoon rather than evening. What is the pharmacotherapy? It is a multifactorial pathophysiology. It is unlikely that one treatment modality will be successful in all the patients. So drugs which are used day-to-day basis in the LUTs, they are effective against daytime symptoms, but sometimes they completely fail to treat nocturia. So for those conditions, we have to go for specific medicine, that is vasopressin analog. Desmopressin is the only drug which is currently FDA approved for treatment of this nocturia. So this is an example of potential simple algorithm for LUTs treatment, in which nighttime LUTs has to be evaluated, and then we can go to the treatment of this nocturia slide. So there are many observational studies on desmopressin. I have included 2 recent studies. So these studies have shown that the number of voids has decreased in the night as a combination therapy is used with the desmopressin as compared to the monotherapy. And first voiding episode after sleeping has the time limit from the first going to sleep to the first episode of voiding has also increased significantly. The combination therapy has also increased the IPSS, quality of life, and Qmax. And it has also showed a significant decrease in nocturnal total voided volume. And mean serum sodium levels has also decreased, but it has remained almost more than 130 millimole per liter in all these studies. So combination of desmopressin with tamsulosin is effective for the treatment of LUTs. Similarly, this is another study which has been done with the combination to the tolterodine. It has also shown that there is beneficial effects of combined therapy in terms of the total voided volume and quality of life. So this is a systemic review of 13 studies, including 3,072 patients. This is the flow chart of the systemic review. So in all these studies, what was the dose used? It was titrated from 0.05 milligram to 0.4 milligram. Usually in our practice we use 0.1 milligram at bedtime and then we titrate the dose. Adverse drug reactions, they range from 2.2 to 6.8% of the patients, and most common is hyponatremia, which occurs from 3% to 8.2%. Other adverse effects are headaches, dizziness, and GI upsets, mainly diarrhea. How do we monitor? We monitor the serum level first at 1 week, and it is followed by 3rd week and 7th week, and dose has to be titrated accordingly. So these are the take-home messages that many patients have both daytime and nighttime LUTs. Both should be treated to bring meaningful benefit to the patients. Desmopressin is combination with the OAB and BPO treatments such as anticholinergic and alpha blockers has been shown to provide additional significant clinical benefits. It has reduced nocturnal voids, increased duration of initial sleep period, improved IPSS scores. There are further studies are warranted to demonstrate this clinical utility of the desmopressin alone or in combination with other drugs in LUTs. Thank you. So I would like to have any questions if.
Pankaj, we would like to know how long you can give this desmopressin, for how long you can give that?
Yeah, so usually at first we monitor this, and if the patient is tolerating it well, then at least for 3 to 6 months we continue the therapy. So the theory behind is this circadian rhythm can be reset. If it is after 6 months we discontinue and patient is still doing well, then we may not introduce it again. Otherwise we have to continue again.
Yeah. Thank you, Pankaj.
Thank you, sir.
Please correct us to the OT. We can have a comment from Dr. Saini.
Can you please connect to the OT?
Dr. Saini, would you like to brief us for a while?
We can continue with the last one.
I think we will move to our next session, next talk.
Dr. Karandeep Guleria, consultant urologist at Akash Hospital, Dwarka, advocating for a role of watchful waiting. Thank you.
Good afternoon, everybody. So the topic that I have been given was a bit of a googly to me because I honestly don't have any experience with phytotherapy or plant extracts. So I really had to dig deep into papers and find out what exact role was there for plant extracts in benign enlargement of prostate. So as we all know, it is very common in aging male, and I'll first come to watchful waiting. Watchful waiting is a very useful management option in people with mild or no bothersome symptoms, which focuses on monitoring rather than immediate treatment. So many times in our OPDs, what we see is we have patients who've just undergone an ultrasound for say some other reason, or have had an ultrasound as a part of their annual screening, which is now done in many companies and in government sector as well. And they come to us with the ultrasound report saying that they have an enlarged prostate. So then you sit down with them, you talk to them, you realize they really don't have any bothersome LUTs. So it is this subset of patients basically where this option is viable. If you look at the latest EUA guidelines and the management options that they have given, they also say that if there are no bothersome LUTs in these patients, then you can go along with watchful waiting in these patients. So it's a conservative approach where patient education is very important, and you have to monitor the patient regularly and only intervene if there is any symptoms or if the patient progresses to symptoms. So as I have already said before, it is indicated in patients who have mild or no bothersome LUTs with minimum impact on quality of life. There was this actually came as a management option because of this study by Vasan, which followed patients for almost 5 years, and they saw that almost 36% of watchful only 36% of patients who were on watchful waiting actually crossed over to the surgical side, with majority still remaining in the watchful waiting group. And the symptoms, with the increase in bother symptoms or PVR volumes, they were the strongest predictors for switching over to a surgical side. So they also defined the monitoring process, which was regular follow-up visits every 6 to 12 months, symptom assessment with IPSS. Here IPSS score becomes very important, and it should be done thoroughly for these patients. A physical examination and urine analysis is also required, and PSA if indicated. You have to sit down with the patient and decide. It has to be a collective decision if PSA has to be done. So it avoids unnecessary medications or surgery for the patient. It minimizes the side effects of these medications and maintains a good quality of life for them. And obviously it's cost effective because the patient doesn't have to buy these medications. There are obviously risks and limitations. That's why it's important to follow up these patients periodically. With the progression of symptoms, sudden risk of urinary retention is always there. And also the patient has to be educated enough and compliant so that he comes for these regular follow-ups. So what do you tell these patients in watchful waiting? So the first thing is that you have to give general lifestyle modification advices, such as reduce your evening fluid intake, limit your caffeine, smoking and alcohol, and bladder training exercises can be taught to the patients, and constipation has to be avoided. So if you look at the new EU guidelines, they say there is another set of lifestyle modifications, which are self-care management that the patient has to do, where we teach the patient double voided techniques, or we ask him to go regularly to the washroom, timed voiding techniques. We teach him urethral milking, distraction techniques, so as he takes his mind off, overactive bladder symptoms. Bladder retraining, which encourages the men to hold his urine so as to increase the time between voids, and reviewing medications which might actually lead to the development of LUTs, such as diuretics, and rearranging the time of administration of these medications, and providing necessary assistance with dexterity, mobility, or help in mental state. So if you come to the EU guidelines, they say that for all patients with mild to, they even say moderate symptoms, with minimal bothersome symptoms, watchful waiting has been strongly recommended, and offer men with LUTs type lifestyle advice with the added self-care medication to increase the effect of watchful waiting. That is also strongly recommended. Now coming to the role of plant extracts. So plant extracts are basically preparations from a part of the plant or from the whole plant as such. They can be given as mono preparations, or two plant extracts can be given together and they become a combined preparation. The relevant compounds include phytosterol, stilsterol, fatty acids and lecithins. In vitro, they have been shown to have many advantages, such as anti-inflammatory, anti-androgenic and estrogenic effects. They decrease the hormone binding globulin and neutralize free radicals. But in vivo, these in vitro reflexes have not been reflected, and therefore the role of plant extracts remains unclear. If you look at the available plant extracts, the majority of them are not actually approved, with only a single plant extract being approved with well-established use, that is the Serona repens or the saw palmetto, and that the solvent which has been used to extract that should be hexane, because if the ethanol solvent has been used, it has not been approved. The rest of them, they are not approved and come under the traditional use. So the difference between the established use and the traditional use is based on the European Medical Agency, which says that a well-established use is a product which has an active ingredient which has been used for more than 10 years and has been shown to have efficacy, whereas traditional uses where they do not fulfill the requirements of a marketing authorization, but there is sufficient safety data available. So saw palmetto, the dose is 160 milligram twice a day, and it improves the urinary symptoms and flow rates. The majority of the papers are just based on this plant extract, where the largest trial which was done and published for saw palmetto actually did not show any improvement in symptoms or objective measure in benign prostatic hyperplasia as compared to placebo. But there are contradicting studies also available which showed that it actually affected nighttime voids and helped patients with nocturia. But the main side effect of this is GI side effects, which is in tune from 3 to 10%, varying upon the studies. So guidelines are only available for saw-palmetto, which say that you can offer it to patients who want to avoid any potential side effects related to sexual functions, and you have to, talk to the patient that later on he might require pharmacological management. The other drugs available are Pygenum africans, which is derived from African plum beak. Again, the dose is 50 milligram twice a day. There was no improvement in LUTs in these patients. Beta stirostol is also available. Dose is 60 to 130 milligrams. Again, for these, there was no long-term effectiveness which has been shown in any trials. Then Utrica dioxia is also available, 120 milligram thrice a day. Again, there was, it is recommended as a complementary extract with pharmacotherapy, and pumpkin seed extracts, which also did not show any improvement. So advantages are it is generally well tolerated, fewer side effects, but it is still debatable. And ultimately, it is the dosage in these is another concern because of the compliance, because each of these plant extracts require dosage of almost 2 to 3 tablets a day, as compared to pharmacotherapy, which is almost 1 tablet a day. And the data is very inconsistent, and there are no large randomized trials, and it is not a substitute, according to me. So you have to decide when to switch over and when the pill can take over the plant extract in case of worsening symptoms, onset of complications, or if the patient actually prefers an intervention. So watchful waiting is safe and effective option in my view for a select cohort of patients who have minimal or bothersome symptoms, but it requires regular monitoring and patient engagement. The goal is to balance this symptom control with the quality of life. Plant extracts may help, but they are more so for patients with mild symptoms. With moderate symptoms, it is always better to go with pharmacotherapy. Thank you.
Are there any questions on the medical management session?
Dr. Raman is here, Raman Tama. So I have a question for the Dr. Raman. Who are the candidates, potential candidate for solo therapy for PDE5 inhibitor? Anybody is prescribing PDE5 inhibitor as a solo therapy. So who are the patient, a group of patient for potential for this solo therapy? Anybody is having experience for this? No.
We generally try to prefer in younger patients. Younger patients having mild LUTs.
But his counter argument was that 40 years it doesn't work because stromal component is less.
Some stromal component in the prostate to make it work. So it should be enlarged. So it should be. The prostate should be there, and otherwise patient should be young. In that scenario, you can give monotherapy. So we have given some patients, and they work when means they are doing good on this monotherapy.
Monotherapy with alpha blocker.
No, only monotherapy. Only monotherapy. Tadalafil 5 mg. They works.
I also, when Dr. Raman was presenting, also I had this doubt when he was telling specifically that when there is the gland should be larger in size.
Yeah.
But if you see the guidelines, basically monotherapy of PDE5 inhibitors specifically indicated where the size of the gland should not be very large, because if it is beyond 50 or 60 grams, where it is better to prescribe a combination with PDE5, combination of alpha blocker with 5-alpha reductase inhibitor rather than PDE5 inhibitors. Monotherapy specifically for those patients which is of a smaller size with associated, if the patient has specifically ED issues, in those group of patients definitely rather than an alpha blocker, it's better because alpha blocker has associated retrograde ejaculation and those side effects, where you can specifically prescribe monotherapy with PDE5, which has that added advantage when compared to over and about an alpha blocker.
So PDE5 receptors are manifested on the stromal components. It's not necessarily the enlarged gland would have more stromal component or a smaller would have more stromal component. There is no way to make out that proportion in a particular index patient. Yeah. So to say that for a larger gland PDE5 will not work is not correct in that sense, because we do not know how much of proportion of that larger gland is made by the stroma.
Okay. Another patient group where I feel that these PDE5 inhibitors are better are the, like he mentioned, that chronic prostatitis patients, where it is known that PDE5 inhibitors actually increase the microvasculature of the gland, leading to substitution of inflammation and then improvement.
Yeah, again, even though they are recommended as a, and there is good data to support that they improve LUTs to the tune of about 3 score levels. But again, in those patients, if the symptoms are primarily urinary, I would still prefer using an alpha blocker first rather than trying and doing this, because there is a long-term data available on alpha blockers in terms of their safety. For PDE5, we don't have that.
But practically, there is a subset of patients who basically have both things, mild LUTs along with the little bit of sexual problems. And you start giving it in 5 milligram doses. And there is some patients who say we are improved. But on the other hand, for basically erectile dysfunction, you give little higher doses, 10 milligram. And here it is a 5 milligram only. So there is evidence that some patients improve, some don't.
So there is a counter evidence for the alpha blockers as well. For patients where the LUTs is due to BPH, giving alpha blockers alone improves the sexual function simultaneously.
But we don't know whether they are because of benign prostatic hyperplasia or prostatitis, because these are relatively younger patients. And then monotherapy.
So even in patients who have some ED with predominant LUTs, using alpha blockers as the first line therapy is the standard still, because they would improve both the
they don't
LUTs
improve.
as well as
come with
the
the problem
function.
of retrograde ejaculation immediately. Even if you give elfugersin, which does it less, then still they come कि साहब ये तो हो गया पर ये गड़बड़ हो गया. We have retrograde. So then PDE5 inhibitors are beneficial in both terms in this subset of cases.
Dr. Gaurav is there?
So, I've got 2 questions, and this is addressing combination therapy with dutasteride and alpha blockers. So this long-term use of this combination therapy, what are the risks of high-grade prostate cancer, and how do you tackle them, or how do you sort of prepare? And secondly, why do, I think there was a presentation which said, there was a comment one of the speakers made, that there are a lot of dropouts of combination therapy. So why do people drop out after 2 or 3 years? So really the question is, the people who've been practicing for a long time, what is the right time to intervene from combination therapy to surgery? So,
there are few patients, they complain of libido, loss of libido and erectile dysfunction in prolonged use of these 5-ARIs. And this is a fact. And finasteride and dutasteride, they are being used in surveillance patient to decrease the PSA also. Though the incidence of high grade cancers has been seen on the rise, but low grade cancers, they are the few. And it has been used in the past for a prevention strategy, a cancer prevention strategy also, finasteride.
So would you use dutasteride in a situation of elevated PSA negative biopsy follow-up?
Yes, in the surveillance, it has been used to keep the PSA level low.
For the, as regard this finasteride syndrome leading to higher grade cancers, the risk that was there, it was only in one study which has been, this risk has been raised. But there are several other studies over long term which have not shown a higher incidence of a high-grade prostate cancer in this group of patients who are using long-term finasteride. There is no such data with dutasteride. It was reported only with finasteride. But no society has ever recommended not to use finasteride or dutasteride just for this particular risk, although there was definite risk in that one study.
But I think that something will come up in the future. I have a feeling that the patients on, that's just observation, but dutasteride used for a long time, when they do develop
cancer, there are several ways, even in that study, one could explain the pick-up rate of a higher prostate cancer, and therefore it is not proven that finasteride leads to a higher prostate cancer risk. And regarding your another question of why there is such dropout rates, Such dropout rates are primarily with combinations which are not with 5-alpha reductase inhibitor. The combinations with the tadalafil, the combination with anticholinergics or beta-3 agonists, in those combinations patients do tend to fall out of those combinations because of the increased side effects profile. The side effect profile with the 5-alpha reductase inhibitors is primarily the loss of libido with the additional 5-alpha reductase inhibitors. Otherwise, the side effect profile of 5-alpha reductase are not that much as with anticholinergics.
But with some few patients have gynecomastia. Few patients have gynecomastia or something.
Yes, yes, gynecomastia and pain can be there, but that is just about 0.5
I
to 1%.
was under the impression that after some times, you actually delete that this 5-alpha reductase.
Yeah, sir, the literature says that
Yes,
the
you can
maximum
do
you
that.
can give 6 months of 5-alpha. Otherwise, after continuing beyond that period is not recommended. You can have an intermittent approach like that. You can switch off the 5-alpha reductase after 6 to 8 months, and then restart when the PVR is increasing or when the patient is having symptom worsen.
Yeah.
Then you can reintroduce it. In this way,
this is what we are
this can
practicing,
tailor the
because
approach.
there is a then significant side effect profile of 5-alpha. Not only libido part, but you have gynecomastia, fluid retention, and all those things can.
No, particularly if gland size is large one, like 80 gram, 100 gram, then you can keep on using it. But if gland size is less, like 30 to 50 gram or so, there is hardly any point in continuing more than 6 months, because whatever 25% action has to be there, it has been done. So in a smaller prostate, keep on giving it for life. You are giving him.
But is it recommended to give it lifelong or for long times?
You can give it. It is safe. In a large gland, if patient is voiding well and he does not require surgery, he is not. So you can keep on.
For the combat study, it was 4 years which was proven, and 4 years was the mean minimum, and there were several patients in that study which were taking more than 6 years, 7 years. So we have long-term data on use of both alpha blockers as well as 5-alpha reductase inhibitors.
So regarding treatment discontinuation, actually I showed that slide. I omitted a slide in which they showed that why was the treatment discontinuation occurred. So there was a number of patients switched to different set of combination, or they went for a surgical arm. So it's not like treatment discontinuation, they stop it. This was a Japanese study where everything is insurance covered. The pattern of prescription at our country is different because we have out-of-pocket expenditure in majority of the cases. So that part should be made clear that it's not treatment discontinuation, they stop medication, they switch to a different combination or go for surgery.
No, but one of the reason of discontinuation is also the development
Side
of the
effects.
sexual dysfunction. And one of the serious side effect is finasteride is seen in suicidal tendency.
Yes. Memory
that is
impairment
seen
also,
in some of the patient, and this is mainly seen those people who take smaller doses of finasteride 1 milligram for hair loss for very long period. There this real risk is shown. And one of the argument given the development of risk of high grade cancer is the prostate size decreases around 30%. So before that, at that time, most of the time is the systemic biopsy was done. This was not the target biopsy was done. So in a smaller gland with the same systematic biopsy number, more cancers were picked up. So that was the one argument in the paper review it was given.
So continuing with that same issue of increasing suicide rates, again this is not confirmed as a effect of finasteride, because what happens is this drug being used in patients who are more concerned about their loss of hair and all, ultimately those patients tend to be more anxious, more reactive to what the symptoms they have. So they tend to be more psychiatric kind of patients. So in those specific patients, whether the drug is actually causing increased suicidal rates, or prima facie they have their disease of psychiatric psychological issues that is driving them to do these suicides, is not confirmed. So it is just a conjecture, not a confirmed side effect of the drug.
But this has been added in the warning.
Yes. So right now there is a lot of hue and cry going on. One particular person is driving this from UK, who is running this post finasteride syndrome society, and is is behind all these legal issues with this finasteride and dutasteride. But scientifically, these are not confirmed as the proven side effects of the drug.
Sorry, sir, to interrupt you in between. Dr. Ashish
Sir,
Sani.
one question more. Dr. Gaurav.
Dr. Ashish Sani is waiting from the OR. He wants to speak.
Yes, Dr. Ashish.
Also present the next case. Please.
Sided, this is the area of the Veru, and this is the area where we have done the lobe with a part of the median lobe. So in this case, what I found was that doing a truss biopsy is not a good idea because there are multiple holes and all of them are actually bleeding. So not a good idea to combine the both approach. If this was the case with an anterior fibromuscular stroma in a TZ zone, I would have just done a enucleation rather than do a biopsy in this case, because it is the biopsies wherever they have been done, they are causing some amount of bleeding and it annoys the surgeon a bit. Regarding the procedure, I usually do a top-down approach. So basically, when I put it like this, you can see now the laser fiber is coming at 12. So when it is coming at 12, in a 30-degree, you get a very wide vision. You change it when you are at the region of the bladder neck. Regarding the store's vision also, the flicker is there even with this advanced machine. I feel the previous the CCD cameras were better, where there was no flicker with the laser fiber. So we will be continuing with the other lobe, and any questions, I'll be more than glad to answer.
Sir,
them.
do you
Dr.
feel,
Ashish,
sir, you are using TFL laser? Are you experiencing any charring effect? Because we
So
don't.
the charring effect is always there because it is a continuous laser. It is purely cutting laser. So any laser which is going to cut will have some amount of charring. Holmium does not cause charring because it desiccates the plane. If we touch the area, then there will be charring. If we are not cutting it in a pure cutting way, the charring will be less. So yes, definitely the charring is more when there is a thulium laser.
So can you show us where you are exactly right now? The left lobe has been taken.
Yeah, so this is the left lobe. This is at the bladder neck.
Bladder neck, yes. And
So this is the area of that's the Veru. Okay.
Okay.
So we are just at the bladder neck.
And the right lobe and the part of the median lobe is still there.
Yes, it is still there.
Okay.
Okay.
Thank you. We'll continue watching Dr. Ashish. In the meantime, we'll present the next case and then we can continue with the lecture.
Good afternoon, gentlemen. So I'm presenting the fourth case capsule for today. He's a 68-year-old gentleman with progressive lower urinary tract symptoms, which are comprising of both storage and voiding types. His examination is grossly normal. He has been on alpha blocker, namely tamsulosin with dutasteride for past 3 months without any improvement. On evaluation, his ultrasound showed prostate volume of 64 grams with significant post-void residual volume. Uroflow had a maximum flow rate of 3.3 ml, and this was the pattern. His PSA is 4.4. His rest of the blood and urine workup are normal. So he's diagnosed with benign prostatic enlargement. He is diagnosed with benign prostatic enlargement with failed medical management. And this case will be performed by Dr. Rohit Joshi. And the surgery is holmium laser enucleation of prostate. Over to you, Dr. Rohit Joshi, sir.
Everyone. Hello.
Yeah, Dr.
Yeah,
Rohit.
hello everyone.
Yes. Yeah, you are audible and visible.
Yeah, Rishi, can you hear me?
Yes, we can hear you.
Okay, so Rishi, this is not HOLEP, this is a mini HOLEP, or we call it as a slim flap. So I would like you to see the instrument trolley here. Can you focus on the instrument trolley? To your right, this is the conventional whole lap assembly, wherein we have a 26 French outer sheath, 24 French inner sheath. Through that goes the laser working element, and there is a 4 mm cystourethroScope. This is the conventional whole lap assembly. Now, of late, because of the incidences of stricture urethra, we all try to minimize the thing. So now what we do is we use this 22 French outer sheath, through which this 19 French sheath goes inside. And then this is a small, we call it as a mini laser enucleating element. And this is a slender 2.9 mm cystoscope. So this is the mini lap assembly. So there are 3 generations of miniaturization. Firstly, there was the 26 French conventional whole lap. Then came the mini lap. But there was an issue. After concluding the enucleation part, we didn't have this kind of a...
We have lost your audio. We have lost, Dr. Rohit, we have just lost your audio. Or is it that our audio is...
instrument size. You can see this morcelloscope has a dedicated 2 channels. One is for the transmission of vision and the light source, and other separate thing.
So
Through which even the bigger morcellar blade goes easily without any problem. So with this morcelloscope, now we have a completely mini lap set. So we can do even the enucleation and subsequent morcellation using only the 22 French sheath. So all through this, the patient urethra will have only 22 French urethral sheath. So that is all about the instrument part. You can get along with your lecture, and once I start my case, I'll again draw your attention back. Thank you so much, and love to Anant Kumar sir, Pankaj Maheshwari sir, Sanyal sir. Thank you so much for this opportunity, sir.
Okay, we'll continue to watch you, Dr. Rohit. You can proceed, please.
I think as far as the medical management is concerned, we must understand that the prostatic symptoms or LUTs have a lot of subjective element. And that's the reason the responses are very variable. So we may have so many guidelines and protocols. End of the day, it's very important to evaluate that patient's need when you decide the treatment and not blindly follow the protocols. Many patients come and tell me that my urologist told me that now you are on the medication, lifelong you take these medications. I think that's where we have to be a little careful, and it's important that time to time you evaluate patient even in the medical management, and it may be appropriate to keep on changing your protocols depending on that patient's need. So I think it's very important. There's so many combinations coming in the market, so many drugs are being bombarded on us by the pharma companies. I think we'll have to take some sort of objective assessment and decide the treatment plan for individual patient. Thank you very much.
Absolutely. So we should know that these are primarily symptomatic treatments, except for the 5-alpha reductase inhibitors, where we can alter the progression of the disease a little bit. Rest all medications are symptomatic treatment, and it is always best to leave it to the patient how much of symptom benefit he wants to take and how long he wants to continue with them.
Another important point which I am realizing over the years, patients are becoming conscious about the cost of the treatment. Yes. I think 5 years ago, nobody asked about the costs, nobody bothered about it. As time I am seeing, because I think as aging population is increasing with so many medications, the cost is becoming a problem. And never ever patient asked me, can we take generic medications? That's another change which I am seeing in last few years, that people want more generic combinations because of the cost factor, which was not the problem earlier.
Thank you, sir. So we will conclude our session. Thank you, speakers and chairpersons, for an excellent session. For the next session, can we call upon our distinguished panel of chairpersons, Dr. T. Manohar, Dr. P. N. Dogra, Dr. Pankaj Maheshwari, Dr. Dheeraj Kasraneni, Dr. Shafiq Ahmed, Dr. Sudhir Devana. Dr. A.K. Sanwal, So please join the panel. So our next speaker is Dr. Manish Chaudhary. He's going to share his ideas on management options for large glands. Dr. Umesh Ojha, can you please join? So please join the panel of chairpersons.
Good afternoon, everyone, and welcome to Max Prostate Conclave. Today, I'll be talking about the management options for large-sized BPH. I'll restrict my talk to mainly the surgical treatment options, and I'll not deep dive into the surgical techniques, steps, or the technical details because we have a 2 days discussion over each modality that we have. So, starting with the large volume BPH, AUA and other guidelines have defined large volume BPH into 2 categories. One is large, that is above 80 up to 150, and another one is the very large, that is above 150 cc. Since we have so many minimally invasive surgical techniques nowadays, so surgical management of BPH has been stratified according to the size of the prostate gland. Coming to the large volume BPH, these are the options that we have in our armamentarium. Either we can use a transabdominal approach, which includes simple prostatectomy by either open, laparoscopic, or robotic approaches. A transurethral approach for large gland, it is mainly enucleation or a combination of vaporization and enucleation. Resection is out of the question in most of the cases. Enucleation can be done with the laser, like holmium, thulium, or green light, and it can also be done with the use of a bipolar coagulation and enucleation. Other alternative is aquablation, which is gradually making its space in the management of large size BPH. So let's see what the guideline recommends so far. AUA guideline says that for BPH which are more than 80 cc, the options that we have right now are either simple prostatectomy by open, laparoscopic, or robotic modalities, or laser enucleation using either holmium or thulium laser. The EUA guideline gives almost the similar indications and modalities recommendation, favoring open prostatectomy, HOLAP as the primary modalities for treatment. But they also give recommendation for other modalities like thulium laser, enucleation, even TUR resection using bipolar, but we have to take it with a pinch of salt because the size they have mentioned is more than 80. So it could be 80 to 100, we can still do bipolar saline resection, or we can still think of using a high power laser for vaporization. So that's why they kept these options also in the armamentarium. But it's better to stick with the AUA guideline with clearly defined prostate 80 to 150, 150 and above, and the guideline recommends either simple prostatectomy or using enucleation with holmium or thulium. So starting with simple prostatectomy, I will not go into the technical details. We have all learned the procedure over last many years during our training. We know it is done by 2 approaches, either transvesical or capsular approach, that is totally extraperitoneal. And in both the approaches, we have to enucleate the gland, sticking just inside the capsule, and at the end, we just trigonize or try to reepithelialize by bridging the defect, bringing trigone close to the urethral epithelium. The drawbacks of this technique is that it is the most invasive of all the modalities used for treatment of large size BPH. It causes considerable blood loss with a transfusion rate of 7 to 14% in different studies. It increases the hospital stay and has prolonged recovery time and catheterization time. The open prostatectomy has remained the traditional gold standard, but in the era of laser enucleation, the gold standard has changed. Even the EUA guideline recommends that if you don't have option for endoscopic enucleation, then you can still consider open prostatectomy as another gold standard or as the treatment of choice. There is strong recommendation from EUA. But we have to see that it is only in the absence of laser enucleation. So far laser enucleation remains as the current gold standard. So coming to the minimally invasive simple prostatectomy methods, there are either by robotic modality or by laparoscopic. I'm not going into the laparoscopic because gradually the laparoscopic has been taken over by robotic because of the ease of performing this procedure. So I'll stick with the robotic assisted simple prostatectomy. Robotic assisted simple prostatectomy, also called RASP, was introduced by Dr. Sotelo from California in 2008 when he described this procedure. Using a 4-arm conventional Da Vinci robot with 6 transperitoneal ports, with the use of endorist, he demonstrated that taking sutures, controlling the vessels were much easier than doing it laparoscopically or by open methods. The advantages over open surgery was less intraoperative blood loss, ergonomic advantage, familiarity of the most urologists with the robotic radical prostatectomy, because radical approach was first introduced for robotic surgeries, and later on we have taken over simple prostatectomy also with the use of robot. That's why it has a shorter learning curve, because most of the robotic surgeons already are doing robotic radical prostatectomy. The approaches for RASP are the standard transvesical, also called Freyr's approach, transcapsular that we know as the Millin's approach, and a modified Freyr's approach. The standard transvesical Freyr's approach uses the approach either from the dome or posterior wall of the bladder. We open the bladder, take either stay sutures or use the ports to hold the bladder open, and then give incision around the bladder neck, enucleate the gland, and then resuture the defect, just like the trigonization we do in the open surgery. In the modified approach, we open directly at the bladder neck, and we perform the surgery almost similar to the radical prostatectomy, except that we don't go beyond or behind the capsule or up to the SVs. The minimally invasive simple prostatectomy has been accepted as one of the new guideline recommended standard of care for large prostate, but they have also recommended that more RCTs are needed to compare it with the enucleation modalities. Comparing robotic assisted simple with open simple prostatectomy, the meta-analysis and systematic reviews shows that the RASP carries similar efficacy but shorter hospitalization time, less transfusion and less complication rate, and has better perioperative outcome and equal functional outcome compared to the open surgeries. There are many, the new change in the robotic simple is the introduction of single port robotic simple prostatectomy that was introduced by Dr. Jihad from Cleveland Clinic in 2020. The advantage of single port over the traditional in these cases is that we can do it even in the supine position, even in patients with hostile abdomen, multiple previous surgeries. This can still be performed because it is totally extraperitoneal. Reaching up to that area is easy because we are using just inflating the bladder and putting the ports directly inside the bladder. They have shown that it is technically feasible, but still we need head-to-head comparative study between the multi-port and single port to prove whether it is better as compared to the extraperitoneal or transperitoneal multi-port procedure. Coming to the enucleation procedures, in the lasers, holmium and thulium has already proven their role and are current gold standard, which are size independent in the management of BPH. There are other modalities also in the transurethral approach like bipolar enucleation or green light vapor enucleation, but they are not the gold standard. So I'll just talk in brief about them. Transurethral enucleation has been compared with the open simple prostatectomy in multiple trials, and the systematic review shows that transurethral enucleation can be performed effectively and safely, and the functional outcome are comparable to open prostatectomy, and the morbidity is much less. Coming to HOLAP, it was introduced by Dr. Peter Gillen in 1998 and has proven to be the true endourological alternative to open prostatectomy. It is a pulse mode laser with cutting effect by vaporization. The challenges initially were mainly the steep learning curve, which caused prolongation of the procedure and increased the complication. So to decrease the learning curve and these challenges, different modifications has been advised, like switching from 3-lobe to 2-lobe or en-bloc technique, using high power or low power laser, using the Moses technology. These are just refinements to decrease the complication, decrease the learning curve, and improve the functional outcome of these patients. Moses, we had a discussion in the morning, so I'm not going into the detail, but this is a systematic review that shows that Moses has a better enucleation efficiency as compared to the standard laser. So maybe in future it may take over or replace enucleation for large prostate glands. This is just to mention, like, so far we don't have any head-to-head comparison between robotic simple and HOLAP for large or very large prostate. There are mainly either retrospective studies or some short-term comparative studies. This was one of the studies conducted by us last year that showed a propensity match analysis for large size prostate that showed similar outcome of HOLAP as compared to robotic simple prostatectomy. But the caveat of this study, it was a propensity match. So in the propensity match group, the median size of the prostate was hardly 110 grams. So we cannot say for very large prostate it holds true or not. Thulium is another laser modality that can be utilized as another gold standard, which is size independent for the management of large size BPH. There are studies showing thulium to be equally efficient to holmium and open prostatectomy and can be utilized for large size BPH management. This was another study comparing the match pair analysis between open, robotic and thulium laser enucleation and comparing HOLAP with THULAP. Based on the results of these study, the vapor enucleation of the prostate using thulium has been included in the EAU guideline and is considered as a safe option for large size prostate management. Bipolar, I'm not going into the detail because it gained initial popularity, but gradually with the presence of other better laser alternatives, it has not remained the procedure of choice, and very few people are actually doing it because we have better options like holmium and thulium laser. This was one of the study comparing it with the open prostatectomy, in which they showed equal functional outcome with the shorter catheterization and the time and the hospital stay. Similar to that, green light laser vapor enucleation, it is just to mention because it is still not the standard of care nowadays because we have better lasers. But this was one of the randomized study comparing green light vapor enucleation with the bipolar resection and with holmium, and they found efficacy was similar, but retreatment rate was higher for bipolar resection and green light vapor enucleation compared to the holmium. Aquablation it's not a new modality, it's been there for almost like 5 years now. It started with aquabeam and gradually changing over to the AI developed newer models. The advantage of aquablation is it is another prostate agnostic modality which is independent of the size and can be used even for large size gland. It uses hydrodissection principle that ablates the gland, leaving the capsule and the vessels preserved. It uses simultaneously transrectal ultrasound and a cystoscopic assistance to plan and guide the surgery so as to prevent the complication and even to preserve the posterior strip of the urethral mucosa over the prostatic area, just to improve the functional outcome, decreasing the anejaculation and retrograde ejaculation of the procedure later on. So the outcome of aquablation, water 2 5-year study trial is available now that was used for large size prostate gland. It has shown that it has very low anejaculation rate compared to the other modalities. The retreatment rate is hardly 3%, and it has shown good functional improvement in terms of the improved Qmax and improvement in the IPSS symptom score. This is an ongoing study, Water 3 study, in which aquablation has been compared randomized in a randomized manner head-to-head with the transurethral enucleation procedures. So far we have a 3 months data only available that shows good functional outcomes, similar symptomatic relief compared to the HOLAP, but lesser ejaculatory dysfunction and lesser stress incontinence. And this is another newer version of the aquablation machine that has been launched recently. This is AI-powered robotic platform for aquablation. This helps in a proper mapping of the gland and giving an individualized treatment based on the size and shape of the gland. So in short, the key takeaways out of this discussion is that so far laser enucleation stands as the size independent option for management of large volume BPH. Robotic simple prostatectomy has already proven its place in the treatment recommendation for large size BPH and especially useful for patients who are having associated stones or diverticulum or need any additional abdominal surgery. The single port robotic prostatectomy, Moses HoLAP, and aquablation carries the future potential for better surgical outcomes and functional outcomes in patients with large volume BPH. For very large prostate, whether to go with HoLAP or robotic assisted simple prostatectomy, it is still debatable, and we have this debate today in the afternoon, so I'll not pitch into this discussion further. But in short, it is the surgeon or the man behind the machine more to play the role than the equipment itself to decide which is the best modality to use. Thank you.
Thank you, Dr. Manish. That was a wonderful compilation. I think Dr. Rohit is waiting in the OT. We'll first go to him, and then if there are any questions, we'll take them.
Sure, thanks.
Can we join Dr. Rohit's OT?
Please connect
Pankaj,
to
sir.
OT10.
Yes, Rohit.
Yes, sir. Hi. Once again, pranam, sir. Whatever I'm doing today is all because of you.
Rohit, Dr.
Thank
Manohar
you,
here.
Rohit.
Yeah, hi, Manohar. So, see, first of all, I would like to focus on this instrument, the exterior view. Let us forget the interview. The exterior view shows now this is a laser working element. Now, Dr. Anil Vashni is a fond of laser bridge. Now, when I started doing enucleation in 2011, initially I found it extremely difficult to use that laser bridge. So then I thought about something different because we all are doing TURP right and left. So we somehow devised at that point of time an enucleating element, and this is the enucleating element. Now this has got can you focus on this blue, can you see this blue thing?
It's a laser bridge.
This is a pinch cock action
stopper.
wherein, you can stabilize the laser fiber. Now, if you are using laser bridge, you do not have anything to fix. So you have to hold the fiber with your finger and your thumb like a pencil. So your entire right hand is occupied with that. Here, nothing like that. So it gives us two things. Number one, it gives us a familiarity of using the working element the way we are using in the TURP. Second thing, it gives us a play. See, now I can stay here and extend my thing right up to there. So this is a play which I am getting by using this enucleating element. So if I want to cut it, like in single go, I can cut it here without advancing the scope. So it minimizes the sheath movement within the urethra. So that again helps a lot. And I have got one more thing to show. Can you see this RIRS adapter attached here?
Yeah, we're able to see that.
Yeah, so normally what happens is there is that washer is there, and we introduce the washer, fiber to the washer, and there is a lot of fluid leaks out, and it is right at the level of the camera. So there is a lot of fogging issue. So I have a little longer adapter, but these guys have a smaller adapter. But even then, it serves two purposes. Number one, once we introduce the fiber, we advance only 2 millimeter tip inside, and then we fix. This is a rotating mechanism, so it remains fixed there. So it remains fixed at two places. And second thing, it reduces the water movement. So this is all about the equipments. Now looking at the prostatic configuration inside, see, it's a very, very classical median lobe. Usually in median lobe, either there is one groove or there are two grooves. So whenever there is a one groove, we incise that groove and shift that median lobe to the opposite lobe. But when there are two grooves, it is better to do it separate median lobe enucleation, so that initially there is a lot of space happens and your irrigation fluid movement improves and your vision improves. But before that, we have to mark the ureteric orifices. This is the left one, this is the right one, though it's not a very big median lobe, but it's always better to mark them. Second thing is, I have only two approaches for the HoLAP. Either it can be an X approach, wherein our incision starts from the ureteric orifice, reaches up to the colliculus, and then it sweeps laterally. So this is the one limb of X, like this, and then the other side there is one more limb of the X. So we start at the orifice, we reach to the colliculus, and then we sweep laterally. For example, if there is no median lobe, there is a flat bladder neck, then we would have done is an Y approach, wherein there is a midline 6 o'clock incision, we reach up to the colliculus, and then we diverge on right and left side. So that is called as Y approach in absence of median lobe. And when there is a median lobe like this, we use the X approach. Lastly, we always tend to preserve this 1 centimeter tissue in front of the veru, which is supposed to be the colliculus. We don't guarantee that there is a ejaculation going to be preserved, but we always make it a point that we preserve this particular tissue. It helps us in two ways. It gives us better ejaculation preservation, and the veru is always protected. So we don't have to always look at the veru. We can always look at this as a separate landmark.
You can start
so
and
now
explain.
So Manohar, any questions, or I'll start with the
You start, we'll ask you then.
Thank you, Manohar, thank you. Yeah, ready.
Thank you. Now we have a brief but important industry-sponsored talk, Refining Urology Visualization, 4K in Laparoscopy and Endourology, powered by Pendulum Design and Laser Shield Safety, by Mr. Kudus Khan.
Hi, good afternoon, everyone. To the esteemed panel of chairpersons, to Dr. Anant and Dr. Desai, thank you so much, on behalf of Stryker, for giving us this opportunity. So I would like to talk about the 4K visualization in lap and endo-uro, powered by Pendulum Design and Laser Shield technology. So today I would like to introduce, Stryker's most sophisticated surgical visualization solution to date. A 1788 platform, a powerful ally in minimally invasive surgery, which is relevant, for across surgical domains. It's the only visualization system which is available and has a dedicated 4K camera for lap and endo-uro, which is available right now in the market. 1788 is the 21st generation video platform launched by Stryker since 1985. I mean, this platform was launched just last year, and this is the 21st generation of video platform. A very quick high-level overview of what we are doing in urology as a company. So we have launched a platform which has a feature and a mode for urology. Then we have recently launched just 3 months back a pendulum camera 4K visualization, and in next 6 to 12 months we have a plan to launch rigid scopes for urology, flexible scopes for upper urinary tract therapies, and lastly we also have a plan to launch a fluid management system which has an application in urology and gynecology. A very quick overview how it works. So we have 3 important aspects, which are included in pendulum camera. One, there is a brake, okay, for the, to prevent the scope rotation. There is a knob, for which helps, for focusing, of the image. And the third one is the coupler, which gives, power or, complete control for the operating surgeons, to do, take, image, capture image, or, capture the video while doing the surgery. They don't have to depend on any assistant or a person, who has to do it on console.
Excuse me, can I interrupt you here?
Yes.
Regarding that pendulum, you said that laser shield is done, but as far as I know, the scientific basis of putting a laser shield, you cannot put a pendulum. It has to be fixed. Initially, when it started, they inventing the laser shield, it should be stable, it should be straight.
Yeah.
When you have a pendulum, I think the rotatory moment, the laser shield will not work. Is it compatible?
No, it is compatible. You can see
because
in the image.
When Sayani was doing it, he was also mentioned there was some lines were coming.
Yeah.
This is with the 30 watt.
Okay.
If you use more than 100, I think bigger lines will come. I mean, only 1188 was the one which was compatible in the Stryker.
Yeah.
Even 4488 had showing a lot of lines. But I don't know about this, but pendulum is scientifically against the principle of putting a laser shield.
Okay. So, sir, if you see the the slide which I have right now and here you can see there are 2 videos simultaneously being played. Just let me go back and excuse me. Can you go to the previous slide, please, and then come back? It's not moving. No. Yeah. So in here you can see, you have both, one video with the, laser shield off and one with the laser shield on, wherein you will not see any flickering effect. And that is the advantage of pendulum camera. So as, Dr. Saini was just, referring, in the previous discussion when he was showing the surgery, he talked, or he preferred, he said that he would have preferred a CCD camera. That, that technology is obsolete now, but as the technology has advanced, the challenge of flickering, has emerged. To solve that problem, when, Stryker has launched this product. So pendulum camera, as I said, it was launched just 3 months back, It has been used, in last 3 months by more than 35 urologists. More than 100 cases have been performed endo-Europe procedures. And these are the, predominantly 15 procedures where it has been used by the surgeons. I'm really fortunate, Dr. Kalyan Sarkar here, he's sitting with us. He's one of the distinguished surgeons, who has used pendulum camera in the initial stage of voice of customers when we were doing, or evaluating the product. One more feature, which is in 1788 is called cyan spectral imaging. This is basically, some of you must be knowing, the same technology by narrowband imaging. This technology actually helps surgeons, to provide visualization of, vasculature. And it is also, by AUA, it is recommended that this technology should be used in patients, who have non-muscle invasive, bladder cancer. So just to summarize, very quickly, 1788 platform with pendulum camera. It's the lightest camera, 4K vision with 4K visualization with the laser mitigation technology. The weight is less than 450 grams. There will be no eye strain for the operating surgeon, due to flickering effect. The surgeons can perform the surgery, endo procedure, while seated comfortably, which is very convenient, in the long procedures. The pendulum design enhances maneuverability, visualization, and procedural efficiency. And lastly, the application of CSI, which helps surgeons, to have a visualization of vasculature for enhanced cystoscopic technique. Thank you.
Thank you, Mr. Kudus.
Okay. Can we take any questions related to the large prostate gland management? Is there a time? Is there any next talk being go to?
I think we will move to the next debate, sir.
Debate.
Yeah. We now come to one of the most awaited and exciting sessions of this conclave, our special debate. The topic is one that sparks passionate discussions in urology corridors worldwide: HOLEP versus robot-assisted simple prostatectomy for large glands greater than 100 grams. Today we will hear from two masters of their craft, each with decades of experience. Speaking in favor of HOLEP, we have Dr. Anil Varshney. Arguing for the robotic approach, we have Dr. Anand Kumar. Dr. Anil Kumar Varshney. Over to you, sir.
Good morning, friends. Really, I am privileged and honored for this opportunity Dr. Anant and his team has done. And why the debate? I had 20 years back a debate on HOLEP versus TURP, and the debater against me was Professor Rajiv Kumar. And since then we are having debates, HOLEP versus green light, HOLEP versus thulium fiber, HOLEP versus THULEP. Well, this process of debates basically ignites the young mind that what is best. And we have to understand that how we have to improve the outcomes without rendering a lot of burden on a patient. So if we look at HOLEP, it's a procedure in existence for more than 25 years. We have stalwarts like Pankaj Maheshwari, Dr. T. Manohar, and Dr. Dheeraj sitting over here, and even Dr. Anant Kumar, who is himself doing HOLEPs. Now comes the question that there are multiple RCTs supporting its weightage. There is a strong evidence, well established for large glands. Coming to robot-assisted, it's making entry into the arena of large glands. There are few RCTs, weak evidence to support, and definitely needs more literature. Now question is, RASP at what cost? If you think cost to the patient, we have to compare safety and efficacy parameters in both modalities. Urologist, technical know-how, certifications, institutions. How many institutions have such technological advances in view of its high cost? If you look at the guidelines, the evidence is weak in support of RASP, and the guidelines offer laser enucleation of the prostate using holmium in men with moderate to severe LUTs. With large prostates, strength rating is strong. So friends, we have sufficient literature supporting efficacy of HOLEP. We have personal experience in large glands and literature which is definitely comparing efficacy and debating RASP, but where we stand as far as the literature goes, it's demonstrating its efficacy and significant improvement in post-operative functional outcomes in patients with prostate volumes across large to very large glands, more than 175, 200 and even 300. So literature is now full of the evidence which supports HOLEP. And this was as long back as 2010, we had 23 RCTs which were comparing various modalities of prostate enucleation, and out of them HOLEP came out as a time efficient procedure where we could compare it. And we could do HOLEPs. Now we are debating whether we have other methods, because open prostatectomy has always been a benchmark. But with HOLEP, if you are patient and perseverant, you can remove very, very large glands also. The question is not HOLEP versus RASP, question is safety. Now, where are the contraindications? Contraindications for RASP, because how HOLEP fares much better at every point where RASP can't be done. So, there are patients who are on strict anticoagulant. We do HOLEP in patients on acetrom and all newer modalities, modifications to reduce stress incontinence, stricture, because I am sure Anand Kumar sir is going to talk about stricture urethra, stress incontinence. But we have now modalities, and we have been improvising all these 25 years to counter. And then now we have ejaculation preserving techniques, newer Moses technology, newer lasers like thulium fiber laser and all. And definitely the contraindications, if you think of the robot assisted, is definitely advanced age. You cannot put them in severe Trendelenburg positions. Severe comorbidities are a contraindication. Extremely large prostate, very difficult to handle if you have 500-600 gram prostate, even with robot. And patients who have had previous extensive pelvic surgery, multiple abdominal surgeries, definitely the access is challenging. And we have done HOLEPs soon after MI, soon after PTCAs. But can you do it? No surgeon would recommend, and RASP is definitely not possible. But HOLEP is possible if patients who are above 80 years, critically ill, on antithrombotics, and it's a procedure for prostate glands more than 200 cc, feasible with minimal morbidity. So friends, if we look at RASP, I am sure Dr. Anand Kumar is going to counter it. But if you have venous plexus injury, we have had conferences and a lot of venous plexus injuries. We have seen capsular perforations in large glands with distorted anatomy. Bladder injury is also possible during anterior bladder and posterior bladder dissections. Ureteric orifice injury, if you are not careful in dissecting during robotic median lobe, large median lobe enucleations, and conversion to open is also a point. But there are intraoperative complications like hematuria with clot retentions, urinary leakage or fistula formation from vesico-urethral or capsular suture line, urinary tract infections, deep vein thrombosis and pulmonary embolism. And sepsis is a very, very big risk in high elderly patients. And this is just what I am talking, as recently Pragnesh said. We have large experience now, more than 10,000 cases, and we are doing practically 50% of these cases on anticoagulants. And these are my experience on large glands, more than 1,500 cases. And I am sure that these could be managed safely. We have never had to use blood transfusions except for just few, 0.4% is the incidence. And the point I am sure Dr. Anand Kumar is going to talk on is stricture and stress incontinence. So friends, urethra has to be friendly. That, let us make it bottom line. If you are accesses through urethra, you have to have a capacious urethra where you can use all kind of maneuvers. But I am proud to say that we have Professor Philip, who invented 22 and 18.5 French scopes, So that is not a challenge. And now sufficient literature, I have been talking about it for 20 years now, but we have sufficient literature to support prevention of stress incontinence and early apical release, as I demonstrated just now in the morning, that prevents ejaculation preserving. And as I told you, Moses has come just to shortage of time, but same-day discharge and same-day trial avoiding success is feasible with MOLEP efficiency. And if you look at efficacy, now literature is coming up, which is showing HOLEP as efficient as 1.28 gram per minute versus 1.06 gram per minute. Perioperative complication rate 15.5 for HOLEP and 26% for RASP. And operative time have also been compared. So I'm saying that literature is adding up. But where is the problem? Problem is in the learning curve. There is a very steep learning curve for enucleations, and I'm proud to say that a lot of masters are now coming up, and learning of RASP is also not less. You need 20 to 40 cases, initial phase, intermediate phase, and proficiency phase, and training, learning, credentialing challenges are there in RASP there. So question is, bottom line is, HOLEP can be learned in moderate sized glands, but getting numbers of patients for RASP in initial phases of learning can be most challenging part. And more important than that is the reach. Laser installations more than 2,000 in India, cost 50 lakhs to 1.5 crores. Robot installations around 500, cost 5 to 20 crores. Robotic systems inaccessible in tier 2 and tier 3 cities where leisure has reached in good numbers. Challenges in robotic surgeries, cost, maintenance and consumables, limited haptic feedback,
Sir,
and equipment downtime. I'm just taking one more slide. Operational and institutional setups, infrastructural requirements, and economic and accessibility concerns. So evidence is tremendous, and this is just comparing HOLEP versus RASP. Lot of publications are coming up which are proving beyond doubt the time taken, the hemoglobin loss, transfusion rates, everything is favoring HOLEP. So friends, this I conclude that both HOLEP and RASP are highly effective for large prostate. So I don't have any debate on that, but HOLEP is preferred in experienced hands for its lower morbidity and quicker recovery. RASP is an alternative in centers where robotic infrastructure with high volume cases and expertise is available, but is robotic availability at every center an utopian dream? At the moment it sounds so, maybe after 10 years we may have a different thing. So with folded hands, I invite my opponent, Dr. Anant Kumar, for
Sir, you'll need to wait for a minute, sir. We'll just go back to OT for Rohit is about to finish. You see, that's a biased umpire for you, sir. We are not even allowing you to speak. Rohit, we are back to you.
Hello?
Yeah, Rohit.
Yeah, sir, this is, we started at 12:45, it is 1:03, 18 minutes have gone. What I have done is I have enucleated the median lobe and placed it in the bladder. And these are the ureteric orifices very well away from our line of enucleation. And now I have, this is the left one and this is the right one. And now I have gone from both the sides below upwards. And you can see the most difficult part you will understand is to incise these flaps. So now what I have done is I have mushroomed these flaps. So this is the apical tissue which I have mushroomed. So now it is only from 3 o'clock to 12 o'clock and 9 o'clock to 12 o'clock. So I have actually gone inside below that and I have separated the entire adenoma from both the sides. So now I am further mushrooming it, and then under vision, proximal to the veru, I will incise both the flaps. So the moment I incise the flap, the entire adenoma becomes free from 12 o'clock, and then I can just enucleate like the way we do with our fingers. So this is the important step for any novice, how to incise this and how to narrow down this. Many people start marking at the beginning. So if we start marking at the beginning, once we get beneath the lobe, now you see this is the lobe, this is the capsule. Can you see, sir?
Very well, Rohit.
So this is the lobe and this is the capsule. So now we get beneath the lobe and then we are in the correct plane. So that's how we can narrow down the flap.
So the capsular plane is absolutely perfect.
Yeah, and this is the flap which we need to incise under vision.
Yes,
That's
yes.
all. This is the most difficult part, but it has been made very easy by this getting beneath the lobe technique, sir.
Absolutely, well said.
Yes,
Can
sir.
we just go to the other OT for
Sure,
also
sir.
for a minute, please?
Sure, sure, sir. Thank you, thank you.
Should we go to Dr. Saini's OT for a minute?
Yes.
Dr. Saini, you want to make any comment before you finish?
So yes, sir, we are about to finish. So I'm using a black Piranha morcellator by Intercardia, and it is working very well. It has a side-to-side movement, and so the morcellation part is very quick in this.
Yes, the
And,
oscillating morcelloscope seems to be working well. Your vision is
Yeah.
clear, so you have achieved good hemostasis. Yeah,
So-
thank you very much, Dr. Saini. I think it is a wonderful job.
Thank you, sir.
Thank you,
Thank you for
Dr.
having
Saini. Sir, you could now take over.
Yeah, we all know that Dr. Anil Vashne is a giant in HOLEP, and I think only he can do 640 gram of prostate, and I think anybody else, I have not heard that who can do such a big prostate with the laser. And but there is no doubt he has a lot of experience, and he was the one who showed all of us how to do HOLEP prostatectomy. But the time has moved. Now if you see the prostate, big prostate is stuck like that, how to take it out? It is easier to pull it out from the above. And now if you see this kind of the gland with the medial lobe is filling the whole of the bladder, and how will you see the ureteric orifice in laser? You cannot. You are looking from the other, you cannot look from through the hill down below. When he was saying that you can cause ureteric injury. In the robot you go there, you lift it and you will see exactly where is the ureteric orifice. So, and such kinds of medial lobe is not unusual. See, gland up to 100-150 gram, we also do the laser. Our limit to go for radical robotic simple prostatectomy is over 150 grams. And from over 150 gram to 300 gram, I have not done 600 gram, but we have done up to 300-350 gram of the prostate. And it is very easy, easier to do, and which will show not only the what we feel, but what the literature says. So it was all the guidelines says if the gland is more than that, you do the open prostatectomy. And I think till 10 years back we have been doing open prostatectomy, and I have done many open prostatectomy with millions prostatectomy. This was my favorite operation because you can control, do good hemostasis there. But bottleneck of the open prostatectomy is a blind procedure. You put your finger and you start tearing everything. So sometimes if the tissue is lot of fibrosis for some reason because of the previous chronic prostatitis, you might do some damage and you might pull out something else also if you are not very careful. And we all have seen there has been bleeding, because we have started our career in the open prostatectomy period, and there was not procedure. We'd have to pack it, and the pack used to remove 24 to 48 hours, and we have seen patients who have been bleeding, require bilateral internal iliac artery ligation. At that time radiological embolization was not there, and we have done a lot of procedure, and still we have seen patient dying of the bleeding with the large gland, and there was high morbidity and patient used to stay very long. But things have changed nowadays. So the typical indication for robotic assisted simple prostatectomy is large gland, as the guideline says. Big median lobe lying into the bladder is another procedure. We often see there is a lymph stones. You can take care of it. You can just pick the stone and take it out. And diverticulum, we have done many procedures, simple prostatectomy as well as the diverticulectomy in the same sitting. Anticoagulant, HOLEP you can do if the patient is on one drug. If the patient is on two drugs, these patients bleeds, and we have seen it, and this happens unless you are using the green light laser. And thulium laser is better in comparison to holmium laser if your patient is on two anti-drugs. And if patient is acetram, Homium is impossible because patient will bleed. And you know that robot has got all the advantage. I don't want to repeat it to show it that yes, it is very good. And one thing is good, you can see the virumontanum, you can see the ejaculatory duct. And we have shown in conferences that you can go there and come in such a way that your ejaculatory duct and that part is spared. So you can do that, but in a very large gland, after that there's so much things to remove that you don't know where are those ejaculatory ducts coming and joining them. So there is a better identification of bilateral ureteric orifices. If there is any other cause in that field, that you can take care of it. And one good thing is that there is a pneumoperitoneum, so we don't see that kind of bleeding which we see in open operation. And even if we see there is a bleeding, immediately as your magnification, you are seeing a magnified view, you immediately coagulate. So there is a bleeding comes and you coagulate. So the bleeding stops. And then you can do tricolonization, you can do the whole reconstruction of urethra to the bladder neck. And then you can put the catheter, you may not need any irrigation and you may not need, and patient can go on the same evening or 1 day later, 2 days, depending on that. Now these are the studies published, these are the latest studies. These are not the old studies which were shown before. And you can see it, this is the one study which shows the trifecta, and its trifecta is that patient should have Qmax more than 15 ml, ISP score should come down to less than 8, and there is no complication. And if you see that it has been possible to achieve this trifecta in 56% of the patient in robotic simple prostatectomy and only 33% in HOLEP. And surgical approach was the only independent predictor of trifecta success. And this has also been seen that clot attention and bleeding is more common in the HOLEP, and then UTI is more common in HOLEP. See, if you are doing large gland, you are staying there in urethra for long with the bigger scopes, and then you are going to rape the urethra with the marcelloscopes, and then the marcellation is also going to take a lot of time, even a large gland. The equal time as you have removed the gland. So urethra is injured and stricture rate is quite high, and that only thing troubles me TURP laser prostatectomy is the stricture urethra, and it is more than what is reported in the literature. In Indian population it is more than, Indian urethra is less than Western urethra, and this problem is quite common and underreported. And bladder neck stenosis is also happens of the laser prostatectomy, but in robotic simple you reconstruct with the mucosa to mucosa, so bladder neck contracture is not there. So you can do urethral sparing surgery with robotic simple prostatectomy. You can preserve the ejaculation in a robotic simple prostatectomy, and these are the techniques which have now been shown that you can use the Firefly technology. You can inject the ICG into the urethra, and you can know where is the urethra, and then you can remove rest of the prostate from there, and you can preserve it. And these are the techniques have been published. And this is another paper from the Korea which has showed that simple prostatectomy has less complication than in comparison to the HOLEP in a follow-up. And see, the learning curve has been debated, but robot has got very simple learning curve. Within most of the people I have seen, our fellows and everything, with 5 and 10 cases they can start doing the complex cases. The HOLEP, even I took more than 50 cases to learn it, and I taught 2 more colleagues. They also took at least 50 cases to have reasonable experience with the HOLEP. And I have, I don't want to name the people, but worked with me who have been very well known for doing HOLEP before they joined me. And I have seen they have done 200 grams, 250 grams. And I know what was the incontinence rate. And we are in the same city, and we have seen patient with large prostate gland and the HOLEP coming back with the incontinence and severe degree of stress and incontinence. not 1 month, 2 months, about 9 months and 1 year. So there is a significant stress incontinence and incontinence after the HoLEP. Larger the gland, higher the incidence, because there the whole thing is falling down, and then such a big gland is pulling into the bladder, and that is pulling the sphincteric complex, and then you are trying to cut it. In simple prostatectomy, that is not the problem, because you are looking antegradely and you are inside the prostate. No dorsal vein bleeding, because you are inside the prostate, inside the capsule. You are not outside the capsule. Nerves are outside. You are inside the capsule. From inside you are looking at this and dissecting the apical lobe. So, and this your fourth arm helps us in doing it, and you can take multiple sutures to pull it down. So your anatomy becomes very simple. You can see and you can control it. So all these, they do not come in your way. So it is easier to learn, simpler to do, and this is another paper which showed robotic assisted simple prostatectomy and homium comparison, and the many other advantage which I have showed, that they have also showed that you can do remove bladder stone quickly, larger stone quickly, diverticulectomy, ureteric reimplantation, and larger gland. Now it has become the preferred procedure, and then this says that it cannot be done. When the patient who have the glaucoma problem or those who do not want to go into Trendelenburg position, we do in flat position. You can do extraperitoneal. We do radical prostatectomy in extraperitoneal position. We do simple prostatectomy in extraperitoneal position. And those patients who are very moribund, had multiple morbidity, will also have same problem with the HoLEP. There also, and there you have to make a lithotomy position. Here you don't have to make lithotomy position. Many of the old patients you cannot make lithotomy position because of there is a knee joint and hip joint problem. But that all this, here you do the procedure in the flat position. So all those contraindication, everything is not there, and those, if you cannot operate with the robot, you cannot operate with the HoLEP also in such a moribund patient. So those patients will be left on SPC only. And the most important thing, this is very, very underreported, is urethral stricture after any transurethral surgery. And here you just leave a catheter, that too, 18 French catheter. And if you do the whole reconstruction, this once the prostate is out, this is the urethra, this is the bladder neck, you can join the prostate with the bladder neck. And the prostate, the dara areas are now all excluded, and catheter is there, you can irrigate it. Or you can do this only trigonalization, and then all the bleeding has stopped, and then you can put a catheter, maybe just precautionary, you can put the irrigation. And the urethra is not raped, so there is no urethral stricture. So this is the, you take a Dwarka expressway after the simple prostatectomy, and that is the narrow lane. You have a big posh car because you are using laser, but there is no place to go, and the urethra gets stuck. So in a patient perspective, small incision, robotic appeal, modern tech perception, many patients prefer single definitive precise surgery. Robotic approach inspires higher confidence in all patients. Reduce risk of long-term urinary complication, improves patient reported satisfaction. No incontinence, no urethral stricture, no bladder neck contracture. Limitation of HoLEP is long learning curve. Morcellation takes equal time as the procedure in large gland, unless you give a small incision and take out from the suprapubic region. Perforation of the large gland, perforation of the bladder wall during morcellation in very large gland is very well reported. People have even sucked the bowel into the morcellator and morcellated the bowel also. Urethral injury is also quite common in laser surgeries. Bench ball effect is also very well described if the patient had some degree of fibrosis or they had operation before that. And it is a difficult procedure. Believe me, if the gland is more than 150, for most of the patient, except few gifted people who have been doing for last 25, 30 years, otherwise it's not possible by most of the people. Sphinctering injury is common, incontinence rate is higher than reported, and it is not reported. Ergonomically, it is an inferior procedure. and there is a higher reintervention rate, and urethra is injured, stricture rate, bladder neck contracture, all are quite high. And so if you do the large gland, you do one procedure, it is a problem, you couldn't remove the whole gland, you do the second procedure, and when the patient develops stricture, no money is left. So it is not a very economical procedure. The patient spend a lot of money in the whole procedure also. So my closing argument is robotic assisted simple prostatectomy for more than 200 gram is the best procedure. It's a very precise, you can control all the bleeding. Ideal for the large gland and complex cases, very short learning curve, ergonomically superior. Now that there is a more than 350 robotic installed all over the country, and next 10 years every theater will have some kind of robotic platform, and all these procedures will be done, most of the procedure will be done robotically. It offers and I have seen one is that after robotic simple prostatectomy patient uroflow, you see it and you love it. It's just like a child passing a urine. Patient satisfaction is very good. Urethra is spared, continence is preserved, bladder neck is reconstructed. So cost alone should not be a deterrent. And it is possible to do telesurgery. And Dr. Ravashne, please learn the robotic surgery so that you can sitting anywhere and operate in Shalimar Bagh. Thank you.
Excellent images, sir. It was a lovely presentation.
So that was quite a high energy debate, sir. So up next we have a brief sponsor talk.
Both were very heavy weights, so they both extended their time, and nobody actually, because, but it was a very well presented arguments. It was a debate. But we know that in bigger prostate, just one question about the audience. If you get a 200 or 100, even 100 gram prostate, what will you be doing? Whether it will be HOLEP or robotic, or you don't have any access to. Third option is you don't have any access, so not to talk about that. What will you do?
No, I think the question is not right. Yeah. I'm sorry to say that. Yeah. You see, up till 150 gram, I don't think there is any discussion. Up till 150 gram, if expertise is available, HOLEP is the way to go. The question will arise, do I really want to do a 250 gram gland? Can I do it? Yes. But do I want to do it? Probably no. For all the reasons that sir has said. One major advantage of robotic would be in patients where there is restricted hip mobility. And these days we get a lot of patients with restricted hip mobility. HOLEP needs a good hip movement, a good abduction at the hip. So for less than 150 gram, I would do robotic only when there is a restricted hip mobility. But up till 150 gram, I think HOLEP, and beyond that, it is a surgeon's choice. Probably robotic could be a good option.
I fully agree your point, sir. Let us say if
Sir, sorry to interrupt you. From the OR10, they want to connect. They have a closing argument over there.
Rohit,
OT10.
Which OT?
Hello, Pankaj sir.
Yeah, Rohit, please.
Yeah, sir, this is the final appearance. It was a 55 to 60 gram glands and we did it in 23 minutes. So, sir, I am with you on your comment that anything up to 150 gram, I think HOLEP is the way to go. And you see, this has the median lobe and this is the en bloc specimen of both lateral lobe. You see, there are multiple nodules here, small nodule here there is a nodule. So this kind of even difficult multinodular prostate, if your plan of dissection is perfect, then you can do a very good job. You hardly see any tissue left here. And this is the specimen which we all love to see at the end of a well-done HOLEP, sir. So with this kind of specimen, if we can get out of HOLEP, and sir, this is, remind you, 55 cc, and we could do it in 23 minutes, despite being it a demonstration case. So I think, sir, the time constraint is not significant as it has been overly kind of popularized. So the debate will remain as such, but this is the result which I could show to you, sir. Over to you, Pankaj, sir.
Rohit, you should not concentrate on the nodules, you should concentrate on the capsule and show the beautiful capsule that you have demonstrated everywhere.
Everywhere, sir.
Yes.
So that's how, if you remain
it's a
confined to the
fabulous
capsule,
dissection in a perfect plane, and really compliments to you.
Dr. Joshi,
Thank you so much, sir. Now we'll do morcellation, sir. Thank you, sir.
Yeah,
just
wonderful.
one question, whether your miniaturization has any difference other than the stricture formation which you have already mentioned?
Yes, sir, because the stricture rate, though Anand Kumar sir also has told that it is underreported many a time, the patient do not turn up to us, and I have seen in my own hands with the 26 French assembly, the stricture rate was in the tune of 10 to 12%.
But
so
other
then
than stricture, doing a
Yeah.
prostate with a smaller scope, does it make any difference or it is no difference?
Sir, basically, your incontinence rate are less because, sir, the moment you see the amount of pull which you are generating, amount of friction which we are generating at the level of the Veru is significantly less with this, sir.
So your
two
maneuverability
things.
is better. Yeah.
Yes, sir. Yes, sir. And then we are not losing anything by reducing size from 26 to 22. We are getting the same vision. We are getting the same irrigation. So why to use a bigger one, sir?
So Rohit, what are the disadvantages of a smaller sheath?
Sir, the only thing is when we are contemplating a very, very large prostate, at that time probably there will be little difference in the time, but we have done, sir, up to 220 grams, 250 grams. Overall, the enucleation time is not much different when we use the larger assembly as compared to the smaller assembly, sir.
Because you see, theoretically speaking or logically speaking, it sounds right that smaller sheath should cause less stricture. But literature has not supported this. There are many studies which have compared MyLab to standard HOLEP, and the risk of stricture is nearly the same.
Sir,
At least literature doesn't support.
Sir, see,
logically, what you're saying is absolutely
sir,
right.
Even sir, in cystoscopically also, you look at the urethra. This is not the kind of urethra which will you see if you are using 26 French, sir. So that is the kind of probably theoretical advantage. We need to publish few studies, and then we can come with some robust data, sir. Yes.
Rohit, can come back to the apex and show me the stay
Yes,
at the
sir.
level of the Veru. Just to come back and stay at the Veru.
Yes, sir.
Yeah, it is overshot there.
So this is the fossa, sir, and this is the initial attachment which I have described. And the main thing is, sir, look at this mucosa. It is well covered with this tissue. So we are not bearing the mucosa at all. So there is always little bit of tissue because of
I mean, this patient will definitely have incontinence for up to 3 months. That's what I wanted to tell you that. So, I mean,
I agree,
I
sir.
have a different technique for this, but that's what I wanted to make sure this. He will 100% will have the incontinence at least for 1 week. And of course, it stops at by 3 months because it is behind the Veru, 3 centimeters almost. The sphincter is okay and anteriorly, I know that one, but sphincter preservation is little, you've gone all around. It's okay. Anyway, the package is...
You see, recently Hemendra Shah has done one study where they have looked at the image of the sphincter at the end of the procedure and tried to correlate whether you can predict incontinence. And with 10 experts looking at those videos, the concordance between real incontinence and what the experts thought was absolutely not there. So I would say don't make that prediction. I would feel it depends more on the patient's frailty, overall muscle tone, associated diabetes, and not exactly on how the sphincter looks.
So I'm just totally agree with you. That is the studies. Even Dr. Anand Kumar said that there are studies which is underreported. Even in my experience, I've done 7,000 cases because that vision is the one which we started doing it enucleation manual. This is a forceful enucleation. After a lot of younger patients have started doing EP HOLEP. Now is my fancy thing is ejaculatory preserving HOLEP. When I started doing ejaculatory preserving HOLEP, I'm having 100% continence. Leaving behind this one, that is the one where the ejaculation is not preserved. It's only 70%, but the continence started improving.
Now,
one thing I would like to highlight, like
1 liter saline.
when I started laser prostatectomy, there was incontinence rate was high. So then I started studying and watching why it is so. And then we did 2 modifications. One modification was that when we used to
Can you mute the OR please for a minute? Yeah.
Yeah. So what we have done, one was that when we are doing dissection from 3 o'clock to 9 o'clock downward, then energy was 80 watts. but or sometimes 100 watt also in larger gland because you want to make it faster. But as soon as we moved between 9 to 3 upper, we brought the to 64 watt. And second thing, what Rohit was showing, what we have done, like you have dissected from this side and that side. The most important thing is not to injure the sphincteric complex. So we know that this is the sphincteric complex, and we just only cut the mucosa at the low watt. And once the mucosa is cut, we left some tissue and then move that side. So that way that area has less heat effect, because one of the reason was also quoted that incontinence is the heat effect which goes to the sphincteric region, and later on which it heals, continence comes back and it causes edema and all that. So by these modification, lowering the energy and just hanging mucosa, we know that from 3 to this class, and just cut the mucosa and then move deeper. And never pull the gland too much into the bladder to drag the sphincter in, then you will cut some part of the sphincter. So by these modifications, we've seen that in our own, that incontinence rate has gone down significantly, and patients are, those who have also 1 or 2 weeks, then they become all right.
Sir, I just want to make one more comment related to the large prostates. As you rightly said, most of the times whenever you see a gland which is more than 100 gram, it's definitely managing endoscopically with minimal invasive is a skillful job. Let us take some opinion from the audience as to, like, if at all you get a gland which is more than 100 grams, how many are there in the audience who are like doing enucleation either using the laser or a simple prostatectomy using a minimal invasive technique? How many are doing these two techniques for a larger gland? I mean, if you see the number of hands being raised, even they are very minimal. So at the end of the day, if practically, if you see most of these patients, I believe.
Other question also. The using the robot also.
I mean, both the procedures, I am telling, both the procedures, there are very few hands. But at the end of the day, if you see, I mean, many people who do, I think maybe like bipolar resection or open prostatectomy, since there are a lot of seniors, teachers, I mean, even Dogra sir is here. Like the most problem which you encounter whenever you do open prostatectomy is the post-operative bleeding which persists for a few days. They have to be on traction, or some of the, even they need packing also. So are there any other tips, like if people are doing other techniques, particularly either bipolar resection or open technique, what are the tips to reduce that bleeding, which is the main problem with the other approaches? So can anybody give those opinion related to that?
Very good question.
In open operation, I have seen both Freyer and Millens. But the Millens prostatectomy, which I have learned when we were in PGI, and then I've been doing for all the bigger gland till I got the robot, we are doing the open prostatectomy. And somehow we get a lot of international patient, and patient from Iraq and Afghanistan and Africa. We got all the large gland we have done is from those countries only. Indians have very few large glands. And then what you do in that patient, you dissect it nicely. Since it is a gland, big gland, you get a nice dissection, retroregius space. And then you cut the caps, take a silk sutures or the vicryl suture, do the interrupted stitch distally and proximally, so all the veins are tied. Okay. You can dissect the internal iliac artery and put bulldog clamp also there to reduce the bleeding, and later on you can remove the bulldog clamp, because your open procedure, they are there. There is another maneuver, you can decrease the bleeding. Once you cut it, you take a long diathermy needle and put the diathermy as a higher one and just start dissecting gently, rather than putting your finger initially. Do most of the dissection with the long diathermy probe, and you will keep on coagulating, and keep the coagulation around 80-100. Nothing happens because you are inside the capsule. And then when most of the dissection is done, posteriorly you can't see because you are now working from here. Then you put your finger and take it out. Once the eyes, pack it for 10 minutes. 10 minutes, I used to talk and sometimes de-scrub, come back after 10-15 minutes. Most of the bleeding has stopped. But then again take the roller ball. And then all the bleeding point, you can see it because now fossa is open. And then do the trigonalization and put a catheter and come out. I have not packed any prostatic fossa after Millen's prostatectomy. And as I grew, almost a bigger gland, we have done it safely. And then they may require 1 or 2 units of blood transfusion.
Sir, adding to that point what you said, like the hemostasis part only, in few patients what we have done where we did open for 150 to 200 gram prostates, like after you remove enucleate the gland, of course fossa would be oozing. So we used to place the Babcocks onto the cystotomy wound because it's an extraperitoneal surgery. Then we again used to take the endoscope, in few cases we did, go inside, you have anyway applied Babcocks, it will not leak much. Then go inside and then using a ball cutter or anything, endoscopy, we used to fulgurate that fossa more close to that apex area, which is difficult to see by an open approach. Like that also we did in few patients, I mean, which we felt it had helped also in the post-operative in decreasing the bleeding. And then of course subsequently you close it anyway.
Sir, can I say something?
Taking suture before capsulotomy, you will stop all the bleeding from the capsule.
My only
I am talking about the Freyer's one.
with all these procedures are, all of you are very, very established surgeons and stalwart. You know all the techniques, right from open prostatectomy, Millen's, Freyer. You have graduated like that. But my concern urology is your very overstatement, like every OT will have a robot in last future 10 years. It is not going to be true in India. It is a very heterogeneous state. You are doing robotic prostatectomy. You are doing HOLEP. I know out of our 1,000 members, how many are doing HOLEP? Demonstration comes only few persons, few select one from India. Where are the rest? Of course, they are increasing and they are very good techniques, but majority are still dependent upon TURP, bipolar or unipolar, or I don't know how much are now even trained in open surgery. Because for bigger prostate, open surgery is still a boon. Second point is, nobody talks about this. When you operate on the prostate, it is a pathophysiology. You operate on a very, very vascular prostate with a severe cystitis, whether you do TURP, HOLEP or whatever, it is going to bleed much more. When it is a less vascular prostate, and when you give a medical therapy, good antibiotic, operate on an appropriate time, then it bleeds very less, whether it is open prostatectomy or TURP or whatever. And we have a means for that. We have alpha blockers, we have receptor blocker. Give it that same bleeding prostate will have half of this bleeding. And we are practicing it daily. And that timing is very important. We are not operating on a prostate, we are operating on a patient whose morbidity and pathophysiology. So in the bigger prostate, I do cystoscopy, see how much vascular it is. We try to reduce its vascularity, and with the same prostate, I don't have HOLEP. I am doing HOLEP in medical college and private setup. My laser is only 30 watt. I don't do. But I am regularly doing 100, 120 gram prostate in a month, 2, 3, 4, without any, because I know there is a problem of volume overload. There is a problem of TURP syndrome. You get electrolyte done. You put a 3% normal saline and nothing happens. All our patients are going well and nobody is having incontinence because even today. So, of course, these are very good techniques and we have to in future, we have to learn because they have a little superiority. But till that, we have to think about overall development. We should know all the techniques and as we have the access to other, we should graduate on that and very good demonstration has been done.
Yeah, only one point I would like to say, very well summarized, that every technology or technique has its own evolution. Yes. And we have to respect that evolution. And Dr. A. Mohan from Bangalore, he once asked me, Anil, I am interested in your evolution. So what he asked me to do was that first 5 years, next 5 years, next 5 years, just compare your data. And so when we compared that, you see, this is just for all the young members, that you also evolve on yourself. So that is something which the message must go correctly, that techniques are there, technologies are there, Be diligent and keep on doing it. And just to tell you that in my hands, if the incontinence rate was 10 to 12% in first 5 years, in last 5 years it has come down to 1 to 2%. So that is evolution of a surgeon in relationship to this. So we must also...
we must
I think, doctor, can I just speak for a minute? See, we all have been doing either bipolar, monopolar TURP, now bipolar, or Millin's prostatectomy. We all know the major limitation of HOLEP at present is whatever we say, sitting in a conference, is the learning curve. And all people are not like expert like Dr. Varshney who are able to reproduce a HOLEP procedure on a prostate which is more than 150 gram. I have seen myself the rate in this city itself, not naming anybody, but rate of stress incontinence something like 8%, 10%, which I have not faced in my practice by doing a Millin's prostatectomy for a prostate which is more than 150 grams. Now, the argument comes, obviously it is very clear, an expert hand up to 100 gram prostate bipolar is good enough. We all know. We all have done monopolar TURPs. With bipolar coming in, there is hardly a challenge of TURP syndrome with us. And all those 3% saline and all, we have hardly needed in any patient. And with a patient with hemoglobin of more than 12, the rate of transfusion is very, very low with the bipolar itself. So up to 100 to 150, maybe one can say, with availability of the robot. Now, there comes the question of the price. I would say robot has got multiple applications. Nobody is buying a robot for a simple prostatectomy. We are doing all the cancer surgery with robot. So you cannot compare cost of the HOLEP with the cost of robot. Robot is already there with you lying there. So cost to the patient is almost similar or maybe 10 to 20% more with the robot there. So there comes a question with a patient with more than 150 gram prostate. My experience with the robotic simple prostatectomy has been very, very good. Like if I compare the uroflowmetry of this, that's equivalent to the Millin's prostatectomy, which is never there in the HOLEP surgery. Of course, I don't do very good HOLEP surgery. I'm really scared of many complications because I'm not able to manage that 150 gram plus kind of prostate. And I know Dr. Varshney can really manage 600 gram, but there will hardly be a surgeon in North India who will be able to perform 600 gram prostate with the HOLEP.
So I think message is to procure the instrument and get it expertise.
Yeah.
Once you are expert in something, it is good in your hand.
Because I knew robotic surgery, I did not need to call anybody to perform a robotic simple prostatectomy. I just saw a video of one of my friends and I started doing it. Even with the CMR system, I did around 4. And one of the prostate was 400 grams from Chandigarh. I was able to enucleate around 300. 100 gram was still left, but that patient is voiding well.
Thank you for the wonderful discussion.
Sir, please.
I think you have to send the message right. The way we are discussing, we are not Anil Varshney and Dr. Anant Kumar. Everyone is not like that. A procedure, if cannot be reproduced by the majority of the people, it cannot be called SOP. Okay? I have done open prostatectomy, I have done endoscopic, mono, bipolar TRP, HOLEP, green light, robotic simple prostatectomy. And I don't feel shy, even in today. I'm working in another institute, Sir Gangaram Hospital. There I done open prostatectomy, and the resident was very pleased to see that. Sir, we have not seen this procedure, and they were so much appreciative. They were initially scared, there will be bleeding and all those mess. Nothing, those patients went on the second, third post-op day home with the tube catheter, no problem. So why you are scaring them not to do open prostatectomy when it can be done, provided you are in the proper plane and you are doing in a proper indicated case.
Very well said.
So, thank you.
I agree your point, sir. Even in our institute also, because a lot of around 20 residents are there with us always. So we also, whenever you get a big gland like more than 120, up to 150, those glands, we specifically tend to do an open case because just for the people to know, bail it out. It's always better to learn an open technique always.
See, we are not very joint. Like, I don't know how many of us have been doing TURP in a prostate gland more than 80 grams. There were only 2 publications, one from Jordan, other from Turkey. I couldn't find any from anywhere in the world, the literature, they're seeing that we are doing TURP in these prostate who are more than 80 gram. So what we are talking, I think we should talk about the realities. Thank you.
So, sir, your message is very loud and clear that all urologists who know how to do a good open prostatectomy, whether it is Millins or even Freres.
Do not be scared of.
Do not be scared of, yes. Fully agreed.
Up next, we have a very short sponsored talk by Mr. Pritam Ghosh from Fujifilm. We are also having working lunch which is being served in the designated dining area outside the hall. The timings are from 1:30 to 3:30. So delegates can have their lunch now. And the official break is for 30 minutes after the sponsored talk. We'll be back with the live operative session second after the lunch at 2:15.
So, good afternoon, everyone. And thanks to Max for giving us this opportunity to present our product here. And I just wanted to give you a warm greetings from Fujifilm India and introduce our product or the solution that we have for the OR or the OT. So you can see the range of product. It is like we say it is illuminating the path from screening to treatment. So we are talking about one ultrasound solution which is able to take care of all your needs, right from the urology or the open surgery. Then we have the laparoscopy or the robotic surgery, neurosurgery, proctology, or the vascular surgeon. So the same ultrasound machine can be utilized in different applications or different departments in a hospital. So I'll just take 2 minutes of your time to take you through all the probe solution that we have here. So this is the regular convex probe. Then we have the dedicated, the PCNL probe. You can see this, we tell it as a center biopsy probe where the biopsies are much easier than the regular probes. Then we have the dedicated biplane transrectal probes. And then the transperineal probes are also available with us. Then you can see actually we have the integrated fusion also which is available with us. And as per the studies that are conducted so far, we are able to claim that, we are able to increase the biopsy detection rate by almost 85 to 90% using the solution. Then we have the laparoscopic probe and the robotic probes available with us. And in terms of robotic also, I just wanted to emphasize here, robotic probes are available of 2 different sizes, which is very unique compared with any of the competitors in the market. So we have a very small robotic probe also, which is around 13 mm aperture, and a regular size robotic probe, which is 26 mm. And there are few open surgery probes which are available with us. And we have a wide range of products, right from Arita 50, then Arita 65, then we have Arita 650 and 750 and 850. These are the models. And after we started the operation from last 3 years, after the takeover of Hitachi imaging division, so we are able to install in most of the major hospitals all across India. Thank you so much.
Thank you, Mr. Pritam. So we will have a group photograph. Please come forward. Anand sir, Varsha sir. That was an excellent session. Thank you. P.N. Dogra, Dr. Amit Agrawal from R&R Hospital, Dr. Umesh Ojha, Dr. Amit Hosamani, Dr. Bijay Man Singh Katwal, and Dr. P.P. Singh. Can we connect to OT? हाँ? कॉल करो ना उधर. Dr. Amit Agrawal from R&R Hospital, Dr. Umesh Ojha, Dr. Bijay Man Singh Katwal, Dr. P.P. Singh. In the next session, we are going to have demonstration of the cutting-edge minimal invasive surgical therapies, including Urolift, RISM, ITIND, and a semi-live virtual presentation by Dr. Nikhil Vasudev, right from United Kingdom. Dr. Rohit Kaushal, sir, or Dr. Umar Khan, are you connected with us? We have a series of MIST therapies today which are going to be demonstrated, including Urolift, RISM, ITIND, and a semi-live presentation on echoablation by Dr. Nikhil Vasudev from UK. सुनो चेयर ऊपर लगानी थी मैं सही बैठा हूँ मैं बिल्कुल सही बैठा
Good afternoon, respected seniors and delegates. Am I audible?
Yeah, Dr. Umar, you are audible. A distinguished panel of chairpersons is waiting for you, Dr. Umar. Can you please start with the case presentation?
Sir, now I'm presenting the 6th case capsule. He's an 80-year-old gentleman with poor urinary flow and mild storage symptoms. He's been on silodosin since last 4 months with inadequate response. He's a diabetic, hypertensive, and hypothyroidism. The examination is grossly normal. On evaluation, his prostate was found to be 40 grams with median lobe on ultrasound, and rest of the blood and urine workup was normal. PSA is 0.6. His uroflowmetry has a max flow of 5.4, and this is the pattern. So the plan was made for iTind implantation. Thank you. This case will be demonstrated by Dr. Ashish Saini. 40 number 11.
Something like that. Hi, am I with the audience?
Yes, Dr. Ashish.
Yes, Ashish, you are
So we have heard about the case history, and so this is a small prostate around 40 grams with a high bladder neck, and we will be doing an implantable titanium nitinol device known as iTind by Olympus. And for this device, we need just a cystoscope. So this is a simple cystoscope by an Olympus. And the procedure, so the device works by, so ये थोड़ा लाल कैसे हो गया? हाँ? इतना लाल कैसे? So this is the jelly effect.
No, I think this patient had a cystoscopy one day before, I think. Yeah, actually we have done cystoscopy all patients who are undergoing minimally invasive procedure.
So sir, one can see that this is an ideal case where there is a high bladder neck and it's a grade 1 prostate. So whenever we are doing a mist therapy, in a patient where there is a high bladder neck and a small prostate, iTind is suited. So
Yeah, this is a very good case. There is no median lobe and this is a, yeah.
So there is no
This
median
will
lobe and there is a grossly trabeculated bladder. So once we have placed the, so you remove the sheath is inside. You can, the camera needs to be fixed here. If somebody can fix the camera here. इसको ऐसे दबा के रख लियो आप.
Ashish, just to enumerate, what is your criteria to do an iTind?
Sir, a patient, the one who wants to preserve their ejaculation, the patient who is a young patient with a primary high bladder neck, where a pelvic dysfunction has been ruled out, a patient who has a small prostate and there is no median lobe, a prostate size up to 40 grams. So basically, they say that you can go up till 60 grams, but what I have found is that up to 40 grams is ideally suited, and if there is a high bladder neck, then that's an ideal indication for a patient for an ITND.
And a patient who has not responded to medical management, isn't it? Such a patient, if he has not responded to medical management, only then we advise them iTind, not as a primary procedure.
For any procedure, wherever even a missed procedure will only be done in a patient where we have tried everything. We have tried the alpha blockers, we have ruled out a pelvic dysfunction on a urodynamics. Then only we are putting these patients on an ITND device.
Do we have a urodynamic on this patient?
Sir, this patient does not have a urodynamics. He is in 80 years with basically a retention. There is a 80 gram prostate. We can see a bladder trabeculation. So in a high bladder neck, in such cases, at 80 years, I don't think a urodynamic would be required. It may be required in a young patient between 20 to 30 years of age, there are many young patients who are coming to us who are primarily having pelvic dysfunction rather than and that may be a high bladder neck with a pelvic dysfunction. So that are the patients where we require urodynamics.
PP.
So once we have, so this is the device.
He is saying high bladder neck.
Yes.
He is at the buromontanum and you can see the meatus. While doing the cystoscopy,
Ashish?
he was at the buromontanum and you could see the internal meatus.
Dr. S.P. Yadav is saying that...
No, sir. I'll show you again. Okay. Just hold on.
Ashish is not to contradict you.
Sir, this is a verumontanum. You cannot see the meatus.
We are seeing the opening at 12 o'clock position.
Just go in little bit more, maybe a centimeter, and lower your
scope.
Yeah.
You can see the, okay, fine.
You don't quantify this as a high bladder neck?
This is a good candidate for I-10.
Yes, this is a good candidate for I-10, that I agree.
And he has symptoms, sir. He has a
no, agreed he has attention, agreed he has mild trabeculation, not gross trabeculation.
He doesn't want a major procedure, so it's a good case.
As far as procedure is concerned, I agree with you, sir.
Yeah.
Don't disagree.
So this is, so इसको बंद कर लो यार, इसको ऐसे नहीं करना है, इसको बंद कर लो, इसको हमें partially full चाहिए bladder.
So he has a small prostate who has not responded to medical management.
Let Ashish explain. Yes, please explain the device. Yeah.
So this device has a blue marking and a white marking.
Please focus it little bigger.
Can you focus it, please? Is it possible to focus? Yeah. So this is the device.
थोड़ा मैग्नीफाई करो. Please focus. Magnify का थोड़ा सा.
Zoom कर दीजिए वहाँ.
Zoom कर दो इसको. Zoom कर दो.
So we need to keep the bladder partially filled. This is the device, and this device. Can you see the zoom in?
Yeah.
So this device has a blue marking and a white marking. The blue marking has to be at the top. It will be at 12 o'clock when we will be seeing it endoscopically to position the device. And there is a knot at the back. So this knot at the back, you need to be very careful that the knot should not open till the time the device is inside. Once the device is being deployed, then only we release this knot. So now, you have to focus here only, boss. Yeah. So we will be putting this device inside. Once we are putting it inside, we will feel a give-way sensation.
So it means it has gone to the bladder.
Yeah. So it has gone in the bladder. So there is a give-way sensation. Now,
Dr. Ashish is blind technique. Till now.
Sir, no, it is not blind, sir.
Now
I'll show you.
Put a scope and
blind.
Place it nicely.
Yeah, so now...
So you have already opened the device by pulling out the outer sheath?
No. We have not done anything, sir. We have just placed the device inside.
No, but you have pulled out the outer sheath, isn't it?
Now he'll go at the side of it.
We have not put anything.
Yeah.
Okay.
The device is inside now. Now we are going back again.
Inside the bladder.
उसके side से जाएगा.
So there is a carrier of, this is the carrier of the device. So I have just pulled out the carrier of the device, okay?
Okay. So this device has not opened as yet. You have just inserted the device into the bladder.
Yeah, sir.
The tip is inside the bladder.
We have just inserted the device inside the bladder. Now, यार इसको ना मेरे को दिखा दो, मेरे को ना, I will need to see this.
Now he has gone with the scope to see around it and not under vision.
Now now this device is inside. Now I am going to reposition it. Repositioning it by putting the blue thing above, so that this blue thing should be seen. Now we will be pulling this device inside. पानी का प्रेशर इसमें ना ये सब निकल रहा है.
And there is a notch. उसको यहाँ पर fix करना है.
So now, this notch is coming down.
Can you focus in the PIP technique outside?
यार एक तो तुम्हारा ना ये कैमरा ऐसा सही नहीं है.
कैमरा तो बहुत अच्छा है सर.
So now, sir, this device is now coming at the veru. Okay.
Yeah, now it is open.
So this is the blanching effect.
There, you'll put it in the prostate. so that it won't get dislodged.
Yeah, so this is the area of the.
हाँ अभी दिखाते हैं.
नहीं ओपन कैसे किया इसने? नॉट खोली है पीछे से.
नहीं जब आप
ओके. फिक्स कर देते. ओके.
So now you can see that this device, ये जो इसका lip है.
ये नाच ये आगे. This will stay in the prostate, and rest will be the outside.
So this is the notch which will stay in the prostate, and this is the device which is being opened. Okay.
No,
so
no.
these are the
I just for the knowledge of everyone, I want to ask you, how did this device opened? It opened on its own, or you did something from outside?
I think Ashish.
No, sir, it opens on its own.
I think one device we should show it outside.
Outside.
Opening and closing.
How
people will understand.
See, when you put it inside, it was closed, and you just put the outer or whatever the sheath it is. So at what time did it open actually?
वो ऐसे साइड पे था. यार एक तो ना ये साला ये ना स्ट्राइकर का ठीक नहीं है तुम्हारा कैमरा. So this is the device. One can see. Inside ठीक तो है यार. ये है तुम्हारे यहाँ पे.
Sir, he has come out of the Viru. PP, it is okay. The outer part has come out of the Viru mountain.
It is all right. So now you can see it has opened it.
Yes.
Okay.
Ji.
It is all right. It's all right.
The length.
Yes.
Ashish, my question is, what maneuver was done to open the device?
Sir, the device actually has a lip. The lip sits at the verumontanum at 6 o'clock.
Right.
Once it is sitting at 6 o'clock, there are 3 flanges in this device. So that if it is at the lip only, then the device will open. If it is at right or left, the device will not open. So this is what happened, that when we were crossing back, the anchor was at the verumontanum, and the trifurcate incision, which will occur at 12 o'clock, 5 o'clock and 7 o'clock, that opens automatically.
Ashish, can you just show the tongue-shaped lip that you are saying, which fixes at 6 o'clock, the anchor? Because when you were coming out, it could not be seen clearly.
Yes, it should be sitting just distal to the bladder neck. No, it should be proximal to the Viru. It should be
the bladder
proximal to
neck,
the
then the
Viru.
device will never open up.
Wire, that wire दिखेगा.
यार ये वैसे नॉट निकाल दिया हमने, तो कैसे खींचेंगे? ठीक है.
And one more question, Ashish. Suppose the device is not positioned properly in the first go. Is it possible to reposition it?
Sir, we can reposition it till the time we are not opening the knot.
Okay.
If you open the knot, then yes, you can do that. You can remove the entire device, just like removal of as you remove the ITND. So you remove it through a open-ended catheter. Then you again place it in this thing, and then you can pull it back. You can position it back.
Okay. Ashish, is not possible to push it back into the bladder and re-pull it back.
No, sir. If you have actually opened this the knot, you cannot reposition it.
If you push it back in the bladder, if you push back,
so you cannot. You have to remove the device and then you have to put it back.
Ashish, for the benefit of everyone, we have not understood the steps of procedure. If you can describe, just take the device outside, just on the table, and explain the procedure step by step.
You want me to actually, since the device is there, you want me to take it out and then place it?
No, don't do that to the
separate
patient.
equipment.
Take another device maybe if the company is ready to give
there
it.
must be a model.
There may be model or something like that. Like
Actually,
half of
sir,
us
they
have
have
not
a
understood
demo.
how to place it.
They have a demo in the conference area. They don't have it here. Otherwise, I would have loved to show it.
And Ashish, one more question.
No
a
catheter.
patient who presents
will
with
void.
retention of urine,
There will be a
is
thread,
this the
there
right
will be
treatment?
thread which will be tapped to the penis. No
Sir,
catheter is.
Yes, in a patient where the one who is in all mist therapies, what we are looking at is a very small time of operating time. So yes, what I have found in my own practice is that in patients where I have chosen them carefully, we have done in 20 cases till now, there is one patient where the device did not open and we had to do a through-flap in that case. Rest of them had a good follow-up. Now the follow-up is almost 1 year. So the device is working. It is not that it's not working. It is basically causing a bladder neck incision. And with that bladder neck incision, a small prostate, just like a TUIP works, it is going to work.
So among these 20 patients, how many were in retention of urine?
Sir, there were 3 patients who were in retention. Rest of them, almost 70% were young patients. There were only 30% who were in the age group of 60 and 70. Majority of them were done for a primary bladder neck obstruction.
Okay, thank you.
How many days do you wait for the device to be removed after placing it?
We will remove the device after 5 to 7 days. And usually what the company says is that 3 days is sufficient for the device to work. But for the benefit of doubt and for everything, just take it, put it for 5 days.
Ashish, what happens if the patient has retention of urine following this procedure?
Is it not
How would you manage that?
7 days is the
You can
recommended
easily
day.
put, if the patient is under spinal anesthesia, you can easily put an infant feeding tube inside.
No, if my patient, I do a procedure today and in the evening I come for the rounds and the patient is having retention of urine, what do I do?
You place an infant feeding tube at the time of the surgery. You can remove it next day.
ना आप मेरा सवाल ही समझ रहे, मैंने डाला नहीं या फीडिंग ट्यूब निकाल दिया और पेशेंट को रिटेंशन हुआ, अब मैं क्या करूँगा? थ्रेड अंदर है.
I have not come across this scenario till now, but what you can do is, usually the patient will not be in retention because there is a mechanical...
No, it is not usual. We all can understand any patient who has even a catheterization for a catheter removal because pain, bleeding, clot formation, there can be retention in any patient. So what is the recommendation if a patient has retention? SPC?
Infant feeding tube can be easily placed in this.
By the side of it?
Yes, it will go through it. You can easily place an infant feeding tube, that is not an issue.
So one can do that?
Yes.
Feeding tube, but not a Foley's catheter.
Foley's catheter has a rough balloon, so we really don't know whether it will dislodge the device from that place, so better to place an infant feeding tube.
Or do an SPC?
SPC, I think an infant feeding tube should be all right. SPC should not be, you can do an SPC to divert.
Yes,
not recommended.
SPC should not be a problem.
Should not be a problem because then you will have to wait
for... Device is at the neck. Device is at the bladder neck.
Yeah.
SPC should not be a problem. Maybe do a small SPC in that case.
Yes.
Ashish sir, can this procedure also be done under a prostate block?
Well, I've tried it under local anesthesia, not a prostate block, and I found that the young patient, they actually squeeze their sphincter whenever the device is opening inside. So it is very difficult to position the device. So it is better to do it under some amount of, yes, a prosthetic block can be done, or you can do it under a saddle block or a anesthesia for a short duration.
So a couple of weeks back, we had a patient from the Middle East. We did an iTint. So after the stent was placed, the patient had very bad pain. So we did only one case. So what is your experience regarding the post-operative pain when the stent is inside?
So what happens is that, especially what I found is if the patient has a history of prostatitis, so this device, because it is opening the bladder neck and it is causing some amount of ischemia, so there will be pelvic pain, and the pelvic pain will be there for initial 3 to 4 days. So you have to tell the patient upfront. The other way is that we always start them on methylprednisolone or something like a steroid to decrease the inflammation. So that way, and the painkillers, that way the pain sensation will be lessened. But yes, all of them will have the pain sensation in the initial 3-4 days.
So the next question, patient is under spinal anesthesia. 60 plus, spinal anesthesia. He is definitely like to have retention of urine. Most of the patients. Even otherwise, young person develops retention quite frequently post-operatively under spinal anesthesia. So why don't they put the feeding tube in the very beginning rather than wait 4 hours, 5
Sir,
hours, 3
I
hours.
always place an infant feeding tube if the patient is in the spinal anesthesia.
Yes.
Always. I always
Under
do
local
that and-
anesthesia, you said you are uncomfortable. So
But
in
we
local,
have
you are
not-
uncomfortable,
we
you
have
are
not-
doing on spinal.
We have done these procedures. We do, our anesthetists give short anesthesia.
Yes.
And if need be, laryngeal mask.
Yeah.
And that anesthesia, as soon as the procedure is over, anesthesia is also over.
Over.
So we don't give spinal
Yeah,
or
that is
anything.
better.
Sometimes they give laryngeal mask, or they don't put, just give thiopentone and just some drug, and just half an hour patient sleeps, and procedure euro left tightened, resume is done, and then it's all over.
That is better.
And also in younger patients, you said somebody who has a high bladder neck and pelvic floor dysfunction. So after placing the stent, does the pelvic floor dysfunction symptoms worsen, or how do they do?
So usually what happens is that if they are contracting their pelvic floor too much, and it is primarily a pelvic floor dysfunction, they may not be benefited by the procedure per se. So that is the reason that it needs to be ruled out, and you need to counsel these patients. So I have placed an infant feeding tube. There is no problem placing it inside, so it goes in easily. So putting in a catheter like a 10 French catheter is not an issue at all.
So will it be right to say that all these patients will require a urodynamic study before they undergo I-10 procedure?
See, if you are looking at a troublesome patient, if you are looking at a history where the patient has a pelvic dysfunction, if you are doing a local examination, and if you feel that there is a lot of tightness in the area, then better to counsel these patients. Even a biofeedback may be helpful to them.
Okay, sir.
And then baclofen can also be added in such cases. So basically, those are the challenging cases.
Thank you.
A primary bladder neck obstruction because of a small prostate is a simple case, straightforward case, and an I-10 can be done in them.
One thing I'd like to know is that, is there any added advantage of this I-10 over other stents like a MemoCath or maybe a spanner which have done very well, reasonably well, and why, I mean, the need for another, because this has got a spring action which is actually a very strong action, and understandably can cause some pain also. And the spanner stent, it was made up of silicone, it's done with.
Actually, sir, the prostatic
Just say we
stents
can
or
change it also,
MemoCath,
sir, Madam.
because they are there for a very long time. They are indwelling stents. So this is basically more of something which is there for 5 to 6 days. And anything beyond that, we have seen that the patient failed because of encrustation of the stents. So that's the reason that this is a device which is truly minimally invasive, in the sense that the patient is off the device in 5 or 6 days. So MemoCath per se will not work in a high bladder neck.
Sorry for the interruption.
Thank you,
sir.
Ashish.
Good
Thank you.
Thank you, sir. Thank you for the time and patient hearing. Thank you.
Thank you so much.
Good afternoon, everyone. So we'll proceed with the 6th case capsule for the day. So this is a
इसमें बस यहाँ टेप लगा देना, बीच-बीच में इसको निकाल देना.
Can you mute this OT? Shift to the other OT where the rhythm is going on.
So we'll proceed with the 6th case capsule for the day. So we have a 68-year-old gentleman who's been having a post-void dribbling and a poor flow with some amount of storage LUTs as well. Patient has been on silodosin 8 milligram since 4 months, and he's not having any symptomatic relief. He's a known diabetic, hypertensive, and he had an episode of cerebrovascular accident 8 years back. His examination findings were grossly normal. On evaluation, he had a 46 grams of prostate. His blood and urine workup were normal. His PSA was 0.22. His uroflowmetry showed a maximum flow rate of 3.6, and this was the pattern. And after the discussion, we have made the plan for resume therapy for this patient. Thank you. This case will be demonstrated by Director of Urology, Department of Urology and Kidney Transplant Robotics at Max Vaishali, Dr. Vimal Dassi. Handing over to you, sir.
Okay. Hi, good afternoon, everybody. Am I audible there?
Yes, sir.
हैंडल को इधर करो एंड कैमरा कहाँ से आ रहा है हमारा? यहीं से कैमरा यहीं से। इसमें वाटर आपको लेना होगा ना? तो पूरा दबा के रखना उसको, ये उसमें जाता है। आईवी से यहाँ एक बॉटल लगेगी, उसमें जाएगा, ये बता देगी आप। जो इरिगेशन इससे जाएगा ना, तो उसमें आता है। तो ये नीचे आउटलेट है, ये आउटलेट है, तो नीचे उसमें जाएगा। वो लग गया ना? हाँ दीपिका, एक मिनट बुला दो। इधर देखो मैडम, थोड़ा इधर। ये आपका आउटलेट है ना? दबा के रखूँ।
विमल पहले मशीन को भी तो दिखाओ जूम करके उसका वो
सीधे इसी से जाएंगे हम लोग।
हेलो विमल।
Hi, good afternoon, sir. Am I audible there, sir?
Now you are audible. I'm saying just explain the machine outside. Ask the cameraman to focus
Right.
it, and then.
Right, sir. We'll do.
Yeah,
We'll do that. Sir.
Explain
we'll do
it.
That. एक मिनट। आपको फोकस करना पड़ेगा मशीन पे। You will have to come this side. You will have to come this side. Deepak side or two.
Equipment को भी explain करना है।
Rotate it this way.
See, just see where the steam is generated, how the steam goes.
Right.
How do you do the?
पानी बंद करो, पानी का इनलेट बंद करो।
How do you fix it on the machine?
Yeah.
How you prepare? Just show it
You have to
everything.
show the machine. No. Can you turn it this way? आप यहाँ से आ जाइए। और आप मशीन फिक्स करिए अपना, थोड़ा हमारी ओर भी। Is the machine part visible now, sir?
Visible. Yeah.
Yeah, so this is the machine that's on your screen right now, is the generator, the radio frequency generator. And this is used to create the steam part. Along with it, we have one syringe which contains around 25 ml of normal saline, which is fitted into this generator. And this is the handle part. Can you zoom on to the handle part? Can you zoom on here? Yeah.
It is not in the focus.
I'm zooming onto the handle part, sir.
Yeah, now it is seen.
So this is the handle part. Once we go inside, we can see three knobs here. The white knob that is seen here, if we press only the white knob, this is for the flushing, for the irrigation part. If I press both the white and the gray, this is like flushing of water. If I press both white and gray, it is going to engage my needle inside the prostatic tissue. And once I am engaged inside the prostate, I will use this blue knob. I am going to press on this, and this is going to deliver the water vapor therapy, the steam, into the prostate. That will be for 9 seconds. Depending upon this machine can generate 15 treatments. Depending upon the size of the prostate, we'll have to decide how many treatments we want to deliver to the patient. The smaller the size, we'll need the smaller treatments, and if the prostate size is larger, then we'll have to deliver more treatments to the prostate. So we have done the cystoscopy. The patient has a high bladder neck and marginal lateral lobe, but he has very poor flow. So we'll be starting with the permission, if you allow me to go ahead. We'll be starting with the procedure then.
So again, Vimal, ideal patient is the one to start with, who has a small prostate and not a very big median lobe.
You should not do it in a very small prostate.
Start with is obviously a very small prostate and not a big median lobe. But the recent FDA guidelines have approved it for the prostate sizes of up to 80 to 100 grams of the prostate, and even the median lobe is not a contraindication. But while we are injecting on the median lobe, we will have to be very careful that we don't engage our needle vertically, because then the chances of the steam going posteriorly into the rectum and the consequent injury, they are high. We will have to engage our needle at slightly 45 degrees to the median lobe. Even in case there's a median lobe, we can do that as well.
So you have to hit it sideways.
The smaller sizes prostates in the beginning.
So one has to put this instrument between the median lobe groove and the lateral lobe, rotate it little bit, so as to
Yes.
inject it laterally
We'll
by
rotate
pressing the
it.
median lobe.
Yes, sir.
Yeah.
We'll have to place it inside the groove and
Yes.
rotate it 45 degrees towards the median lobe and then fire the water vapor into the prostate.
Has the rectal injury been reported in the literature with this
Not
equipment?
so far, sir.
Not.
Not so far. But there's a potential chance of creating a rectal injury.
What is the length of the needle which comes out?
The length of the needle is around 1 centimeters, 10 mm.
No, 1.5 centimeter, no? Just
10
ask.
mm, he says. He said 1 centimeter.
So once I do the priming part, I will be showing you the needle and how we do it, sir. We'll be doing the priming of the machine first.
then you will see the
before
needle
we go
comes out.
inside the patient. Are we
So,
ready for the
so for
priming?
the benefit of the listeners, this has got basically two switches. The first one is white and gray and the second one is blue. Once we press white, only water will come, and if we
Right,
press
sir.
both white and the gray together, that is little more, then the needle comes out. And to
The needle
inject
will
the
get
water
engaged.
vapor, one has to press the blue after that.
Right, sir.
Which
And
gives
once
the
the
vapor
balloon-
for 9 seconds.
Yes, and,
And
once
when-
that is complete, we have a knob here.
Yeah.
We'll have to press on this knob and the needle is going to get withdrawn, is going to get disengaged so that we are set for the next treatment cycle.
Just show the knob again. Maybe focus on the knob, which knob is to be pressed to
Here,
withdraw
sir,
the
here.
needle. Okay.
Can you see it, sir?
Yes,
Here.
yes. And you said one can give 15 shots with this
Yeah,
equipment.
this handle has 15 shots, sir, yes.
So, have you ever reused it? Suppose you use only
The company
6,
does
7.
not allow you to reuse it, sir, but because we are constrained with our costs and the patients that we have, I have reused it, but we do it ETO. And if you are planning to do the ETO of this thing, then
Mhm.
it's suggested that we keep the needle open and then give the machine for the ETO so that everything is taken care of nicely.
What about plasma?
We can do plasma as well, sir.
Which is better?
Yeah.
Dear,
Can we start the
Hello.
priming part now?
sir, Vimal,
Vimal, Dr. Yadav wants to ask.
what I believe the softer and juicy prostate must behave better than the firmer and harder prostates. Means which are more vascular, they are softer one. They should behave better
Volume
post-operatively
thodi bada hai, volume.
with
I'm not
this
able to hear.
rather
Volume,
than
yeah.
those who are hard. In doing TURP, you see lot of prostate are juicy, they come out fast. Same way they should be burnt out better with the high temperature rather than other prostates.
I didn't get your question, sir. Can you repeat once, please?
So it was a comment which said that
Right.
this is better in a softer prostate rather than a fibrotic and a harder prostate.
I mean, there's no differentiation per se as per the data that we have, whether it's better in a vascular prostate or a fibrotic prostate. But obviously, if we have a spongy, softer prostate, theoretically it shall be better in that.
But needle is very sharp, it will pierce any
It's
prostate.
very sure. Yeah.
So I wanted to ask, the steam is going to cause cavity formation by coagulative necrosis. If you remember Medimac from Australia, New Zealand, they came out with a very similar thing, Prostaject, if you remember. They had a needle going inside with the exactly same handle. They used to inject ethoxyscleral, say that the protein, there will be coagulative necrosis, formation of cavities, and that failed miserably. This is because after 2 or 3 months, patients used to come with bleeding, they used to come with, a lot of dysuria, and so the mechanism is the same, cavity formation, coagulative necrosis, maybe the system is different, some uses steam, and in the same way tuna also, transjudicial needle ablation, same handle, same needles going inside, causing coagulative necrosis. So where is the long-term data to support? You have two very similar things, like a Prostaject which failed and a tuna which failed. So how is this going to be any different?
See, this is very well
Well,
known.
well,
I'll
raise
tell you,
the- raise-
I'll
Shall
tell
I
you
answer
that problem is this, you must counsel the patient. That catheter will stay minimum of 10 days. Usually people leave it for 2 weeks. And all patients have a severe degree
baar
of
karna?
irritative symptoms. And symptoms last for 1 month. In most of the time, Western world, what they do, they only give appointment after a month. Because first month patient has lot of symptoms. And I have also seen the patient is not properly counseled. This causes problem. But after 1 month, patient starts seeing very good response. And since the water is injected and needle size is 1.5 and it creates cavity and there is absorption. And then slowly the prostate resolves. And there is a data published that these patients have shown good response. And probably there is all the bleeding and septic complication is not there because we are injecting steam, and which causes the coagulation and then auto-absorption by the prostate, and prostate opens up. So this
But
is
sir,
the
that
data.
didn't answer my question actually. I
No,
mean,
I
this is
will-
because
I-
this is the
I'll-
same thing
yeah.
that you're getting inside the other different modalities.
I'll
And
answer that.
I mean,
I'll answer
even if you tell the patient to wait for 1 month, 2 months, is it, I mean, ideal to ask the patient that, look, you're going to suffer with the same results that you have with other minimal invasive therapies? This is because ultimately the science is the same and mechanism is the same, the coagulative necrosis is the same. So
Yeah. So science is not the same. It is not a coagulative necrosis. Rhesus is a radio frequency heated. It is not the same as tuna or
No, but
coagulative
ultimately, if you
necrosis.
look at the end pathology, it is
This
necrosis of the
convection.
proteins.
It is not conduction. It is a convection
It is
wave
convection.
of heat.
Ultimately,
which has
heat
got
would
a-
result inside, sir, the coagulative necrosis. I mean, whether you do it by convention, whether you do it with steam, whether you do it with chemical, whether you do it with radio frequency, convection, conduction, or combination of both, ultimately the end result is coagulation of tissue
No, no, it
and
won't-
necrosis.
It won't coagulation in the
So,
sense it produces some cell-to-cell death. It is a convection method, and I have done nearly up to the 150 cases. Regarding the case selection, I think if you have a prostate, I mean, guideline is 30 to 80 gram. Why less than 30? Because the prostate, the needle can go out and produce an injury. So the best way of case selection in a small prostate is the width of the prostate should be minimum 4 centimeters, number one. Number two, when selecting the case, there should not be tenderness on digital rectal examination. If you find a tenderness of the prostate, he is not a candidate definitely for resume. He will have severe pain and dysuria, and he will have to put a catheter for many more days. And the third thing is urinary tract infection. A recurrent urinary tract infection, again, it is not a good case for the resume. The median lobes can be done. Yes, small median lobes can be done. The prostate up to 80 gram is, guideline is given from 30 to 80 gram. These are the few indications where it can be done. Early results are very good. I mean, the uroflowmetry is comparably better, is equivalent to uroflowmetry, provided the case selection is good.
But most of these patients would require an indwelling catheter in immediate postoperative.
That is the flip side. Per gram per day.
Yes.
30 gram, 3 days.
3 days.
50 gram, probably 7 days. And sometimes if the 80 gram and all, you have to keep for even a 1 month. Initial period is very, very stormy, but after 1 month, because the mechanism of action is up to 3 months. You cannot do anything. The patient has to be told for 3 months. The mechanism of action of convection of radio frequency waves go on up to 3 months in resume. The water vapor hydrotherapy, the mechanism of action, the science is for 3 months. The patient should be told, don't look at that for 3 months. We have to give alpha blocker. We have to give anti-edema measures. Some people are giving practice in Europe and Canada, and they are giving steroids till up to 3 months. After 3 months, you will see a very good change.
I think we can let the surgery go and then we have the discussion.
Yeah, only one last
Achha,
point,
okay.
sir. Only one last
Yeah.
one. If you look, yeah, he can start. Only one last one. If you look at the guidelines, unfortunately for this resume and all, there are no guidelines even in the Canadian Urological Association or the EUA. The Americans, they have given guidelines and they say that it can be considered as a secondary procedure after other procedures like a holmium or a TUR or bipolar has been discussed with the patient. If you
No,
look at
I-
guidelines throughout the world, still there are no primary guidelines regarding these
I
secondary
think I would like to correct you on that point, sir. This resume has been FDA approved in 2015, and now we have more than 5 years follow-up data available with us, which shows reduction in IPSS scores, which shows a good improvement in Qmax and reduction PVR scores. The
No, we're saying
rate-
about AUA guidelines. I mean, this is apples and oranges.
No,
FDA
like-
approved and
no, you
guidelines
want-
are totally
no,
different
you-
thing.
you asked
You can
about
have
the
something
follow-up.
which is FDA
You asked-
approved, but it cannot be inside the guidelines. It's
No,
totally
we are
different
talking
thing.
about- No, we are talking about the outcomes. The outcomes for the last 5-year follow-up that we have is that the retreatment surgically is less than 5%, and the retreatment patients
I think
requiring
let's
retreatment
see the
medical man is less than 10%.
let's see the
Vimal,
procedure
Vimal,
now. Let's
you
see
can
the
start.
procedure.
Vimal, you can start.
Yeah, let's see the
Right, sir.
procedure.
Thank you, sir.
First show the priming.
Yeah,
First
we'll
show
be
the-
doing the priming first. So for the priming, you'll have zoom in here. So what we'll be doing is engaging, we'll be pressing the white and the gray button together so that the needle comes out. So there you see the needle is popping out, and once it's out, I'm going to press on the blue button, which is going to inject the water vapor later on, therapy. So this
Against
is
the green button.
Ania.
Can you just focus
You can
it
see
little
the
more?
steam coming
Right,
out
sir.
of it.
Yes.
Yeah. Yes, now it's seen. Thank you.
Can you see this? So you have to zoom in there also. The priming on the generator. So once the shows comes, yeah. Is it visible there, sir?
Yes, yes.
So the priming is complete. Now what I am going to do, I am going to press the upper gray knob and withdraw the needle back. So the needle goes back and I am going to perform one more set of priming again and repeat the same cycle. So the needle pops out and this is the priming going on.
Why is this priming so important? Can you just enlighten us with that?
It is important to calibrate the machine and see that things are in order, sir. Yeah, okay. Thank you. Now we'll go to the endo view. So we need, apart from this handle, the only thing that we need is a 4 mm 30-degree telescope. That's all the armamentarium that we need in this. जल्दी थोड़ी सी लगा दीजिए, थोड़ी जल्दी लगा, थोड़ी सी स्कोप है, वो उसमें ना हार्ड लीजर.
15-20 दिन होता तो फिर ठीक हो जाता.
What is the approximate diameter of the steam bubble which is made after one injection, and what is the distance between the two injections which you'll be putting through?
1 centimeter distance between the two injections, sir. And with each steam jet, we'll be delivering around 0.42 ml of saline into the prostate.
That makes a diameter of approximately 2 centimeter or so? 1
Roughly
centimeter.
around 1.5 centimeters or so. Yeah, gauze piece and. So now I'm starting the cystoscopy part. थोड़ा आगे करो. Yes. So 18, 20 ka through. So before we actually perform the procedure, what is important is that we have to measure this area between the bladder neck up till the vero. So this distance from tip to what I can see is around 5 millimeters. So till here is 5 millimeters, and then again this one is around 5 millimeters. So this will be somewhere near here will be 1 centimeter, and then again roughly 2 centimeters. So I will need 2 shots, maybe on either sides, 2 on the right side, 2 on the left side. And since we don't have a big median lobe here, we don't need to do anything about that. So we have to give the injections that we give have to be given at 3 o'clock and 9 o'clock. So the first injection that I will do is one and roughly here. One and one. So this is the bulk of the prostate. I will go at around 3 o'clock. Now I am going to engage my needle. Here it goes. And once I am done, I'll be pressing the injection therapy, that water vapor therapy. It goes on for around 9 seconds. Can you show on the monitor? Each cycle goes for 9 seconds. And once that is done, we'll disengage it and go to the other point. You'll have to show the screen also. Huh? Okay. So this is treating. This cycle will go on for 9 seconds. So once the cycle is finished, we stay there for around a couple of seconds and then we withdraw the needle. Same maneuver I am going to repeat on the right hand side. Roughly here, okay. Okay. We'll check on the value again, is here, so we, yeah.
Sir, for the clarity, the mechanism of action of resume is thermal therapy. The radio frequency which is being used, I just checked on literature actually. Radio frequency which is being used is not to ablate the tissue, but to produce the water vapor. So the water vapor at high temperature is
Around
being injected, which leads to thermoablation of the prostate. So radio frequency per se has no role in the prostate ablation. It is only being used to produce the water vapor which is being injected.
It produces the water vapor, sir, which goes into the interstices of the cells, and then it transfers again into the liquid state, sort of destroys the architecture of the cells, and the method mainly is convection. While as in other radioablative methods, the energy transfer is through conductive measures, and that does not give a uniform distribution of energy to the whole of the prostate.
So
while as here the energy transfer
is thermal ablation. It is thermal ablation.
Right. So that completes the procedure. There's hardly any bleeding. There's nothing. I mean, it can be done at an office setting as a daycare procedure. And
yeah, can you do the cystoscopy, Vimal, to show how it looks now?
Yes, sir. I'll change it and do it, sir. Thank you.
Sir, can I ask a question, sir? Yeah. Like we are discussing in the morning, like sometimes cystourethroskopy, scopy also, the findings based on the scopy also will tell you to decide a treatment approach, some type of mist, whatever it may be. Like in this given case, like when you see the scopy, basically the lateral lobes are actually, they are not touching, and only predominantly it looks as if it is a high bladder neck with a small gland. Like in such type of scopy, if you have such type of a scopy finding, so will you consider like this procedure per se which will offer benefit compared to a gland where there is like grade 2 prostate lobes which are touching each other? Because to me it looks like in this procedure giving a transurethral incision of prostate or anything like that would be a simpler and a more better outcome procedure rather than this, because there is nothing to atrophy much actually.
Yeah,
right.
Actually, I agree with you. Like in this patient, when cystoscopy is done and you see it, I think amongst all three procedures, the first choice mine will be the urolift. You put one clip this side, one clip that side, it will further open up the whole passage. Even iTind will also work in this patient.
Yes, sir.
For resume, probably the gland is just optimal site to put it, and it's not a very big one.
Big one, yeah.
And yes, in this patient you can get bladder neck incision either with laser or with the cautery. That will also give good effect.
Yeah,
so
we can use either of these modalities.
Yeah, so all these BNI, these procedures are there. Now minimally invasive are the just replacement to them.
Basically, ejaculation preserving is the main one of
now what you see it here, it will worse than the pre-op when you will see in resume, because now you have injected and the tissue has swollen, and that's why you keep a catheter. Once this swelling will go away, around 1 month patient starts showing very good response. So counseling is very important, because I remember one of my friend has done this patient and he did not counsel. And this patient was very, very unhappy. But when I explained him, it is not any complication, it is the part procedure. You will have these symptoms for 1 month. Then he became happy and he went back and talked to that, my friend, why did not counsel me before? So this is very important to, the course of therapy is to be told to the patient.
So shall I come out now, sir?
Yes, you can come out. Thank you.
So counseling and consent are very important in these procedures when we are not very sure about the outcome of the procedure also.
Anand, can I add another doubt?
And I'll tell you one more thing. one patient came to me, and he on Google he has read about resume. So he said, I want resume and no other procedure. I want to preserve I have gone through everything, and he was like advocate. So he studied everything. But then I saw in ultrasound there was some median lobe. I said, I will do your cystoscopy first to check how big is the median lobe. So there was a median lobe. So I told him, you are not a good candidate. But he said, I want to do resume. Then I thought I will do hybrid procedure. I will just with the laser remove your median lobe only, not coming to just the part of the median lobe near the neck, and then do the resume. So when I booked it, the Boston Scientific said, no, this is not allowed. I said, no, I am a doctor, I will do it the procedure. So with the laser, I removed only the median lobe and then did the resume. And this patient is so happy, his uroflow is very good. And
Sir, he would have avoided otherwise then.
No. His uroflow was very bad before that.
No, you removed the medial lobe, you would avoid it anyway.
No, but he also had resumed for that. And so I thought that we should do this hybrid procedure if it required like this. You can, medial lobe may not become Dr. N.P. Gupta.
So he paid double, sir. He paid for laser as well as this.
He did not bother for money.
No, Anand, when you are doing counseling for rhizome, it is very important to tell the patient that it may be possible he may require catheter for 1 or 2 month period. So this is my personal experience. That's why I thought I'll share with you all that counseling is very important in rhizome. Sometimes, some patients, I'm not saying everyone, but minimum 2 weeks, company recommends, but my experience goes to 4 to 8 weeks.
Sir, you are right, sir. In one of my patients who had 80-gram prostate, in which I said it may or may not work, I had a difficult time. Patient has had hematuria. On day 1, we started irrigation. He settled after 1.5 days. Then repeated attempts of removal of catheter did not work. After 4 weeks, he said, "Sir, thoda urine abhi aa raha hai." So ultimately, he was not satisfied.
PP, the question is, क्या आपको जरूरत पड़ी तो आप करवाएंगे ये टेक्निक?
No.
So then why do you advise the patient?
That's what you are right. This patient.
This is important. This is important question.
Absolutely right, sir. Yes. Absolutely right, sir. This was, in fact, I have done only 2 patients by now with resume. This patient had a true indication in the sense that he was declared totally unfit. He is an army man of 84 years, absolutely fit to walk, looks like 60. He was declared totally unfit for anesthesia by multiple institutions. He was on Foley's catheter, and they said it is contraindicated. We will not give him anesthesia. It was done under local anesthesia with little bit of sedation.
Dr. Singh. Fine, sir. The question in science is, if I cannot afford an operation on myself, I should not have a right to operate.
Correct. Absolutely agree.
For research, it is good.
Dr. Yadav, in fact, I offered him SPC also. His son, who was much more aggressive than the patient, he said, let my father say. Father said, I do not want an SPC. I will commit suicide if you don't. Actually, you rarely get these patients. But he said, I can't live. I will not live on this catheter. So he was adamant. Ultimately, he is not the happy patient, I am not the happy doctor after a procedure.
Thank you, sir. We are running short of time. Dr. Samit is ready with the Eurolift. Can we
Rohit,
go to the OT?
Rohit, yes.
Yeah,
छोटा सा point, sir.
I think you can.
Sir, छोटा सा point है. The median lobe does not contraindicate doing a resume. So we don't need to do hybrid therapy. Initially, we also did that. We have 7 patients with a predominant median lobe. There is a retrograde 45-degree injection method. Now we have done that in 7 patients with very good result. So we don't need to combine laser enucleation.
But there has to be a significant size of the median lobe so that you can put oblique, because and that patient did not have that much of median lobe.
But that is
so
not
I thought probably if it goes little deeper and can cause problem.
Correct, sir. Secondly, sir, last thing is what Sudhir said was correct, sir. When the voluminous glands are not occluding, neither Eurolift nor resume will work there. It was
Eurolift works. Eurolift
works. Sir, even then, see now what we call as a high riding bladder neck, the correct scientific term for a high riding bladder neck is central zone hyperplasia. It is defined as more than 35-degree angle between the urethra and the slope. So when there is a central zone hyperplasia, even in those kind of patients, resume injection can work, sir. So there is a definite indication for resume for high riding bladder neck, which is correctly called as CZH.
But the tissue is less.
Correct, sir.
You might go into...
We have to do a truss at the same time, sir. Under that guidance we can do, and there we don't need to penetrate the needle fully, like the way we do in the lateral lobe. We have to keep it just so that all the 4 holes are
I think this is just extending the procedure and...
Can we switch to Dr.
Okay, go ahead.
Can we switch to the OT, Dr. Samit Chaturvedi?
Dr. Samit Chaturvedi.
Good afternoon, everyone. Am I audible, sir?
Yeah, you are audible.
So I'll take just a minute to present the 7th case capsule of Urolift to be performed by Dr. Samit Chaturvedi. So our patient is a 70-year-old gentleman with mixed lower urinary tract symptoms. And he has been on alpha blocker with dutasteride since last 5 years. And he has been taking mirabegron 50 mg for last 1 year. So he is a hypertensive and hypothyroidism. He's having hypothyroidism and he's having hypertension. His physical examination is grossly normal. His prostate size was 32 grams on ultrasound. His routine blood and urine workup were grossly normal. His PSA is 0.44. On uroflowmetry, he had the maximum flow rate of 8.2 ml per second, and the pattern is obstructed. So the plan was made to perform Urolift on this patient. The case will be demonstrated by Dr. Samit Chaturvedi, Senior Director, Department of Urology and Kidney Transplantation and Robotics, Max Hospital, Saket. Handing over to you, sir. Thank you.
Hello. Am I audible?
Yeah, Samit, you are audible.
Yes, sir. Good afternoon, everybody, respected teachers and delegates. We are going ahead with the third procedure of minimally invasive surgical therapy called MIST for prostate. We have here is a prostatic urethral lift. It's called Urolift. Most of you have seen the device. If you can see here. So how you operate a device is you first click the button, so the thing is ready for use. Then you click the blue button and the needle is deployed through the prostate. And once that is done, then you press both gray and blue buttons for the outer strut to apply. Then you pull the scope little medially so that you can see a white line, and then you fire the posterior button and it deploys a stainless steel clip inside and cuts the PET wire. So this is in the nutshell. You deploy a clip, the outer end at the capsule, the inner end at the mucosa, and with the compression effect over a long time, with the pressure effect and apoptosis, slowly the channel opens up, and it remains open for a very long time. So there are retreatment rates, but in comparison with the others, the chances of retreatment rates are really low. So it's an FDA approved device. You can see it being mentioned in the guidelines, both European and American guidelines. It is recommended from 30 grams to up to 80 grams, but the company people claim that you can use it up to 100 grams if you know how to use it for good effect, especially in patients. Those who have a lot of comorbidities, cannot undergo a routine procedure like HOLAP and stuff like that, they are a candidate for this.
Samit,
sir,
sorry, I'm interrupting you. How does one make sure that the inner side of the clip goes outside the prostate capsule?
Yeah, if it hits the bone, especially like the patient that we are doing today is a very thin-built elderly patient with only 30-32 grams of prostate. So in those cases, there is a chance of a bone hit, that you go out and you hit. If you either hit a bone or if you are in the prostate, it will not deploy. So you will have to take it out, use another implant. And depending upon the size of the capsule, if you want to be really precise, then you do an MRI and find the distance between the inner mucosal line and the capsule. The needle is 33 mm. So based on that, you can see how much pressure you need to apply once you're inside. If the distance is more, you need to apply more pressure once you deploy the needle so that it goes out. It's a sturdy needle,
so
one
has to make sure that the needle pierces the whole lobe of the prostate and goes out of the prostatic capsule.
Yeah, it goes out of the capsule, and there the clip is deployed, the outer clip, and the inner clip is deployed once you cut it, the thread.
So
automatically
can one use the transrectal ultrasound? Can one use the transrectal ultrasound to train.
Yeah, you can use transrectal ultrasound as a rough guide, but the best thing is to do an MR if you want to be very sure.
No, MR you
But
can't do it on
more-
the table. How do you
more
make
or
sure the
less-
table that you have gone out?
No, more or less you need to choose the patient correctly. Don't use more than 80 grams or less than 30, because less than 30 there is a chance of bone hit, that the distance is too small and the needle is going to hit the bone and won't be deployed. Or if it is too big, then also you won't be able to go out. So
it is-
depending upon the initial experience, you know that how much pressure you need to give for the needle to go out and the clip to deploy outside the capsule.
See, this,
So initially you may have 1 or 2 implants which will go waste.
See,
So
this,
that
this,
I
no,
agree.
see what Samit is saying, that this clip.
But that is the learning curve of every procedure.
This
The
device
advantage
has-
of this procedure is you can use it in patients who are comorbid, who otherwise cannot undergo any surgery on catheter for a long time.
So the waste is
or
paid-
in younger patients who want to preserve their sexual function, no retrograde ejaculation,
So
because
the-
you are not touching the bladder neck.
So the waste clip is paid by the patient or the company? The
No,
clip
it is
which goes
paid by the patient.
by the patient.
So
It's
the
paid by the patient.
one implant that you use will cost you
75,000.
somewhere between
75,000 rupees to learn.
Yeah, to
Okay,
80.
but it is basically your cognitive assessment. It's not, you don't have a fixed thing, because
Yeah,
you know it is
because-
3.2 centimeter will go out of the capsule.
Yeah, so 33 centimeter is the size. So about
Millimeter.
in a gland of about 40, you know that you need to give about 10 degrees of pressure once the needle goes in. If the prostate is smaller, probably give 5 degree. If the
Okay.
prostate is bigger, say 60 or 70, then you give more compression, 25 degree compression.
So,
So that will come with experience probably, and you should know the exact size of the prostate. But if you want to be exact, then a truss or an MRI is the right way.
Any precaution to be used near the apex of the prostate?
You don't do
Yeah,
apex surgery.
see,
Don't do
the
near
prostate is like this, thickest at the center and thin at bladder neck and near the apex. So the idea is how it is different from other things, other procedures, is that it creates an anterior channel. Till now with URP or any other procedure, we have been told to create a good passage at the floor. This is exactly the opposite. It creates the passage at the roof, at the anterior most part, so that urine can pass easily. So you may find it difficult to understand initially when you do few cases that how the patient is going to void. But trust me, he does, and the IPSS improvement is also there for everyone to see. And there is a lot of literature on it now. So, I mean, it's a well-tested procedure.
Actually, basically, this one has a clip, one outside the prostatic fascia and one inside the prostate, and these clips are tightened, and that compresses the prostate, and this
Yeah.
compression causes apoptosis in long
Apoptosis.
run, and then it decreases in size. And also, in a Eurolift, the best effect comes after 1 month. And now Eurolift 5-year follow-up has been published. And that's
Yeah,
why
the-
they said longer gland should not be taken larger than 80 gram. In that, if the bulk is too much, the needle may not, that outer clip may not be implied. So that's why that is the size restriction is there.
And the other thing that makes it little different from other missed procedures is that you can see it on table whether the passage is opened up or not. The catheter time is either the same day you can remove the catheter in the evening or maybe a day after. So very early results are there for everybody to see. So patient is happy if he gets a good result very fast. He doesn't need to be on catheter for a long time. He doesn't have a lot of lower urinary tract symptoms and stuff like that. So
And
in that regard, it's a better procedure as compared to the other missed procedures.
And continue alpha blocker till first month, that is also recommendation.
Yeah. And the other thing is that even if you hit bone, which is, I mean, in this case also we are expecting that we may have that because it's a very thin patient, very small prostate. So in that case, we do a thing called midline maneuver, where you come out a little so that the needle comes out, and then you press it back again and try to deploy the clip. Many of the times you are successful, so the implant is not a waste. But yes, sometimes, especially in your initial learning curve, it can happen.
On an average, one requires 4 implants in a 40-gram prostate.
Yeah, about a 40-50 gram gland, you need 4 implants. As you go higher, you may need 1, 2, or 3 more. If it is a gland like this, about 30 cc or less, then probably 2 implants will do. So we'll see how the anterior channel, if we can see it open really okay, then we may not need another implant after 2. So with your permission, I would like to start the procedure.
Yeah, please go ahead.
Thank you.
रिज्यूम 3-4 हुए हैं 10-12 ये हुए होंगे
डिवाइस खोल दो डिवाइस डिवाइस खोल दो डिवाइस दो थोड़ा सा नर्विंग है तो this is the orifice. Tabulations you can see. Okay. ठीक है स्टार्ट करें हम वो So now once you do a scopy, you take the implant. The scope is specially designed for it. So one thing you need to be mindful is that you do all the maneuvers inside the bladder, not in the prostate. So we keep it flat from the floor. You rotate it to the one side where you need to put the clip. Then you come out. This is the bladder neck. So you come out 1.5 centimeter from the bladder neck. And you can see the veru here. So this is the bulge.
Samit, imply it over the bulging lobe. That yeah. Take this one and put the clip at the bulging part.
We give little compression. Then you unlock from here.
उस पे लगाना था नीचे लगाना था
Then you place it. Then you give little more compression so that you are sure that it goes out. Then you completely. Then you do it a second time to be sure. Then you come out a little till you see the white line move towards the bladder neck like this, and you see the line.
White line, and then cut.
And now you deploy. Then you go back in, and then remove and get your second implant ready.
Samit, the bulging part, the part which was protruding most, probably,
yes, sir.
Probably it is better to clip that one.
So we will deploy 2 clips, sir, and then see whether we need additional clips.
Yeah.
So this, the other side, as you can see, the bulge is there, as you rightly said. So I'll try and take that bulge and make it little lateral. So you go with the floor, come out. And this is the bulge you see.
Yeah, this you can just press it, yeah. Just.
So you don't need to go here because you need to create anterior channel.
Yeah. No, but that's not necessary. You can just do it just below it. So
you want me to clip that like this?
Just little above. Yeah. यहाँ पे you can put it there.
Okay.
Yeah.
Okay.
फिर नहीं ऊपर चले गए तुम थोड़ा सा नीचे आओ.
I think you do what you think is appropriate. No advices from the platform.
और compression तो नहीं ना? Let me now, we have applied 2, let me put in the scope and see whether we will need more or not.
Yeah, sir, Anand Kumar sir, a couple of feedback. First time when we do endoscopy, that is the time when we have a sheath which has got the markings. So first thing what you should do while performing this with the diagnostic sheath, you need to measure the urethral angle because you have to at least stay 1.5 centimeter distal to bladder neck and proximal to veru. So first thing is that should be done.
So now I am coming out. You can see the bladder neck.
Very good, yeah.
Which is well preserved. And you see the clips, both clips. If you want, I can put one more here on my left side.
It has clearly opened.
Yeah, you put left one side, and that's again that bulging part should be little compressed.
So the idea is to open the anterior channel, not the lower one. But if you want, I can put one clip here.
Samit, I will strictly request you not to do that because the urolift is only to create the anterior channel. This kind of apical tissue bulge will not hamper
Dr.
the
Rohit,
uroloft.
Dr.
Yes.
Rohit, I can't hear you. Can you speak a little louder?
This, the posterior compartment bulge many times happens because once we do tag the implant, there is an edema happening. So don't get carried away and never ever apply a clip on those posterior bulging part. The best you could have done was you could have swept it at the first time and then you could have just lifted it at the anterior compartment 3 o'clock and 9 o'clock. That was, but this channel is very well open. I really don't think we need to apply any more clips, please.
So I think we'll put the catheter and come out.
Sir, regarding the prostatic volume, sir, because we have to see there is a curvature. So whenever we are hitting the needle, it's a 33 millimeter. So we have done 100 urolift implants and we have done a randomized MRI studies of 20 patients. And then how we decided, we measured the distance between the mid-urethral line and the prostatic capsule angle. And we have measured the length at apical level, at midline level, at the veru level. And we have done that study and we found out that between 40 to 80 grams, the average length between the midline and the prostatic capsule is more than 38 millimeter. So whenever the gland size is more than 40, that time the needle we can do. And once we increase, we see the more voluminous gland, 5 degree, 10 degree and 15 degrees. So 40 grams gland, don't compress at all. 50 grams gland, 5 degree, 60 gram, 10 degree and 80 grams, it is to be 15 degrees. So that is the compression which will be required to traverse the hole. That is done on an MRI study, which we are yet to publish. But that is what we have to do and we cannot just go by the
But my point is, when you are seeing it, and that most bulging part is here.
Yeah.
It is not at 2 o'clock, it is 3 o'clock, maybe between 3 and 4. The most bulging part, if you just press ND, and then you see the effect, because I have it is not necessary you follow it, just you have to put it 2 o'clock and this
Correct.
10 o'clock. You can put it 3 o'clock and you put 9 o'clock.
Got it.
And that most bulging part will have biggest diameter also, and that will get compressed. And then you look at it, and those patients do very well.
Correct, sir. But then initially we have to sweep it little anteriorly. For example, here
Yeah,
there was a
you
bulge.
can do like
Sweep
that.
little anteriorly
Yeah.
and then tag at 3 o'clock. But we can't do it 5 o'clock, sir. I beg your pardon, sir.
No, I'm not, again, I'm not doing 5 and 7. I never said 5 and 7. This was at 3
You
o'clock.
Sweep it, yeah.
So if you just do like that, you do like that, and it will just get fixed there.
Good afternoon, Dr. Samit.
Thank you for your patient listening. If there are any questions,
Yes.
I'd be happy to answer.
Hi, sir. Dr. Himanshu here.
Hi,
Sir-
Himanshu.
Sir. Sir, regarding the compression, I just heard Dr. Rohit, and I actually agree with that. What I have found is that one of the patients, so I'm doing Urolift quite frequently. One of the patients, after 8 or 9 days of Urolift, developed hematuria, which was managed conservatively. But thereafter, when I went through the literature, I found that there are actually large pelvic hematomas which have been formed because of excess compression.
Yes.
So I think for a smaller gland, just minimal when these the teleflex people come, they even tell you to compress for a 30-35 gram prostate. But I think that is not required. For a smaller prostate, just a minimal compression works quite well.
Yeah, 5 to 10 degrees of compression is enough. As you go more than 40, then probably yes, you'll need 25-30 degree compression. So minimal compression, especially that too once you deployed the needle, not before. Because if you, before deploying the needle, if you make more compression, then the chances of bone hit are there. So even if you have to give some compression, first you deploy the needle, you know that it will go out because of the small prostate. Then you make a little compression to make sure that the thing is deployed outside the capsule, the clip. So I perfectly agree with you that for smaller glands you don't need compression.
And
At least not
Himanshu,
initially.
that hematoma, extra prostatic hematoma forms because needle which comes out from the prostate hits the vein or the bone. And that's how the hematoma forms. Hematoma doesn't form because of the compression.
No, sir. When we compress more, there is a more chance of the needle overshooting and hitting the pelvic wall or a vessel there.
Yeah.
Yes. And second, sir, another thing was that when we are, waiting for the white line maneuver, so even, there were reports when we overshoot that white line should be right in the middle.
In the middle only.
Yes, that is where we cut.
Yeah.
So when we inadvertently overshoot that, they have reported that, hematuria and pelvic hematomas in such patients also.
Yes, you are right.
Sir, now the second generation implant is coming
Yeah.
with the Urolift. Now this is the generation 1, wherein what happens is we have to go inside. So that's why we
Inside
have
the
to
bladder.
stay at least 1.5 centimeter away from bladder neck. Now this particular generation of implant doesn't allow us to do it in median lobe. So now the next generation which we people are coming is, now rather than moving a forward thing, what we are planning is to get a rotational movement. So even if a median lobe is there, you tag there and then you don't need to move forward. If you move forward, you will go into the bladder. So what now next generation we are planning is that we will be doing a rotational movement, and that is how the tension will get and the suture will be cut there and then. So you can put it there and cut it there and the implant stays there and then. So that's how we can tackle the median lobe.
That because you have to do that because in second generation you don't have to take the device out. You can do the multiple fire with the
Sir,
same device.
that generation is that is too. It's a greener initiative. That is a different thing. This what I am talking is it's not yet come. It is in the pipeline. It is in the research thing. What second generation you are talking is that to reduce the burden of the entire implant,
Yes.
they have got only this staple. So you can you reuse the same device, the bulky device. You can remove the staple and attach one more. So that is second generation in that sense. What I am talking is the conceptual.
So can we hold the discussion for a while? We have Dr. Nikhil Vasudev from UK who is online. We have a semi-live virtual presentation by Dr. Nikhil Vasudev, who is a professor and chair of robotic surgery at University of Hertfordshire, UK. He is a consultant urologist and robotic surgeon at Lisio Hospital, UK. So he'll be demonstrating us a case of aquablation. Dr. Nikhil Vasudev, can you hear, sir?
Hi, morning.
I've already sent my talk.
Dr. Nikhil, is it?
Very good morning. Thank you very much for the invitation, Prof. Kumar and Pragnesh. It's a real pleasure to show you some of the data on aquablation. And now, having had completed 100 cases, I really want to sort of show you the latest data which exists, but more importantly, the setup on how aquablation gets going. I'm working very hard with Prostate to ensure that India has access to this technology, and hopefully it'll come to us in the not too distant future. The aquablation treatment, as the name suggests,
This video is not running.
is ablating the prostate using water jet technology. This uses AI, it uses a lot of precision, and the main advantage of aquablation is that it doesn't use too much heat. So unlike your current sources of treatment which exist, be it a TURP, monopolar, bipolar, be it HOLEP, you use a lot of heat on the prostate, and whether this is to the detriment, especially with regards to incontinence, erectile dysfunction, and most importantly, ejaculatory preservation is something which I want to consider. So, without acknowledging two more very important people, Prof. Kumar and I have known each other for many, many years. He's a senior mentor that I look up to. And, thanks for the invitation. Obviously, Pragnesh and I'll be in India at the end of the month to go to Hyderabad for the AINU meeting, and I look forward to seeing some of you there at the conference itself. Now, what is taking place at the moment in urology is there's a lot of advent of AI, but AI seems to be in the cornerstone of a lot of digital surgery, automation, robotics, but also with regards to imaging, AI seems to be a very, very important field to play, especially with MRI. The AquaBeam robot or the Prostate robot really allows you to use level 3 independence of autonomy, in which the ablated part of the resection is done using an AquaBeam with AI. So you only have control on how the machine is starting or stopping, and I'll show you a video on a patient that I've just done. But the importance lies in the fact that precision and anatomical preservation of key structures such as the sphincter, and especially with regards to ejaculatory function preservation, is off the record. So this is 100 cases that I completed 2 months ago with my team in Hertfordshire, and patient feedback is superb. So I have got 0% incontinence in my patients, and I've operated for patients with prostate volumes from 50 cc up to 285 cc. So I've done a broad variety of cases, and with the versatility of the AquaBeam, you can really operate on these patients with a lot of confidence, and I'll show you how and why. So Prostate Biorobotics has been in the mix since 2007, where we had the first commercialization in Europe. But now, in our region itself, which has a catchment of 4 million patients, we have 5 systems which are being installed. So, we get a lot of work come through, and patient demand is very, very high. This has been implemented in the EAU guidelines in March 2020, but with regards to your IPO PRCT, it was 2022, following which things have gone on. But as time has moved on, and I'll show you some of the data on latest evidence from the point of view of the Water 1, Water 2 study and the Water 3 study, which I'll be presenting at the North Zone USICON meeting with Dr. P.P. Singh and Rishi, who've got me to come and talk in November on the Water 3 trial. So we have a lot of centers in Europe doing aquablation. In the UK, we have 16 centers now. I was the 3rd adopter of this technology in the UK. But the advantage of aquablation is size doesn't matter. So you can ablate prostates right from small prostates, which, whether these patients benefit more from a bladder neck incision is something of debate. But certainly from the 40 cc onwards up to 200-300 prostates, you can deal with this without a problem. The main types of treatments which exist is to ensure that patients have symptomatic relief, but also continence preservation and sexual function is preserved in these patients. And men certainly are not willing to sacrifice either of these particular domains when they have treatment for BPH. So the size, depending on what you offer to patients, I know in India you have very, very experienced whole-lap surgeons. I've seen them in action at Apollo and in Max and in different centers in India. but ejaculatory dysfunction is high. Also, we want to ensure that ejaculatory dysfunction is low in these patients who are undergoing surgery, so that we really ensure that the quality of life of patients is very, very high. Now, with the Aqua Beam, the main setup, and I'll show you a video for a setup of a case that I've just done. The main prerogative is that you develop a real-time image guidance, you have a personalized treatment plan, and the automated robotic execution is the real onus of a level 3 automated robot for aquablation. But the main positive, in my opinion, is heat-free water jet treatment. So in 106 patients that I've done, I've had a 0% blood transfusion rate. But yes, I'm quite pedantic with hemostasis at the end, which takes me about 20 minutes to do at the bladder neck, and I'll show you a video on this too. Some people talk about aquablation being an enhanced TURP. That's absolute nonsense. It's not. It is a completely different operation, and I hope to convince you on this by the end of this presentation. The mechanism of how an aquablation beam works is basically three. It destroys collagen and soft tissue. It leads to disruption of collagen and destruction of soft tissue. But also, on the other hand, with the penetrability of the Aqua Beam, which works at 40,000 FPS, it allows quite a lot of preservation too to take place with regards to tissue modulation, especially the anterior part of the prostate when you're ablating it. This is real-time guidance that we use. So the patients have an ultrasound happening live, and you do a lot of mapping, and I'll show you how in a few seconds. So you have a cystoscopy phase with the Aqua Beam, plus you have image guidance phases which work out with regards to doing the technology. Key important parameters are preserved when you're planning. So I probably used to take an hour and a half to do a case when I started off in my first 30, but now I can do 100 cc prostate in about 30 minutes. This is from start to finish with the Aqua Beam, and I'll show you the speed at which it works. But there's certain key structures. You can do planning for the median lobe. You can do bladder neck, your bladder neck preservation. You need to be quite careful of the bladder neck because the Aqua Beam can penetrate and go down deep. And you can see this is 27 millimeters of resection that can be done. Lateral lobe dissection, you can bring out to 270 degrees upwards. But key structure preservation, such as the verum montanum preservation, and also the external sphincter presentation is good, because you can create a personalized plan to create a treatment contour for these patients. The shape and independence with regard to prostate size doesn't matter. So this is the video of one of my aquablations that I've done. At the end, you can see, you can get a very, very good flow come through. You do have a little bit of anterior tissue, which you might need to take down with your resectoscope. But on the whole, you get a patent cavity. And even when you scope these patients afterwards, in case you suspect an issue, I've had to scope 2 patients of mine with a query suspicion of a stricture. They didn't have any stricture, they had no problem. But there was some kissing tissue at the verum montanum, which you need to be cautious of when you start off with being quite conservative with regards to your dissection time. The heat-free dissection allows delayed healing of the prostatic urethra, but we need to make sure that you do not end up underestimating the accuracy of the AI, the large language model which exists with an aquablation, because you don't want to overcut and perforate the capsule whilst you are doing an Aqua Beam. So this is what it looks like. You do some 5 millimeter cuts at the verum montanum, and you do some butterfly cuts and winging, especially at the veru preservation zone. And this is really, really accurate with your aquablation technique that you tend to do. This is how it looks like when the operation is taking place with the aquajet working its way through resecting tissue. And you have complete control of the pedal, and I'll show you that in a second whilst operating. So this is a patient of mine who came to me for an aquablation. He had a 260 cc prostate. This is a setup in my theater. You have the on-table ultrasound. You also have the Aqua Beam stack. And this man came to me, he was 64 years old. He wanted to ensure that he had treatment done from the point of view of accuracy of treatment, but also wanted to ensure that he didn't risk ejaculatory dysfunction and didn't risk incontinence, because these are important concepts for these patients to preserve. And this is what's really driving quite a lot of aquablation. You can see he had a median lobe too, quite a chunky big prostate. So the startup basically is I have a fixed team of nurses. I work with 4 nurses who've trained up. Learning curve of the whole team is important to new technology. You need to make sure that everybody knows what they're doing, because there are steps in this technology which involve the aquablation resection, plus there are also steps in this technology which involve quite a lot of different steps from the resectoscope point of view at the end, which is about 20 minutes of resection. What you're seeing up here is the handpiece. of the aqua beam. It has a couple of components in it. So the advantage of an aqua beam is you have no tissue to morcellate, you have no tissue to evacuate. Obviously, when you do a limited TURP at the apical tissue or the anterior tissue, you may have to use an ELIC to get it out. But within the aqua beam parameter handpiece itself, once the aqua ablation takes place, all the tissue which is being resected is sucked out. So there is no debris or dirt left in the bladder which takes place. Now, the first setup is of the handpiece. So you can see we're setting up the handpiece in this patient. This takes a bit of time. And within the handpiece itself, you've got the scope inside. So this is the handpiece that I'm putting on to the patient. This is something which is not disposable. We have a sterile cover on it as we're putting it on. And once this is connected, we will ensure that it's calibrated accurately to get going. The next step basically ensures that it's wrapped up, water secure, and ProCep comes to every case that I do. I'm a proctor for them. I have set up 10 surgeons with their proctorship. In my unit, I have to train 2 of my colleagues to do aqua ablation. This is saline that's used, and you can see it's quite a big prostate. You know, this is the 280 cc gland that I'll be doing, and I'll demonstrate this to you. Lots of different checks are performed to ensure that all the connectivity is absolutely secure, because what you don't want is a blockage in the connectivity. Now, before the operation starts off, I will prime my scope. That means I will prime water through the entire system to ensure that it's working out fine. There's no air locks or air blockages taking place, because you don't want any suction blockage when an aqua ablation is happening. And we have quite a unique drape. So this you can see this is the patient that I'm doing. I'm putting the scope inside the patient. Quite a big gland. So that's the handpiece which goes inside. He's got quite a lot of anterior tissue too. And once I fix the scope on the outside, I do some planning. So this is the handpiece planning that I've done with the water jet. So this particular double edge is where the water jets are firing through. Quite a big prostate. I'm doing some angulation. This is the rectum here. This is the anterior aspect of the prostate. And what I'll do is, the traditional degree is 150, but I'm just going to go out a little bit higher up to do more lateral lobe dissection, because what you don't want to do is do an aqua beam in the middle of the prostate on your lateral lobes which are prolapsing in. So once this is done, I identify the nozzle of the aqua beam by firing some parameters. You can see that's a nozzle right there. And the length of the scope that you're operating on is 70 millimeters, 70 millimeters. I run it through, and I'm doing some planning. So I'm looking at a few. So this is the 280 cc prostate, and I'm going to ablate it in 5 minutes. So you can see ergonomically what the benefit is. If you do a HODEP or a TURP in a prostate of this size, you'll be there for about an hour and a half ablating. So ergonomically, this is really, really good. This patient wasn't too fussed, with regards to a blood transfusion risk. So I told him that, look, you may need a blood transfusion, although his hemoglobin drop was only by 1.5. But I will not do an aqua ablation on patients who are anticoagulated. And I'm doing all my aqua ablations under a general anesthetic. I'm not doing under spinal, because you cannot have any room for movement in these patients. So this is the time when we get going. You can see that this is the pump level. So the pump level is 60%. That means on the 24.3 depth, it's working at 70% of the level. But you can see that the ablation is very, very accurate. It's cutting the tissue quite nicely live as things go on. So this is something called the first pass that I'll do. And I'm being a little bit conservative. So I have complete control on the depth of the aqua beam, because you can see that it's cutting the treatment. And you can stop the treatment, start the treatment, as per your accord. This is not an automated, but the robot is automated. So this part is automated, but you're controlling it with the foot pedal on the feedback. Now you can see the pump is working at 100% of the level. That's when the resections really are happening. We're quite deep. We're resecting quite nicely. So I've cut up to this level. And with the Veru preservation, the aqua beam drops down. So the angulation is a lot lower. This is the butterfly cuts. I will do one more pass on this. So I will go back again, do a prime, just to see where the level is. You can see that already we've got a nice cavity. We will replan, because sometimes the prostate moves a little bit. So you can use your AI and replan. And I will do another pass which will take place. You can see this is my second pass. In very big prostates, I'll do 4 passes. That means I'll do 70 millimeters, and I'll move again. So I have a patient who has a 350 cc gland that I'm doing next Saturday. So you can see how it works out, and it's pretty accurate when the aqua beam is done. The tissue is really being ablated, it's being hit quite hard, and it works out quite well. Now, outcomes with superiority, and I'll show you some of the superiority with Water 1, Water 2 trial, which was in patients with a 30 to 80 cc prostate with an 80 to 150 cc. And I already took permission from Dr. Pragnesh and Professor Kumar to show you breakthrough data on the Water 3 trial, which I'll show you shortly, which is comparing HOLEP versus aquablation, which is quite interesting. And you can see that the ejaculatory preservation was excellent. Ejaculatory dysfunction rate was 7% versus 15%. So you can really reassure patients who really want ejaculatory sparing with aquablation. The risk of incontinence on our BOWS database is 1%, which is what's being seen with aquablation treatment. Sphincter preservation is important. This is how we sort of make it out from the point of view of some results coming through. But 50% of my patients are day case now. So they will go home the same day with their catheter. So I operate on a Tuesday and a Saturday privately and NHS, and patients will come back 3 days later to have their catheters removed with a 100% TWOC rate so far. The trials which we've looked at are different. So this is a part of the EAU, AUA, the NICE guidelines in the UK. You can see numbers, 181 patients, superior safety compared to TURP due to low irreversible complications. And with prostates, which are slightly larger, 80 to 150 cc, this is a size-independent procedure, as I've explained to you. So size doesn't matter, and there's significant relief which takes place. Now, let's sort of delve into some of the data which is coming up. My IPSS improvement at 3 months is 16. My Qmax improvement is 20. I have no incontinence, touch wood. I have no ejaculatory dysfunction. And I have 14 patients who had catheters in before, all of who had successful TWOCs. And there's some data to suggest good amount of superiority in patients who've had catheters in with chronic retention prior to surgery per se. Now, I'll just sort of move on with some of the important aspects with some of the new data coming through with durability. So 5-year retreatment rate with aquablation is 3.2% compared to TURP, which is 17%. It's maybe lower in India, I'm not sure, with TURP with expert hands. But certainly there is a statistically significant difference based on RCTs coming out, especially in patients who have 50 to 80 cc prostate glands. The IPSS improvement is very, very superior with aquablation. The setup is important. You need your anesthetist on board. I give my patients a bit of tranexamic acid before I start because this is, quite a athermal procedure, so bleeding risk was something which concerned me a fair amount. So let's look into some of the trials and the data which is concluding on this. So we had the Water 1, Water 2 study, and I'm just going to show you some of the advantage technology which is taking place because the Water 1 study didn't involve any hemostasis. So you would do the aquablation, put a catheter on the traction and leave it be. But now we have focal neck cautery, and I'll show you a video on this as to how important it is because right now we do have quite a lot of cautery taking place, which is 100% since 2024. An important question which comes up and people ask us, is it the higher bleeding risk? Probably was when you're not using cautery, but now that we use focal neck cautery, there is no difference at all. There's a significant decline in bleeding risk in reintervention, and the risk of blood transfusion in 70,000 patients analyzed worldwide was sort of sub 0.2%. So the risk of blood transfusion is very low. This is how my catheters look at the end of the procedure. This is the patient who I had done with 145 cc prostate, slow irrigation, and he's going to go home the same day. So this is something in recovery. It's just trickling through, and this is what we tend to see. So the bleeding risk is sort of unsubstantiated, and probably when you start your procedure off, you want to take a little bit longer to ensure that patients have a little bit of time. We're sort of looking at some data. So this is some breakthrough data which I want to show you. I was at the SIU meeting in Delhi in 2014 where I presented a breakthrough data on this, but we matured this data to 70,000 cases from a total of 40,000 that I had presented. So this is predictive across patient populations, and this is my data that I presented at the SIU based on different trials, from Desai, Professor Desai in India. plus the open water study, but also we've looked at quite a lot of data coming from Japan now, because Japan has basically implemented aqua ablation through the entire setup. Most importantly, we've also just in the process of writing up a systematic review, myself, Phil Charlesworth, and Ben Chullicum from Guy's on 70,000 patients, which will be submitting to JU Roll by September. Now, across size gland volume, if you look at 50,000 procedure, a majority of the procedures which are taking place are 60 to 80 to 100 cc, but you can take on bigger gland volumes which take place. But with regards to your symptom score, based on 1 month to 5 year data, there is a big improvement even at 5 years in these patients with low retreatment rates. Your peak flow, based on different trials which is taking place, ranges between 50 to 25% improvement at 3 months. It's especially from the Water 2 and from the Japan PMS study, which we've evaluated. The risk of residual volumes, so there's a high success rate in patients who've had catheters before. So there is a 90% chance that they have a successful outcome. We haven't really got a lot of comparison data with HOLEP and TURP, but 90% is a good figure to quote to patients who have indwelling chronic urinary retention catheters prior to surgery, or patients in acute retention who have failed their trial without catheters, of course. The volume group in sexual preservation is high, so the weighted average is 5.6%, which is very solid data with ejaculatory dysfunction. So you have 95% ejaculatory function taking place throughout the series. And weighting data with dermographic and efficacy, this is fresh data that I've got ready for this presentation today. You can see, your Qmax, your IPSS, and most importantly, quality of life improvement is very high. Now, percentage of patients in retention who had successful TWOCs. So you can see very high successful rates of TWOCs, 100% rate in certain studies. So pretty solid to say the least in this cohort. So we're looking about same-day discharge. We're certainly looking at 0.46% transfusion rate, which is low. It's not as high as mentioned before. And this is data on 70,000 patients internationally. So this is a big demographic group which we've looked at. The main thing that we're working on right now is standardization of protocol. I'm working with Procept on how to develop a standardized protocol, especially with aqua ablation compared to HOLEP, green light, and thulium laser. But there's a large body of evidence to suggest aqua ablation is superior regardless of prostate size with low blood transfusion rate. So let's delve into the real hot topic of this meeting today for the MAX meeting that I've got ready with my team. So this is breakthrough data on something called the Water 3 trial, which I've been involved with. So this is a trial looking at prostates between 80 cc and 180 cc for comparing aqua ablation with laser enucleation, because HOLEP is here to stay. I don't think HOLEP is going to go anywhere. You cannot do aqua ablation right now on patients who are anticoagulated, although we are developing more AI and certainly more hemostats. We're looking at a hemostatic project. We're looking at a new AI system in which we can spray the prostate cavity potentially with a hemostat, but this is in development right now. But let's look at Water 3 trial. So this is early data. So this is a 5-year project with secondary outcomes, but right now we are sort of really looking at 3-month data. And the cohort of patients that we've included were patients between the age of 45 and 80 with a prostate volume between 80 and 180. And there were 3 German sites and there were 2 UK sites. That's hence the reason why I'm involved with this. And the criteria was that all of us in the trial should have done at least 30 aqua ablation. So there's no learning curve issue. And this is learning curve with aqua. It takes about 30 cases for you to get up and running with your aqua ablation program. The standardization with regards to the IPSS preoperatively catheter-dependent rates was 19% in the aqua ablation arm versus 24%. And the procedure duration, was very similar. So obviously very experienced HOLEP surgeons compared to nuances who've done 30, 40 cases with aqua ablation. Prostate volumes range at about 105 to 108. So very comparative. And you can see statistically, based on our demographics, there was no reduction. Now, when we compare the primary results at 3 months, so like I said, this is 3-month data, it's early data. We've not sort of looked at this. This is carrying on with valuation, but I wanted to get something done. And this is largely based on your basin statistics and pool statistics that we run with the aqua ablation. You can see that the 3-month change with IPSS with aquablation was about 13, so fairly comparative. But at 3 months, patients did notice a bit more improvement with aquablation compared to HOLEP. So 9.1 versus 9.3 is statistically significant. The statisticians say no, but there is definitely a difference at 3 months, but early on they're fairly comparable. Your efficacy of results with your Qmax improvement is way higher with aquablation. So the Qmax improvement was higher from the point of view at baseline, but when you compare it to HOLEP, the aquablation improved, the Qmax improved at 28, whereas with aquablation it improved at 20. So the question is, are we getting a much more bigger patent cavity with HOLEP? We do not know. With post-void residual volumes, again, a bit of superiority with aquablation, but the prostate size reduction based on post-operative MRIs and CT scans, so this is baseline, you can see that you're probably ablating a bit more tissue with HOLEP compared to aquablation, which what you would expect, especially with more of a resection which takes place with the HOLEP, and your aquablation probably doesn't take into account so much anterior tissue which you need to resect out as the operation takes place. The risks of complications, bleeding, 2% versus 1.1%, so not statistically significant difference between these big prostates. Fulguration was the same, but your importance with regards to complications were higher with HOLEP at 54.5%. This is all Clavin-Dindal 1 in 5 to 40%. So complications being slightly higher. The risk of catheter-associated UTIs or UTIs afterwards was comparable between both trials. Now, ejaculatory preservation was way higher with aquablation. So only 14% of patients complained of ejaculatory dysfunction, whereas 77% compared that with HOLEP. And the symptoms of sort of urge incontinence were higher with HOLEP, and certainly stress incontinence was higher with HOLEP. So you can see at 3-month data, there is already functional preservation, which is taking place in a much more superior way with regards to ejaculation and incontinence. This is what we have noticed previously. So what can we draw from this data so far? Look, it's 3 months. I will keep you posted when I come to the North Zone meeting on some more mature data, which I'll get ready, and I've spoken to Rishi about this already. So short-term improvement, no real difference. Blood transfusion rates, no real difference. Bleeding rate, no real difference. The prostate volume reduction in flow rate, yes, HOLEP is superior compared to aquablation, but functional outcomes-wise, IPS score-wise, ejaculatory dysfunction is way lower, and stress incontinence is way lower statistically with aquablation compared to HOLEP. So I'll stop with that. Thanks so much for the opportunity. I'm sort of doing 2 robots prostates, but I'll reach out to you and take any questions after my presentation. So nice to see you all, and look forward to seeing you in India very soon. Thank you.
Thank you, Nikhil. Wonderful lecture with all that lot of data, very convincing data, and the only problem is this device is very expensive. Otherwise, we love to have it. So, if anybody wants to have any question, then he will be happy to answer.
Nikhil, excellent talk. I am really impressed. The only thing is,
thank you, sir.
Can we do it in patients on anticoagulants? What is your policy? You don't do it at all?
No, sir, I don't. The reason is that obviously, we are still working on development of a better protocol. But with this particular procedure, if someone is anticoagulated, because this is a heat-free cut that we perform, the risk of bleeding is high. So in patients who are anticoagulated, my HOLEP colleagues will handle and help us out with them. But certainly on someone who's anticoagulated, and a lot of patients, especially the elderly group now in the UK and Europe, tend to get anticoagulation for some reason or the other. So we are quite cautious, but I would not definitely take a patient on with aquablation who's anticoagulated. Not at all.
But Nikhil, after the procedure,
Sir.
aquablation, you put the cystoscope, and all the bleeding is to be coagulated because there is some oozing going on, and it has to be, hemostasis has to be done in all cases.
So the hemostatic time is 5 to 7 minutes. So
Yeah,
I
but
will
you have
not
to do it.
do only at the bladder neck, Professor Kumar. So you don't have to do hemostasis within the prostate. The collagenase mechanism of how the aqua beam works, it sort of is quite pro-coagulant. It will help you coagulate that tissue. But at the bladder neck, because the fibers are so exposed, majority of the time we just have to use a rolly ball in that area. So in a patient that I did, which was a 350 cc gland, my coagulation time was 4 minutes at the bladder neck, and that's all I did. And you put a catheter in. Now, the catheter removal time is important. So my patients go home, day case 50%, but they'll come back and have their catheters taken out in 72 hours. You don't want to take the catheter out too quickly because that coagulum itself acts as a bit of an obstructive feature. And patients will notice passing this coagulum for about 4 to 6 weeks afterwards. So as far as driving is concerned, we say they shouldn't drive for 2 weeks. And exercising and going to the gym is concerned, it's about 4 weeks.
Dr. Nikhil?
Hi,
Yeah,
Dr. Singh.
Yeah. So you don't get any tissue for the histopathology in this procedure?
Only when you use a loop, sir, to resect. So the tissue which is being aqua ablated is not analyzed. Now, there's some work taking place. We're doing a trial called the Water 4 trial, in which we're doing it for cancer. So it's a trial comparing robotic prostatectomy versus aqua ablation, which is recruiting right now. So we are actively recruiting into that. Now, with that tissue which is being anticoagulated, we are doing some extraversatile work on the coagulum to evaluate the characteristics of the biopsy tissue. But as far as the BPH procedure is concerned, sir, we will not do any. The only analysis we get is when you put a loop in and take some anterior tissue down and ELIC and send it away. But the tissue that you're anticoagulating, there is no histology done on it.
And why do you need to work near the bladder neck?
So the issue is that when we do an aqua beam, and I've showed the video, we are slightly conservative at the bladder neck. So we don't want a perforation. The aqua beam is so precise that it does exactly what you want it to do. So, when we start off with the initial program of an aqua ablation, I will use very low energy at the bladder neck to just sort of run it in that area. Then when I come in the middle of the prostate, I'm happy to use a high pump level. So I don't want to perforate my bladder neck during an aqua ablation. That's the risk with this if you're not careful. But now, and the important aspect of the AI with this technology, suppose when you start off your program, and like I mentioned, I'm working very hard. We're working very hard to get this across to India, which will happen soon in April next year. I know you and I have spoken about this a few times.
Yeah.
The key is the AI will correct you from going too deep with aqua ablation too. So there's a huge safety mechanism, and my trainees who do aqua ablation will love it because, it's a lot of AI. So just to give you an example, this 350 cc prostate was done in 16 minutes. Now, if you do a 350 cc HOLEP, it's going to take you an hour and a half to 2 to get it right. So, the ergonomics of the aqua beam and being autonomous has and this is the first generation of the system. We have a lot more which will happen over the next few years.
Okay. Nikhil, this is Dr. N.P. Gupta. Hello.
Hi, Dr. Gupta. Good morning.
Good morning. Nikhil, what about dysuria and all that? Because you are saying that coagulum will be there and it will come out after 4 weeks, so patient must be having a lot of dysuria.
So, that was a main concern which came up with the Water 1 trial. But, on our audits and data, they don't complain of anything at all. Because the coagulum is very, it's hypercoagulated tissue. So it's not that it's chunky coagulin that we used to see with green light or with PVP, when we have a lot of coagulation which takes place. But patients don't complain of it much. If someone goes, running at 2 weeks, they will have a bit of blood and will pass that coagulum, but that coagulum slowly passes out. So if in my 106 patients, only one has complained about significant dysuria, but he had a catheter in before with a lot of prostatitis, so I'm not sure what caused it, but on the whole, patients are very happy. There's no real issue at all.
Just one question more. Nikhil, we do HOLEPs regularly, and we find that the PSA reduction is sustained even up to 20 years or more. So the question is that if there is raised PSA post-HOLEP, we always suspect malignancy. So the question is, what is your view on PSA reductions? I don't know, but then what is the studies telling about this?
Yeah, so the volume reduction compared to HOLEPs is slightly lower because you don't have that anterior tissue or the lateral wing tissue that you deal with. On the Water 3 trial, when we've compared HOLEP versus aquablation, we're waiting for some data to mature because right now we are at 9 months. At a year, we'll evaluate this. But all of our patients, if not most of them, will have an MRI before. So, if we suspect a malignancy, they'll certainly have a biopsy from the point of view of before an aquablation. But sometimes I have done 2 patients who've had aquablation and gone on to do a robotic prostatectomy on them. And I can promise you it's equally as sticky as what it is with the HOLEP. So, the resection is fairly similar, in my opinion, because you would think that if you're not ablating as much, you probably will not need to probably have a slight difference in tissue planes, but a robotic prostatectomy post-aquablation is equally as hard as it is post-HOLEP. But as the data matures, sir, I'll speak with the trial team and we look at PSA figures in our patients. But we have a big program of MRIs before, etc. So if there's something malignant, we will do a fusion biopsy and then before the aqua.
So Nikhil,
Thank you.
You can apply this technology in different sizes of the prostate.
Sir.
So you think that if financially it becomes viable, it will replace all the techniques which you are using to treat BPH?
So the demand from patients is very high. And in the UK, sir, what is happening is we've just published a paper in the New England Journal in which patients basically bypass non-robotic centers. So similarly, the demand for this technology is such that, from three devices 24 months ago, we're up to 65. So, this is not being driven by us alone. Patients are demanding it for it too. I think this has a strong role to play for us as surgeons for an ergonomic technology in which patients who want to have ejaculatory preservation and whom incontinence is a big deal, they will certainly pursue this. This is what patients come to us for. But whether this will dent or replace HOLEP, in my opinion, I don't think. I think the indications for HOLEP are very, very specific and severe. But this will certainly replace TURP going forward. And maybe, certainly as time evolves with better hemostatic protocols, maybe HOLEP too. But I'm not so convinced that HOLEP will get replaced.
What do you think will be the learning curve for young urologists?
So we've done a lot of work on this. So on the 70,000 patient data that we've looked at and presented, and I've just submitted this to JUROL and the data that I showed at the meeting, 30 is the number that we come up with regards to, and this is the whole team. So the team takes about 10, 15 patients to get used to, how you do it. There's a lot of steps involved. Your anesthetist also has to know that the patient has to be absolutely paralyzed. So, I don't do these with spinal because you don't want any patient moving or coughing when the aqua beam is moving. But I know that Rick Popert, my senior colleague at Guy's, does it with a spinal with an operator block, etc. So I think 30 cases is what we look at with the learning curve. That's why in the Water 3 trial, we included surgeons who had done 30 cases and above for the learning curve's point of view.
So this is all data. In your personal experience, what was the complication that really worried you or you'd be very conscious about using this technology? I mean, data publication is a very different thing. But the true personal experience makes all the difference to really tell us the truth. What are the challenges?
So, I've got 2 of my gurus sitting right next to you, Dr. Kumar and Dr. Singh. So, I will be open and honest with complications. So I had a complication on my 4th patient, which was a bladder neck perforation. And I think, I had done 3 cases which had gone off really well. I honestly thought it was a 45 cc prostate and the aqua ablation was probably not resecting as much as it was saying. So I pushed it a bit more and I learned my lesson then because the accuracy of the aqua beam at 40,000 FPS is so precise that I perforated the neck. So I put the scope back in at the end for hemostasis and I had a complete perforation. I had to put a suprapubic catheter and come out. I didn't sleep for a couple of nights because this was a private patient in the UK that I had done. But that's the reason why I say that, with the advent of this technology, you have to respect what the aqua beam is doing. It very, very precisely cuts exactly what it's showing with the live ultrasound. So that was my only complication. And after then, it's been okay because I've shown a lot of respect to this device and it's working out well.
Great, thank you.
Hello, Nikhil, this is Dr. Dogra. Good morning.
Hello, Dr. Dogra.
Good
morning, sir.
I know it's very exhaustive lecture and it's a lot of data. People are developed.
Thank you, sir.
And I just want to ask you one thing. It's just in a lighter way. it is the job of a technician like physicist and radiation medicine. They're the one who are more important than the radiation oncologist because he only advises radiation to be given or not, if given, how much is the dose. The rest of the job is done by the technicians. So same way in aquablation, what is the role of these type of specialized trained technician we will need, because this is not a job which an ordinary person can calibrate.
Absolutely, Dr. Rogra. I think the key is to have a full team. We don't have physician associates doing surgery in the UK yet, but I'm sure there will be dedicated BPH physician associates that will develop in the future. But as far as the technology is concerned, Dr. Rogra, the main thing is to make sure that everybody is up and running, because the setup for this procedure was taking about an hour and a half initially. There's so many different devices. It's not only a resectoscope or a holoscope. You have an aqua tower, you have an ultrasound, you have so many different protocols which are running. So like you said, they are dedicated team members who are now purely doing this.
This is what I'm saying. You need to have a very specialized trained technician. You will not be able to work in an ordinary setup.
And the other thing is the hospitals like it because, if you would do, say, 2 HOLEPs in an all-morning list, I do 4 cases from 9 to 12, irrespective of prostate volume. So our productivity has gone up a fair bit with aquablation because the procedure is so quick.
Well, thank you very much.
Dr. Dogra, my submission, my PP.
Dr. Nikhil, last question.
Sir.
So, in the pre-operative workup of these patients, are you doing MRI regularly to assess the prostate if the PSA is normal?
No, sir. If the PSA is normal, I do an ultrasound because you need an ultrasound before. And what you don't want to be caught out with, Dr. Singh, is something atypical. So, you don't want to be caught out with a papillary lesion in the bladder, etc. But the ultrasound is very important because whilst you are doing your procedure, your aqua beam itself, you have a live ultrasound, which you do as a urologist, on the sagittal section, etc. But I do a baseline scan because if someone's prostate is, say, 300 cc, then we will do 4 passes. So you will do 2 passes in the beginning towards the bladder neck, then move the so you have to tell the team to be prepared. So that's the reason why I do it, just to get an accurate gauge of the volume. We can do a truss in the clinic, but I think, a lot of these patients are chronic retention. I just want to make sure there's no hydro. And I also do a flow test in the radiology department so that for our audit, because we have to submit our audit data with the new technology to see the Qmax improvement. So it's all more governance related. But I think a baseline ultrasound is enough. But, if someone's PSA is above, then you should do an MRI.
Right. And do you see...
And in this particular device, Dr. Singh, we have, if someone has a median lobe, you have a separate software for the aquablation in which the aqua beam only cuts at 112 degrees and not higher to prevent any risk of ureteric orifice injury.
That was my question. So you take special precaution in patient of big median lobes.
So there's a separate part of the aquablation when you're doing your planning. If someone has a median lobe, you can use that software for the initial planning in which the aqua beam only goes sideways and not downwards. So this is the safety protocol.
So we hope to see you operating live with us.
100%. Looking forward.
Dr. Vasdev, one question, please. PP. Dr. Vasdev, have you thought of using it in a localized CA prostate?
Yes, we have. That's why the trial is running right now, sir. So we're doing a trial called the Waterfall trial, which is ablating the entire prostate with aqua beam between 7 centers, between the US and the UK and Europe, compared to robotic prostatectomy. So we are actively recruiting right now because the question is, will this replace, I don't think this will replace robotic prostatectomy, but it will strongly replace focal therapy because now we are getting a live cognitive fusion MRI with aqua beam to treat focal prostate cancer.
Good.
Dr. Nikhil, Dr. Amit Osmani here. Sir, in India, we see a lot of chronic prostatitis patients who have multiple small pockets of pus. So when this beam go through these pockets of pus, what do you think are the chances of the patient going into sepsis?
So this is a very important question because my concern also used to be, especially in diabetic patients with catheters in, with recurrent UTIs, is there a higher risk when you are dissipating bacteria at this level? Are they going to get septic? So the answer is we haven't seen that. Obviously, they have to be on antibiotics before. The other thing also is that we do a lot of aqua redo. So I've done 3 patients who've had urolifts which have failed with an aqua beam. So it basically is very precise, but there's no increased risk of sepsis. We have looked at this in our 70,000 patient paper, and there's no difference. But obviously you need to cover them with antibiotics correctly before.
So we need to make sure that the urine culture is sterile before we go ahead with this procedure?
Or you give them, look, you and I know that it's very unlikely that it'll ever be sterile in someone who's got chronic prostatitis. It never clears up, and these guys are plagued. So I think for symptomatic relief, there is no difference between a TURP or a HOLEP and an aqua ablation in these patients. So there's no disseminated risk of sepsis, if that's your question.
Yeah, thanks.
Thank you very much, Nikhil. It's a wonderful lecture. Thank you very much
for
taking time from your robotic surgery. You could see you are sitting in the robot. So thank you very much.
So see you soon.
Okay, thank you. Bye.
Bye-bye. Thank you. Bye.
Thank you, Dr. Nikhil, for your valuable experience.
All these missed modalities are there when patient comes to us like medium-sized prostate. So which to offer for an average prostate? Like all modalities can be done. So if we give too many options to the patient, so they'll get confused and like it is difficult for us to counsel.
No, the problem today is patient decides and come to you. And if you don't give options sometime, they may think you don't know your subject. Today the scenario is completely different. So you have no choice but to mention the name that these are the procedures available. If at all, I would recommend this. But you can't say patient do this procedure.
Sir, now we transition to our next live operative session 3. For that, I would call upon the stage the next chairpersons, Dr. T. Manohar, Dr. Aditya Pradhan, Dr. Amit Shah, Dr. A.K. Sanwal, Dr. Aditya Prakash Sharma, Dr. S.P. Yadav. So please join us on the stage for the next live operative session. Dr. T. Manohar, Dr. Aditya Pradhan, Dr. Amit Shah, Dr. A.K. Sanwal, Dr. Aditya Prakash Sharma, Dr. S.P. Yadav. We have live operative session 3, which is dedicated to advanced prostatic biopsy techniques using the fusion imaging technology. So OT11, we are connected with Dr. Rohit Kaushal right now.
Good afternoon, respected sirs. This is Dr. Umar. I'll be briefing the patient's history in few lines before we hand it over to Dr. Rohit Kaushal. So this is the 8th case capsule for the day. And this patient is a 51-year-old gentleman who primarily came to us with obstructed urine flow with some amount of storage LUTs as well. He's a hypertensive. His abdominal and genitalia with digital rectal examination were grossly normal. He had a grade 2 gland. On evaluation, his PSA came out to be 9.2, for which he was then started on 2 weeks antibiotic therapy, following which his PSA again was 9.3. His multiparametric MRI revealed a gland size of 34 grams and a Pyrads 3 lesion in left peripheral zone and right transitional zone, both measuring around 7 mm. His routine blood and urine workups were normal. His urine flow was, maximum urine flow was 9.7 ml per second, and the pattern is given in the image. So the diagnosis came out to be benign prostatic enlargement with bothersome LUTs, with raised PSA and Pyrads 3 lesion under evaluation. So the plan was made to perform a MR Trust Fusion Transperineal Stabilized Prostate Biopsy using BK 5000 system. Now handing over to Dr. Rohit Kaushal, sir.
Hello, Dr. Rohit, Dr. Manohar here.
Hello, hi Dr. Manohar. Hi, welcome. First and foremost, warm greetings from Max Saket. Am I audible?
Yeah, you're audible. Please go ahead.
Warm greeting. So as my colleague has already outlined the case history, so briefly, first and foremost, I'd like to make you all aware about the hardware which we're using. Today we are using the BK 5000 system, as you can see on the screen. And this has
Dr.
attachments for... Hello?
Dr. Rohit, good afternoon. Dr. Gaurav this side.
Yeah, good afternoon.
Before we start the biopsy, I would like to ask what antibiotic prophylaxis protocol you routinely use for your patients?
Just a single dose of injection Magnix at the time of induction, 2 grams. That's it.
Okay, you give all these preoperative in all transperineal biopsies? Okay.
Pardon, sir?
You give them 2 gram of injectables in all patients
Yeah,
of transperineal?
yeah, we give 1 dose of injectable antibiotics in all
One dose,
transperineal,
okay. Yeah.
all transfusion biopsies. So coming out to the hardware, this is a BK5000 system, and it has attachments for both the transrectal as well as the transperineal fusion. The transrectal fusion has already been demonstrated today morning by Dr. Vivek. You must have witnessed it. So I'll be demonstrating the transperineal stabilized fusion biopsy. So the hardware consists of 3 components basically. One component has been, if you can, I don't know if you can see on the surface view, there's a thing which has been attached onto the OT table on the side rails, on which there's a system known as a stabilizer, which is attached to the side rails. And then on the top of it, we have a cradle. So onto this cradle, which you can see, we have snugly fitted the transperineal biopsy probe. Now this transperineal biopsy probe is a biplanar probe which has 2 arrays. One is the transverse array and another is the sagittal array. So you can see on the ultrasound screen that now my probe is inside the rectum. The probe has been firmly fitted onto the cradle, and I can move in to and fro based on a knob which is located over here. And you can see the simultaneous images on the ultrasound. Like if I come from towards the base to the apex, you can see as I move out, you can see the appearance of the small median lobe, the gland, the seminal vesicles, and I am coming out from base to apex. Now I've just scanned the whole of the prostate. Now I'll again go back from the apex to the base.
Yeah, that is the stepper.
So the fusion biopsy involves first a preliminary imaging to see whether all the imaging settings are appropriate, whether we need to adjust anything else, the zoom, every functions, and then we go for the proper fusion steps. So the first step of fusion is loading the contoured prostate. Now the contouring is a separate set of steps which is done on a software which has been provided by the company on our computer system. On that software, we load the MRI of the patient through either a pen drive, a hard disk, or the compact disk, and then we load all the imaging sequence on that software. We do the contouring of the prostate right from the apex to base. Due to time constraint, I won't be able to show that contouring process. I've already done it and saved onto my pen drive. And then we also mark the region of interest which has been discussed with a radiologist and reported on the MRI. And we do the region of interest marking in different color coding, as you can see in the subsequent steps.
That I will cover it in my lecture if you permit.
Sure, sure.
Yeah, I'll do that. Don't
so
worry.
I'll just move ahead with the biopsy process per se. So once we have done the thorough scanning of the prostate gland, we'll move to the fusion step. So we activate this, we choose the transperineal and all the particulars, and we start the procedure. Can you have the view of the ultrasound image?
But in the monitor, it was showing TR biopsy. It is not TP?
No, it is TP biopsy, TP.
Because of the patient.
Here, TR was on the side one, but we have selected the TP one.
Okay.
So now we go for the confirm. So this is a virtual grid. This is actually the, can you see this? This is the grid which we'll be using during the biopsy. So this is the same grid which is used for the brachytherapy.
Grid.
And this same virtual grid you can see on the screen. So we confirm the grid alignment, the numbering, everything by clicking on this confirm grid alignment button. Following this, we wait for the software to load.
Oh yeah, now
we already marked contoured prostate onto this system. Now on the top, you can see the real-time ultrasound image. And on the below mentioned images, you can see different cuts of the prostate which has been contoured by me on a software elsewhere, which has already been loaded onto this machine.
But you have
So
shown
the first step involves,
you have shown 2 area of interest, no? And 2 high.
Yeah, 2 area of interest, right.
Yeah.
I will come to that in the subsequent images. Yeah. So right now, first and foremost thing we need to do is match the best sequence of the contoured prostate with the real-time ultrasound image. Now, how do we do it? We choose one particular area of the ultrasound scan on the prostate, which closely fits the contoured prostate. We can choose it anywhere, right? We can choose this, we can choose this, we can choose this one, anyone. So I'll start with the first one, which I have marked it. He has a small median lobe. So I have chosen this reference plane, which I will fuse onto the ultrasound real image by dragging this and doing fine tuning with this drag option. And then we select it. So now we have to follow these steps which has been highlighted like sync stepper, auto capture, realignment, proceed to biopsy. We press onto sync stepper. Now we start moving the knob of the cradle, and the ultrasound probe starts moving out from the base towards the apex. And the contoured prostate moves along with my real-time ultrasound. As you can see, I've moved the knob out. I'm coming from the base towards the apex side one at a time. So the contoured prostate also moves along with my ultrasound real image. So here you can see this lesion marked in green color on the right-hand side. This is a Pyrite 3 lesion which has been reported and discussed with our radiologist. The green is the one which I have marked for my reference, the urethra. And the blue is the prostatic outline, the contoured prostate. So as we move further out from the base to the apex, we can see the appearance of the other lesion which has been marked by me, the pink color lesion which is present on the left peripheral zone. And the right region of interest is on the right transition zone, just above the peripheral zone. So now I keep on moving out. And if at any step I find that I am not exactly following the contour, I can do a small correction by placing this drag option. And continuing with my contoured prostate. So now I have reached the apex of the prostate. So I have scanned the entire prostate from base to apex. So now I'll again go back to the base and we'll move on to the next step, which is the auto capture function. Now auto capture will store each and every sequence in the memory of this system. So once we click on the auto capture switch on button, we just go on moving again, same steps from base to apex, and it will start storing these images. Once you have confirmed that the stepper is syncing appropriately as expected, we start auto capturing it. So now we have reached the apex. We'll stop the auto capture function. I'll do the realignment and I'll just check whether everything is fine as expected. I'll run this on an axial section. I may run it on a sagittal, but I'll just skip this step and we'll put a green flag to this. And after this, finally, we proceed to the biopsy. So now after proceeding to biopsy, it is very important we have to switch the plane from the axial to the sagittal plane. Now you can see the prostate in the sagittal view. So on the top, you can see the ultrasound image. On the lower down, you can see the MR images, which we have already marked and now fused with the real-time ultrasound. So as I move the probe inside, now you can see my probe is going right inside from the apex to the base, and we can see the appearance of the prostate gland and the contoured prostate, and the urethra marked in green, and with a small median lobe. And this side is the bladder. The black is the bladder. And this is the entire contoured prostate gland. This is the urethra, which you can see on a sagittal section. These are the perineal soft tissue, and this is the pubic arch over here. So now we go on to the lower image, and we scroll to our area of interest, which is the pink and the green lesion. So now you can see that there is a virtual grid which has been created over here, which you can see the multiple numbering 4.55, 3.53, and on the x-axis you can see small capital A, capital B, small b. So this every numbering and the alphabets corresponds to a coordinate. For example, capital A 2.0, capital A 3.0. So it's a coordinate, so which you can match on this grid, as you can see. So exactly the same virtual grid which you're seeing on the screen, you can see on this grid, which I'll be placing on this. So now we'll place this virtual grid onto this cradle, so as to fix it. यहाँ दिखाओ इधर या थोड़े इसको सेंटर पे ले आओ या सेंटर पे लाओ या so this is the grid which has been fixed onto the cradle. Now we slide this system, as you can see, we can slide it. We slide it onto the perineum. We don't press it too hard. We just have to press it against the perineum and lock it. So now half of the work is done. Everything is fixed and in place. Now we just have to target the lesion by rotating our red pointer. You can see on the ultrasound. Can I have the ultrasound image? Zoom in, please. So you can see on the lower image that we have a central red line. This corresponds to the central line on the probe. So this, as we rotate the cradle with the probe, you can see the red line is rotating towards the right side. And as I rotate towards the left side, it rotates along with it. So we can exactly target the desired area based on the coordinates. Like for example, first and foremost, we'll target this area on the left peripheral zone. So this is a Pirates 3 lesion. So you can see I have made it on the 1.5 and capital F is my coordinate. So same coordinate I follow on the grid. Now coming on to the biopsy gun, I am using a Bart's biopsy gun which is 18 gauge, 20 centimeters. Initially we were using 25 centimeters, but we were facing some problem with wobbling of the needle tip, not hitting the target. So we modified a technique. Now we are using 18 gauge, 20 centimeter needle. So now I'll just use the same coordinate, 1.5 and capital F. On the grid you can see. And you can see on the sagittal section on the top view that my needle is now close to target. I just have to fire it. And my biopsy is done. The target biopsy, the first core. So this throw of the needle is around 1.5 centimeter and it takes 0.5 centimeter of the core. So approximately the total core length is 22 millimeters. So we'll fire just proximal to the core, approximately half centimeter. You can see it has hit the target and we can label it. Extra left. So we have got a very nice, good core. I don't know if you can appreciate. I may not be able to show it. So we have got a very nice core. Now we'll take, now depending on the size of the region of interest, we take 2 to 3 extra cores from each target. Line. Yeah, Rako. And small e. So my next is one and capital.
You are taking only targeted biopsy or you are planning even sector biopsies also, Rohit?
I am planning section biopsy as well.
Sector also?
Yeah, yeah.
Template, okay. Yeah. Why you do that? It's not...
We can do it freehand as well, but we are routinely doing it sectioned also with the grid, using the grid. It is ideally ideally suited for the target biopsies.
Yeah.
But no, yes, we may.
Yeah, because I mean, in the doubtful manner, in my practice, if it is a 3 doubtful lesion, if there is a suspicious, so yes, basically we do targeted and sector biopsies. That means the template. If it is 4 and 5, I'm very sure they are going to be positive. So I'm going to do only targeted biopsy. That's what I was hinting at. So I think in this case, 3 suspicious lesion, you can go and do a few biopsies around the lesion, and also template biopsy, some target lesion, plus some of the lesions, some outside the surrounding area, you can take it. That's what I was hinting.
Yes, absolutely. I always take a perilesional biopsy. Because many times cancers are present in the perilesion as well.
So we are doing that, and we move to the next theater till we will be seeing you.
Sure, sir.
We'll go to the next theater with Dr. Amitabh.
Thank you, sir.
Thank you, thank you. Please go ahead. We are watching you.
All right, sir. Thank you so much.
Is the other theater is ready? Any question from the floor regarding the TP biopsy stabilized? Yeah, once when I was doing it, one of my...
Good afternoon, everyone.
Amitabh is ready?
Proceeding with the 9th case capsule.
Wait for a while, Umar. Wait for a while.
We have a patient.
Left.
Umar, wait for a while. Can you show the OT9?
Right कर ले लो.
We can't see your slides, Umar.
हाँ.
Please connect us to the OT9.
So Manohar sir, meanwhile they are setting up, the patient is always under general anesthesia or spinal or regional?
It is, we do regularly in pudendal block.
Pudendal block.
Pudendal block. And also we sometimes do a prostatic block with some mild sedation.
Right.
So very rarely we give it. General anesthesia is given in a very small lesion.
Okay.
Suppose about 1 centimeter lesion, you want to target it. Suppose in case of pudendal block or whatever, if he moves, that fusion is gone. The patient should not move. Suppose if it's a bigger lesion, even if it moves, you know that it's a bigger lesion, 1.5 centimeters, you can go and take. Smaller lesion, it's a general anesthesia. So I don't want him to move because once the patient moves, the fusion is gone.
Sorry for the interruption, sirs. So I'll briefly narrate the summary of the 9th case capsule of the day.
Please go ahead.
So we have a 67-year-old male patient who came to us primarily with the mixed lower urinary tract symptoms. On evaluation, elevated PSA was noted, but other than that, there was no prior urological interventions or any history of urinary tract infections. He's a known hypertensive, and his examination, abdominal and genitalia examination were normal. On digital rectal examination, his prostate was grade 3. However, no nodule was palpable. On evaluation, his urine and blood reports were normal. His total PSA came out to be 19.04, for which an MRI was done, which revealed a prostate size of 170 cc, and there were 3 suspicious lesions. One, Pyrex 4 lesion in right posterior transitional zone from mid-gland to apex. Second, right anterior transitional zone at the apex, which was Pyrex 3. Another Pyrex 4 lesion was there in left posteromedial peripheral zone near the apex. So these are the MRI images. So the plan was made to perform a MRI truss fusion prostate stabilized biopsy using Artemis system. This case will be demonstrated by Dr. Amitabh Singh, Senior Consultant, Department of Uro-Oncology, Rajiv Gandhi Cancer Institute and Research Center. Handing over to you, sir. Thank you.
Good evening, everyone.
Good evening.
Hello.
Yeah, good evening, Dr. Manohar here. We are panel here. We are ready to see your procedure.
Yes, sir. So can you hear me?
Yeah, we are able to hear you.
Okay. So can you see the machine, sir? Egan Artemis machine.
We are able to see you, but the machine is not been focused.
We are able to see you, sir, not the machine.
Cameraman to show the
machine दिख रहा है?
Machine partially दिख रहा है, आप पूरा दिख रहे हैं.
Okay.
Now
no, this one.
See that Artemis. Yeah.
No, can you come closer?
I think you should come from your end.
हाँ. बिल्कुल. Yes. Nice. So this is totally different machine than BK, sir.
Yeah.
So we have been using this machine for last 10 years, more than 10 years in fact. So initially we were doing transrectal MR fusion biopsy with this machine. But when we just asked for the transperineal, they just modified few hardware in the same machine and they made it compatible for transperineal fusion machine. So compared to the BK, it was like more economical for us. So that's why we just got everything changed on the same machine. And we are doing transperineal fusion biopsies with the same machine.
How economical, if I can ask you?
Without having any difficulty. So this is actually, you can say there are like 2 patented technology for Egan Artemis. One is this remote centered motion. So you can appreciate this motion, this robotic arm. So this is basically hub where all the trackers for the robotic arms are there. So it tracks the motion of the arm, the point of the ultrasound machine, and that's how it tells you where exactly you are in the prostate. And it has another patented technology where it has got the this elastic fusion system, because most of all these machines like BK software and every machine, they are using rigid registration, but this machine also uses elastic fusion. And I think most of you must be knowing what is the difference between this rigid registration and elastic fusion. If you don't know the difference, then I can explain you about the rigid and elastic fusion.
Please go ahead, sir. Explain for the sake of audience.
So,
go ahead.
Yeah, sure. So now this is Erita ultrasound. So this is the same probe, biplanar with linear array. Jelly, sister Jelly. Sister Jelly. So I think I have got the ideal setup because patient is intubated, but we are doing transperineal biopsy under local anesthesia also. We are doing, I think if the lesion is significant and size is very much like more than 1 centimeter or more than 1.5 centimeter, then we are doing transperineal fusion biopsy under local anesthesia also, and patients are tolerating it very well. But if the size of the lesion is very small, then we are trying to get the transperineal fusion biopsy under general anesthesia, short general anesthesia. So now you can see the images of ultrasound image.
But this is transrectal. Do you think he requires general anesthesia?
So I can't hear you properly. Ek second. Can you increase the sound? Because I can't hear him properly.
This is a transrectal. Hello? This is transrectal, Dr. Amitabh. Hello?
Hello, Manoran sir?
This is transrectal. Do you require anesthesia for this?
Pardon sir, I couldn't hear you. Your volume बढ़ाना थोड़ा सा please. हाँ नहीं बस मुझे दिखा.
Do you require general anesthesia for transrectal biopsies?
No sir, no. So when we were doing transrectal MR fusion biopsy, we were doing perfectly under local anesthesia.
Yeah.
So when we just shifted to transperineal biopsy, then we started asking general anesthesia for this patient, because it is a painful procedure and patient had to be very cooperative to get the biopsy, especially when the size of the lesion is very small, because we want patient to be very still. He should not move up even like 1 centimeter, otherwise the lesion will be missed. We can miss that target.
Correct.
So that's why we ask for the general anesthesia. But like suppose half of the lobe is involved, then we do under local anesthesia.
Yeah,
so
that's
what
we were discussing.
Yeah, exactly. So we have developed our own technique of local anesthesia, giving superficial skin block, giving deep muscular blocks, and most of the patients, they are tolerating it very well. Image kyun nahi aa rahi? So now,
show the images.
Yeah, so this is the ultrasound image. Can you see the?
No, we are not able to see the image. Yeah, now we are able to see.
Yeah, so this is the, you can see this is the actually pelvic diaphragm.
Yeah.
So this is the apex, this is the urethra, this hypoechoic urethra. Now this is the peripheral zone. You can see the well demarcated peripheral zone, the centrally enlarged transition zone. This prostate is very huge. You can see the seminal vesicle also. Now the bladder is full. Actually, it's having almost 150 cc gland. So this gland is very huge. So this is the whole picture. When I will rotate my this probe of ultrasound, then this is the right side of the prostate, right lateral. You can see the right SV also at the tip of prostate. Now I am just moving my ultrasound probe towards the left side. That is mean clockwise. Now you can see the mid gland. This is, now I am going to the left lobe. You can see these ducts also.
This is only a uniplanar?
Yeah, this is uniplanar actually, sir.
Okay.
This is uniplanar.
So this is not biplanar probe?
Sir, this is uniplanar actually, but a linear array, you can say. Because for all these transperineal, you have to be a linear array to see the prostate in whole length. So this is the left extreme of the prostate. You can see the levator ani muscles also on this pelvic diaphragm, you can say.
Okay.
These fibers, yeah, like this.
Sir, can you increase the gain a bit? It's the image is still
gain increase
blurry.
कर सकते? Gain, कोई बढ़ा सकता है? Sudhanshu, can you increase the gain?
Yeah,
I think now you can appreciate
yeah,
it.
sir, much better.
Yeah. So this is the pelvic diaphragm on the left side, and this is just the end of prostate, left lobe of the prostate. But you can see the seminal vesicle, left SV on that side. So just I am coming to the midline of the prostate and I am coming out. So this is the urethra. You can see this hypoechoic lumen. Now I'll just dock this ultrasound probe on the Artemis Egan machine. Brother, isko thoda sa piche karna. 1 second. Brother, you just hold this.
So the main difference with the BK is that it's biplanar, whereas in this case it's a uniplanar, whereas BK has got a rigid registration, whereas this has got an elastic registration.
Sir, this has got a rigid plus elastic both, sir. 1 second.
One machine cannot have both.
Sir, actually,
I don't know why you're telling that.
Actually, they say that the alignment process is rigid. When they align the image of ultrasound and MRI, they follow the rigid registration, and after that they follow the elastic fusion.
Yeah, but technically speaking, scientifically, if you want to fuse lesion to lesion, you need to have a rigid registration. Elastic means you can change. It will change the shape when you move it. So there is a disadvantage of the fusion, actually. So if you have a rigid registration, when you match it, it will perfectly match the lesion to lesion, so that accurate target is possible when you have a rigid registration. There is a theoretical scientific explanation.
So in that explanation, they say what happens when you touch the prostate, so it deforms the prostate also. So that's why the shape of the lesion can change. So that's why they try to register both images with the rigid registration, but for the benefit of initial like beginners, just to understand the boundary of prostate, they follow the elastic fusion, where you need not to like apply your mind very enough to where is the boundary of the prostate, whether it is matching with the prostate of ultrasound or not. So that's why they say they follow the elastic fusion.
Anyway, let us see the procedure.
Yeah, and they say that this is actually a patented technology for Artemis. Exactly. 1 second. 1 second. 1 second. थोड़ा सा ना वो नहीं डेप्थ बढ़ाना पड़ेगा. प्रोस्टेट बहुत बड़ा है ना. अभी इसकी कितना 6 पे है. नहीं कम करो. सॉरी कम. हाँ अब ठीक. कितने पे? ओके. हाँ नीचे करो. नहीं होगा. टेबल अप हो जाएगा. टेबल अप कर दीजिए. हो गया. चलो एक ना अल्ट्रासाउंड का मशीन थोड़ा इधर कर सकते हैं क्या? प्लीज अल्ट्रासाउंड का मशीन थोड़ा सर इधर कर सकते हैं क्या? हाँ एक बार केबल देख लेना. हमने इसमें करने पाया. बस ठीक. आ जाओ. यार वो इमेज चली गई. तार हिला दिया बंदे ने. आ जाओ. मशीन उसका केबल मत छुओ ना, वो लूज है. One second.
Finish with the biopsy. Just wanted to show the final.
Okay. So Amitabh, we're watching you, and we will go to the other theater.
Yeah, sure, sir.
To Rohit theater.
Yeah, once I will set, I will come back, sir.
Yeah, sure. When you keep on setting that, once you're done, we will come back to you. We'll go back to Dr. Rohit's theater. Transparent. Yeah, Dr. Rohit, we are with you. Hello.
एक simple image देखना है.
Am I audible, sir?
Yeah, please go ahead.
पीछे से बंद कर. खुला है. चल रहा है ना? Okay. So we have finished the biopsy.
Okay.
So this is our surface view after post biopsy. इनको zoom कर लो sir.
I think you washed out everything. There will be small.
So this is the surface view. You can see there is no major bleeding, no hematoma. I'll be infiltrating a local anesthesia bupivacaine along this triangle area in the perineum, which gives very good post-op pain relief to the patients, and patients are totally comfortable, complaining not at all of any pain. Okay. And at the end of the biopsy, we can generate this type of report. As you can see on the ultrasound image, that we have a report generated by the software in which we can see how many targets, how many biopsy score we have taken from each target. It is represented very well in this diagram. And this we can give a printout to the patients. We can see we can have a format. This can be printed and handed over to the patient. And at the end, it contains a chart in which we can finally
Dr. Rohit?
Enter the biopsy reports.
Dr. Rohit, Dr. Gaurav this side.
Yeah, Dr. Gaurav.
What is your protocol for like putting a catheter? Do you routinely put a catheter after biopsy?
No, no, not at all. We don't put a catheter.
Any consideration based on size of the prostate? Like in the other theater, we are having a 150-gram prostate.
Yeah, true. So actually, I counsel my patients accordingly in the OPD. If I have a very large gland, large median lobe, I counsel them that they might need post-op catheterization for a few days and might need alpha blockers. But if the gland size is not too big, mostly they don't need catheterization. But yes, patients with very big glands, I always counsel them, and if needed, I catheterize them for a few days.
I think that is one of the limitation of the stabilized
transperineal. In my experience,
biopsy.
I think.
Because the size of the prostate is so big, they go underneath the pubic symphysis. So you are stabilized, the needle will hit the bone. So in fact, with a larger prostate, if the lesion is anterior, in fact, we have to do a freehand also. Probably we have to do a hybrid technique. We have to do the stabilized and then take out the stabilizer, because to reach the large prostate, they are underneath the pubic symphysis. We may have to go by the side and have to do a freehand. We may have to do sometimes freehand plus stabilizer for a larger prostate if the lesion is anterior.
Absolutely true. The same thing I follow. Same.
So I think you completed the procedure. The other theater is also ready. This is
right.
Dr. Manoj Timula is ready with transperineal biopsy freehand technique. We'll go on to the other theater if this case is ready.
Sir. Okay.
Thank you. Good work.
Thank you.
Rohit.
Thank you, sir. Thank you so much. Thank you so much, sir. Thanks all.
If Dr. Manoj Timula is ready. Case caps. Yeah, you can present that.
Good evening, gentlemen. I'm Dr. Umar from the OT complex. Now, finally, we are proceeding towards our 10th and last case capsule. So for today, we have a patient who's a 73-year-old male who's a known case of carcinoma prostate since 2022, who is on active surveillance. His initial biopsy was Gleason's 3+3. 1 out of 12 cores were positive at right apex. His PSA trends are as follows, and currently it is 15. Patient is symptomatic and he's been on tablet Silodocin 8 milligrams since 2017. He's not having any significant comorbidities. His physical examination is grossly normal. His current MRI prostate reveals size of 46 grams and a Pyrates 4 lesion in right peripheral zone. His urine and blood workup are normal. His current total PSA is 15.9. And the plan was made to perform a freehand transperineal fusion prostate biopsy. These are the MRI images. And this case will be demonstrated by Dr. Manoj Tumala, who's a consultant urologist at Chennai Urology and Robotics Institute. Handing over to you, sir. Thank you.
Hello, can you hear me?
Yeah. Good evening, Dr. Thumala. Yeah, we can see you.
Hi, sir. Thanks for the opportunity. And offset, I want to thank Dr. Anandakrishnan and the organizing team for giving the opportunity. So today I'm here to demonstrate transperineal freehand technique. So what we do as a stabilizing thing is using a precision point. And a lot of companies now coming out with similar devices like precision point, where you can stabilize the needle so that the targeting and other systemic cores can be taken with in a short time. We can focus on the target areas. So what we use is a precision point. Apart from that, this is a 17 gauge coaxial needle. So 17 gauge coaxial needle will go inside the stepper like thing which is there in the precision point, depending upon the biopsy needle, which like how it is going to go more superior or
can
more
we zoom in further on this?
Yeah. So depending upon that, you can adjust the height of the coaxial needle going into the holes so that you can target the prostate in more efficient way. And apart from that, we have a 18 gauge 20 centimeters barred biopsy gun. So this is all the equipment we require. Apart from that, we require a biplanar transperineal probe. That is the only investment you need to do for getting into transperineal biopsy. So unlike getting a fusion biopsies where you have in 2 OTs, they are doing a fusion biopsies. The equipment required for this procedure is very minimal. Only thing is it will take some 20 cases odd to get into the groove. Once you get into 20, 21 cases, you'll be fine and you can easily take it from there.
Dr. Thumala, is it compatible with only BK probe or with any other company probe is also compatible?
Sir, we use a Fujifilm probe in Chennai. Only I use BK when I come to this live operative workshop. So otherwise we do in Fujifilm. And apart from Fujifilm, Mindray is having the same transperineal probe where you can, any probe we can go it's inside. So it doesn't have any fixed thing. So it basically contains a groove where you need to put the ultrasound probe inside and just lock it like this.
Yeah, we can see that.
So Mindray is having the transperineal probe, and even Esota is having a transperineal probe. BK, Fujifilm, whichever thing you can use it. There's no.
Yeah, actually last year I was in MGH, they were having Artemis probe, which was a little larger as compared to a BK probe. And they had problem with putting it, so they devised their own device. As you were saying that a lot of companies are coming up with a device which can be used for freehand biopsies. Go ahead, please.
Yes, sir. Yes, sir. Yes, sir.
Meanwhile, we can, just by a show of hand, how many of we are indulging in transperineal biopsy, if at all? Very few, I think. Two or three people are indulging in transperineal. I started, but due to initially starting doing it after ORRs, it was taking my own time and getting anesthesia ready. It becomes a problem for particularly set up at PGI because you have to do it at the end of the procedure. And transrectal, our residents are very well conversant doing in a suite which is investigative urology down there under local anesthesia. So that's why it went out. So
transperineal biopsy and HOLEP, they have some kind of learning curve. Rather, it is in the initial stage, it has got some steep learning curve. But once you learn, both the techniques are very useful, especially transperineal. It's just that our mindset, which is not there. Once you start seeing the more and more prostate, more and more start feeling transrectal probe, you put it in lithotomy position, you start doing the transrectal ultrasound, so you get a picture, then you get to know where to put the probe to take a biopsy. Freehand biopsies are also easy. You need not have to have precision. After doing stabilize, after doing precision, now I am doing freehand just straight away. Looking at the ultrasound, we are doing the biopsies like that. It's actually it is very easy.
We went up to PSMA PET targeted biopsies actually. So we outsource kind of to our nuclear medicine people, and we are now doing it especially for all these patients. We just take a couple or 3 courses. We don't go for a conventional biopsy in these cases. So in gantry with a robotic arm in a PSMA PET suite, we get a PET CT followed by this thing.
We have done close to 200 cases, not even a single infection. Not even a single infection.
So do you use antibiotic routinely for these patients?
We give oral tablets. Earlier we used to give injectables. Now we are giving oral tablets.
I think one of the advantages of transperineal biopsy is that you can actually do away with the antibiotics totally.
Dr. Amitabh is ready. If we can, if Dr. Amitabh is ready, we can move there.
Sir? Ideally, sir, totally होना चाहिए. जो भी studies अभी तक आए हैं transperineal versus transrectal, they claim that without antibiotic you have equivalent outcomes in terms of infection versus transrectal.
Yeah, I've done 2,000 cases of transrectal. After that, now we have done close to 200 cases of transperineal. In both centers, we do one center we do a transrectal even today, where we don't have. In another center, we are doing transperineal basically, but our aim is to tell them we have a technology, we would like to do transperineal given the chance.
In your center, yes.
Yeah, in our series, if you look at it, it's more than 10 to 12% infection. We used to give the antibiotic regularly. I mean, just mild infection. Sepsis to the tune of 1 to 1.2%. That is, they used to go to the ICU. There is near death almost situation. So that is the kind of situation. It's almost 10 to 12% antibiotic requirement. 1 to 1.2% of sepsis out of 2,000 cases. So there is quite a lot. And after doing transperineal, not even a single case. Not even a single case. Yeah, I think it is now, I think we were neglecting the anterior lesion earlier when we were doing transectal biopsies. If you see 10 MRI, I think since morning, all the MRI reports, they are telling 3 or 4 lesions in the transitional zone, anterior lesions. We are picking up a lot of anterior lesions. In fact, the CA prostate, anterior lesions are more than 50% are anterior. They are called as SPEAT, prostate evasive tumors. They are more serious. They are actually more aggressive tumors. They are called as SPEAT tumors. PAT is prostate evasive anterior tumors. They are more aggressive, and we are picking them with more and more MRI. So earlier we used to miss, by transectal ultrasound, we used to miss the anterior lesions. Now with transperineal, we are able to get more and more lesions. That is the CDR rate is also increased. In my next talk, I'll be talking about the CDR rates, vice versa, comparing with the transectal and transperineal in my next talk after this. Yes, sir.
See, in my experience, I do transrectal biopsy for last 22 years now. And we have a very strict protocol for the cleaning of the bowel, giving him the Delcolex and some enema in the morning or previous evening. Then we are doing a thorough betadine wash outside and inside the rectum. That is the routine practice. And then we are giving a cover of 1 shot of the injectable antibiotic and oral Ciplox TZ start from previous evening. And this is the regime what I am following, and I don't have to regret. I have done 1,000 biopsy, and what you are talking of anterior lesion, now we are doing MRI in every case before biopsy. So if I know that I have got an anterior lesion, I will do a fusion biopsy. So I am doing routinely from 2012, I am doing fusion biopsy. The same this IGAN machine. And we are very comfortable, you know. So I am saying it's all right. There, one study has also come, they have shown an equal result of the infection, whether you do transrectal or transperineal. Only thing is that if you are doing transrectal, you have to do a very thorough preparation of the patient also.
Yeah.
And we do under local anesthesia all biopsies.
Transrectal.
Yes.
Yeah. Transrectal, I mean, there is no need to give anesthesia. Even we had a lot of 2000 case experience, but then we thought that after that, most of the cases were infection. When we looked back, what was the case of infection? Most of them had a fluctuating PSA. That means they had some kind of infection. PSA was 19, it came up to 4, then it went up again. To rule out the malignancy, when we look back, what was the high rate of infection? Because in South we have a lot of cases who have a fluctuating PSA. PSA today, we give antibiotic, it comes down. They are already having some kind of hidden infection. When you biopsy them, they come out with this one. So prostatitis, fluctuating PSA, these are the cases were shown up when we did it transrectally, they were showing into going for a sepsis.
See, I agree with you that it is very important to have a urine culture in every case. There's no need for a shortcut like that. And if culture is positive, don't do the biopsy. Second thing, I get a lot of patients with high PSA 60, 70 after an attack of the acute prostatitis or something, and they are sent to us for biopsy. I said, no, nothing doing. Wait 2-3 months, let your infection settle down. Then your PSA also comes down. So what is the need for a biopsy then? You know? So selection of the case is equally important.
Yeah, I mean,
that's two comments I would like to ask you, sir. Sir, do you think all patients should be offered a fusion biopsy?
No. We have published our paper also from Medanta only. And first 200 cases we have analyzed. Our postgraduate have done that job. So there are selected 5 indications for the fusion biopsy, not all cases.
I think Dr. Amitabh is ready.
Yes, sir. I'm ready, sir. So now you can see this whole setup.
Yeah.
Now ultrasound probe is fixed on the cradle of this Egan machine. So now you can see the images, and you can see
the stepper.
Screen.
That is the stepper, what you're telling.
Yeah, so we call it cradle actually, we don't call it. So because it's like ultrasound probe sits on this. So this is a basically machine, you can say there is a tracker which just track the motion of the needle ultrasound probe. And this is the screen. Now you can see this screen. So now there are 3 parts actually. First is the tracking of the prostate, where we just mark the boundary, we just measure the volume, we mark the boundary, then we do segmentation of ultrasound image of the prostate, and then we try to rigid registration with the MRI images of the prostate, and finally we fuse both images to see or to overlap the MRI target ROI on the ultrasound images. So here just what I need to do, I need to just rotate this ultrasound clockwise very slowly, because it is acquiring the ultrasound image of the prostate. So I need to be very slow so that my probe should acquire image properly. Now you can see the prostate is coming out into the image. So this is the right part of the prostate. Now I am coming up to the mid line of the prostate. You can see the urethra also. Now I am going towards the left side of the prostate. You can see very well transition zone and peripheral zone of the prostate. You can see the pelvic floor muscles on the both sides. So now just I am going to end my rotation. So this will acquire the complete image of the prostate. So now this is the acquired image of the prostate. Now I have to tell what are the margins. So I have to tell the software this is the margin of the prostate. Like this. So this is the axial and this is the sagittal one. Actually this prostate is very used. It is not coming into one image.
Yeah, it is going
so that's
behind.
why you can't see. Yeah, it's a very large gland in fact. So that's why it is not coming in complete picture. So here you can see this is SV, this is perirectal fat, this is the fat between the seminal vesicle and the base of the prostate. So I have just told the software the boundary of the prostate in axial and the sagittal. Depending on this information, it will mark a 3D image. It will make a 3D image. This software will make a 3D image of the prostate. So this process is called as a segmentation of this software. Now, so this gives us option of refining images also. So now I'll just mark a transverse. I'll just scroll down from like towards apex. I'll just see this green boundary whether it is matching with the ultrasound image of the prostate boundary or not. So it is almost matching to the prostate boundary. Again I will just go towards the base of prostate. If it doesn't match, then I can change this line like this. You just put your cursor, just put it, press it, it will just change the direction of the green line.
The elastic registration, okay.
Yeah, so this is just marking. You can see the both SVs on the base of the prostate. So if suppose you feel that it is not covering the whole prostate, which is intravesical part of the prostate, you can just change this thing because the whole prostate is not coming into the image. That's why I am doing this. So you can do it under like this sagittal one also if you are interested, but it is almost coinciding with the prostate boundary in the sagittal. You can see, you can do it under coronal also, but I prefer usually doing in transverse and sagittal. So if I am confident, I'll just finish this thing. I'll go next. So now you see rigid fusion. You just saw the screen. It showed that now it's a rigid fusion. So now I have to align the image. So I have to tell the software that it is perfectly aligning with the MRI images or not. Now you can see, like suppose if I'm zooming out, you can see this is the perirectal fat. This is the perirectal fat. So I'll just put one marker here, another marker here near apex, another marker here near at apex. So now it will just ask this transverse. Now I have to tell the software that whether this alignment in the axial section is matching with the MRI image or not. So I have to just make 3 points. Like this is the midpoint at the anterior part. This is the midpoint at the posterior part. Same here. And I'll just mark 1 point on the lateral side. So it will just match the rotation of the prostate. So if you're not happy, like suppose if you are feeling this prostate is more tilted towards the right side of this thing, then you can again go. You can go for the refined alignment. You can again put these markers just to have a perfect realignment so that you should not miss the region of interest. Okay, so I think I am pretty confident that this is matching. The whole rotation of the prostate is perfectly fine. So now the angular movement and the position, axial, sagittal, transverse, everything is matching with the MRI images. So now I'll just go next. It will do elastic fusion. So that is the patented technology for this thing. Now here you can see there are 3 lesions. You can see here 1, 2 and 3, and they can be seen in this 3D constructed images based on the software. So 1 lesion, 2nd lesion and the 3rd lesion. Again I'll go next. Now these lesions can be seen here. Okay. Now I can just go for the biopsy. So now you just see this movement. Can you see this movement, sir?
Yeah, we are able to see. But what you didn't, you contoured the normal prostate, but you didn't contour the lesions.
So now in this software, what happens, this is the Profuse software. So we pre-mark all these lesions. And we import those images in this machine. And we just take 3D image of ultrasound and we fuse both images. So we don't need to mark these region of interest in this software, in this machine only. Unlike this BK machine.
Yeah, there we have to contour the whole lesions.
Yeah, exactly. So here it is not required.
So you have to just contour the whole prostate and match it with the MRI, and it will show the MRI images will get superimposed on that with the lesions.
Exactly.
Okay.
So now you can see this green ring. You can see this green ring. So this is the, you can say, the biplanar probe, the plane of ultrasound array. So once you are moving the ultrasound on the right side, on the left side, this green ring is moving. Like suppose I am on the right side. Now you want to go towards the peripheral zone, then I need to switch this thing, this rotator. So I'll just make a deflection. 1 second. So I'll just deflect this down, so this point will go down like this. You got it, sir?
Yeah, we are able to see that.
Yeah, exactly. Now I have to just put a marker. This is the plastic, actually this is a stabilizer, you can say, for my barred needle, 18 gauge needle.
This is a micro. In the BK we thought it like an elephant. It was very huge, getting attached to the, and now you are telling it is a stabilizer which is very small as...
For the needle, sir.
Yeah, the stabilizer in BK is huge.
Yeah, so now you can see this ultrasound image of the prostate, live image of the ultrasound of the prostate. You can see this yellow line. So this is the tracker line, this yellow solid line. So there is one dotted line, there is one solid yellow line.
Yeah.
So this solid yellow line is basically the follow path of my needle, biopsy needle.
Then what is that dotted needles meant?
So dotted needle is basically deflection. So they have made some like confidence interval sort of thing like a stat. So if just, I'll just rotate
it indicates the movement of the probe.
Yeah, exactly.
Yeah, I got it.
And you can see this yellow ROI, which I have already marked on the prostate. Where, can you see this, sir?
Yeah, we are seeing.
Yeah.
Go ahead, please.
So now there is a red actually arrow from here to solid line. So this is the biopsy gun path. So the whole length is approximately 1.5 centimeter. So this is approximately 1.5 centimeter. So I have to start from this solid triangle, and then my needle will go up to this solid line, red line. And this red dot is basically at the center of this whole biopsy path, you can say.
Okay.
So I'll just go to take the biopsy.
Yeah.
Because this is a very large prostate, so there might be some deflection of the needle because of the resistance of the tissue. So I have to poke it. Ultrasound, wo hai na? Line hai. 1 second.
I think this is the maximum thing that is which requires. After this, I think you need to put a needle and take the biopsy.
Yeah, yes, sir.
Yeah,
exactly.
This is what you did was there. So once you take one biopsy, then we'll move on to the other theater. Let's keep them ready. Yeah, we want to see the needle. Yeah.
Actually, because he is very big man, so my needle.
You are also big man.
Yeah. 1 second, sir.
Yeah, but the needle is going down below.
Yeah. 1 second. So it's because of the deflection. So what happens here in this case?
Now sometimes the probe which is put it, if it is more anteriorly placed, the prostate moves upwards. So I think.
Yes. So I'm just putting very close to the skin. This yellow
because
thing.
actually the needle is going very low down. It's not going in the line.
Now you
can
now
you have got it.
Exactly.
Yes.
So now it is into the alignment of this yellow line. Now you can see my tip.
So you need to adjust that stabilizer. You did adjust that stabilizer.
So now it is almost following this path.
Okay.
Now you can see my needle is coming. It is
almost
following
we are able to see
path.
now.
Exactly. Now, so just I'll fire my needle now.
Yeah, we saw that. It's going through the.
Yeah.
So these
Target
procedures like BK and Artemis, there was a comment when I was also doing, all these things looks like more complex than the radical prostatectomy itself.
So just targeting very small lesion is sometimes very difficult because of the tissue resistance.
Yeah, no,
So
when I
they
was doing
had-
it, some people asked me
Yeah.
this question.
Yeah.
That's why we had only
So-
3 people doing it, sir, on the audience.
Yeah. So they had actually 20 gauge needle also. So that's why I asked for 18 friends, just because it will be much, it is much thicker. So I thought the deflection would be much lesser.
Okay.
Yeah.
But I think if we have both coronal and sagittal, then I think we know exactly. Yeah, you are putting the needle there.
One second.
The first one, you got it. You got the biopsy tissue.
Yeah, I got the tissue, sir.
So then we'll be watching you. Then Dr. Manoj is waiting.
Yes, sir. Sure, sir. Sure.
Less complex than what it is. So we'll move
Manohar,
there and then we'll come back to you.
I like to make a comment.
Yes, sir.
I do transrectal fusion biopsy,
Hmm.
and I'm seeing the difficulty which he is facing of doing this. I think so. Transrectal is much more simpler. Straight away, within 10 minutes or less than 5 minutes, I can finish my job.
Transrectal.
Yes.
Yeah.
Yeah,
That's
yeah.
what we were
Fusion
discussing.
biopsy, you can do it very well. No problem. No, but if you are doing fusion, then same. But in this case, probably the gland is very large. That's why he's having so much problem.
No, because in the larger prostate, the problem is with the anterior lesion size. Actually, the base lesions are not at all a problem, actually. I mean, there's something... No, actually, what happened, the probe, that's the reason the BK has given a reslicer in the software itself, wherein the probe, if it presses upwards, you tend to attach you tend to get a good proper picture. So we tend to put the probe more toward the prostate, and the prostate move anteriorly, and that's where we lose the contact of the lesion. That's the reason BK has given a reslicer in the software itself, so that the virtual probe in the rectum, you have to adjust it so that it will matches to that. That's one of the advantages which other machines don't have. Anyway, we'll move on to the Dr. Manoj. He's waiting since the time, and is Dr. Manoj? Dr. Manoj Tumala, are we connected
Yes,
to
sir.
it? Yeah, please. Yeah, we are seeing your probe in the rectum, and
Yes,
with
sir.
your precision point fixed to the
Yes, sir.
probe.
So, I just want to show you the markings, sir.
Did you
So
put
what-
any local anesthesia, or you were under general anesthesia?
Sir, patient is under GA.
GA,
but
okay,
I'm
fine.
going to demonstrate the local anesthesia, how we used to give. And before that, we usually mark like this. This is the midline.
Yeah.
From the midline, near the perineal body, we go on both sides around 1 to 1.5 centimeters away from the midline, so that we won't be hitting urethra anywhere.
Mm-hmm.
Yeah, so 1.5 centimeters away from the midline, close to the perineal body, okay? So the scrotum has to be stretched so that the entire skin and everything should be opened.
Yeah,
Sometimes when the
correct.
scrotum is not stretched properly, we tend to do a little bit higher. Most of the
Yeah,
times
that's
it
a
doesn't
good point
happen.
you mentioned, even that
Yeah,
that's
so it
the
has to-
stretching of
has to be
the,
stretched.
yeah.
So when we put the point higher, we tend to move our probe also higher, and we won't be reaching that. Sometimes the anterior course will be difficult, sometimes the posterior course will be difficult, depending on the inside the prostate. So it should be close to the perineal body, 1.5 centimeters away. So from there, we give local anesthesia, get the bleb. So we use 10 ml of xylocaine, 10 ml of bupivacaine, 10 ml of distilled water.
Once patient is in GA, why you are giving local anesthesia?
Just want to show, sir.
He just want to show. He said that he just want to show how it will be done. And local it can
Other
be
pair-
done.
Okay.
So only 2 points you make it. Through that you are
Yes,
going
sir.
to zigzag
sir.
the needle.
Yes, sir.
So bigger prostate you will move away.
Yeah, yes, sir. So once we put a 11 blade, put a small stab incision, use the coaxial needle, insert inside, okay?
So you'll give
17 goes.
not regularly in anesthesia you will also inject into the space of alley.
Yes, sir, yes, sir.
Yeah, because in the apex.
I'll do that.
Yeah, because you can inject into the space of alley, put a
Yeah.
needle and then inject some local anesthesia at the apex. We can see while doing in the free hand. What is that fluid coming out?
So this is the space of LSA between the prostatic apex and the levator animuscle.
They ask them to make the bigger picture of the ultrasound while doing that.
Can you put only sagittal view? Only sagittal.
Yeah, we have to see the needle into the space of LA. Yeah, that is the area. Yeah, correct. I mean, you entered into the bladder actually. Yeah, there is a space of LA, apex in front. Probably little down will be the space of LA. It is a little above.
Yes, sir. Going there.
Yeah, that is the where. Yeah.
Okay.
Oh, that is a area of LA.
Yeah,
Probably
yeah.
you are doing in a sagittal plane. Yeah.
Yes, sir.
Correct.
So the entire track you can inject.
Yeah. But it is gone into. Okay.
Okay. Biopsy.
Now I think you can go ahead. It's a local where
This patient is having a right anterior lateral lesion, sir.
Something, whether it's a local saline, things become a little better. If it's a very small lesion, then you can better localize it.
Adjust it. Okay. So target that area.
Yeah.
Okay.
Okay, you're taking the biopsy now, anterior.
So,
So
right target.
Is this a cognitive? You have MRI image and you're taking, or you're
Yes,
taking
sir. I saw the MRI image.
Where are
Dr.
the
Rohit has sent me the MRI image.
Okay.
And what I usually prefer is getting a sectoral mapping also. So that
Okay,
we
you're
can
doing a
show it to
sectoral mapping biopsy. Can you do a
Yes, sir.
targeted biopsy in this precision point freehand technique? Can you do a?
Yes, sir. Yes. Yes, sir. Yes, sir. So this patient is having a right anterior lateral area, 7 millimeters area. So what we see is there is a hypoechoic area on the anterior peripheral zone. So we try to target that and take at least
That is
4 to 5.
actually anterior region that you're taken.
So 4 to 5 cores from that surrounding
What is the size
area.
of the prostate? It looks very compressed. What is the size of the prostate?
Right
in
target,
there?
right target. 45 grams, sir.
45, okay. So they can show the surface.
Fast,
Okay.
fast, fast.
You're taking on which side? On the left side or right side? It's
Right
only-
side, sir. Right side.
You're taking on the
Right
right
side.
side.
Right
so
side,
you're coming,
anterior left.
starting from above to below.
So this is the peripheral zone.
Okay.
And we are going to the transition zone.
And then
This
middle
is the
zone.
midline. This is the midline.
Okay, okay.
This is the midline. You can see the bladder neck here. So right side, peripheral zone we are targeting.
Oh, is it not good to have a biplanar images in this when you're doing it? You know what where exactly you're doing it? Why are you
Sir,
doing
what
only
is
with
the-
the sagittal plane?
So what is happening, sir, when you push the BK probe more inside, the axial view is in the front of the
Yeah,
the
you have
so
to adjust it and then you have to move it. Move the probe.
okay. Okay. So I'm not used to this BK, sir. We use in Fuji. Fuji, you have
Okay.
sagittal area in the front and the axial in the back. So here I'm finding it difficult because in the axial, when I try to do, I'm seeing only the bladder when I try to push more inside. When you
Yeah,
want
that's
to
what
do-
it looks more compressed. I don't know whether
Now,
the
sir?
fluid you put it is too much. I don't know. What is that?
No, I injected only 8 ml, sir.
So we'll be watching you. Then we'll move on to Dr. Amitabh if he wants to tell, or he has
Okay.
finished. Yeah, Dr. Amitabh.
Sir, just I wanted to make one comment. Like
Yeah.
suppose I am inside the prostate, but I can't see my needle. So then what I do personally, I just move the ultrasound probe
Okay.
to see where exactly my needle is.
So I think we're watching you, and then we can
Yes, sir.
move
Yes.
with the next
Yeah, sure, sir.
talk. If you're here, Dr. Manoj, if you want to anything, final comments. We're seeing you that you're doing the freehand biopsy with the precision. You're taking on the right side, and after that you're going to the. Oh yeah, you got a good piece there through the capsule.
Yes, sir, yes.
So
Yes,
we're
sir.
watching you, and we'll be going to the next lecture.
Sure, sir. Sure, sir.
Thank you.
Dr. T. Manohar will be delivering a
Right,
focused lecture on the transperineal Shebel's fusion biopsy. Dr. S.P. Yadav, sir, we request you to please join the chairperson's panel. Dr. Anil Helens. Sir, can you please join the panel? Thank you, sir.
I thanked the Max, Dr. Anant Kumar and Rohit for giving me this opportunity. So today he has asked me to talk about the MR fusion, only stabilized biopsy. So let us see why the only stabilized biopsy. So in this component, I'm going to just talk about little of results, cancer detection rate, and what is fusion, little touch upon, and then why stabilized and technical update and our results and guidelines and some take-home message. Why there's a sudden change? Suddenly we are talking about transrectal. Why there's a sudden change to transperineal biopsies? A little update on this. So we see that there is transrectal, some kind of infection rate almost to the tune of, if you look at the world literature, rectal bleeding is to the tune of 10%, and hematuria, which is happening nearly to the tune of 12% in TP and transrectal in 16%. And the fever, the infection rate to the tune of 6% worldwide, but other reports which shows about 2 to 25% in some of the centers. But an average in this meta-analysis which shows that about 6% of the transrectal biopsy showed fever and infection. So the main world of infection rate following trust biopsy varying from 1 to 12% in all the reports, with severe sepsis varying from 0.1 to 2%, and that's also our experience, and with rapid antibacterial resistance, especially in India, I think we are having much more problems than what it has been mentioned here. So why this? You might have heard about Brexit, but this is the article which showed that in Brexit in Britain in 2020, this article, they just completely abandoned the transrectal ultrasound biopsy because they found that the infection rate post transrectal biopsy infection is increasing and was recently reported in the alarmingly as much as 10%. So coming to the perineal versus transrectal, what is there any detection rate? You can see that cancer detection rate is 2008 and 2000 et al. There's not much of difference, but in 2015 that made a change because when the learning curve is improved, we found that there is definitely significantly improved cancer detection rate in transperineal biopsies. So there are, after that, the era has come where MR fusion and the people started doing biparametric, now multiparametric. And in the precision trial, we found that there is 38% or more in MRI transperineal biopsies, 38% significantly higher when assigned to biopsies in 38% than those with sextant biopsies. So they found that with the MRI and with the experience of the MRI, the pickup of the lesion is more and more, so that adoption of the MRI has come into picture. So when we started doing MRI, segmental versus targeted biopsies, in both transrectal and transperineal, the cancer detection rate is to the tune of 55% versus 23% when we started doing the targeted versus sextant biopsies. And clinically significant cancer, better sampling efficacy was found with MRA targeted biopsies, 46% was 1.5%, and clinically significant cancer to the tune of 6.2%. So MR fusion in both TP and TR, the cancer detection ratio was more with 44% versus 33%. And with MRI TP fusion target, so in the systemic, you got both together with the target and systemic, there's definitely 46% versus 23%. So comparing TP MRF targeted biopsy with vice versa with the TP and TR, there are about 8 studies which showed that the CDR improved when we compared with the transperineal, transrectal with transperineal, cancer detection rates improved by 13% in transperineal as against transrectal target biopsies. So this is historical perspective where we know that one availability of transrectal and moved into the era where now in the last 5 years or so, we are into the era of where we are doing the majorly the MRI fusion biopsies, especially multiparametric, and the radiologists are very well versed with identifying the lesion, and we are more towards doing only targeted biopsies than even the sextant biopsies. That's where we are moving towards. So that is the reason to improve the CDR cancer detection rate, all these stabilize, all these innovations, all these complex maneuvers are happening to improve the cancer detection rate and to
plan only for the targeted biopsies. So what are the components? When you want to say targeted biopsy, what do you require? So you require MR fusion, you require a software, or you require a software-specific ultrasound, you require a stepper, that's what the cradle they were mentioning. It's a stepper device, and you have to have a compatible probes, and you require a grid and template. And of course, when you call about stabilized biopsy to improve this CDR, you require a stabilizer. Stabilizer is a bigger version of it, and the stabilizer is different in different machines. So you have to stabilize the machine to target it. That's what I meant to say. So these are the machines which specifically, Artemis, BK Fusion, College, Urinaway, all the things are there. I'm not going to the detail, and there are various differences are there, but that can be debatable. Somebody says elastic is good, somebody says rigid is good, so there's a lot of debate is going on. I'm not going to the detail of that because the time is not much. So what we are going to, I'll just skip this slide, and what we require is MR in the 3 dynamic T2 weighted images, diffusion weighted images, and dynamic contrast. So these 3 are mandatory to do a contouring effect, especially in the PIRADS 2 version 2. So these are some of the lesions. So these 3 are a requirement to do an important component is the MIM software. So the different software in Artemis, but here in BK what we are using it is an MIM software. The complexity is this each software is different for transperineal, the software is different for transrectal. And to make it complex, each software is nearly to the crore. It's 1 crore. It's just a software of this to fusion. So that complex it is. So this is regarding the contour. I think he has not mentioned it. I thought that I'll just take up this, show this little software where you take that ultrasound picture. That's what was Dr. Amitabh was mentioning, and Dr. Rohit was also mentioning. You know that you take it, you put these images into the software. This is the MIM software. I uploaded this MRI images into the software and started contouring. You can see that contouring has been happening here in this. So the blue light is the contour of the prostate, and different level from base to the apex, you have to do that. And then also some of the contour of the, this, you can see that. You can erase it and you can properly mark it. And you can also do the contouring of the lesion. I just move this so that, see that we are contouring that is the lesion there, that is the lesion. But contouring of the lesion also has been done. So this is regarding the contouring. You have to sit and do it because sometimes you may not be able to do it on yourself. You have to sit with the radiologist. You do the lesions, what are the type of the lesion. This is anterior lesion most commonly. You can see that the contouring has been done. So once you do the contouring, and then this is one of the important points which I was mentioning in this machine is that this is the reslicer which I wanted to tell. This is the reslicer. In the software itself, you know the how rectum is positioned, whether rectum is flat, whether it's a curved. This is the rectal probe in the virtual imaging probe. This has been done in the software itself, in the computer, so that when you're doing the position, it matches mostly, so the target is very much possible. Even 2 mm lesion can be done if you have this reslicer matched with the software itself. So this is the transferred now. Now the image has been transferred to the ultrasound where you're going to do it. So coming to the technology requirement, that's regarding the contour. Technology requirement for the biopsy stabilized and freehand. You have to see this is the freehand that is stabilized. You see that this is the Civico stepper. We call it, that's what the grid they are telling. And advantage of the stabilizer is, what is the advantage of stabilizer? This is the big, I'm going to show that. This has got 6 movements, 1, 2, 3, 4, 5, 6. This is XX, YY, ZZ, the 6 movements, so that you try to do the movements with the stabilizer, because that's the joint is so big, so that you can exactly pinpoint the lesion where you want to go, where the needle want to go. That is the advantages, that is the precision of the target when you add a stabilizer to the stepper. This is what they show you. This is how the complex this stabilizer. All those instruments are different. This is the stabilizer itself. This has been taken and the patient has been, stabilizer has been put into the area because Rohit didn't show this, so I thought that I'll make it to show this. This is how it's been fixed into the table. And this is the joint. This has got that 6 joint movements wherein you can movement adjust so that when you put the ultrasound probe onto the stepper. So this is how it looks. And then I can just show that. I'll just fast forward this. And this is the stepper which you are placing. This is the stepper. the stepper has been placed on the stabilizer. This is entirely different. The cradle which they are mentioning is the stepper. And then you place the stabilizer and then fix it. Oh, sorry. I think that's the one which I wanted to show. The stabilizer and stepper. And then you place the ultrasound probe. And then this one, the ultrasound probe is placed onto the stepper. And then this is the syncing. So here they are doing the syncing. The syncing effect has been done here with put this initial cable onto the ultrasound and then put the probe and then take the contouring of the probe, and that's what we have seen now. So the biopsy pattern is same, the sector probe and the targeted probe, and targeted template biopsies, and sometimes you can do a target-only lesions if the lesion is more than 1.5 centimeters. That's what we have mentioned. I'm not going to the detail of that. And this is anesthesia. Then one can do a mapping anesthesia. One can do grid anesthesia. This is a grid technique. If you're doing a grid technique, this is the space of LA. You can know exactly the positions of 6 o'clock, and the seminar vesicles where you see that you can see the needle and you can put a local anesthesia. And this is how the reporting which has been showed. I'm going to come to my experience of doing 194 cases. Transperineal biopsies, we have done about MRI fusion with 167 biopsies with 167 stabilized and 27 freehand biopsies. We found that duration is more as compared to the transrectal. Transperineal duration is more. We can do under pudendal block GA. There's no local surface elastization. Transrectal pain score is 3, but infection rate, we had about around what I was mentioning, 2.3% is our infection rate. Sepsis to the tune of 0.4%, and there's no infection rate in transperineal biopsies. And urinary retention is more common, I don't know, because it's not in the literature, but we see that in target and template biopsies, 9% of the patients have a retention of urine. When we started doing only target biopsy, the retention rate has come down to 1.8%. That's what the significance we've seen, whereas retention rate is not very common in transrectal biopsies. Rectal bleeding is also, of course, equally present in this transperineal biopsies. We found perineal hematoma less than 1%, but when we started doing only target, that even hematoma stopped showing the decrease in the incidence. So in our results, where we started doing positivity of number of cores, out of which 47% in trans ultrasound biopsies, positivity, and in 72% in transperineal biopsies, there is increase of 25% core positivity percentage, where we started looked at the repeat biopsy. Out of 45 cases of transrectal repeat biopsy, we are able to pick up 3 out of 45, whereas 11 out of 35 in stabilized transperineal biopsies, which is almost, the percentage is increased in 77.4%, especially when you're doing a repeat biopsy, which was negative earlier through the transrectal biopsies. So the number of cores positivity, which shows here that number of cores are 1,000 cores where positivity is 61%. And when we started improving the components with the all PIRATS suspicion component with the systemic, 73% positivity yield. But when we started doing target only with the PIRATS 4, 5, PIRATS 3 plus more than 1.5 centimeters, high suspicion, clinically evident, when you do a stabilized biopsy, 92% of the time you get a positivity results. So our preliminary data shows that there is a CDR rate is 95% accuracy with this transperineal stabilized as compared to the freehand. And target and sector biopsies, 98% accuracy as against 89% in freehand. So post-op retention is very less as compared to the freehand. Overall duration is actually more with the stabilized because the instrumentation, all the technique which required, I think you saw that Manu Tumala was doing it very fast, whereas the other theater, it was struggling. So the actual duration is more. The median duration, once everything is set, the biopsy is, the duration is very less. And you can see the comparative results. And cancer detection rate is more, 34% more in stabilized as compared to the freehand. So limiting factor for stabilized, I was mentioning, large prostate more than 100 gram. They go underneath the pubic arch, normal pelvis, narrow pelvis. Improper flow placement in the rectum, wrong virtual probing will cause definitely limitation in the larger prostate for the stabilized biopsies. This is our guideline, which we have done it. So if there is a prostate biopsy, if the MR fusion is available, this is what we have followed up. We have done a guideline for this. If the PIRATS 3 are less than 3, then template and target biopsies. If the PIRATS is more than 3, then we prefer only target biopsy. If the lesions are multiple, if the lesions are larger, then just do only target biopsies. In stabilized biopsies, if the lesion is less than 3, better to go for, again, template and target. And if it is more than 3, even if it is a smaller lesion, under general anesthesia, we prefer general anesthesia for a smaller lesion. Better to do a general anesthesia and do a target biopsy. Thank you.
Thank you, Manohar, sir.
If there's any questions, I can.
Sir,
I think time is. Oh, yeah.
sir, what is the cost paid by the patient for a transperineal biopsy, which is a stabilized biopsy, versus a transrectal freehand, which you
In
do?
general ward, they pay around 72,000. In semi-special, they somewhere around it comes to 90-95. In special ward, I think you can take a guess.
So I think
it's somewhere average around 80,000, 75 to 78,000.
Transrectal, sir?
Transrectal, we are doing it, it's around 35,000.
So just twice the rate, that's what it is.
Yeah.
So
No, they wanted to keep it initially. When we did the first case, the charges were reading, the corporate, the manager, he had given 2.75 lakh. He put TMC, AMC, machine charges, everything he has put it. So we gave them, we sat with them, look here, we are doing a biopsy, he's an assistant, don't look at each and every, it's not an ATM machine, he's going to bring it back. We are doing the procedure, we have to keep it as a regular procedure. And then when we started reducing, then they started reducing, we have stopped using all the disposable, the balloon is also different, we are using a condom nowadays. That even that balloon itself is costly, it comes to 15,000. So we reduced all those, and then we are doing only the consumable is the needle. We are doing the fresh needle. So in that, we are able to come down with this cost. Even still it is higher, it's double the cost of the transrectal.
But once you are, it's admitted, then only insurance company, most of the insurance company covers.
Yeah,
While in majority of transrectal can be done on OPD basis or for a single day care.
If you ask me, one of the 9 patients who had underwent sepsis, in my scenario, one patient had spent 24 lakh. After transrectal biopsy, he had a sepsis, he went into ICU. This is, I'm talking about in earlier, when we started in 2009, I remember, one of the patient, transrectal biopsy, he had a sepsis, he went into ICU, he was in ICU for about 31 days, just for transrectal biopsy. One case, I still remember that. He was in ICU and he paid about 24 lakhs. So we have to look at the bigger picture of the complication. I know it's a 1 case, 2 case, we may neglect it, but it happens, it happens.
But I think that insurance company is not covering for diagnostic procedures. Is it like that?
Nowadays, they are giving. Earlier, they were not giving.
Right now also, I think many of the insurance companies refusing.
Some of them are doing that, but when you say that admitted, general anesthesia, right now I think most of the companies are now, they are coming out giving the...
They are covering, but there are various criteria. If biopsy comes positive, then we will pay. If it comes negative, we will not pay. Something like that. So they have very bizarre rules.
Yeah, no, insurance, they have a bizarre rules. That's a different issue, but I mean, of course, most of them...
Sir.
No, I like to make some comment.
Yes, sir.
Anecdotal case doesn't mean anything actually in medical science. It has to be a commonality. I will not say more than that. Second thing is about this diagnostic procedure. It depends upon the policy of the person, which kind of policy he has taken. There are policies in which outpatient procedure, diagnostic procedure, outdoor treatment also is covered. So it depends upon the amount of the insurance which person has taken actually,
Can we shift to the OT for last comment?
Thank you, sir, for such an insightful talk.
Yeah.
Can we move to the next session? We will conclude this session. Thank you, sir.
Thank you, everybody.
The next session is a case-based panel discussion. The session will be moderated by Dr. Vivek Vasudev and Dr. Anuj Sharma, who will guide our expert panel through a series of complex cases. Our distinguished panel includes Dr. Anil Goyal, Dr. Nikhil Khattar, Dr. Samir Trivedi, Dr. Anant Kumar, Dr. N.P. Gupta, Dr. P.P. Singh. Please give them a loud round of applause. Over to you, sir.
ठीक है, बस टारगेट और अच्छा से ले लेते हैं. अभी नीचे ही जा रहा है.
Good evening, everyone. After the exhausting whole day, a lot of surgeries, all the different kind of surgeries available for prostate, we have demonstrated. Now coming to conclude the day with a case-based panel discussion. All the cases are related to prostate with different scenarios. And all the cases are our own cases. This is the first case, is a 70-year-old male with progressive LUTs over 2 years, now presented in emergency with painless urinary retention. Examination had grade 2 to 3 smooth prostate, non-nodular, had a palpable bladder. Neurological examination was normal. He had no comorbidities. Ultrasound KUB had a prostate volume of 92 cc with enlarged median lobe with intravesical protrusion around 1 centimeter. Post-void was 640 cc with bilateral hydroureteronephrosis. Creatinine was 1.5. Urine culture was positive for E. coli and PSA was 2.1. This is the ultrasound images. You can see bilateral hydroureteronephrosis, mild to moderate, great median lobe, and good size prostate. So, Dr. Nikhil Katar, sir, what will be the initial management? Okay. So basically, it's around grade 3 prostate, around 90 cc in.
Okay, yeah, I can join in later.
Okay, sir. No issues.
So we have a man who has got history of, you said, acute retention of urine.
No, sir, it was a painless one.
Huh?
Painless retention.
Painless retention of urine, but you have not given any past history, long past history of.
There is no history of any retention in the past?
In the past.
Yes, sir.
But at the same time, he is a non-diabetic, he has no other comorbid condition,
yes.
And he has got a large amount of residual urine. Yes. Obviously, it's a large bladder which is there, around 1000 cc with large PVR.
PVR is 640.
And he has got an obstructive uropathy.
Right.
First and foremost, he requires a catheterization immediately in the casualty and taking urine culture at the same time, because we need to relieve his obstruction. As I understand, his renal function is normal.
Renal function is 1.9, sir. Serum creatinine is 1.9.
So then there is some renal dysfunction also. So we need to gently decompress his bladder and send a urine culture at the same time. And then we need to cover him on antibiotics, send his other blood parameters on the next day, manage his fluid and electrolyte general management, and investigate him further for the cause of retention. Obviously, you have got prostate which is enlarged. There is bilateral hydroureteronephrosis. His bladder capacity on clinical presentation is large.
Yes, sir. Right, sir. So, regarding this case, since it was a very high PVR, yes, sir.
I think let's first put in the diagnosis. It is a chronic retention with UTI, with the hydroureteronephrosis and uremia. That's the diagnosis. Yes, so initially the control of urinary tract infection, decompression, catheterization, and then see the follow-up. And with the large capacity bladder, I think whenever his urine infection is controlled and kidney function is stabilized, then I think he will need a urodynamics assessment. That's my take on that.
Yes. Okay. So regarding such a high residual urine in bladder, many of us practice slow decompression of bladder in fear that immediate decompression will lead to hematuria. So what is your take on that, sir?
I have done thousands of decompression with 1 liter of urine. There is nothing like slow decompression, as far as my experience goes, and I don't see any logic behind this.
Okay. Thank you. Any different opinion in the panel regarding this?
See, if you do a sudden decompression, there is a risk that there may be a profuse hematuria after that. And why it happens? Because after your decompression, some of the veins in the bladder, they may rupture and they may have hematuria. So a slow decompression is recommended. And there are different ways of doing slow decompression, but simple way is you put a bag, don't empty immediately, put a clamp, put a IV stand, and hang your tubing coming over the stand,
It'll drain against
stand,
gravity.
and then gradually bring down the height of the stand in the duration of about maybe next 12 hours or 24 hours, like that. The other thing is you make clamp the caster by slow decompression by 50 ml, 100 ml at a time at the interval of 2-3 hours. So like that, you can do it gradually also.
So you mean to say, I mean, for 24 hours, we should decompress the bladder? I mean,
yes.
Okay.
Well, the classical teaching has been slow decompression.
We have been following this.
Yeah, but of late there has been numerous things to suggest that probably it's not required, it doesn't work. If it has to bleed, it will bleed.
Yes.
No, what I used to practice is that you keep the Eurobag at the same level as the patient's bladder and allow it to decompress slowly. That will be over 1.5 to 2 hours rather than putting it down. So, but this is a new thing that it has to be decompressed over 24 hours.
I think slow decompression means that only.
Okay. So it has different meanings.
As far as the new guidelines are concerned, there is no logic behind the slow decompression.
Sir, I never practice slow decompression, and sometimes it bleeds, then it just settles down.
Sir, I would agree with you that there would be practically no logic for slow decompression. The reason being, even if you reduce the volume by 100 ml, the pressure drop is significant enough as if you drain it completely. So even 100 ml reduction in volume of a 1 liter bladder would reduce the intravesical pressure significantly. So, and there are ample literature to say that slow versus rapid decompression, the risk of bleeding or other complications is nearly similar. So as it is very difficult to do slow decompression, sir.
See, when
because once you put in a catheter,
when it is
just
2 or
leaks.
300 ml of residual urine, it may not make any difference. I agree with you. But if it's large amount, there's higher chances of bleeding, and hematuria can be significant. Then a patient will need hospitalization, and then you have to again wait.
Sorry to say, sir, but it would again amount to the same thing which you said sometime back, anecdotal case.
No, this is not anecdotal case. This is many cases we have seen. Maybe I'm an old timer, so in my time that was the practice.
So the next question is for Nikhil Khattar, sir. Sir, after the drainage, how common is this post-obstructive diuresis, and what are the ways to manage it?
So if the patient has bilateral hydroureteronephrosis and deranged renal parameters, then there is definitely some fluid overload there. And as you decompress, allow the urine to come out, and he has high chances of landing into post-obstructive diuresis. That you recognize first of all whether it is happening or not. That you have to recognize by having a close watch on the urine output. If it is more than 2 ml per kg per hour, then it is post-obstructive diuresis. And you don't have to replace anything, you just have to give him free access to fluid. You don't have to chase the urine output. And if generally that takes care, that is what is recommended, that you don't have to chase the urine output, but give free access to the patient, and a bit of more of salt can be advised at the same time.
Okay, thank you, sir.
So in such kind of cases, would you consider voiding trial? And if yes, then what would be the ideal time?
No, will not consider avoiding trial.
Obviously, there is a reason because the upper tracts are at risk. But the patient is adamant. Will you still refuse that I will not give? That he doesn't want anything. He just wants just Dr. Sahab ek bar bas check kar lo, shayad ho jaye.
No, that is a very different kind of scenario. That's a non-medical discussion. If the patient is insistent that you have to remove my catheter, you have to remove it. But then you'll have to counsel it about the risk of that. And if he is ready for CIC, maybe you can advise him to do CIC if he really wants to get rid of catheter. But ideally, it should be urodynamics followed by definitive management.
And you need to know how is he stabilized. What is his renal function after 1 week? What is his urine culture status? Just let us know how.
Right. So
how it is coming down or it is not coming down. Urea and
so
creatinine.
the creatinine improved a bit. It came down to 1.4. He didn't had.
Can I make a point? Here.
Yes,
sir. This patient has upper tract changes with creatinine of 1.9. If he even if he has a chronic retention, we don't have earlier PVR values. A couple of values will add to it. He has a high pressure chronic retention, and in such a scenario, I think he will deem outlet tackling if the upper tract changes come down, the hydronephrosis resolved, and the creatinine, as he's saying, is coming down. I don't see a role of urodynamics in such a case.
I would tend to differ with you. Urodynamics, if it is available easily, you can't expect a tier 4 city guy to send him to Bombay or Delhi for urodynamics. But if it is available, it gives you a lot of information to counsel the patient and to predict the results of whatever procedure you are planning.
Sir, before going for a urodynamics, want to know what will be the ideal time to go for a urodynamic after the drainage?
Usually we prefer to wait at least 3 weeks for the bladder to get back.
Okay, sir.
Yeah, the urodynamic in the present scenario in this patient who has got a large capacity bladder is mandatory from 2 points of view. One, to prognosticate the patient. If he just straight away go on to some kind of intervention and he does not pass urine, then we have no knowledge what was happening before.
Definitely.
And why it is happening. That is one. Second, for the sake of our own knowledge also what is actually happening, many of these patients actually the bladder recovers very well following catheterization. After all, this patient has not given us any previous history of any neurological illness. There is no other history in the past about obstructive urinary symptoms.
Right.
So one has to actually establish a correct diagnosis about the bladder function before we actually go ahead with any intervention. On the face of it, this patient has got an obstructive uropathy and is going to require some kind of surgical intervention.
Yes. As for the guidelines also, if the PVR is more than 300 ml, we have to go for a urodynamic.
One thing I want to tell that whenever there is such a big retention, the bladder muscles goes, which is known as detrusor fatigue. So it is recommended that you should wait at least for 10 days, probably, and so after 10 days you can do the urodynamics. You don't have to wait too long. Yeah. That is enough for bladder to recover.
I just want to add, you said it was a painless bladder.
Yes.
So we need to know what is the detrusor contractility.
Definitely.
Somebody said high pressure bladder, hydroureteronephrosis and all. So it may be chronic retention, not necessarily the detrusor hyperreflexia. So we must know what is the detrusor contractility index, bladder outlet obstruction index and all that. Urodynamics is must in this.
Right. So we did the same. Obviously,
I'd like to add one thing more. In this situation where patient has got a bilateral hydroureteronephrosis, I like to add a MCU along with urodynamic.
So video UDS.
Yeah. Either you do video or separately. You can do in other room MCU and followed by urodynamic. The reason is if he has even a reflux, sometimes there can be a reflux also associated with the obstruction. So in that case, your urodynamic values can also be altered and your management will also alter because this chronic recurrent UTI will persist even after the surgery.
Right, sir. So in this urodynamics was done. Pictures. So
was the patient voiding before he was catheterized? Was he voiding?
Yes, he was complained of long-standing LUTs.
Yeah,
Maybe
okay,
he was
okay.
voiding, but obviously he had long
Obstructive
periods.
roots of long duration of approximately 2 years.
So this was the urodynamic.
Compliance.
There are 3 graphs. The first one is composite of filling and voiding. Then the second one is separate filling, and the third one is of voiding. So in filling, we can see is a good compliant bladder. The detrusor pressure is not rising, and we could fill bladder till 250 around. And then in voiding phase, it was all abdominal straining only.
P that is.
So regarding the values, he couldn't void, The PDET at Qmax was 4 centimeter only.
Yeah, I mean, this does not change the management. I do not know. It prognosticates that he
Yes,
may
it
not be able to void as good as, but still one would like to go ahead with de-obstruction, and you cannot even say that the result will be bad or good. It can be good as well.
No, just a minute. With this PDAT 16 ml, BOI 9, BCI 22, this is a underactive bladder. Possibly he'll not be able to void, and I think he'll need CIC.
No, but
Operation
what I don't
possibly will not help.
Yes. Yeah, I agree with sir. What I don't understand is why the bladder capacity is only 273 ml in this. He had a large bladder to begin with. So what happened during filling that why you had to stop at 273?
The patient just asked.
Just if you allow one question. This is urodynamics or a particular time. Is with time his urodynamics parameter will also improve or will remain the same?
See, no, it will improve.
It will improve.
I'll tell you, there's a paper which has been published from Calcutta, and they have done urodynamics about this particular case. I will like to wait for 4 weeks on catheter, and after 4 weeks, I'm going to repeat the urodynamic. And I'm sure these picture of Qmax and all that will change in this case also.
Okay, so
number one, that is one option.
Yeah.
The second option is he has a 92 gram prostate. So definitely prostate is a contributing factor for the detrusor hyporeflexia. So that's why you can go ahead with the surgery, explain him the prognosis. You may void, may not void, but you should take a chance. And it may be possible that after the surgery, you may have to give alpha blocker or urotone for some time, and then his residual urine also gradually will settle down.
But one point I will differ, this is very well written in all the books. Size of the gland has no correlation with degree of obstruction. We have seen patient roaming around with 100 gram with no symptom, and when 30 gram is scratching his head all the time. So, but this patient, like currently, he is showing hypoactive bladder. So we have to believe this study that it is hypoactive. Patient should be treated as hypoactive, either remain on catheter for some more time, or you can teach him CIC now. And CIC has got two advantages. If the patient goes for CIC now, even patient himself can assess his PVR or his voiding. Just before putting the catheter, he should void, and after putting the catheter, he should how much PVR is there. He himself can tell whether his bladder is recovering or not. You get better idea. And CIC is associated with less infection. Anybody stays on catheter for 1 month is invariably related to the higher degree of infection. So if patient doesn't want CIC, you can keep the patient on catheter for some more time and repeat urodynamics. That is a better option because you have seen hypoactive bladder and patient has a very large capacity bladder.
Problem with CIC with our patients, maybe in Delhi they are much more educated, they never do proper CIC and ultimately they have to be catheterized. But with our experience in many hypotonic bladder in which we have done TURP, we have prognosticated you may void, you may not void. And actually they have not voided after TURP, after voiding trial. But with that 1 week, 2 week, 3 week giving till supportive treatment, they ultimately more than 60-70% patients have voided well and they are well now. Because initial problem was obstructive uropathy and this was secondary pathophysiology. So there was gradual improvement and that depends from how much time he has got that obstructive uropathy. So decompensation is also depends upon if it is from long time, chances of recovery is less. But if it is a short time phenomena, maybe 1-2 months, he recovers very well.
But there is one more catch point. If you are doing here and you see detrusor pressure is around 40, then it is very probability that if you reduce the outlet obstruction, you may void. Yes. But if the pressure is 20, 25, 30, it is taking a risk. Then you just wait for some more time, repeat urodynamics. You may be able to prosnicate better.
That bilkul, sir, because urodynamic as an investigation is also dynamic. It is not a one-time study. It has to be with time. We have to assess whether he is improving, urodynamic parameters are improving or not.
Sir, I just want to make a statement. I just want to make a statement that all urology centers should have a urodynamic assessment with them.
Next.
So for the young urologist, just want to know what is, when we documented the retention as coronary urinary retention. Dr. P.P. Singh, sir.
No. See, chronic urinary retention described is one when the patient is in retention and it is a painless retention to start with. It means there is no sensation and if the bladder is palpable, clinically the bladder is palpable, but patient is not feeling any pain or sensation to void, as this is in this patient.
Okay.
And if this situation remains for a particular period of time,
6 months,
there is a time band which is given, which has to be, you have to give him few months to see whether he is actually in chronic urinary retention or not. Like this one episode, one patient, he has taken sometime you get a patient who has taken some drug, some anticholinergic drug, and they are not feeling it. You can't label this patient as chronic urinary retention. So you have to give them a voiding trial and see whether over a particular period of time they are still retaining urine, which is painless retention of urine.
Right.
Yes.
So there are different types of chronic urinary retention, just as the panel suggested, like low pressure versus high pressure. What could be the possible cause in this patient, because he didn't had any comorbidities, he was more or less a fine patient. So what could be the cause in this patient?
Chronic bladder outlet obstruction, possibly there he has not taken care of that. So neglected bladder outlet obstruction.
Right. So BPH with progressive obstruction. Regarding medical therapy in chronic retention, so are we trying any medical therapy for chronic retention, and does it really have some, does it really help us or the patient to improve his condition?
See, in my practice, if I do, as I said, see, one has to decide case to case. And in this particular case, 92 gram prostate, I'm sure prostate, outlet obstruction is contributing factor in this case. And again, we go back to the basics, complicated BPH, uncomplicated BPH. So this is a case of complicated BPH.
Yes.
That's why surgical treatment is the treatment of choice in this particular case of scenario. Other contradictory thing in this case is your urodynamics saying 293 ml urine. Yes. How suddenly the bladder has become such a small size? It is, again, you know, it might have overstretched at that time. That's why it was 1000. And that your finding of 4 ml mx, that is not matching actually, you know. So I'm doubting on this urodynamic study also. And who has done this study? How careful he was? We don't know any of these things. So the question is, we should give a best benefit to the patient. Ultimately, he will need a surgery. That I'm 100% sure. Whether you do it now or do after 4 weeks. But certainly, if patient says, no, I want to wait, we let him wait.
No, this patient has gone beyond chronic retention.
Now, after the surgery, now I'm coming to the next scenario, the question you asked, medical treatment. Sometime when we have done the surgery, his PVR may still be 100, 150 ml.
Right.
So that's a scenario. I personally, methanicol hydrochloride or urotone, the tablet, I'm certainly using it. And alpha blocker also I add along with that. And in my practice, I have seen patients after 1 or 2 or 3 months, their PVR gradually goes down to 50 ml or something. Then I stop all medication.
Sir, the next question is the same, is what is the role of methanacol in this case? Or
certainly, I like to give a trial to him. Though literature says that methanacol has got no
It is
effect,
all empirical. Literature does not prove it at all.
Does it clinical practice is
but we all have been doing it because since the time of our training and now, there have been only 2 medicines, carbachol followed by methanacol. So we don't have a medicine for underactive bladder, so we have been using it. But if we see the evidence-based medicine, there is no evidence that methanacol per se would improve the patient of chronic retention.
does it improve in your clinical practice? The symptoms?
I don't have a
As
case
I
control
said,
trial, we all have been using it.
In my practice, I am using it,
but
only selected cases, not every case. You know.
Dose, what is the dose you are using, sir?
I use this 25 milligram 3 times a day. Now we have got 50 milligram tablet, we have 100 milligram tablet also. So like that you can decide, but that is the standard dose.
You can go up to 100, but you have to look at the pulse rate of the patient. You have to tell them if the pulse rate comes less than 60, then the dose is to be accordingly reduced or stopped.
Okay. So most of the time we get biased by the urodynamics report. And many a times, you see, if you repeat it once or twice, they all differ. So therefore, patient must get the benefit. You counsel the patient, tell all the pros and cons of the procedure. Surgery need to be done because CIC with 92 gram prostate is also a hassle. They damages their prostate, hematuria, recurrent problems, and somebody does the CIC and they have false passages and whatnot. So having disobstructed these patients, we have seen that CIC afterwards, if required, it is required in hardly 5% of the cases. Similar cases, if you do hundreds, you will hardly have 3-4 patients, and if you have counseled them pre-operatively, there is no problem.
So actually this is an absolute indication for TURP. All those absolute indications for TURP, this is an absolute indication for
And in fact,
prostate.
urodynamics become counterproductive because now you are in a dilemma because it's a completely
Yes,
underactive
yes,
bladder and
because
you are just
anyway you had
cornered.
to de-obstruct.
Yes.
And sir's point that sir raised, CIC in a large prostate will be, so if CIC has to be done, would you prefer already resected prostate? If a patient,
if you do a good HOLEP, CIC becomes very simple and easy, and they are so happy.
Yes.
Yeah.
So I go one forward. Professor Gupta sir was telling TURP is absolutely indicated. I go one forward. It's an absolute indication for HOLEP because the
Yes.
HOLEP like that,
TURP or-
the resistance is so much reduced. 95% of the time they will pass urine without incontinence. Whatever you do it, remove the complete enucleation. He is a very good and ideal absolute indication for HOLEP.
No, I agree. When I say TURP means TURP or HOLEP. Both are same as far as I am concerned.
The amount of tissue removed in HOLEP is
No,
I
that
think,
won't.
more.
That won't change. That won't change the scenario. Please.
It will. It
no,
will.
no.
That's what I was trying to tell.
Sir, the volume of the you have to provide an adequate outlet to these patients, whichever means you know best. Whatever 92 gram prostate in good hands, people can remove up to 70 gram prostate also. That I can assure you, one can check volume to volume.
No, what I
Doing
was-
an extra, what I mean to say, I don't disagree with your statement that there will be, we have to decrease the outlet pressure in this patient. But doesn't mean that you have got a massive difference between doing a HOLEP versus a very good bipolar TURP.
No, I'm not talking about the technology part of it. Whereas, the incontinence rate is more if you're doing a regular where the high pressures are more. In this case, you don't have that also. You will have a good patient performance with the HOLEP. That's what I was trying to get.
In good hands, the incontinence rate is same. In good hands, the incontinence rate is same.
No, Manohar, unfortunately, TURP, why the results are inferior? Because how much tissue you have resected. Whereas in enucleation, you are going up to the capsule. But if you are a good resectionist, you know you can go up to the surgical capsule in every case, and you see everywhere. That is the standard TURP, what I am doing at least, So I know what is the outcome is difference, more or less same.
Just for the sake of residents, you said the resistance bladder outlet. You know exactly what is the bladder outlet resistance and index, that you know the contractility also. So what I would propose, then again repeat, because this is looking little not normal.
Not matching with the case.
Not matching with the case. So you need to redo it after say 4 weeks, as Dr. Anant was saying, and then decide it again. Everything is science. You can't say that there is a resistance, this is this, this is this. Everything comes in urodynamics. Every data is there.
Yeah, we will come to, because of the underactivity, we know that complication rate in this case is the main complication post-operative is bladder neck contracture.
Sir,
Whatever we do it, bladder neck contracture is to the tune of 30%, especially in an underactive detrusor when you do a procedure.
Yes, Dr. Rohit, please.
Yeah, sir, one critical comment regarding this borderline cases, because, whenever such cases wherein we don't know we are sure that we are not going to give him optimum result. What we are trying to do is to reduce bladder outlet resistance. In such borderline cases, rather than, it's a radical thought, you might not agree with me, but rather than giving them complete thing like a good resection or a good HOLEP, here comes the role of MIS, sir. We have a patient from Umesh Bhai. That patient was an MNC guy, 55-year-old, acontragal detrusor, and then we offered him Urolift, not 90 grams, but that I told him that if I am not going to give you optimum result, at least I am not taking away anything from you. Because if you do HOLEP, you take away sexual function, you take away little erectile function and all that. So these are the cases where we do see there is a role of some measure. You might not agree, but there is, something you don't promise him that, you are going to give him them, you are taking away everything from him.
No, I am smiling on your...
This case is an absolute contraindication for mist. It's an absolute contraindication.
Your point is not well taken.
This is an absolute
Sir, Rohit says, I'm not taking away anything from you, but he is paying 5 lakhs.
92 gram glands, sir, but what I'm telling is somebody who has a 40 to 60 gram glands, rather than offering him, he is having acontragal detrusors, what you need is to reduce the bladder outlet. You don't need to remove the entire prostate for that, sir.
No, but
so that's a very
I doubt, Dr. Rohit, many will agree with you on that.
No,
I mean, if you take a straw poll.
Rohit, what you said after that, sexual dysfunction and all that, I think ejaculatory you can mention, but not the sexual part.
How will do sex with the catheter intact?
Okay. So if we are planning for a surgery, what is the ideal time after the decompression to doing a surgery in this case?
See, in this, not in this particular case, but otherwise we have seen cases with 5, 6 creatinine also coming down up to 2. And if sodium potassium is normal, no contraindication for surgery.
3 creatinine ideally after around 3 to 6 weeks.
2. We take 2.
The safe creatinine is 3.
Whenever the creatine stabilizes, nadir creatinine value is reached, it's a good time.
Preferable.
Just go back to the slides, sir.
Which one, sir?
Yes.
This one.
I will request Dr. N.P. Gupta Sahab, please change this. Who is doing open or simple prostatectomy for prostate? Dr. Anil Varshney will do HOLEP for 150 and 200. This is American guideline. Let's have an Indian guideline, sir. Please.
No. Statement number 2 is correct. Either you can do HOLEP or good bipolar enucleation of prostate is good enough for this particular case, 92 gram prostate. It can be done, both can be done safely, both can be done with same outcome, whether you do HOLEP or you do bipolar enucleation. It depends upon the surgeon's choice also and surgeon's training also.
Right.
If he is comfortable with TURP, he can do TURP. If he is comfortable with HOLEP, let him do with the HOLEP. We have no objection for that.
I think
as far as simple prostatectomy is concerned, if somebody has got a large gland, more than 150 gram, 200 gram, I think so you are more kinder to the urethra if you are doing simple robotic prostatectomy. Exactly. So that is my current indication of the simple robotic prostatectomy.
I think one point I would think is that 92 grams was in acute retention with so much of residue. So just labeling that 92 at that point in time may not be appropriate once bladder is decongested and prostate is stabilized. So I think that's an important point sometimes, that what you see initially and by the time you decide the procedure, things can be different. So it's good to reassess before you are definite that now if there is a big gland, I must go for robotic or I must go for HOLEP.
No, what you said is right. Because of the inflammation, size of the prostate may be bigger or infection. But gradually, how much it is going to make difference, 10 or 20 gram? So it's 70, 80, 90 is not going to make any difference to us actually,
Yeah, points well taken, sir. So this is from the guidelines only that TURP is adequate.
It makes a very much difference on operating on an acute phase prostate and one prostate who has reduced and vascularity is reduced and stabilized, especially those prostate who are on larger side. 70, 80 gram, you take a bite and it bleeds hell of a thing, and you take 10 bites and hardly any bleeds. So once we are experiencing again and again, even any prostate who is in acute phase, we give it 2-3 weeks time before he embark upon operation, it becomes much easier. And let him operate, and most of these parameters may also improve. Not only his 80 gram may become 60 gram by giving receptor blocker, antibiotics, inflammation may subside. Why we should, as a surgeon, only want operation? We should do whole treatment, and then medical treatment is very, very important in such cases.
Okay. So, good points regarding this case. This is the final gist that even after surgery, detrusor recovery may take time, weeks to months. Then he may need CIC during recovery, and maybe in the end also. You have to monitor the renal function and the residual urine, and maybe CKD follow-up is also necessary. Obviously, regarding evaluation part, timing of urodynamic is important. You should wait for 3-4 weeks. Then obviously repeat urodynamic if you feel that it will better explain the things and you can better explain your patient, and then only plan the treatment. Coming to the next case. There is a small announcement for residents and fellows. There is a moderated quiz tomorrow. If anyone want to participate, he can give his names to Dr. Swapnil Kushwaha. He might be in the group. He can, the resident or fellow can reach him via the group or can directly come to them and just register their names for tomorrow quiz.
So this is a second case scenario in which the 68-year-old male patient came to us with the complaints of predominantly weak stream intermittency and straining. He is having comorbidities, hypertension on amlodipine and well controlled, and diabetes which is well controlled. He is also having complaint of increased frequency and nocturia from last 12 months and from last 2 years, and the sexual function is fine, and occasionally the patient complained of urgency. His IPSS score is 26, quality of life score is 5. In ultrasound, the PVR is 140 ml. The prostate size is 38 cc with median lobe intraprostatic protrusion is 2 centimeter. Serum creatinine is normal, urine culture is sterile, and PSI is 2.8. So just want to know one thing from the panelist, Dr. Sameer sir, what is the role of median lobe in determining the treatment option?
Well, before moving on to the median lobe, I would have liked to get a uroflowmetry done for this patient.
Yeah, it will be done.
Because the PVR is, you have not mentioned the pre-void, so I don't know what is the bladder capacity out of which 140 ml is the PVR. So if it's a large bladder, he is a diabetic for some time. Okay.
These are the two PVR which are done at the 6 month separate time. Before starting the medical management and after starting the medical management, almost the flow is normal, and in both the cases the post void is around 500 ml, 400 ml, and the residual urine is around 100 to 140 ml.
So he is clearly obstructed. He has got large residual. He has got an obstructed flow. And in any case, among all the parameters, if you look at detrusor wall thickness, if you look at the median lobe, probably IPP is one of the most significant predictors of response to medical therapy. So higher is the IPP, less is the chances of success of medical treatment. So it is a determinant in decision making.
I think there is one point I think the guy has in mind is the median lobe. This is very well published. If the median lobe is more than 1.5 centimeter, most of the medical therapy will not work. That's why if you see all the guideline, even minimally invasive therapy, median lobe is more or less contraindication. People are extending the indication to do that. So median lobe is one thing which causes valve-like effect in most of the widening problems. So median lobe becomes indication for surgery. So that was the thing one should remember, and most of the patient, even this patient did not respond 6 months of the medical therapy.
Still
I like to add something more. He has both kind of symptoms, irritative and obstructive. So keep in mind that also, because it may be possible even after your surgery, irritative symptoms may not subside completely. So he may need some additional medical treatment. So if you are doing surgery, you have to tell him, counsel him properly that surgery is only for obstruction. However, it may also relieve your irritative symptoms, but may not be completely.
Still on understanding, he has got a median lobe, which is 2 centimeter intravesical projection. He's a 67-year male who is sexually active. His shame score is okay. He'll still go on an alpha blocker, preferably alfuzosin to start with. Of course, making him understand that patients with large median lobe may not be as good responder to the medical management as patients without median lobe. As far as irritative urinary symptoms are concerned, we need to decide once we start the alpha blocker. Still with obstructive and irritative, we will start with the alpha blocker and add on bladder relaxant at a later date in case the irritative symptom persists and the obstructive symptoms are improving.
This is ideal case for shared decision making. You have to discuss with patient the alternative treatments, the medical and surgical both. You have to discuss with him and then decide.
Right. So in this patient, initially, obviously we tried alpha blockers, and he was started on alfuzosin since he was sexually active. Since the prostate size is around 38 cc, he was added finasteride also because of persistent symptoms, obviously explaining that it may lead to some kind of sexual issues. The patient obviously changed, he was compliant to the medicines, lifestyle modifications is followed, but with time the symptoms worsened again. And obviously this was the Euroflow after the treatment. So what defines the failed medical management? Even
When we go for an intervention or the changing in treatment?
Before that, actually.
Do we want to?
Yeah, before that,
Yeah.
finasteride really has no role in this patient.
Mhm.
I mean, guidelines are very clear. There is a lot of evidence. For finasteride, 40 ml has been the cutoff. For dutasteride, you could have tried dutasteride because 30 ml and between 30 to 40 grams, it has shown some benefit. But finasteride less than 40 ml probably has no role.
Okay, so regarding alpha blockers, if the flow is not improving, would you like to try some other alpha blocker apart from alfuzosin, or combination therapy or something, or right away you will ask for the surgical treatment?
No, we'll counsel the patient if he is not happy. The quality of life, that score should also be considered in the mind.
Quality of life
So quality of life score should be recorded.
Yeah, is hampered, yes.
Hampered. So if he has quality life is also hampered, in this scenario, I think so, after waiting of 3 months, you have already tried. At the most, you can wait for 6 months. But if he is not improving, that is called failed medical treatment. And go for surgical option. Which surgical option? That can be left open for the debate here now.
Sir, just want to ask one question. Is there any logic to use 2 alpha blocker, once in the morning and once in the night? I saw some prescriptions from the senior urologist only. They use 2 alpha blocker, once in the night and once in the morning.
If patient says, I do not want surgical treatment, then you can add one more. Otherwise not.
Because that guideline said it
No
is
point
only...
of adding 2 alpha blocker.
If not, otherwise I said also, no, same.
Only one alpha blocker
Yeah,
at a
exactly.
time.
There is no evidence to suggest 2 alpha blockers work. What could be tried was probably firstly ask the patient which symptoms have persisted, which symptoms have improved, if there is partial relief. And if mainly the obstructive symptoms which have persisted, you can try switching over to say silodosin from alfuzosin. If it is mainly the storage symptoms which have persisted, you could go in for adding say a mirabegron. If it's mainly the nocturia which is bothering him, you can try lifestyle changes. So look at the detailed picture of what is happening.
In this case, as it is a mixed lower urinary tract symptoms, so what is the logic behind using the anticholinergic in this case? Is there any use? Useful
not
for the patient?
anticholinergic, I said mirabegron.
But it will cause the obstructive symptoms more worsened.
No,
No, it's not like that.
But you said they are more, not at all bothersome. Bothersome was
Voiding symptoms. So that's why I am asking.
With such a large median lobe, ultimately, earlier you do, better he will be, because he is not going to improve ultimately. Now, second phenomena which can happen is the bladder may worsen with the increasing obstruction with time. So if you delay surgery, there are 2 symptoms. Everybody of us knows. One is a storage symptom and one is voiding. Voiding symptom may improve, but a storage symptom may worsen. And with majority of patients, because they come late, some or the other symptoms remain. That is why prostate operation is such a operation, whether you do HOLAP or whatever you do, more than 30-40% patients are not satisfied because they have bladder problems. So for that, medication has to be given, and that is to be well counseled to the patient and explained to the patient. That's all. And with majority of our patients, that is why it is dictum is that you operate on a patient, 30 patients are fully satisfied, 30 patients are somewhat satisfied, and 30% are not satisfied.
So I tell you, just to add our experience, we have published a paper from All India Institute, 1,000 cases who have come to us with retention of urine following alpha blockers. And the conclusion of the study was only that if alpha blockers and the dutasteride going to work up to the 6 months. If somebody who has not improved up to the 6 months, then better not to wait further for the surgery, what he has already said. So the question is, how long you will give these medications? 1 year, 2 years, 3 years is all waste of time.
6 months.
I will further modify. Alpha blocker works same day. When next day you get the uroflow, you'll get the effect. Dutasteride takes 3 months. You get the maximum effect in dutasteride, and finasteride it's 6 months. Dutasteride is little faster. So if you have started dutasteride and 3 months are gone, 2 months are gone, patient is not showing response, he is not going to show response. Alpha blocker response within next day you do it, you'll get the alpha blocker is working or not, you will see the in uroflow.
Right, sir. So this was a failed medical management because we tried good enough time the medical therapy. It is defined as a persistent bothersome LUTs despite more than 6 months of appropriate alpha blocker plus minus 5 alpha reductase inhibitors. And objective evidence should be there like high IPSS, high PVR or recurrent retention. In this reason, obviously this has been discussed that it was a good size median lobe which was the reason for patient's treatment failure.
Now there is a rider to this 6 months or whatever period is, that if a patient developed some kind of recurrent complications like hematuria, infection, now this 6 months is not a fixed period, it's not a fixed line. Yeah. So there the clinician needs to decide when to intervene. This like a patient in which there is a progression in the IPSS 1 within few weeks of initiation, or the patient who is developing a recurrent complication in form of retention, UTI, hematuria, there this 6 months is a variable period.
Yes. So the question is for Nikhil Khattar sir. Sir, what is the role of truss in benign prostatic hyperplasia, and what is additional advantage of doing truss in BPH cases? In the same case
truss
only.
will only give you good estimation of the size, but otherwise here it is not required. So I do not get any transrectal ultrasound for this.
So like no one of us are getting truss for better volume estimation. It's only transabdominal.
Yeah, that is good enough.
Truss is basically only for academic studies it has been done to see the transition zone versus peripheral zone volume, and if you are giving any drug therapy or something to seeing the response. So for academic regions, trials, okay, otherwise in clinical practice we don't get truss.
And then is it going to change the treatment? That is it is not going to change the treatment.
Yes.
So that is the logic that truss is not needed.
No, but see, one thing is important. I think the question should be that what is the role of ultrasound? If you see various guidelines, ultrasound is not required. But to my mind, ultrasound is required for 2 reasons. You decide the mode of therapy or the size of the prostate and presence or absence of the median lobe, which ultrasound will tell. Whether you are doing minimally invasive procedure, whether you are doing alpha blocker, dutasteride, or you are doing the HOLAP, everything is size of the gland does matter. And ultrasound also tells you the PVR. So even you see the guidelines, alpha block, the ultrasound is not recommended. If you see the guideline in most, but this ultrasound is required when you are trying to find out which treatment modality you will choose.
Okay. So this is the AUA guidelines where they have said ultrasound or renal function test is not required. which is totally wrong. I think so. I request you all to please go to USI guidelines for BPH management. They have been published now, and in India now ultrasound is so easily available. And what he said is, I agree with him 100% that renal function test and ultrasound must be done in every case.
In fact, the earlier version of Kittifu's paper on grading of the median lobe, grade 1, grade 2, grade 3, depending on 1 centimeter, 1 to 2, and 2 to 3 centimeters. Grade 2, he has first said that first line interventional therapy for those patients who's a grade 2 Kittifu median lobe enlargement. So even they didn't want to offer the medical management.
So obviously, this patient has landed up in situation in which there is no other option but to choose from one of the surgical options. So in this patient, which option will you choose? Dr. Trivedi, sir?
Well, the median lobe would dictate the surgical option. So all the myths which don't target the median lobe like Eurolift are out. Going by conventional route, this patient is suitable for so many procedures. He is young and sexually active and he has got good erections, so probably something like a sexual function preserving, if he can preserve his ejaculation, would be a good option. So thinking on those lines, probably TURP would not be the first choice because it will definitely affect the ejaculation. So you can think of a number of minimally invasive therapies except things like Eurolift which don't target the median lobe. So rest all of them, the evidence is there.
Sir, which procedure you go for in this case?
Well, both. If I have all the facilities available with me, then probably the patient would be a good candidate either for resume or for aquablation. But in our settings,
Sir,
probably...
This much,
suppose if the resume is not available, suppose if the resume and aquablation is not available,
yes.
What would you prefer, sir?
I would tell him that I will do a TUR, your ejaculation would be gone.
Yeah, that's what median lobe resection is enough.
Just median lobe resection may not affect his ejaculation even. If we selectively only resect the median lobe, do not resect all around, and do not go near the ejaculatory duct, he may just continue to ejaculate.
Yeah, you just leave
So
some
ejaculation
tissue
preserving
there at the
TUR.
apex and ejaculation sparing TUR.
Ejaculation preserving TUR, my option.
So you catheterize the ejaculatory ducts first and then resect?
No. You just leave some tissue near the apex, above the veru. That's it.
So the question is for Anant Kumar, sir.
Just 1 minute. You have to counsel the patient, you have to discuss the patient. Now you have heard so many options are available. So what is the idea of doing the operation? Operation is done for relieving of the obstruction. Second thing, tell the patient that if you are going for a TURP or HOLEP, there's a chances that you will lose the ejaculation. But it is not, we have to also give him a confidence that your sexuality, whatsoever is the erectile function is there, that will be maintained. And most of the patient will agree for the surgery. If not, you have the options like median lobe resection only. You can do only ejaculatory preserving TURP also. You have the option of one of these resume or Eurolift also. There is nowadays we can do with median lobe. So these are all options available. So if he is very keen, no, at any cost, I don't want my ejaculation to go, do one of these minimal invasive therapy.
Any hybrid?
So, sir,
I advocate the
hybrid, Dr. Anant Kumar.
My hybrid procedure.
Even I for hybrid.
Take the median lobe and then put Eurolift or resume.
Do only median
all
lobe.
right.
The other option, similar case, it was an MLA in Bangalore. He wanted 100% ejaculatory function preservation. Unfortunately, I didn't do the cystoscopy. But when I went inside, there was a median lobe. So I told him that I'm going to do only Eurolift. And you want 100% ejaculatory function. So when we went inside, there was a big median lobe. So we did Eurolift for both the lobes, but still median lobe was there. We took a resume and put median lobe resume. He's very happy after the 3 weeks he had a lot of problems.
Procedure. That's what
yeah, hybrid, that's what.
Hybrid.
So in this case also we do the hybrid procedure. The median lobe is tackled with the TURP and for the rest of the gland we do the resume.
Anant Kumar already said that actually.
Yes, sir.
But you charge both the procedures.
Because sir is doing the same.
Yes. Patient was happy to pay.
This is suppose insurance patient. Insurance.
No, I'll tell you about this patient. I tell you about this patient. This patient was advocate, money was not problem, but he was very particular that he wants resume. I told him, you have a median lobe, then what, he said, whatever you do, I have read everything, and I read literature, and I think the resume is the best procedure for me. So I said, you have a median lobe, then I'll have to resect the median lobe and then resume. He said, do it. So we did it. He is now very happy, his flow is good, he did well, his ejaculation is preserved, and he's a happy patient.
Moreover, he does not will listen to your advice. He will go to Professor N.P. Gupta, he will go to Professor Dongra, Dr. P.P. Singh, then he will not listen to anybody. He will simply go to ChatGPT and Perplexity and put all his papers and ask what should be done in my case with all these investigations. And then he will give more weightage to AI advice rather than your advice. And he will be utterly confused also.
Yes. But at least finally he will go to somebody,
He will
either
go-
him or you or somebody.
See, luckily I tell you, it's just on the sideways, we are not talking here. We have practice like that in Delhi.
But sir, you put this case on ChatGPT, it will give you the best answer. Because it
You
will
can put now
take
only and see what
everything.
answer you get.
Yes.
Just put in ChatGPT this answer. You just see
Yes,
what answer
put
you get.
all the investigation and see just show the result here.
Okay, just put it and after some time we'll tell.
Samal, you put chat GPT, you can have 3 answers in 3 different time. That also you should know.
Complex cases, this is the actual scenario. People are putting all the complex cases is there, and it is giving advice based on the common knowledge and basic knowledge. It will not go waver.
आगे बढ़ो.
The chat GPT gives very dubious answers. It is the question which is framed in what way. Actually, I have seen people coming out with multiple answers, and they say that this question was framed like this, like this, like this, like this. So I think we have to be very vigilant with these AI tools, because they are many a times hazardous.
Yeah. Thank you so much, everyone, for the enriching discussion, and we will proceed for the the inaugural function. Sorry.
I request Dr. Anil Goel, Dr. Anant Kumar, Dr. N.P. Gupta to please stay on the stage for the inaugural ceremony.
एक question discuss करना रह गया. One question रह गया. चलो.
Dr. Anant Kumar, Dr. Anil Goel and Dr. N.P. Gupta to please stay on the stage for the inaugural ceremony, sir.
The chat GPT says TURP as first option, prostate lift as second option, not ideal, and water vapor therapy as another option. And then TURP as first option, chat GPT. Second one, prostate lift, not ideal because median lobe is there. Water vapor therapy, it is minimally invasive, can be used. Holmium laser, very effective for prostate.
I request the audience to please stay back. We are having an inaugural ceremony soon in next 10 minutes. Audience to please stay back. Kindly take your seats.
क्या option है? TURP first option. TURP first option.
सुनो ये जो है ना सीट्स ये सेंटर में लगा बढ़िया हम भी थोड़ा सा आराम हो गए थे ब्लैडर खाली करके आ रहे हैं ऐसा बोल रहे हो गया ना आपका चलो आ जाओ
अभी आएंगे थैंक यू टू ऑल
अभी देखो सब लोग खड़े हो वो आप मैंने कहा ये कह रहा था मैंने कहा सब लोग खड़े हो गए अभी
ठीक है ठीक है
आपको ये चाहिए या नहीं चाहिए
आप रख दो आप
चलो ठीक है
नहीं ये दे दो ना सेम ही है ना मैं तो इतना ही बोला मैं तो अपनी लाइन ऐड कर रही थी कि अगर मुझे अगर डिपेंड ऑन सिनेरियो मैंने तो बोला सिनेरियो चेंज हो गया अभी बोलना पड़ जाएगा व्हाई इट्स ये हमने इतनी दूर क्यों रखवाया इधर रखवाओ ना आप लोगों को इजी रहेगा ना नहीं मैं पास करती हूँ ठीक है आप इधर आओगे ऊपर इधर आएगा ऊपर चढ़ आएगा ठीक है एनीवेज तन गुरु नानक रहे हो आप? एक साथ होंगे तो आवाज़ अच्छी रहेगी। हेलो, अभी तो बंद है। ठीक है, ठीक है। हाँ, इसकी रिक्वायरमेंट तो नहीं है, पर ये रहता है ना तो नहीं। अच्छा चलो ठीक है, लेट इट बी। क्या क्यों उठाना खुला रहता है तो पेपर छुपा रहता है, पेपर छुपा रहता है। इसको रहने दो, इतना रहने दो, पेपर छुपा रहता है ना। आप समझ रहे हो? इसको पीछे कर दो, पेपर छुपा रहता है। ये लो, ऐसे पेपर छुपा रहता है।
ये सही लग रहा है, दोनों के आगे नहीं कर रहे होगे तो ये पानी की बोतल वगैरह उसी की बोतल इधर इधर इधर।
Take their seats as we are about to commence the inaugural ceremony of the Max Prostate Conclave 2025. Over to you, Jasmine.
Happy evening to everyone. Your participation and insights made this event informative and engaging. We are grateful for your enthusiasm and contribution. This evening, we have the privilege of welcoming some of the most distinguished names in urology and Indian healthcare as our dignitaries on stage. Their presence today marks the formal commencement of our academic celebration.
I request our esteemed guests to kindly come forward to the stage as I announce their names. Dr. Anil Goyal, who is the guest of honor of the evening. He is currently serving as a respected member of the Legislative Assembly in Delhi, Medical Director of Goyal Hospital and Urology Center. He has served as past President of the Delhi Medical Association and North Zone USI. Dr. Anant Kumar, Chairman of the Urology Department and organizing patron of this conclave. Dr. N.P. Gupta, Professor Emeritus Urology at Medanta, Gurgaon. Dr. P.N. Dogra, who is the advisor of Urology Department at Sir Gangaram Hospital, Delhi. Dr. A.K. Sanwal, who is the Medical Director of Sanwal Hospital and Betwa Stone Clinic at Jhansi. Dr. Pragnesh Desai, Organizing Secretary of this event. Please welcome them with a loud round of applause. I request Jasmeet to kindly present floral bouquets to our dignitaries as a token of respect and gratitude. Dr. Anil Goyal. Dr. Anant Kumar. Dr. N.P. Gupta. Dr. A.K. Sanwal. Dr. Pragnesh Desai. To open the ceremony, I request Dr. Anant Kumar, our organizing patron, to address the gathering and set the stage for the evening.
Premnath, first let Premnath come. पहले Premnath को honor करो.
Sir. After that, sir, after that talk of, after that, sir will address.
पहले Premnath को करो.
Just me, please hand over the bouquet to Dr. Dogra.
The chairperson, Professor Gupta, Dr. Goyal, Professor Premnath, Dr. Sanyal, and Mahesh Desai, fellow delegates, friends, colleagues, students. Every year we do one educational program and we change the theme. This year we kept prostate because when we were under surgical training, at that time, most of the prostate operation was done open. Only one surgeon who was doing TURP, and that too, we have seen all kinds of complications which you will not even imagine. We have seen the colostomy after the prostatectomy also. But then when we are doing MCH, then we saw the very refined surgeons and very good TURP. Professor Bapna's TURP is the real pleasure to watch. No patient, we have not seen any complication, but if any gland is more than 60 gram, he will just take out the scope and ask, just do Millen's prostatectomy. So I'm saying that things have changed. There was a time anybody coming to the urology OPD, elderly patient with urinary symptoms, straightway goes for TURP, and any woman coming to the gynecology OPD straightway goes for hysterectomy. So from those days, things have changed. Now you today have seen the prostate has become such a complex. For everything, even the senior faculty and experienced people have different opinion. Each aspect has got, even symptoms has got so many things. Each investigation has got so many of discussion and finer points, and the prostate has seen so many procedures. Like you may not be knowing that there was a microwave therapy, there was a tuna, there was a laser, interstitial laser therapy, then there was a prostatic stents, then there was a ethanol injection into the prostate. Everything was done. Prostate was cooked, injected, frosted, cryoablation, then resected, removed. Everything was done, and still things are evolving. Now you see that so many procedures we have discussed. Today we'll discuss some more procedure, and like prostatic arterial embolization, aquablation, then you have seen resume, urolift. So we thought that probably things are changing and it will keep on changing. It's not that we have reached to the final destination. It will keep on changing. So we thought we will discuss one subject in great detail because prostate is a bread and butter for all the urologists. It is the most common patient in our OPD. And we should offer the best treatment. And nowadays you have seen the situation has become different. Before that there was a Dr. Google, now there is a Professor ChatGTP. So we are getting lot of information, patients are coming and now demanding what to do. So we have to be updated, we have to know what is the current literature, current science, and we thought this is a right time to discuss prostate threadbare and have better knowledge so that we can serve our patient in a better way. So that's why we have chosen this prostate, and I hope we are meeting the standard, we are meeting the expectation, and tomorrow we also have a very good sessions, and tomorrow morning 8 o'clock there is a very good lecture on multiparametric MRI. Now everybody is doing. We should learn what is multiparametric MRI. So I think I'll request everybody should be at time tomorrow to listen to the lecture. With this, I welcome you all and thank you all for coming to this meeting and having very lively discussion. And I was very happy to see that there was a very lively discussion from everybody asking various questions, raising the doubt and contradicting each other to understand better. So once again, thank you all. Thank you very much.
Thank you, sir.
We will now proceed the lamp lighting ceremony, a symbol of enlightenment, hope, and the illumination of knowledge. I request all our dignitaries on the stage to kindly light the ceremonial lamp, marking the auspicious beginning of the Max Prostate Conclave 2025. Thank you. To invoke blessing for wisdom, knowledge, and success, may I request everyone to rise and join in the Saraswati Vandana followed.
Next, I request Dr. Anil Goel, guest of honor of the evening, to kindly address the gathering. Thank you.
Good evening. Sitting on the dais is our teacher of teachers, Dr. N.P. Gupta, the organizing chairman, Dr. Anant Kumar, Dr. P.N. Dogra, Dr. Sawal, who is President, North Zone Urology Society of India, Dr. Pragnesh, who is, I think, the brain behind all of this, and he has done a hard work and talking to each one of you, distinguished guest, and also the residents sitting on the floor. Friends, I must compliment Dr. Anant Kumar and I know him since 1975. He was 1 year senior to me in KGMC, and thereafter, when he came to Delhi, he had just added the urologic sciences in the field in the city of Delhi. You are one of the doyen of urologists who had brought laurels to Delhi Urology Society, who had brought laurels to the urological fraternity in Delhi. I thank you, I compliment you that you are the teacher to many of the people sitting here and also not sitting here. I must compliment you. And you are always, as you said, every year you are coming with Max Conclave. And this year, this is Max Prostate Conclave, which is organized by Department of Urology, Uro-Oncology, Robotics, and Kidney Transplant. And what is important about you is, I think what I love about you is, you are so fluent in changing. With the changing times, you also change accordingly, whether it was robotic surgery or maybe now Urolift, Rhizome, maybe I trained or whatever, prostatic artery embolization, which your conference is talking throughout the day, and tomorrow also the residents and all the delegates would be updated on that. But all these procedures, when we talk of these procedures, obviously we are the world leaders in medical tourism in the country. I'm seeing lots of leaders of urology field, Dr. Anil Alens, Rohit, and everyone sitting, Anil Varshne, PP Singh, Yadavji. Kamaljeet is not interested in listening to what I'm talking. So I'm now talking to the world leaders in the field of urology. And what you are doing is that you have brought world tourism, medical tourism to Indian shores. That's one part. And that too in affordable cost. And that is why they are coming here. But I always feel now is the time for the innovations. As our Prime Minister says, when previously it was Jai Jawan, Jai Kisan, then Jai Vigyan. Now the Prime Minister is saying Jai Anusandhan. Now we need to have Indian innovations. We need to have Indian literature. We need to have the skills in the Indian equipment. And why can't we have the Indian endoscope? Why can't we have the Indian robots? And we only have one, say, Mahintra, which is being used here. We need to have the Indian literature support. As Dr. N.P. Gupta sitting here, he is the right person to lead in this field of innovations, skill building, and the literature support. Let's listen to many people saying, Dr. Anant Kumar said, and this coming out from the American person. That is what I'm looking for as an individual, as a urologist. That's the next level which we need to achieve. Then only we will become Atmanirbhar. We need a self-reliant India. We need a developed India. We need an India which is developed in all, but on whatever we say, that developed in Indian literature, urology literature I'm talking of, Indian innovations, medical equipment, or whatever, in every field of this. Now is the time that Indian Journal of Urology needs to be quoted more and more often. And we have the brain, sitting here, sitting on the dais. You are the people who can do this. And I think this government is going to support all kind of innovations which is being done. And if you just listened yesterday to our Honorable Prime Minister from the Red Fort, what he is coming out with the massive reduction in GST tariffs. This will certainly include the medical equipment also. But as we have done in the warfare, whether it is BrahMos, whether it is Akash missile, let's have our own endoscope BrahMos, let's have our own Akash, and then I think that would be the day for Urology Society of India, the Delhi Urology Society, and all of the people sitting here. I think that's what is my vision. That's why. And someone asking me, are you doing urology? So I would like to make a statement here. That's my soul, that's my passion, and that's why we have now 2 DNB urology students. Suppose I work 14, 15 hours a day, 4, 5 hours are for urology. So please, you can call me in any symposium as Dr. Anant called me. I am so happy today to be among my friends, to be among the urologists. sharing my own thoughts and listening to your thoughts. I'm very happy today. And for that, I thank again Desai, Vignesh, and Dr. Anand Kumar and his team. And lastly, whenever we talk of any new procedures, please see the Indian scenario as far as the cost, benefit, and please also tell him that's the alternative treatment. That's the take on this today. If you say you need Razum, you have to tell him the other treatment also, the alternative treatment. That is what is the quality of medical care nowadays. Again, I thank all of you, dear friends, and especially Dr. Anand, Dr. N.P. Gupta, Dr. Prem Dogra. They are all my teachers. Thank you all.
Thank you, sir, for your kind words. I now call upon Dr. N.P. Gupta to share his thoughts with us.
All the dignitaries on the dais and off the dais, all delegates and ladies and gentlemen. I'd like to thank Anand for inviting me for this inaugural function. And I also want to compliment him that he has selected this topic of BPH management. Now everybody is interested in management of BPH. Why? Because half of the world population have got the prostate gland. 11% of the population today in India is also above the age of 60 years. And in this age group, 50 to 60% of patients have got lower urinary tract symptoms. And out of that, again, maybe 30-40% requires only medical treatment. And then remaining requires 20%, 30% surgical management. So it is a very big responsibility on all of us to do a proper evaluation of a patient of the LUTS. It is very important to know when to operate, when not to operate, because you have alternative of a medical management. The second thing is now coming to the surgical treatment. As you have heard today whole morning, there are so many options are available. So it is a confusion for the doctor, treating doctor also, which one to choose for a particular patient, and similarly for the patient also to get which procedure. So it is the responsibility of the treating urologist to select a proper procedure for a patient, which should be giving the maximum benefit to the patient, long-term benefit to the patient, not short-term, as well as it should be cost-effective as mentioned by Anil. So I totally agree with him also that treatment has to be affordable. We should not think of only these big towns like Delhi and Bombay or Ahmedabad, but we should think of the middle class and lower cities also, B class and C class cities, where there are minimum facilities are available. So in this plethora of the situation, I have got my own way of thinking, so that I will like to share with you. And I have also written down also, if somebody want, I can give you that statement. So how do I choose a technique? That I will share you with today. So anybody who is not fit for anesthesia, due to for any cardiac reserve is very poor, 15% ejection fraction, 20% ejection fraction, not fit for any kind of anesthesia, other comorbidities. Then there is the procedure of prostate artery embolization. That is the thing which you can do without any anesthesia. If somebody have a large prostate, more than 100 gram, what we have already discussed, then we have options of the and surgically fit. We have the options of the either TURP, nothing wrong in that, HOLEP, or robotic prostatectomy. Patients who are high risk again, poor cardiac reserve, ejection fraction of 25, 30, which may not be suitable for full anesthesia. We may require some kind of just control anesthesia. So these are the procedures where there is definitely a role of Razum is there. And those who are on caster, because they don't mind remaining in caster for another 4 or 6 weeks, And those patients who have got 50 to 80 gram or 100 gram prostate fit, I think so either HOLEP or bipolar TURP is good procedure. Those who have got less than 50 gram prostate and those who are very much interested for preservation of the ejaculation, then there is a role of these minimal invasive therapy, which can be either Urolift iTind, Urolume, or you can do Rhizome. So, it is very important to select out which one you want to do on which particular patient. So that is the way we should decide. And last point which I want to highlight, TURP is still the gold standard, according to me, with its modifications. That is what I have added, that with modifications like saline TURP or bipolar TURP, with thick loop, I think so, and good endovision camera, the bipolar, this with modifications, TURP is still the gold standard. My concern is only one, that all young urologists and postgraduates in their training time, I think so they must learn TURP first. They should learn TURP, then they can embark on other procedures like laser and all that. Unless you know the basics of the surgical management, that you have to go up to the surgical capsule, we have to remain within your boundaries. I think so TURP is a very safe operation. I must warn you here, it is a very highly technically skilled. So please, like your mentorship, you should have a good one to teach you how to do a good TURP. So please learn TURP, then you can embark on any of these modifications. So that is my message to you all. And with this, I like to thank Anand and his team for this excellent program. And I hope this will benefit you all.
Thank you, sir. May I request Dr. P.N. Dogra to kindly address the audience.
Dear esteemed colleagues, ladies and gentlemen, I really feel privileged and it is a matter of honor for me that Dr. Anand Kumar, my dear friend, many of you will not be knowing that what is our equation and relationship. And Dr. Pragnesh for giving me this honor of inviting through this conference and also asking me to sit on the dais in this inaugural function. Well, friends, you have heard a lot about this medical terminology, prostate, treatment, yeah, this and that. I'll little bit deviate from this. In the civil services, when they are given training, they are taught about 3 C's. I think we as a medical fraternity are also going towards that. 3 C's mean first C's is someone come to you with any complaint, try to convince him. And if he's not getting convinced, then create a conflict. And even that, if he's not working, then confuse him. So I think we have also reached to that stage. So you confuse so that he surrenders to you and says, whatever you want to do, do it. So my dear friend, I'll not take much time. As a surgeon, we should not have any technical limitation, nor emotional commitment, nor financial conflict, I will add it, to any particular type of procedure, but should be able to do and decide, even on the table, in the right patient, in the right given setting. Thank you very much.
Thank you, sir. And finally, I invite Dr. A.K. Sanwal to deliver his address. Thank you.
Our guest of honor, my elder brother, friend and mentor, Dr. Anil Goyal, who is also अब हमारे माननीय विधायक जी हो गए, तो विधायक जी के साथ हमारे यहाँ एक आरा अटैच हो जाता, तो उनके साथ आरा तो नहीं है पर उनके बाल बहुत अच्छे हो गए. आई मस्ट कॉम्प्लीमेंट यू. सो आप ऐसे ही यंग बने रहें और हम सब लोगों को प्रेरणा देते रहें. Since my residency, I am learning from my gurus, Professor N.P. Gupta, Professor Dengura, Dr. Anand Kumar sir, and still I am seeing they are still teaching. And that zeal we should all imbibe upon, and it should be there to teach. And we are seeing from a very small gathering, when it was in a lecture theater, NJUSI used to become. It is now so many conferences, so much learning. and we have worshipped the Saraswati. Sar matlab talab. स्वती मतलब जो उसका भावना हो रही है, तो जो झरने की धार ज्ञान की बह रही है, उस ज्ञान की धारा को हमारे ये गुरुजन लगातार प्रवाहित कर रहे हैं, उनको बहुत बहुत प्रणाम है। और वो ही नहीं, मेरे बहुत से सीनियर जो ऑफ द डायस बैठे हैं, लगातार वो ज्ञान दे रहे हैं। आई एम वर्किंग इन अ C class city, but simultaneously you have chosen me as president of NJDUSI. Is itself shows that it is not only in a class 1 city, knowledge is also percolating in class 2, 3 cities. There are in even class 2 to 3 cities, there are 4 or 5 urologists in every city. Now it has to go to district basis. And 30,000 जनता पर एक यूरोलॉजिस्ट होना चाहिए, दैट इज अ नाम एंड दैट इज गोइंग टू बी फुलफिल्ड वेरी सून। मैं डॉक्टर अनंत कुमार साहब को पुनः बधाई देना चाहूँगा कि एनी कॉन्फ्रेंस ऑन ए डेडिकेटेड टॉपिक एक्चुअली डज वेरी वेरी गुड, एंड दे हैव डन ऑन द prostate. Prostate is definitely our bread of butter, but I will again go on my basics. From too much zeal what is new and contempt for the old, from treating patient as cases, good Lord deliver us. That was written in Bailey and Love. So many new techniques have come, and so many also have come in the past. Thermotherapy, tuna, alcoholic injection, and nobody is taking their name. So any technique, but HOLEP has come, it has stayed. Bipolar TURP has come, it has stayed. So any technique which is good is going to stay. So since so many new techniques have come, but data is still not very large against the gold standard. So gold standard, you see today's even enlarged prostate, even open surgery still exists. Very large bladder stone with very large prostate, I will not think of the second time, but will do open surgery. Same is with TURP. It also depends upon person to person, what person masters at. I am doing TURP, unipolar, bipolar. I have done more than 5,000 prostate. Regularly, I am getting 80, 90, 100 gram prostate. Why should I go to HOLEP? I am not master of that. They should go to Dr. Bashne sir or anybody who has mastered it. And to master it takes बहुत सारी तपस्या लगती है। किसी भी चीज़ को मास्टर करने में you have to go in, बहुत सारे डिटेल्स आपको जानने पड़ते हैं, अपने अनुभव से लगातार सीखना पड़ता है, तब आप उसके मास्टर होते हैं। और साइमल्टेनियसली इट इज़ अ पेशेंट आल्सो, इट इज़ नॉट ओनली यू कि आई विल डू दिस, आई विल डू दिस। Knowledge has expanded so much. We all know now it is prostate operation is not the end. So much physiology is there. So it is the medical part. We are both physician and surgeon. So we must not only properly diagnose it, properly know that. Again, I just forgotten one part of medical litany, that making patient inability to live well alone. किसी को ऐसी सर्जरी ना कर दें कि वो परमानेंटली क्रिपल हो जाए। इनेबिलिटी टू लिव वेल अलोन, उसको छोड़ दें, मेडिकल ट्रीटमेंट में रहने दें। तो ये सब बातें अगर हम ध्यान रखते हैं, अपनी बेसिक्स को ध्यान रखते हैं, साइमल्टेनियसली वी मस्ट कीप ऑन डेवलपिंग न्यू ज्ञान। जो हमारे गोयल सर ने बोला है कि वी must develop, and irony is even endoscope is developed by our Indian urologists, but it is costlier than Western, which have a standard. So definitely we must develop new technology, new technique, new literature, new guidelines, then only we will say कि हमारा भारत में urology पूरी तरह से उपलब्ध है. We are the best surgeons in world, but in instrument, in literature, we are definitely lacking. So dear friends, we must all, you are young persons, so much of young and talented urologists are coming, they must continuously work for this. Thank you, well again.
Thank you, sir. Just yesterday, our nation celebrated Independence Day, a day when we honor the sacrifices of the countless individuals who gave us the gift of freedom and the opportunity to build a healthier, stronger India and soon a Viksit Bharat. In that spirit, I request everyone present here to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
To conclude the inaugural ceremony, I request Dr. Pragnesh Desai to please deliver the vote of thanks.
Good evening. Please be seated. Let me thank you all. Good evening. On behalf of Department of Urology, Renal Transplant, Uro-Oncology and Robotics, Max Super Speciality Hospital, Saket, it is my proud privilege to extend our heartfelt gratitude as we bring the curtain down on the Max Prostate Conclave 2025, a unique blend of CME, live operative workshop, and hands-on simulation session. First and foremost, I would like to thank our esteemed chief guest, Dr. Anil Goyal, and other dignitaries on the stage, Dr. Anand Kumar, Dr. N.P. Gupta, Dr. Dogra, Dr. Sanwal, for gracing the occasion with their presence and inspiring words. Your encouragement fuels our passion to raise the bar in academic excellence and patient care. A special note of appreciation to our distinguished faculty, national and international experts, the list is long, who generously shared their knowledge, surgical skills in live operative sessions and clinical wisdom. Your live demonstration, insightful lectures, and interactive sessions have truly enriched the learning experience for all of us. We are deeply grateful to our delegates, the urologists, residents, and trainees for your active participation, thought-provoking questions, and enthusiasm, and embracing new technologies and techniques, especially in the simulation training modules. Our heartfelt thanks to the organizing committee, patron Dr. Anand Kumar, for showing trust on us, guiding us in every difficult task we faced, organizing chairman Dr. M.S. Jha and Dr. Samit Chaturvedi and Dr. Manish Chaudhary for moderating and facilitating live demonstration and smooth live OT telecast. Special thanks to my dear colleague, organizing co-secretary Dr. Rohit Kaushal for his excellent scientific agenda and live operative case management. Joint Secretary Dr. Vivek Vasudeva, Dr. Amit Agrawal, Dr. Anuj Sharma for their enriching case-based discussion, as Amit Agrawal is going to do it tomorrow. And Dr. Swapnil, he will be organizing a quiz competition tomorrow. Our heartfelt thanks to our coordinator, Mr. Jasbir, Mr. Ayush, Mr. Prema, Mrs. Prema, Ms. Mumtaz, and Mr. Hanif Asija, and residents and fellow volunteers, Nipun Bansal, Jasmeet, for excellent moderation of the entire event at Max Prostate Conclave 2025. Dr. Nishan Setia, Dr. Rahul Agrawal, Dr. Shaunak Mitra, Dr. Umar Khan, Dr. Kumar Nishant, Dr. Ashish Garg, Dr. Fawaz, Dr. Puneet Sharma, whose meticulous planning and tireless efforts have made this event seamless. A big thanks to our anesthetist, especially Dr. Raj Tobin and her excellent team, OT staff and technical crews, Mr. Deepak Singh Fagna, Mr. Sashi Ranjan, Mr. Jay Prakash, for ensuring that every live surgery and session ran smoothly. Finally, we also extend our gratitude to our industry partners for their valuable support and for showcasing cutting-edge innovations that complement our clinical practice. Olympus Medical System, Boston Scientific, Teleflex Medical Private Limited, Healthware, VP Impacts, IPG Photonics, Intuitive, Medtronics, Johnson & Johnson, Stryker, Bebron, Welfare Medical, Sun Pharma, Intas, Cipla, Ipca Laboratories, Dr. Reddy Laboratories, FutureMed, DSS Image Tech Private Limited, Merrill, BioClick Technologies, Fujifilm India, Medicon, Genova Biopharmaceuticals, Blue Neem, Eagle Medical System, SAT Pharma, Concord Biotech, and BioKindle. Lastly, to everyone who joined us today and who will join us tomorrow, thank you for your time, your energy, and your commitment to advancing prostate care. Together, we have created a platform of learning, collaboration, and excellence that we can be all proud of. Wishing you all a safe journey, as many of you will not be here tomorrow at the end, and looking forward to meeting again at future editions of the Max Prostate Conclave. Thank you. I would like everyone to come on the desk for a group photo.